These are all original questions that are made by me. Basically, it's everything that you will need to know by the time you've finished and marked off your review for NBME 30. Of course, this does not replace the National Board of Medical Examiners, the practice tests they have there. Definitely complete them. This is just my own original question bank where we're covering topics that you should know by the time you finish your prep. I'm also releasing a website for free, ivmed.net. Be sure to check that out. And if you're interested in the mission here at Ivy Tutoring, then please like and subscribe. It really helps out. Okay, let's do this. So starting out strong. A 3-year-old girl brought to the pediatric clinic. She's got problems with hearing and vision. We covered this before. She has some neural crest migration issues, which are kind of ending up in different parts of the body, kind of wreaking havoc in different areas. One of them is causing vision problems. One is causing hearing, but also they have differences in eye color like heterochromia. And so this is Waardenburg syndrome, where you have abnormal neural crest cell migration. You can have the black hair with the white forelock. You need hearing aids and have sensory neural deafness as well. It's not albinism, because albinism would not be patchy. Connexin would not be related to pigment, and tyrosinase would not be patchy as well. That's the mechanism for albinism. Okay, so that's the first question. I'm going to try to go a little bit more quickly in the future. But here's our next question. Number 2, we have a 45-year-old man, clinical trial, responses to different nutrients, and he consumes a high-fat meal, and now he has an increase in insulin levels compared to when he consumes a low-fat one. So what explains these observations? So basically, we're increasing the insulin release and more rapid glucose reduction after a high-fat meal. And so the incretin, the GLP-1s, are secreted by intestinal L cells in response to the nutrient ingestion, especially fats or carbohydrates. And so it increases the glucose-dependent insulin release. It also suppresses glucagon, and it slows gastric emptying. So that explains why the insulin levels are at rise after you have a fatty meal, and also glucose is cleared faster. So the leptin and the ghrelin, these guys regulate appetite, and the CCK stimulates the gallbladder, and the secretin increases the pancreatic bicarbonate secretion. How about some other answers like leptin? So leptin, that's going to be associated with adipose-derived satiety. Ghrelin, that's going to be the hunger hormone, so the stomach-driven hunger hormone. And CCK, that's the gallbladder constriction and pancreatic enzyme secretion. And so that it helps digest the fats, but wouldn't stimulate the actual insulin release, whereas GLP does. So GLP is secreted from the L cells in the distal ileum and colon, especially fats and carbs, and has a powerful effect on the increasing insulin release while suppressing glucagon. Fatty Liver King says, and specific to the raise in blood glucose, right? Yeah, so GLP-1s are released by nutrients like fat, and they act in the presence of elevated blood glucose. So you have that blood glucose, and that'll boost the insulin and decrease the glucagon, and that normalizes the glucose even faster. Gliptins are another point for GLP-1, says Fatty. Yeah, so this only works when the glucose is high. Motilin would be small intestine, fasting, and M cells. Gastrin is G cells, gastrin the antrum. Secretin is S in the duodenum. And so GLP-1s, they're incretin hormones, and so they're glucose dependent. And DP4 is what degrades GLP-1s. And then gliptins inhibit DPP4s. So Fatty was talking about gliptins. Gliptins inhibit DPP4s, and they prolong GLP-1 action. And so these are used in like type 2 diabetes management. GLP-1 secretion is going to be in the ileum and the colon, and the L cells are stimulated by fats more than they are carbohydrates. And then DPP4 inhibitors in the ileum cause prolonged incretin effect locally and systemically. The big takeaway is, since this is a glucose-dependent mechanism, there's minimal hypoglycemia risk, which is why they're great drugs. And so agonists would promote weight loss, and gliptins are weight neutral. They both reduce the HbA1c in type 2 diabetes. Yep, and gliptins, they guard the gut. They stop you from being clipped by DPP4. So we'll scroll down and see all these answer choices here. Gulp the Tide Pods. The DPP4s are gliptins, prolonged GLP action. GLP is degraded by DPP4. Okay, I think the questions are generating images now. That's good. Sorry, I had to do some debugging there. All right, in our next question, we have a 67-year-old woman. There she is, presenting to the emergency department with a 4-day history of fever, productive cough, and worsening shortness of breath. Temperature is 102, respiratory rate is 28, decreased breath sounds, dullness of percussion in the right lower field. X-ray shows right lower lobe consolidation. Which structure is responsible for facilitating the spread of the infection? Yes, I gave you this last time on Twitch. Good, yeah. I was preparing to make this video beforehand on the live stream. Yep, this is the pores of Kohn, right? So the answer is going to be the interalveolar septa. And so here in lobar pneumonia, Streptococcus pneumonia infects a single lobe and rapidly spreads between the adjacent alveoli through the pores of Kohn, which are the openings in the interalveolar septa that connect the neighboring alveoli. And so these pores allow macrophage migration and collateral ventilation under normal conditions, but they also serve as a conduit for pathogens. Okay, so here are the trap answers and why they're wrong. Fatty Liver King says, and broncho is the bronchioles. Yeah, so the bronchial arteries, these supply oxygenated blood to lung tissue, and they're not involved in the pathogen spread. And you're right about the broncho and the bronchioles. So lobar pneumonia is going to be Streptococcus pneumonia. And then bronchopneumonia is like Staphylococcus aureus, H. influenza, Klebsiella pseudomonas. And the spread in lobar pneumonia is, it starts in the alveolus, and then it goes through the pores of Kohn. Whereas for the bronchioles, it's going to go through the bronchioles to the adjacent alveoli, and it spreads along the airways. And if it's spreading along the airways like that, it's going to be patchy multifocal areas, often bilateral or basal. And then if it's lobar, it's going to be the entire lobe. So the spreading is different. Lobar is going to be through the interalveolar connections, and then bronchial is going to be the spread of the bronchioles in the terminal airways. All right, there are the buzzwords here. Streptococcus pneumonia, lobar consolidation, pores of Kohn, decreased breath sounds is a sign of lobar pneumonia. Lobar is looks like grapes, and how they spread, how it takes over the whole lobe. So here's our next question. We have a 3-year-old boy is brought to the pediatrician by his parents due to developmental delay, eczema, and musty body odor. Child is born at home and has not had regular medical checkups or newborn screening. So there's the image of our child. What should be supplemented in this child? The answer is tyrosine if he has the mousy odor, right? This is phenylketonuria. It's a deficiency in phenylalanine hydroxylase, which converts this into tyrosine. And so you don't have it, you can't make tyrosine, and you have phenylalanine buildup, and that can be neurotoxic. Tryptophan for serotonin, leucine, buildup involved in maple syrup disease. So this is PKU. It's from a deficiency in phenylalanine hydroxylase, which normally converts phenylalanine into tyrosine. But because tyrosine synthesis is impaired, tyrosine becomes the essential amino acid that has to be supplemented in the diet. All right, so musty body odor and hypopigmentation and developmental delays are seen. Tyrosine is a precursor for melanin, dopamine, and all these other things as well. Fatty says, another point with pneumonia is you get hypoxic vasoconstriction as compensation for a low to A gradient. Whenever a region of the lung becomes hypoxic, then you have local pulmonary arterial constriction instead of dilation. And so the purpose is to shunt the blood away from the poorly ventilated regions. And so you have better ventilated regions, and it optimizes for the ventilation perfusion VQ matching. So in pneumonia, you get alveolar consolidation, and the fluid and exudate fill those air spaces, and the alveoli are poorly ventilated. And so you have decreased alveolar pressure of oxygen. And so the local pulmonary vessels are going to constrict, and you get hypoxic vasoconstriction, and that reduces the blood flow to those lobes. Okay. PKU requires dietary supplementation of tyrosine due to phenylalanine hydroxylase deficiency. And here are the notes that I took on this. Mousy odor, what do you give? Tyrosine. So you build up phenylalanine, so you got to give them tyrosine. All right, in our next question, we have our little anatomical model, and we did this on stream as well, but for the YouTubers. So here we have a 68-year-old man presenting with primary care. He's got right-sided flank pain, discomfort. Abdominal ultrasound is performed and shows dilation of the vessels causing compression of the right ureter at the level of the pelvic inlet, resulting in moderate hydronephrosis. Which of the following arteries is involved in this compression? Okay, so if we zoom in here, we can actually see what's going on in this little image that I put right here. There are 3 constriction points: the pelviuretic junction, the bifurcation of the common iliac, which is going to be the answer to this question, and then the intramural part, more distally. And so the answer is the common iliac. All right, so there's the common iliac artery. Compression can occur right there in our little model. And if you have a bruit in your right lower abdomen, you should think of an iliac aneurysm, and hydronephrosis is going to be a post-renal obstruction, and there's a pelvic inlet compression which crosses the ureter over the iliac artery. And the risk factors are going to be an older man, hypertension, hyperlipidemia because of the atherosclerosis, which can contribute to the aneurysm. So this is going to be associated with atherosclerosis, which is the major cause of this. Also AAA, because this can extend into the iliac arteries as well. And so this can rupture, you can have a thromboembolism, or you can have just ureteral obstruction as well. Celiac would be the foregut supply. Superior mesenteric would be nutcracker syndrome, compresses the left renal vein, not the ureter. Inferior epigastric is the anterior abdominal wall. Gonadal crosses ureter, but it's too narrow to cause that mechanical compression. Okay, there's the bottom line. Compression of the right ureter due to the right gonadal artery is a common cause of hydronephrosis. And here are the notes that I took on this before. And we'll slide on over to our next question, where we're going to have a lot of notes. All right, in this question, we have a 27-year-old woman presenting to the clinic for a routine prenatal visit. 8 weeks gestation based on her last menstrual. She's nauseous. Lab tests show normal complete blood count and serum electrolytes. In early pregnancy, which of the following structures is primarily responsible for the production of progesterone? So early on, it's the corpus luteum. Good, yeah, you nailed it. Good job, Fatty. By the way, his name is Fatty Liver King, so that's why I'm calling him Fatty, not just being mean. That's funny. Yeah, so basically the corpus luteum is going to help in their early stages, and then you have the FSH, which contributes to the follicular growth, granulosa to the estrogen. And so your corpus luteum is fed by that HCG, which maintains it, and then it secretes the progesterone. The progesterone thickens the cervix and maintains the endometrium early on in the cycle. And so what gives here is you have your LH surge, ovulation, which leads to the formation of this guy. The ovulation leads to the formation of the corpus luteum. And then the syncytio trophoblasts, these guys release HCG, and then it binds to the LH receptors. And the corpus luteum then continues progesterone secretion, and it sustains early pregnancy. And the placenta starts to produce progesterone around week 8 to 10. So early pregnancy progesterone source is the corpus luteum, and HCG maintains it, and placenta then takes over around week 10. And so if you have a corpus luteum failure, then you're probably going to have some sort of a miscarriage. It produces the progesterone, which is super important for establishing the lining. Endometrium is going to be that lining, which produces prostaglandins, not progesterone. Hypothalamus is the GnRH pulse generator. Ovarian follicle is the estrogen producer, and adrenal cortex produces cortisol, aldosterone, and androgen, not the source of progesterone. It's the corpus luteum, especially in early pregnancy. Okay, so there's the bottom line. Corpus luteum, primary source of progesterone in early pregnancy. And this is what it looks like. So now moving on to our next one about relative risk. So if they're saying, hey, what's the risk of, tubal versus oral? You just divide. Yeah, you divide these, and that's all there is to do with relative risk. You take the risk of this, the risk of that, and you just divide them. That's the relative risk. All right, similarly for this one, we actually covered this one on stream. Basically, if we're optimizing sensitivity, specificity, or both, we need to know how we should be moving this cutoff point. And if we have a sensitive test, then that's going to be really good for ruling out a morbid diagnosis. So if there's somebody where most people die like 90%, then you want it to be super, super sensitive, which is the true positive rate, minimizing those false negatives. So like the way to think about this is high sensitivity means that you have few false negatives, because if it's morbid, you're going to want to know that you have it. So it'll catch almost everybody who has the disease. And so if the test is negative, you can be pretty confident that they don't have it, because the sensitivity rules out the diagnosis. So true positive is up and false negative is down. And so you're going to want to cut it off like right around here. That way, the people who are infected, you'll catch. And those who aren't infected, you'll leave alone, but you're erring on the side to the left. Okay, next, the difference between Horner, Gerstmann, Wallenberg, and Weber. So Horner is your classic ptosis, meiosis, anhydrosis. You have a sympathetic chain problem and commonly associated with the Pancoast tumor. Gerstmann has agraphia. So here's a look at Horner syndrome. Problem with the sympathetic nerve supply, one side of the face, results in meiosis, which is constricted pupils. Ptosis, which is the droopy eyelid. And anhydrosis is the failure to sweat. It's that sympathetic chain. Agraphia for Gerstmann, you have right-left disorientation, finger agnosia, acalculia. You have a whole bunch of problems here. And then Wallenberg is the lateral, pica, vertigo, hoarseness. So Wallenberg affects the pica, posterior inferior cerebellar artery, and the vertebral artery. So this, you might see Horner syndrome, double vision, slurred speech, dizziness, lateral, pica. Yeah, and then Fatty Liver King says need medial medullary as well as Wallenberg. Yeah, that's true. So the medial medullary syndrome, the cause is going to be an infarct of the paramedian branches of the anterior spinal artery. And so it affects the medial medulla. And then the lateral medullary syndrome, this is also known as the Wallenbergs. All right, so that's the pica, so posterior inferior cerebellar artery, and that affects the lateral medulla. So medial, ASA, lateral, Wallenberg. And so just to do a little test between these Wallenberg, the lateral and the medial. So if they have dysphagia and they have hoarseness after a stroke, then it's probably Wallenberg. And it's going to be a nucleus ambiguous lesion. And if it's tongue deviation toward the lesion, then it's going to be an ASA stroke, so medial medullary. And if it's contralateral hemiparesis and proprioception, then it's going to be like a medial. And if it's Wallenberg, then it's going to be loss in pain and temperature on the ipsilateral and then the contralateral body. So Wallenberg, pica, hoarseness. The pica horse can't eat is the way you can remember that. Pica, hoarseness, dysphagia. The pica horse can't eat, Wallenberg. And then medial is ASA, the tongue medial. So ASA is the tongue stuff, because you have the cranial nerve 12 lesions for the ASA, which is the medial. All right, now for question 10, dorsomedial aggression, lateral hunger, posterior heat, ventral medial lesions make you massive. So it looks like this person has central diabetes insipidus. They have polyuria, polydipsia, and so it's going to be the supraoptic. This is going to be seen with low urine osmolality, high serum osmolality, and usually it's after like head trauma or neurosurgery is going to be central DI, and this does respond to desmopressin. So supraoptic has ADH production associations. Paraventricular would be oxytocin production. Posterior pituitary is the neurohypophysis. So that stores and releases both of them if they asked about that. All right, so those are the answer choices, and here are the reasons why they are right or wrong. Mammillary would be Wernicke-Korsakoff, causes amnesia. So you have a lesion to the supraoptic nucleus, and that decreases your ADH synthesis. And so you have no ADH release, and so the collecting ducts remain impermeable to water, and you have large volumes of dilute urine. Okay, so there's the bottom line. DI due to a lesion that affects the supraoptic, impairing ADH secretion. And Fatty Liver King says we use water deprivation to test this. Yes, indeed. Water deprivation test is a good test for the supraoptic nucleus because we're going to be producing that vasopressin. The neurons in the supraoptic nucleus produce the vasopressin, and then the kidney responds. So you have a dehydration phase where they stop drinking, because then if they had a healthy supraoptic nucleus, then they would produce concentrated urine. And then if the urine does not become concentrated, then they give them desmopressin, which is a synthetic form of vasopressin, to see if the kidneys will respond. So normally the urine is concentrated, but in central diabetes insipidus, they have damaged supraoptic nucleus. And so the urine is still going to be dilute during dehydration because the supraoptic nucleus is not producing enough vasopressin. And so you give them the desmopressin and it corrects it. And then nephrogenic diabetes insipidus, that's where the urine remains dilute during dehydration, but also fails to concentrate after you give them desmopressin. That's because it's not a problem with the supraoptic nucleus at all. It's just the kidney's inability to respond to the hormone. Okay, on to the next one. We have a 45-year-old construction worker from Arizona. And that honestly is enough to tell you it's coccidioides. Man. Diffuse nodular infiltrates. Yep. We'll just look at all of these and why they're buzzy for each. Blasto, broad-based budding, more common in Great Lakes, Ohio River. Histo is going to be Ohio, Mississippi. Sporothrix is rose gardener problem, cigar-shaped yeast. And Streptococcus pneumoniae will be rust-colored sputum. It's a bacterium, not a fungus. Fatty liver king says really high yield for either hypothalamic and pituitary adenomas causing central. And also, yes, good. Lithium causing nephrogenic, so bipolar is a good cue. Nice. Very, very nice. Really good tips. So, yep, the supraoptic, it'll make the ADH. The post will store a stock, will ship it out. And any break along that highway causes central diabetes insipidus. Okay, here's the bottom line for this question. Coccidioides immitis causes pulmonary and cutaneous symptoms in endemic areas, confirmed by spherules in biopsy. So California, Arizona gives it away. This would be head and neck. Histo, Ohio, Mississippi, Legionella is gram-negative. Okay, here's the next question. We have a 45-year-old male accidentally injects himself with a solution containing botulinum toxin. What explains his weakness? Okay, so we have some sort of a descending weakness that starts with the facial muscles, and then you have the swallowing issues. And so what happens is the toxin cleaves the snare protein in the presynaptic nerve terminal. And so if you don't have that protein, then the vesicles that carry the acetylcholine are not going to be released into the synaptic cleft. And so that's why the flaccid paralysis happens. And the muscle is still going to be contracting when acetylcholine is applied directly. And so basically it's going to be the disruption. You're disrupting the acetylcholine vesicle fusion and release. It's because of that snare cleavage, which is the mechanism. So you have autonomic dysfunction, which is dry mouth and blurred vision. And you have normal nerve conduction and decreased response with repetition. And now I wrote a lot of this stuff out here, but it was more because the question was on the presynaptic stuff with Lambert-Eaton syndrome and small cell lung cancer. But this one, the toxin enters into the presynaptic terminal, it cleaves the snare proteins, and so now the vesicles aren't going to be able to fuse with the membrane, and so you have no acetylcholine release into the synaptic cleft, and so the muscles can't depolarize, then that's flaccid paralysis right there. And so exogenous acetylcholine can bypass that block, and you have normal contraction, and that'll confirm that it's a postsynaptic apparatus. All right, botulism, botulinum toxin, the snare protein. Fatty Liver King says this is inhibition of vesicular fusion or maybe packaging. Yeah, the snare proteins are required for vesicular fusion because they're going to tether the acetylcholine-filled vessels to that presynaptic membrane, and that way it can exocytose the acetylcholine into the synaptic cleft. And so you're inhibiting that vesicular fusion and the exocytosis of acetylcholine. Okay, other myasthenia gravis is a blockage of the postsynaptic, inhibition of acetylcholine synthesis, hemiclinium, low yield, impairment of postsynaptic, long-term receptor regulation, blockage of presynaptic is Lambert-Eaton. That would cause proximal limb weakness, if nothing else, but also this would improve with use. There's some buzzwords, and here's some associations. There's the pathophysiology that we explained, and here are the normal features. Yep. And then fatty liver says they love feeding honey to babies or canned food for botulism because it's anaerobic and loves low oxygen. Very nice. Very awesome addition there. Thanks, fatty liver. That was great. It causes weakness by blocking presynaptic voltage-gated calcium channels, preventing acetylcholine release. All right, next we have a 42-year-old woman, comes to the clinic for annual health checkup. She has a history of hypertension, well controlled. Her blood pressure is normal. Which of the following factors would be contraindicated or would contraindicate the use of oral contraceptive pills? Okay, there's our patient. So what we should know for this one is that oral contraceptive pills increase the risk of clots and stroke. And so in women who have a migraine with aura, then the risk is going to jump way up because estrogen and aura-related vasospasms can trigger cerebral ischemia. And so a migraine with aura is an absolute contraindication. Yep, you got it right, fatty liver, nice. Well-controlled hypertension, normal BMI, and occasional alcohol, these are not deal breakers here. Let's look at especially why. If you thought any of those were the case, you can pause and view why. They are fine. Moderate, not contraindication if no end organ damage at 140 or greater, over 90. And even if sedentary wouldn't be standalone contraindication. Migraine with aura. Uncontrolled smoking greater than 35 years. So tobacco use is going to be a huge one as well. Migraine with aura, promotes clotting. Contraindications, smoking would be a big one. So estrogen increases hepatic production of clotting factors. Migraine with aura means that you have some cortical spreading depression and endothelial dysfunction. And so you combine those two, whoop, that's not going to be good. You're going to get some clots and you're going to have some sort of stroke. All right, so history of migraine with aura contraindicates oral contraceptive pill use due to the increased stroke risk. By the way, what is the aura? Aura is a transient, reversible focal neurological symptom that precedes or sometimes accompanies a migraine. So it's a wave of cortical spreading depression, and it's slow, self-propagating depolarization of neurons that temporarily silence brain activity in that region. So this is like some whatever neurological symptoms you get before you have a migraine. So usually it's going to be some sort of a visual thing. Basically, it denotes that you might have some endothelial problems or you might be at risk and definitely contraindicated with OCPs. And then here's the clot risk, OCP, estrogen, progesterone pills as a treatment for PCOS or menorrhagia. Avoid because you can have DVTs, pulmonary embolisms, myocardial infarction, hypertension, cirrhosis, breast cancer, all the like. And Fatty Liver King says, yeah, that's why we give triptans for migraine because it stabilizes vasospasm. Yeah, that's a really good connection. Yeah, the vascular tone. And so it'll break the cycle of dilation causing and pain and neurogenic inflammation. So that's why they're effective for acute migraine attacks. Because triptans have that 5-HT1B1D receptor agonism. And so they vasoconstrict the dilated cerebral meningeal vessels, and that inhibits the trigeminal nerve activation. And that decreases the release of the pro-inflammatory neuropeptides like substance P. So that's what triptans do. All right. Now on to our next question. 35-year-old woman, progressive forgetfulness, personality changes, history of poorly managed HIV infection, not taken antiretroviral therapy. CD4 count is 45, poorly demarcated hyperintensities. What is her diagnosis? Is it toxo or is it HIV? Yeah, those are the two that you would choose. So fatty liver, thinking toxo. So the answer for this one is actually HIV-associated neurocognitive disorder. And the reason why it's not toxo is usually have the multiple ring-enhancing lesions, but here they're non-enhancing and symmetric. But I liked the thought process of toxo. Solitary mass would be primary CNS, cytomegaly encephalitis, periventricular enhancement, global subcortical normal CSF, and diffuse changes in imaging. So she's forgetful, has the wide-based gait, HIV, CD4 count is super low, that's AIDS defining, and that is also risk factor less than 50. So it's in the CNS, causes immune activation inflammation. Now you have demyelination and all that motor decline. Ring enhancing is toxo. MRI lesions would be asymmetric, sharply demarcated if it were progressive multifocal leukoencephalopathy. Progressive multifocal single ring enhancing is lymphoma from HIV or associated with. Yeah, so if you see ring enhancing lesions, then there are three possibilities. There's toxo if it's multiple ring enhancing lesions. If it's primary CNS, then it's usually just a single, but it could also be a few like ring enhancing lesions. And then multifocal leukoencephalopathy that has non-enhancing and there's no mass effect and it's white matter. But the location also matters because the toxo is going to be typically in the basal ganglia, and periventricular is where the primary CNS lymphoma is going to lay. And the CD4 count as well, toxo is less than 100 and primary CNS lymphoma is less than 50 typically, and both of them will have mass effect. So multiple ring enhancing lesions is toxo. It's the most common in like advanced AIDS. If it has a single solitary ring enhancing lesion, then primary CNS, and it's probably Epstein-Barr virus related. And then primary CNS lymphoma, Epstein-Barr virus associated, is different than the no ring enhancement stuff. That's going to be like our condition here, hand or PML. So lymphoma is often going to be single and it shows ring enhancement because of the breakdown of the blood-brain barrier and the central necrosis. Yeah, Epstein-Barr virus always high yield for lymphoma. Okay, HIV-associated neurocognitive disorder, hand, is common in patients with low CD4 and presents with cognitive decline and motor defects. And I think we'll take a quick break after 15, but we're going to go all the way in this live stream to 50. Fatty Liver says, A, love that. All right, this will update soon. Right now she's a 70-year-old girl, but soon she'll be a 7. Presents a pediatrician with history of fever, sore throat. For the past 48 hours, she has no significant past medical history and is up to date with her vaccinations. Physical examination reveals mild cervical lymphadenopathy, erythematous oropharynx without exudates. What is most crucial for the initial elimination of a virus? So we talked about this on stream. What do you think? So this is a 7-year-old girl, so she probably has like influenza, maybe like an RNA virus, right? It's infecting her epithelial cells. And so because of that, we're guessing B. Nice. You got it. This requires cell-mediated cytotoxic T cell immunity for clearance because CD8 positive cytotoxic T lymphocytes, they recognize the viral peptides that are presented on the MHC class 1 molecules, and they kill the infected host cells, and that stops the viral infection. So here's the explanation. Initial clearance depends on CD8 cytotoxicity. Nice. IgG, Secondary humoral response. IgG is key for long-term immunity. Not the first line though. Activation. Bacterial lysis in the complement system targets the bacteria and antibody complexes, not the viruses. IL-4 by Th2, that'd be the class switching immunity. That's a Th2 response. And then mast cell would be allergies. So to fight viral infection, we use this tiered strategy. Innate defenses slow it, then it's infected, and now CD8 positive is like, ooh, that's viral. I'm going to kill you. MHC class 1, they all display it. IL-2 drives CD8 positive T-cell proliferation. Pathophys, virus infects respiratory epithelium. Naive CD8 positive T cells recognize the antigen co-stimulation, become activated. And then they have apoptosis to kill them. All right, trained assassins, CD8 positive T cells, cytotoxic lymphocytes. Frontline killers, number one stop. What can you say? Here's the bottom line. CD8 positive T lymphocyte activity is crucial for the initial elimination of the virus-infected host cells in influenza. For this one, real quick, we'll just cover it because it's a pressure volume loop one, really simple. Basically, you just have to know how the preload, afterload, cardiac contractility changes all of the stuff. And if you have a decrease in the afterload, then you have a shorter loop. It's going to be shifted to the left because you don't need as much pressure. And you also get rid of more. And systolic volume is here and diastolic volume is here. Those are the two most important things to keep in mind. This is pressure, this is volume. Now we did this one on stream 17. If this is cardiac output, this is the left ventricular end diastolic volume right here. And this is normal, and this is the patient. Then what do they have? They have chronic heart failure. Less volume, left output. Core pulmonale is the right. Heart muscles weakened. So this is a congestive heart failure. Okay, and fatty liver says, wouldn't heart failure have more diastolic volume if it's left heart because you have systolic? Never mind, less blood coming back. Yeah, you got it. Basically here, what's happening is if it's left-sided systolic heart failure, then the end diastolic volume is going to be normal or decreased, but the pressure is going to be elevated. So in left-sided systolic heart failure, think of that as just a weak pump. The ventricle can't contract, and so decreased contractility, it'll eject blood, but like less blood, and so that decreases the stroke volume and decreases the ejection fraction. And so what happens next is because the ejection, like systolic failure, the ejection is poor, more blood remains in the ventricle after systole. And so that's the end systolic volume is going to be elevated. And then on the next filling phase, the venous return adds even more blood on top of that. And so then you have an increased end diastolic volume as well. So the heart is trying to compensate with the Frank-Starling mechanisms. And so it stretches more. So it's causing increased preload, which then makes it pump harder. But if it's failing, then the ventricle is just way too weak. And so the extra stretch does not produce enough force. And so the blood backs up into the lungs that causes pulmonary congestion, dyspnea, and then the orthopnea. And so in systolic heart failure, the end diastolic pressure is also increased and the ejection fraction is going to be decreased and the left ventricular size is dilated. It's going to be eccentric. And so you have the elevated left ventricular end diastolic pressure and it'll back up into the pulmonary veins and causes pulmonary congestion and dyspnea, even though the volume isn't very high. So in diastolic heart failure, the end diastolic volume is normal or going to be decreased because the ventricle just can't fill. It's just stiff-walled. But the pressure is way up. And the ejection fraction is normal, but the left ventricular size is also going to be small. So it's like a tight ventricle, fills less, and the pressure is way, way, way high. Okay, let's take a quick break here. I'm going to load the next question. I'll come back in about 5 minutes. Just give me 1 second. There we go. So anybody in the chat, as long as you interact with the chat in the next 10 minutes, you'll be rewarded with a tomato for your tomato garden, which is always cute and fun to have. Yeah, there you go. You get a tomato. Everyone gets a tomato. All right, let's do 20 more questions, shall we? Well, that was a fun little detour. Thank you, Harry Potter. Next question. All right, so here we have a 32-year-old woman. She's complaining with fatigue, lightheadedness, heavy menstrual cycles. This is microcytic anemia because the MCP is going to be super low. This is just iron deficiency anemia. Macro would be B12 and schistocytes would be microangiopathic hemolytic anemia. And so you have to distinguish between TTP, the terrible pentad, HUS, and DIC. I have a video on this. Target cells would be thalassemia, and spherocytes is hereditary spherocytosis with autoimmune hemolytic anemia. So differentiating between them, fatigue and pallor, MCV at 70, central pallor, dietary vegan diet, GI, pica, craving ice, and the blood loss, less iron, chronic state of fatigue, brittle nares, pica. So yep, iron deficiency anemia, the most common nutritional deficiency in the world. Pencil cells always niche for microcytic. Oh yeah. So blood loss, iron, vegetarian diet, all this stuff be making us think of this condition. And the ringed sideroblasts, they look like pencils. There we go. That's a nice photo of it. The pencil cell, hypochromatic pencil. So I guess the pencil cells from that low hemoglobin and the unstable red blood cell membranes, which causes the elongation. Look at that little pencil right there. All right, question 19. Just give me 1 second. Okay, so the different bacteria that you have to know, the bugs for chronic granulomatous disease, nocardia, aspergillus, Burkholderia, and Staph aureus. So here's our practice question. So skin abscesses caused by Staph Burkholderia, physical examination says no lymphadenopathy or hepatosplenomegaly. Lab tests indicate normal, but we do have a decreased fluorescence. And so this is going to be chronic granulomatous disease. And so the recurrence infections caused by these catalase positive organisms, that's how you need to know them. Abnormal DHR, defective NADPH oxidase and neutrophils. Cheetah Kagashi, giant cells and partial myeloperoxidase deficiency. Normal DHR, mild candida. Neutrophil specific granule, defect in granule formation, impaired chemotaxis. Not R fluorescence defect. And Wiskott has the eczema, thrombocytopenia, and recurrent infections and T and B cell dysfunction. All right, so how do the neutrophils kill the pathogens? Phagocytosis, NADPH oxidase, superoxide is then converted to hydrogen peroxide, and then you have hypochlorite by myeloperoxidase. And so step 2, the NADPH oxidase complex creating the superoxide is failing here, so you don't have that oxidative burst. Okay, here's the bottom line. Chronic granulomatous disease is characterized by recurrent infections, decreased neutrophil function confirmed by DHR flow cytometry. This is cool, the green screen. All right, here are the notes that I took for question 20. And yes, as Fatty says, that is why you are susceptible to catalase-positive organisms, 100%. So here we have a 62-year-old Asian man presenting to the dermatology clinic with darkly pigmented lesion on his left forearm. Several years, but recently increased both size and darkness. Which the following histo findings is most likely to assist differentiating this lesion from non-melanocyte skin lesions? This is a good question. Nice. Nailed it. C. Surely C indeed. Very, very nice. So here is our correct answer. It is C. Brief explanation. Melanosomes are organelles found in melanocytes that synthesize and store melanin. This makes melanosomes a defining histologic feature, distinguishing melanocyte tumors from other skin lesions, and the ABCD also points strongly to melanoma. So a number of fibroblasts, dermal scarring, presence of Langerhans cells, immune surveillance found in all layers of the epidermis, not specific to melanocytes. Some Langerhans cells are not specific. Presence of spongiosis, eczema would be associated with that, and number of neutrophils would be acute inflammation. So what distinguishes melanoma histologically? Melanoma is a melanocyte tumor, and so it arises from the melanocytes, and these are the pigment-producing cells of the basal epidermis, and the melanocytes have melanosomes, and these are intracellular organelles that synthesize and store melanin. And so melanomas, you have increased number of atypical melanocytes and abnormal melanosomes, number, size, and distribution. So it's the number of somes versus the sites. Yes, and then you have A, B, C, D, E. Nice. Very, very good. You also have that pagetoid spreading, the melanocytes that migrate to the upper epidermis. And so it's the presence and the number of the melanosomes tells you the type melanoma, nevus, right, versus a non-melanocytic lesion like a seborrheic keratosis or a basal cell carcinoma. Yep. Yeah, the pagetoid stuff, right? That's the upward, the suprabasal migration of the atypical melanocytes through those layers of the epidermis away from the normal position of the basal layer. So normally the melanocytes, they live only in that basal layer of the epidermis. They live basally. But in a melanoma, the malignant melanocytes, they proliferate and they move upward, and then they appear scattered atypical cells among the keratinocytes through the epidermis. So that's typically on like an H&E stain. They'll be large, hyperchromatic nuclei with abundant cytoplasm, and they're going to be seen above the basal layer. But the superficial spreading is going to be most common. Yeah, so Fatty says migration melanosomes, okay, the depth of invasion is something. Yeah, probably thinking of the Breslow thickness, the Breslow depth. Is that what you're talking about? The Breslow? Because that's the depth of the invasion of melanosomes. Basically, you have the millimeters at the top of the granular layer of the epidermis and then the deepest point of the tumor involvement. And yeah, okay. Irregular borders, varied pigmentation, pagetoid spread, upward migration, melanosomes. Nice. Cool beans on this one. Let's move on. But first, the bottom line, histological presence of melanosomes is key to differentiating melanoma from non-melanocytic skin lesions. Melanosomes. Okay, here's our next question. We have a 65-year-old man, history of chronic hepatitis C. He has been on a viral regimen that includes drug recently approved for managing his condition. Drug is known to interfere with the cellular protein degradation and was originally developed as cancer therapy. Increased fatigue, though, and look at that, we have reduced CD8 positive T cell activity. Which process is most likely inhibited in this viral treatment? Okay, so we have chronic hepatitis C, and we're treating this with direct-acting antivirals, and then we're giving them a drug, which is originally a cancer therapy, and this interferes with the cellular protein degradation, and it causes low CD8 positive activity. So I think the big part here is protein degradation, and so, yeah, C is good. The processing and presentation of the viral peptides. So this is a proteasome inhibitor. This is how you degrade endogenous proteins into peptide fragments that are loaded onto MHC class 1 molecules. This process is vital for CD8 positive cytotoxic T cell activation. Inhibiting proteasome disrupts the antigen presentation pathway. So the clue is the drug was originally developed as a cancer therapy, a protease inhibitor used in multiple myeloma, bortezomib. Now we're repurposing it. Natural killers, part of the innate, detects those that lack the MHC1. CD4 T co-stimulation, that's the B7 CD28. Phagocytosis of ionized particles would be neutrophil phagocytosis, antibody-mediated, and the release of cytokines, interferon gamma by the Th1 cells. So this is proteasome inhibition that blocks the degradation of viral proteins, and it inhibits the MHC class 1 presentation, and it weakens the cytotoxic CD8 positive T cell response. Okay, there are some buzzwords here. Here are the associations. Proteasome inhibition. So the immune system relies on protein degradation to recognize viral infections. You degrade systolic proteins into peptides, and then you wear them. It's like a little spear. You put a head on the sphere, and you're like, you shall not pass. All right. Yep, it's the proteasome, chopping up those viral proteins into little peptides. So here is the bottom line. Antiviral treatment likely inhibits processing and presentation of viral peptides on MHC class 1 molecules, impairing CD8 positive T cell activity. All right, in our next question, we have a 16-year-old patient presenting to the clinic with concerns about not having started menstruation. And look at that, it's actually an XY karyotype. So lab tests show elevated levels of luteinizing hormone and testosterone, and there's an absence of a uterus. XY, what's happening is there's just androgen insensitivity. Primary amenorrhea, normal breast development, absent uterus, karyotype, complete androgen insensitivity syndrome. Normal testes, high testosterone, defective androgen prevents masculinization. And so you have external female genitalia and absence of internal stuff because of the Mullerian inhibiting substance that is found in the XY. Mullerian agenesis is going to be an XX. Turner syndrome would have streak ovaries and no breast development. Ambiguous genitalia, there you'd have high 17. Klinefelter's is XXY. So one thing that's worth distinguishing though is complete androgen insensitivity and then congenital adrenal hyperplasia. So in complete androgen insensitivity, it's almost always going to be, and then in congenital adrenal hyperplasia, it's almost always going to be XX. And here, this is always going to be like your 21 hydroxylase. And then this just does not have a good androgen receptor. And so here the testes are making testosterone. And here you have low cortisol, which then causes increased, and that causes increased androgens. This one has female genitalia and this one has ambiguous genitalia. But here you have the uterus and the ovaries are present. And here they are not. And due to this 21, here the 17 is elevated. All right, that's how to distinguish them. Bottom line, 46XY genotype, absent uterus, normal breast development indicates complete androgen insensitivity. All right, so here we have joint pain, stiffness, gradually worsened. Her ring doesn't fit, so this is acromegaly. And this causes insulin resistance with decreased muscle glucose uptake and also increased glucose uptake and increased hepatic gluconeogenesis. Here we have a 42-year-old woman, difficulty speaking, weakness in her right arm and leg, migraines, hypertension, she's taking lisinopril, blood pressure is 150, facial droop, 2 to 5 motor strength, E of the head, shows no acute hemorrhaging. Nailed it. Fatty Liver King nailed it. Let me put your chat down here. So you got the diagnosis right. What is the correct answer now? So basically the clinical picture while you're typing that in the chat, it's a sudden onset dysarthria and also acute stroke. E is what we're thinking. Nice. Right to left show through the patent foramen ovale every single time, 100%. So basically 42, this is young for atherosclerotic stroke. No atrial fibrillation, no murmur, no endocarditis, right? So the embolic source has to be considered. Embolism. Also this transesophageal echocardiography. This is actually really good for finding the cardioembolic sources of a stroke, like the left atrial thrombus, valvular vegetations like endocarditis and septal defects. And the septal defects is what's going to cause the paradoxical emboli. And so you have a patent foramen ovale, and that allows the blood to pass from the right to the left side of the heart. And then especially when the right atrial pressure transiently exceeds the left during a Valsalva or coughing. And so normally the venous clots go to the lungs, and that causes like a pulmonary embolism. But with a PF, the venous thrombus actually bypasses the pulmonary circulation entirely, and then it goes whoop straight up to the brain. Not fun. Yep. Atrial septal defect is fixed. Left ventricular aneurysm, mitral valve, opening snap. You got it. Migraine with aura, higher prevalence, Valsalva maneuver. PFO persistence, increased right atrial pressure, travels up. You had the bubble study. There's all the high yield information for this one. Bottom line, transesophageal echocardiography can reveal right to left shunt in a patient who has a foramen ovale and genic stroke patients. Next question. A 54-year-old man presents at the clinic with progressive loss of vision on the right eye and headaches that have worsened over the past 3 months. He has papilledema and decreased visual acuity of the right eye. The brain shows extraaxial dural-based mass that is homogeneously enhanced with a broad-based dural attachment. Surgical resection is performed Histoexamination reveals a tumor composed of spindle-shaped, arranged in seminoma bodies. Yes. Good. Nailed it. D, right again. Meningothelial cell. So the gradual vision loss, the headache, and the slow-growing mass, all this stuff is going to be increasing the intracranial pressure. And papilledema also increases this and is due to this increased intracranial pressure as well. And the MRI has an extraaxial dural-based, homogeneously enhancing broad-based attachment. That means it's a meningioma. And then, of course, the spindle cells and whorls and seminoma bodies. That's classic pathognomonic for meningioma. And so these arise from the arachnoid, the meningothelial cells in the arachnoid villi. So that's part of the meninges. And they are not glial or neural cells. They come from the meninges. They're mesodermally derived coverings of the brain. So the Schwann cells, the schwannomas, are usually the cerebellopontine angle. Vestibular schwannomas, for instance, they're always S100 positive. Look at these other answer choices. Not Dura-based. Oligodendrocyte would have that fried egg look. Intrinsic brain tumor. Croglial cell does not form tumors. So all this stuff, extraaxial, dural tail, all this stuff is classic meningioma. Whorls and seminoma bodies. Vision changes mean, and all this stuff, the papilledema, the vision changes. This means there's increased intracranial pressure due to mass effect. And meningiomas are the most common brain tumors in adults. Give this a second to load. Yeah. 62-year-old woman goes to the hospital with severe headache, altered mental status, found at home by her neighbor, who noted she has been unwell. Look at that, 240 over 130. Which finding is most likely going to be seen? And there are a lot of answer choices here. The key fact is malignant hypertension. Yes, indeed. Malignant hypertension. So you're going to have hyperplastic arteriosclerosis, onion skinning, E, onion skinning. So that chronic malignant hypertension, we have chronic pressure on the small arteries. We know that it's malignant hypertension and they're dead within days. So that means it's an acute vascular catastrophe, not like a slow-moving disease. And then there's an autopsy question. Yeah, it should be acute. You're right. You are right. So this is going to be atherosclerosis, not glomerular or like papillary stuff. Onion skinning is the hyperplastic arteriosclerosis. That's the concentric smooth muscle in the basement membrane. Amyloidosis would be the deposition of the misfolded proteins. And it's not a papillary necrosis. It's like a subacute kind of ischemic necrosis thing. Thrombotic microangiopathy, schistocytes, MAHA. Hyperplastic atherosclerosis is laminated onion skin appearance. And hyaline would be in benign hypertension. Malignant is hyperplastic atherosclerosis. So bottom line, onion skin is severe hypertension-related stuff in the renal small arteries. And then diabetes is hyaline as well, and chronic hypertension, per the fatty liver king. Yeah, that's well put. So the hyaline, atherosclerosis, that's going to be chronic, slow developing, small vessels, and long-standing, and also diabetes. Because in diabetes, you have the non-enzymatic glycosylation of the vascular basement membrane, and that makes them leaky. The leakiness because of the non-enzyme glycosylation, and then the plasma proteins start to leak. And so you get the same hyaline thickening even without the hypertension. And so the arterioles show homogeneous pink glossy stuff, the hyaline thickening. All right, new question. This one we could see the answer here, but it's constriction of the efferents. In response to renal perfusion, like if you're clamping the renal artery, then the kidney is going to be activating the RAS system, so angiotensin II is produced, and that constricts the efferent arterioles. Decrease, that's vasodilation, which would decrease the GFR. We're always aiming for GFR of around 125. So if perfusion drops, RAS is activated, and then we're squeezing that arterial constriction. SEDS causes that afferent arterial constriction by decreasing prostaglandins. These guys block angiotensin II, decreasing GFR. Dilation of the afferent, constriction of the efferent, increased secretion of renin. Nice. Triple whammy is NSAIDs, ACE inhibitors, and diuretics. Nailing it. Stenosis causes increased constriction. Diabetes causes increased GFR due to the afferent arteriodilation. So decreased perfusion, JG cells release the renin, angiotensin II constricts, and you have maintaining or increasing the pressure, preserving the GR. So yeah, there definitely are drugs that interfere with the RAS mechanisms and the GFR stuff. So NSAIDs block the prostaglandin, and that causes afferent arterial constriction, so there's less renal blood flow in an NSAID. ACE inhibitors, you have decreased glomerular pressure because there's efferent arterial dilation for the ACE inhibition, and then, or rather lack of constriction, I should say. Diuretics would have decreased renal perfusion and it activates the RAS further. So basically, the triple whammy that you're talking about removes the kidney's autoregulatory supports, and it's just low perfusion because of the diuretic, no afferent dilation because of the NSAID, and no constriction from the ACE inhibitors. And think like heart failure patient has a headache and then decides to take Voltaren. Yep, that'll knock out the prostaglandin-mediated afferent dilation, and it causes the renal perfusion to crash. Because heart failure means the kidneys are relying on the prostaglandins. NSAIDs block the prostaglandins, and then it causes afferent constriction. And then the ACE inhibitors, efferent dilation, and then diuretics volume depletion. Boom, 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 shika-booms. So Here we get that rabbit renal artery is clamped, and so we have a drop of the GFR, but you'd expect a drop of the GFR, but it just stays steady because of the compensation effects. Okay, couple more questions. I feel like this one we can do without, because we covered this on stream. Factitious gain. Gain is not seen for malingering. You want the external reward, and you know that because you want McDonald's. And Munchausen by proxy is when the mom sabotages her child. You want to be a sick patient for Munchausen, very pathological. And malingering is not like a psychiatric condition. Malingering is literally just a behavior pattern. Whereas diseases like Lyme disease would cause erythema migrans and AML would cause weird blood counts. Fatty Liver King says, just me decompensated heart failure, we probably prescribed him an ACE and a diuretic. Yeah, that'd be a standard management for decompensated heart failure, especially if they have like left-sided heart failure. They have that low cardiac output. And so the kidneys are like, oh my gosh, low perfusion, let's activate the RAS. And then they get angiotensin 2 and aldosterone and all that stuff. And then you get worsening heart failure over time. So sad because, you're trying to reduce the volume overload and block that maladaptive RAS stuff. And so the loop diuretics to decrease the peripheral congestion, the ACE inhibitors to stop the remodeling. Got to prove those symptoms, improve mortality as well with the ACE inhibitors. Now, this one I just want to talk about as well. Potter sequence is deformation. And I made a video on this and published it today. Basically, Potter sequence is after neurodevelopment. Disruption would be like amniotic bands. And malformation is developmental error. And multifactorial would be like cleft palate stuff. And teratogenic would be like an ACE inhibitor. Potter sequence is a triad. Yeah, it's like a sequence, right? It's all from severe oligohydramnios, clubfoot, urethral valves, lung hypoplasia, also oligohydramnios. Yeah. It all stems from the oligohydramnios. The question that this is from is asking about, we have a newborn with oligohydramnios. They have dysplastic fetal kidneys. And so the answer is deformation because it's Potter sequence. So Potter sequence, yep, all in utero. So step one of Potter sequence is you have a renal abnormality, right? So you have bilateral renal agenesis and polycystic kidneys and then posterior urethral valves, and that decreases the fetal urine. You have decreased fetal urine, that's like amniotic fluid is decreased, so the fetus does not have the cushioning. And then the fetal compression happens. So you get deformation. That's when the flattened face occurs. That's when the deformation occurs. You also get pulmonary hypoplasia. Well, it still is classified as deformation. Deformation is any disruption in organ morphogenesis after the embryonic period. So technically, Potter sequence classifies as a deformation because that's why the flattened facies occur. You have the ears, they're just going to be low set or compressed tone. And you have the limbs, they're just deformed, right? And it's because of that compression that they are deformed. Like the club foot, for instance, that's extrinsic mechanical distortion of the normal tissue. The tissue is totally normal. It's just that it's a club foot now from the uterine constraint, right? The uterus is like, even though it's totally normal, like the tissue is normal, it just gets deformed. And so technically it classifies as a deformation. But you're right, it is a sequence. And it all starts with oligohydramnios because of the renal failure. Last question. Here we go. Researcher studying the impact of newly discovered genetic mutation. These mice exhibit a defect in the rank L, leading to impaired osteoclast function. Which of the following is most likely? Okay, so impaired osteoclast. Not overactive, so it's not osteoporosis. FGFR3 mutation for achondroplasia, super important to remember. Osteomalacia is vitamin D, osteoporosis, trabecular bone loss, and fibrous dysplasia would have the GNAS mutation, where the fibroosseous tissue replaces the bone. Not a problem here. Bone remodeling, rank L, crucial for osteoclast differentiation, and it's a receptor activator of nuclear factor kappa B ligand. Yep, so your bones are just super dense. And what happens here is the bones are just like so dense, in fact, that they can crush your own nerves and crowd out the bone marrow. That's osteopetrosis. Normally you chew up that old bone and make space for new stuff, but nope, this time you're just going to make it super brittle and it'll just crowd out all of your nerves. Very pathogenic. Cool beans. Here's the bottom line. You got it right. Impaired osteoclast function from rank L leads to osteopetrosis due to excessive bone density. Nice stuff. That's the good stuff. Okay, time to take a break. Take a break. I am on my way. There's a little surprise before supper. Cannot wait. You know what time it is. It's time to earn a tomato. It's time to get a tomato because you're walking around Hogwarts with your tomato timer intact. Yes, indeed, it is break time, but I'm making it tomato time so we can all get tomatoes. Fatty Liver King's going to have 2 tomatoes because they've been with us the longest. Must feel nice. I aspire to have 2 tomatoes at some point in my life. Fun fact, you cannot eat tomatoes in chronic kidney disease. Yeah, I guess you got to avoid any high potassium food in chronic kidney disease. Bananas, tomatoes, potatoes, avocados. Wow. 300 milligrams of potassium in every single tomato. Oh my tomato. Holy tomato. Tomato is yet holy tomato. All right, only 20 questions left before we take a longer break, but I think I might just keep going and do all 200 questions. Okay, here we go. A 40-year-old man presents to the emergency department with a severe abdominal pain, and he has a history of alcohol abuse. He's got tortuous vessels. Okay, so this is portal hypertension in some capacity. Now, is it Budd-Chiari syndrome, or is this portal hypertension? Yeah, that's fair fatty liver. All right, so let's break these down one by one. Angiosarcoma, that would be chloride exposure, so that's very rare, and it wouldn't cause these esophageal varices or acute bleeding. Budd-Chiari is going to be hepatic vein thrombosis and ascites without JVD. So this would cause hepatic congestion and hepatomegaly, but it wouldn't just be isolated esophageal varices. Mallory obese, that one's the hematemesis after retching. Nice, yeah, I'd love that. Portal caver, yeah, good. This is E. Portocaval shunting would be the TIPS procedure for portal hypertension. It's a treatment, though, not a cause. And so the answer is portal hypertension. All right, there are the explanations right here. Cirrhosis is a common cause, rupturing. Esophageal varices, rectal hemorrhoids, hematemesis and cirrhosis. And where can it occur without? We talked about this last time. Schistosomiasis was when the parasite stops it. Non-alcoholic would be seen in obesity and diabetes insipidus. Autoimmune, primary biliary and primary sclerosing. And then right heart failure causing the nutmeg liver. So here's the bottom line. Portal hypertension due to chronic alcohol use disorder causes esophageal varices and presents with hematemesis. Now this question, 65-year-old, persistent cough, occasional chest pain. Which environmental factor? He's lost 10 pounds. He's got this pleural mass encasing in the left lung. Okay, so dyspnea, weight loss, pleural effusion, pleural-based mass, spindle-shaped stuff. Yeah, I told you. Yep, occupational asbestos, indeed. Mode exposure would be hypersensitivity. Consumption of alcohol would cause cirrhosis, or Wernicke is not the cancer of the pleura. So this is a pleural-based process, not lung parenchymal process. Beta blockers, cardiovascular modulation, and traveling hypoxic regions would not be pleural pathology. So this is mesothelioma, pleural-based mass, encasing lung, spindle cells, asbestos exposure. So insulators, shipyard workers, pipe fillers, pipe fitters. This isn't actually linked with smoking, unlike bronchiogenic carcinoma, which is. Calretinin and cytokeratin would lead to mesothelioma markers in the pharyngeus bodies. The iron-coated asbestos is seen in the lung biopsies. Here are the associations. All right, there's the bottom line right here. Occupational asbestos exposure is the key risk factor for pleural mesothelioma in patients with pleural mass and effusions. This is a good question. 60-year-old, history of chronic cough and smoking, diminished deep tendon reflexes in the lower extremities, suspicious mass in the right lung. What's the mechanism for these symptoms that he experiences? Lambert-Eaton syndrome, nice, yep, presynaptic. So it's a perineoplastic process that is tied to the small cell lung cancer. So the difficulty rising from the chair, climbing stairs, this is proximal muscle weakness, and the reflexes are slow, and they improve with repeated stimulation, so it's Lambert-Eaton syndrome. Everything else, you can look at these answers and pause if you want to see them. Pre versus post, myasthenia gravis, reflex normal worsens with activity. Yep, 60% of Lambert-Eaton cases are linked with small cell lung cancer. You got to treat the cancer. Proximal muscle weakness, diminished reflex with an improvement on stimulation suggests Lambert-Eaton syndrome due to presynaptic calcium channel autoantibodies. All right, finally, my notes don't give this one away fully, maybe a little bit. Here's the next question. 70-year-old woman lives alone with her grandson. Lives alone, but her grandson visits her daily. Well-groomed, 21 out of 30, mild cognitive impairment. VDRL and FTA-ABS are both positive. What's the best next step? Okay, this is an interesting ethics question. Basically, there are ranges. If it's like really severe, then she probably can't handle the conversation. But insofar as you can, right, you're not going to jump to just treatment and tests, right, that are invasive. You're going to talk to the patient. Always broach, yep, you got it. Discuss the diagnosis and evaluate. Evaluate her ability to understand and consent. Especially if it's like in the 21 to 24 range, because they might have cognitive capacity. 10 to 20, they don't in the mini exam. So discuss the diagnosis. Always discuss, always open conversations. Okay, so here there is a 27-year-old pregnant woman, 18 weeks gestation, complaints of intermittent sharp pain with the right side of her lower abdomen, especially when she changes positions. On examination, there is no uterine tenderness. Cervix is closed. Which of the following is most likely responsible for this? You're right, the answer is bolded. This is round ligament. Yep, round ligament pain in the second trimester. And here I got an image of the round ligament. Goes through the inguinal canal. Broad ligament, uterine support, provides structural support, but is not going to be implicated in pain. Ovarian ligament anchors it medially, does not get stretched with uterine growth, and involves, so it's the round ligament, the anatomy of the uterine ligaments round, courses through the inguinal canal, and inserts into the labia majora, so you have pain there. Broad ligament, double layer, cardinal, supports the cervix, upper vagina. Round ligament uniquely stretches with uterine growth. That's what you have to know about this one. Oh, Fatty Liver said, what are those tests? Not the MMI. Are you talking about the tests from the previous question? The dementia patient? The memory cognitive decline patient? Oh, okay. So those were like the VDR. L in the FTA-ABS tests, that's going to be signs for neurosyphilis or neurosyphilis tests. And those are actually really important because in lupus, you can test positive. Even if you don't have it, you get a false positive test because of the cardiolipin activation. So yeah, she has neurosyphilis because that ABS test like is definitive for a neurosyphilis. But yeah, so here it's just ligament stuff. Having a baby, round ligaments can expand, especially in like that second trimester, and it radiates to the labia majora, and the pain worsens with sudden movement and position changes. Ouch. Would not want to have a baby. Yep, stabbing groin pain in the second trimester. Yes, indeed, fatty liver. Yes, indeed. That's why you got to do the ABS test. Okay, round ligament pain common, presenting as sharp positional abdominal pain without uterine tenderness. There it is. All right. Here, a 45-year-old scientist is reviewing the physiological processes in the human body, and he studies how the pulmonary vein has relatively high partial pressure of carbon dioxide compared to most. What's the reason behind the higher PCO2 in the pulmonary vein? So pulmonary tissue has like the high blood flow relative to the metabolic demand. This is a good question. Because veins are deoxygenated, can you give me a little bit more than that? But yep, that's pretty much the long short of it, right? That's why there's CO2 and oxygen-rich blood. Because the pulmonary veins carry oxygenated blood, but they can still have some CO2. And so CO2 in the pulmonary vein, what does that mean? So here in this condition, there's some slightly elevated PCO2 in the pulmonary vein because of physiological shunting. So there's some venous blood from the lung tissue itself that bypasses the alveoli and it drains directly into the pulmonary veins. And so the non-oxygenated CO2 rich blood mixes with and erases the PCO2 in the pulmonary venous structure. And so that's like a normal anatomical shunt. It's not pathologic, and it contributes to that small big A little a gradient, the difference between the alveolar and the arterial O2 that's observed in healthy individuals. I thought pulmonary veins carry blood to the lungs. Am I reversed? So pulmonary veins bring oxygenated blood from the lungs to the left atrium. They just happen to carry arterial blood, even though they're called veins. Yeah, it's a very common mix-up. Yeah, very, very, very common. The way to think about vein is not like oxygenated or deoxygenated. No. Toward heart. Just think of it that way. Then it's really easy. Artery away, vein away from the lungs to the heart and the left atrium. And so they carry oxygenated blood that they just picked up in the O2. So the answer here is the pulmonary circulation has high blood flow per unit of tissue weight, reducing the PCO2 gradient. So the answer is B, high blood flow. So this gradient is reduced. Oh, it happens, man. High lung metabolism. All right, so this is a question about the physiology. Lungs have a high blood flow, but low oxygen consumption. CO2 must diffuse from blood to alveoli. If blood flow is high, less time is available for full equilibration, especially in areas of hyperfusion. And so some CO2 remains in the blood even after gas exchange. Tricky. So there's high pulmonary blood flow, so the blood is moving quickly. There's low tissue metabolic rate, so you have minimal CO2 production, reduced gradient, less CO2 is offloading, so higher than expected CO2 in pulmonary vein is due to the incomplete equilibrium. So the blood is definitely going to get cleaned by the lungs, right? CO2 out, O2 in. But some of the dirty blood, right, from the lungs, called the bronchial blood, is the term for this blood. It skips the cleaning and it drains straight into the pulmonary vein. And it goes to the heart. So now the pulmonary vein has a little bit of extra CO2-rich blood in the mix. And that's what keeps the CO2 a bit higher than expected, even though most of the blood is going to be oxygenated. So a little bit of CO2 going on there. It's not perfectly clean like we'd like it to be. It's not a clean machine. Penny Lane is in my... High blood flow in pulmonary circulation reduces PCO2 gradient, resulting in elevated carbon dioxide levels in the pulmonary vein. Nice. For this one, I just want to go over the timelines. Brief psychotic disorder, less than 1 month. Schizophreniform, 1 to 6. Schizophrenia greater than 6. Delusional greater than 1 month. Schizoaffective mood and psychosis. That's that question. Next one. This is the question that with those labs that we were talking about earlier. This is a good question. Lupus, antiphospholipid antibody, RPR test, false positives, Mallory rash, arthritis, ANA positive antibodies, and anti-DS DNA and anti-Smith are specific. Yep. And what you said, yes, that's true, fatty liver king. Anticardiolipin is one of the 3 antibodies there. So there's anticardiolipin, lupus anticoagulant, and anti-beta-2 glycoprotein 1. And there is a false positive rate with these VDRL RPR tests. Also, you have hypercoagulability and you have miscarriages. Anti-Smith is the most specific for lupus. Specific. So the ANA is most sensitive, but it's not specific. And the anti-DS DNA correlates with the nephritis, like you said. And anti-Smith is most specific for SLE, though it has low sensitivity. and Anticar is the disease activity. Because if they have the positive ANA and also the symptoms, then you should check the anti-dsDNA and also the anti-Smith to confirm. And if there's renal involvement, anti-dsDNA is going to be the best correlate for the severity and the damage. Like you said, it's the degree of the disease. Now, positive ANA in lupus can lead to false positive tests due to the cross-reactivity. Yep, so it's the reagents, the plasma reagent. So it's the antibody that your body produces, but it's not against the microbe. It's the autoantibody made against the lipid-like material that's released from your own damaged cells. Trying to remember if it's antihistone. Yeah, that's fair. That is totally fair. Antihistone is definitely nonspecific. It's associated with drug-induced lupus, would be antihistones, but it doesn't track the activity and it's nonspecific. Anti-dsDNA, super specific for lupus and lupus nephritis, class 3 or 4. Yep. Antihistone would make you think of drugs. That's seen in 95% of all of the drug-induced lupus cases, like hydralazine, procainamide, isoniazid, and methyldopa. Yep. So the antibody that tracks the disease activity, anti-dsDNA. Oh yeah, that's totally understandable. The whole thing about, autoantibodies being lumped together. Anti-dsDNA is going to be lupus every single time. Rheumatoid arthritis has also some antibodies you have to know, like rheumatoid factor. That's non-specific though. Anti-CCP. It's the anticyclic citranucleated peptide that is in rheumatoid arthritis. And that's most specific for rheumatoid arthritis is the citranucleated peptide. So dsDNA, maybe for that one, think of a mnemonic, right? DS, you could think, damn, SLE, right? DS, because it's lupus. I don't know. Whatever it is, whatever helps. Anti-Smith is super specific, right? Low sensitivity, rules in the disease. And so too is DNA, anti-dsDNA. Rheumatoid factor, anti-CCP, those are the rheumatoid ones. It's dead horse for a while. Let's move on. Okay. Alcohol, America's favorite toxin. I was singing Midnight Train to Georgia. I turned the mic off because I didn't want to interrupt you guys, but I wanted to sing Midnight Train of Georgia. He's a-leaving, oh, on that midnight train to Georgia. Anti-dsDNA, that's going to be in lupus established. We got that, right? Anti-CCP is going to be rheumatoid arthritis. And you're saying there's one specifically. Yeah, maybe Saswan can help you out with that specifically. But the way that I would think about it is anti-CCP is rheumatoid arthritis, and the dsDNA is lupus. Yeah, that's all I could say about that one. All right, on to our next pregunta. 35-year-old woman presents to the emergency department with confusion, vomiting, and abdominal pain. She has a history of alcohol use disorder and reports that she has been binge drinking. In an attempt to relieve the persistent tension headache, she consumed several doses of acetaminophen, or as Donald Trump says, acetaminophen. Her liver tests show elevated AST and it's alcoholic-induced. So chronic alcohol, this upregulates the 2E1 as part of the cytochrome P450 system. So it converts acetaminophen into the hepatotoxic metabolite, NAPQ. Oop, there it is, right? And that damages us. And so the answer is D. Increased metabolites. Oh, you said C? Let's go over this one real quick. Because I know that that's like a really good intuition is to think of a NAP, like glutathione stuff, because like Tylenol, I guess, if you think of the glutathiones. But the reason why alcohol increases the risk is the CYP2E1 induction. Glutathione depletion, that happens from the high NAPQ, and it makes the toxicity worse. It's true, but that's not the mechanism of alcohol. Inhibition, glutathione store is important for toxicity. Alcohol does not deplete the glutathione. It increases the NAPQI. The NAPQI does. The NAPQI does. Kind of a pedantic point there, but it's relevant. All right. So bottom line, alcohol induces cytochrome P450 enzymes, increasing toxic acetaminophen metabolite production and risk of hepatotoxicity. That's how it works. That's the way the world works. That's the way the world works. Are you guys having fun already? All right, question 40. Non-edemerismus versus edematous kwashiorkor. Kwashiorkor has the lower protein and the big old belly protein deficiency. Rickets vitamin D deficiency, scurvy vitamin C. Pellagra has the Ds, B3, all super high yield. Crazy high yield. Here we have a 2-year-old girl brought to the pediatrician due to concerns about her growth. Very thin, visible ribs, prominent bones. Her mother reports that she eats very little due to financial constraints. Child is alert, interactive. Whoa, 10%, 50% height, no edema, lab tests exclude anemia and liver functions. What is the diagnosis? Which one is it? B or D? Okay, so global malnutrition. Think of protein versus calorie deficiencies. So marasmus has the total calorie deficiency, not the edema. Oh, good. Okay, this is going to be a good learning point. Kwashiorkor has the protein deficiency, and that one has the edema in the skin and the hair changes, right? And so they've got global malnutrition. They have low weight and visible wasting, but no edema. And so there's preserved alertedness. Hey, Saswan. Thanks. Thank you so much. Thanks for interacting with the chat there, Saswan. That's helpful. And so they've got global malnutrition, low weight, visible wasting, no edema, preserved alertness. That's classic marasmus. Calorie deficiency, the body is burning fat and muscle for energy, and the child is emaciated but mentally alert. There's no edema, there's no skin lesions, there's no fatty liver. Trichoir is when you have edema, apathy, dermatitis, fatty liver due to protein deficiency, and that's because you don't have adequate calories but proteins specifically. So you have edema there, and dermatitis and apathy, and that's not present in this patient. Cool. There's a total calorie deficiency, so it's B. Does not have the signs of celiac, and this is Kwashiorkor as a protein deficiency only. And the alert versus the apathy, right? So marasmus, they're going to be interactive. Kwashiorkor, they're going to be withdrawn. So they just have inadequate total energy intake, and so the body is burning the fat and then the muscle, and there's no albumin loss, there's no edema, there's no wasting. There's a wasting and stunting if it's chronic, but she's still mentally active is the thing. And so you might be asking, okay, well, why does Kwashiorkor feel like it's worse if it's just protein loss? Well, that's because protein does way more than calories when it comes to maintaining your internal balance, right? So albumin is a plasma protein which maintains the oncotic pressure of the blood. Maybe we'll say this in our explanation here. And so without albumin, the fluid is leaking in the vessels and you get edema. And so Kwashiorkor, despite enough calories, the lack of protein causes pitting edema, ascites, fatty liver, skin and hair changes, and also apathy and developmental delay, right? So a lot of problems just from that protein gradient difference. So protein's needed for building enzymes, immune defense, transporting stuff, maintaining, importantly, oncotic pressure. And so without it, you are bloated, you're immunocompromised, you are fatty livered, and you are shutting down, right? And so that is Kwashiorkor, whereas this is total deficiency marasmus. Does that make sense? There we go. There's everything you need to know. Here's the bottom line. Marasmus. Severe malnutrition, weight loss, invisible bones in children with inadequate calorie intake. Very sad. Oh, look at that cute little kid. Okay, for these next ones, I'm going to do a little bit of a speed run. Tibial tubercle on a young athlete, Osgood-Slaughters, right? This one I'll actually make a question about because I think this is important. You better hope they give you Osgood-Slaughters. That's just easy points. Them easy bookins. Them easy bookins. I don't even know what bookins means. I guess I just made it up. All right. Here we go. 28-year-old woman visits dermatology clinic due to chronic skin lesions that worsen with sun exposure. What is this? What's the condition? Oh, it's bolded. Uroporphyrinogen decarboxylase. Uroporphyrinogen decarboxylase. So PCT, defective heme, easy way to remember, sounds like urine. So a huge proportion of patients test positive for Hep C. In fact, they'll literally, in most of these questions, they'll be like, hey, they have a history of Hep C, IV drug use, transfusion factors, and it's worsening the liver function. And yes, you're totally right about that. 100%. So liver dysfunction, iron overload, oxidative stress, and sunlight causes the skin lesions and the scarring, right? So typically the mechanism there is your liver bad, iron everywhere, right? Oxidative stress, and that triggers the stuff and the blistering and the scarring and all that stuff. Knowing the entire pathway is crazy. I did think it was interesting when I was reviewing this because it starts with glycine and cysteine-CoA. I thought that was a really cool idea of, hey, where does your heme come from? It comes from glycine and cysteine-CoA. And then you shove it together with your B6 and allosynthetase to make ALA. And then you do ALA dehydratase to get your porpho, and then your porphodeaminase to get to hydroxy. And then you turn into uro, and then you do uroporphyrinogen carboxylase, your PCT. And AIP, importantly, is dealing with the ferrobilinogen deaminase. And that links you to coporphyrinogen 3, and then ferrochelatase to heme. They love it. That reminds me of this quote from Smiling Friends. You love it. Oh man, so funny. Glucokinase, insulin secretion. Marfanoid habitus is cystathionine beta synthase. They're really given just the kitchen sink. N-acetyl glutamate synthase, that's a deficiency causing lethargy and dermatologic symptoms, ornithine transcarbamylase, orotic aciduria. Heme synthesis pathway, photosensitivity, blisters, because it's in the urine and it's gross, just like fatty liver king said. All right, here's the bottom line. Elevated urinary porphyrins and sun-sensitive skin lesions indicate pyrinogen decarboxylase deficiency. I try. I'm curious, how did you come up with the name Fatty Liver King? I study medicine instead of shilling liver supplements and denying steroid use. Yep, that's a good idea. But it's also just a progression. Just wait 10 years. I'm just kidding. 62-year-old man with a history of advanced prostate cancer. Follow-up, new treatment. Whoa, look at that. Decreased serum of both. What is this? What's the answer? And they're giving it continuously. That's the hint. Yeah, lupulide. Woo! We got it. Nice. Good job. Lupulide. All right. How about this one? A. That's an aromatase inhibitor that's used in and also breast cancer. It blocks the estrogen and not testosterone. Finasteride. That is a 5-alpha reductase inhibitor. Decreases DHT. Using BPH, male pattern baldness. Although I would not use this for male pattern baldness because some studies are coming out showing that it causes some extra problems. It's like shooting sparrows out of the sky with a cannonball. I just wouldn't prescribe it. Fluid androgen receptor antagonist blocks the receptor, but LH rises from the loss of feedback. So it's an androgen receptor antagonist. And then tamoxifen, that is a selective estrogen receptor modulator, and also in breast cancer, not prostate. Leuprolide agonist, given continuously, causes the problems. And then Fatty Liver says, what is the thing with tamoxifen and the bone? So tamoxifen is a selective estrogen receptor modulator, and that means in some tissues, it's an agonist for estrogen, where it's supposed to be for the bone. And so it inhibits the osteoclast, and then when tamoxifen mimics estrogen in the bone, it helps the bone strength. And so it's good for the bone, but there's also a risk for endometrial cancer. Yep, and then they also like to test this with the other one. And raloxifene, that has a bone agonist action as well, and there's a decreased risk of endometrial cancer there. All right, so tamoxifen, think tamoxifen for like toxic. They're both good for bones, but raloxifene protects the uterus as well, right? So tamoxifen is agonist and decreases osteoporosis risk. Why don't we give it menopausal? Okay. Well, it's because in premenopausal women, estrogen levels are already high. That's why. It's a partial antagonism in some tissues, but if you gave it, it would disrupt the natural hormone balance, right? There are a lot of better options like oral contraceptives or weight-bearing exercise. I keep telling my mom, I'm like, just do more weight-bearing exercises or calcium, vitamin D, right? And also like there's risk of endometrial cancer, not cervical cancer, which is important. The difference there. Estrogen, not the cervix. Oh man, I gotta pop. Because cervical cancer is like HPV related, whereas endometrial cancer is not going to be HPV related. It's like stimulates the lining, so just different mechanism there. Because cervical cancer, the cervix is at the opening of the uterus, and for the risk factors of cervical would be like HPV 16 and 18. What was the question? No, I mean which drug we give for breast cancer in young women. So tamoxifen is probably what we give for sure. Because the strategy is going to be you block the estrogen receptor directly with tamoxifen. You give them tamoxifen and also like an aromatase inhibitor, and then ovarian suppression if they're premenopausal. So you could do like leuprolide, and then postmenopausal, you give them like aromatase inhibitors. So tamoxifen works in both pre and postmenopausal, and aromatase inhibitors only work if estrogen is not being made by the ovaries. So basically, a young woman got breast cancer, then you start with tamoxifen. And in higher risk cases, you can do some aromatase inhibition and ovarian suppression as well. Let's see what else they talk about here. And we got off on some tangents. You said you had a CBL where they said something like we don't give tamoxifen to young or old. Yes, we absolutely give tamoxifen to premenopausal women. It's actually first line if you're using ovarian suppression. Tangents are how you learn. Yeah, for sure. Yep. And then a good follow-up for this one, another tangent, I guess, is why not aromatase inhibitors alone in young women? Well, that's because the ovaries are still making estrogen, right? Because aromatase inhibitors are going to block the peripheral conversion for the tissues, but don't stop the ovarian estrogen unless you suppress the whole HPG axis with a GnRH agonist like leuprolide in this question. And so in your CBL, what you probably heard in the CBL is they're like, we don't give tamoxifen to postmenopausal women when these are available. And that's because the AIs are better for older women. So that's probably what they said. Because we use the AIs in high-risk premenopausal women, but only with ovarian suppression. Does that make sense? So premenopausal, tamoxifen. Postmenopausal, aromatase inhibitors, AIs. Let's see here. Anything else in this question? The bottom line, leuprolide effectively lowers LH and testosterone, indicating successful androgen deprivation therapy in advanced prostate cancer. Very nice. Okay, the next question I think we can just talk about. So here there's a patient, they've got like some constipation problems, they're bloating, got some cramping and defecating, kind of weird stuff happening. And also sleep, they're agitated generally. This is irritable bowel syndrome. There's no structural differences in this. Next question. Okay, this one is actually kind of worth diving into the weeds on because it's frustrating. And I want to like nail this one down. Let's get down to business to defeat the business. Two bacteria in the same place. Transformation. Sounds like we're doing like a trailer on bacteria. This is the story of two bacteria. All right, a team of researchers studying E. coli. They observed when bacteria cell are cultured the presence of DNA from a light strain of Salmonella that carries the antibiotic resistance gene. Some E. coli become resistant. What's responsible? Mutation? Horizontal gene transfer? What's going on here? This is a tough little question. C, uptake of the naked DNA. Yes, very nice, very nice. Transformation, right? Bacterial transformation. So just make this really simple. We got E. coli in a dish. Yum, yum, yum. Kind of like we're Chipotle. And Salmonella bursts open, right? It lyses. And DNA from Salmonella is floating around. And then E. coli soaks up the DNA and becomes antibiotic resistant. This is transformation. Nom nom nom, naked DNA. That's transformation. Conjugation is live bacteria share the DNA through a pilus. It's like sex. Transduction is the phage. Moves the DNA between the bacteria. Oh man, the MCAT days. Glad it's being regurgitated. Me too. Fun times. Fun times. I'm also going to make these chats stay longer, so let me make a note of that. So on future live streams, the chats will just stay a little bit longer than average because I feel like I'll miss some of the chats if I don't make them a little longer. It's just part of the development of 3 to 5 year olds. They view it as death is reversible. Punishment for bad behavior? Nope. Yep. This is just Piaget's stages of cognitive development, concrete operational stage. You can see things are tangible, but you struggle with the irreversibility and abstract stuff. Clearly, this boy has a higher understanding of the existential meaning of life. Probably. That's MCAT content as well. 100%. 100% it is. Little did you know this is an MCAT study stream. Death is temporary. Wouldn't that be nice? Okay, what is fibronectin? So fibronectin is involved in the proliferative early stages of wound healing. Well, actually, I guess not proliferative, the migratory phases. So we got a guy, he's got a burn wound on his right forearm. Look at that photo. On examination, we have partial thickness and it's beginning to show signs of initial healing. The patient asks about the process involved. Which of the following options plays a fundamental role? It's fibronectin. And this is a high molecular weight glycoprotein that's essential for the early phases of wound healing. So wound healing needs cells to migrate in the damaged tissues, and this requires a scaffolding. And fibronectin is the best there. It helps the cells attach and move during those early stages of repair. Elastin gives elasticity, not repair migration. Clotting precursor for prothrombin converts to thrombin during coagulation. Integrin binds fibronectin, converts to fibrin in its coagulation cascade. So fibronectin. So you have a tissue injury cascade is activated with fibrinogen and thrombin. Inflammatory cells are recruited. Fibronectin is then deposited in the ECM. Migrating cells attach the integrins of fibronectin and a granulation tissue forms. The new matrix is laid down. So fibronectin is found in the plasma and ECM, mediates cell adhesion, and blocking fibronectin and integrin interaction can impair wound healing. Fatty liver king, is it like a chemokine? I would say no, not necessarily, but they do kind of work together in the wound healing process. So the difference between a chemokine is that's going to be a signaling, like a signaling cytokine. And the fibronectin is a structural ECM, extracellular membrane protein, a glycoprotein. And so this is like physical scaffolding, like you said. Yeah, it's a scaffolding protein. It's not like a signaling messenger, really. It just helps cells attach and crawl to stuff. Whereas like a chemokine would like actually tell the immune cells where they're going to go. But the chemokines, they act like, they're like, hey, fibroblasts, come here. Fibronectin is like, hey, fibroblasts, here's the road that you can take. Yeah, I mean, the fibronectin's like a sidewalk that they walk on. And the chemokines are like, I don't know, like a text message. I don't know. But yep, bottom line, fibronectin is crucial in the initial migration of the healing and partial thickness burn of the wounds. Okay, we only have 3 more questions. Here we go. So let's just talk about case control. That's when you start with the disease outcome status, and then you have to analyze the odds of exposure. But you start with the odd people. This one we will do together, because this is a good one. More MCAT content here. Oh yeah. Okay, so nystagmus, similar eye findings, translocations. What is the mechanism causing this patient's conditions? C. Yes, you got it. Nice. Nailed it. Well done. So aniridia due to disruption of the PAX6 regulatory elements while the coding region remains intact, the balance translocation disrupts the regulatory DNA. Regulatory. Yep. Promoter, enhancer, silencer, repressor. I don't know why I wrote insulator there, but repressor. Basically, they're saying you can inactivate genes by separating them from their regulatory sequences. And the phenotype, aniridia, autosomal dominant inheritance pattern. Basically just being aware that regulatory mechanisms exist. A balanced translocation moves the regulatory enhancer far from the PAX, and so it decreases and you have inadequate eye development because these regulatory genes are far away. So you get aniridia, nystagmus, and visual impairment. No coding mutations. So here, like the gene is totally intact, it's just dysfunctional because the regulatory element is broken. They're moved. Bottom line, disruption near gene locus suggests interruption of regulatory element as the cause of the eye condition. All right, you ready for the last question? The final question? Pretty sure PAX6 is a weed vape. I don't know about that. Final question, let's go. 45-year-old woman, morbid obesity, prescribed drug Y for hypertension. She takes the same 20 milligram dose once daily as her 35-year-old sister who has normal BMI. Plasma drug concentration are measured. And then what's the difference between them? The obese sister has lower plasma concentration. Yes, you got it. It's more widely distributed in her fat, right? Because the volume of distribution, I wrote out it's the amount over the plasma, and there's more of it in the fat, right? And so obesity increases the VD because the adipose tissue mass is greatly expanded, and so lipophilic or the fat-soluble drugs distribute extensively into the fat. That increases their volume of distribution, and so there's less drug that's in the plasma, and there's lower measure of concentration. What about these other choices? Slower absorption, that would delay the peak, not steady-state plasma. I love your comments, Fatty Livered. These are great comments. Yeah, volatile anesthetics, definitely. So like your halothane, isoflurane, sevoflurane, all the fluranes, they're very lipid soluble. And so you have slow induction and recovery in obese patients because the fat uptake is like in a slow release So the fat is like a reservoir for it. So anesthesiologists have to use less soluble agents like desflurane or sevoflurane in obese patients. So it washes in and out of the brain. Yep, you nailed it. Yep. So it'll be like, hey, an obese patient has delayed emergence. The mechanism is redistributed lipophilic drug from the adipose tissue, causing a prolonged anesthetic effect because that fat adipose reservoir. Very strong work, I'd say. Now I just have to copy this all, edit it all, but it's my pleasure, and post it to the YouTubes. Click my button, watch this. Hey, let's go. Look at that. Aren't we going for the 200? Yeah, we're going for the 200, 100%. I just got to take a break. I just got to stretch and stuff. But we'll be back. We'll do more. Oh, yeah. I'm all jazzed up. I'm all juiced up on the studies of life. All right, let's get some tomatoes, everybody. So timer. This is our bigger break because we just finished a block of 50, so we get a 15-minute break. Good work, everybody. We did 50 questions. We're going to do 150 more questions, hopefully, by the end of this stream. But we got to take some breaks. So go out there, get some stretching, and we'll be right back at it again. Or if you just want to keep grinding, just do some grinding, you know? But I'm going to make a couple of improvements to the stream. All right, question 51. Here we go. A 58-year-old man presents to his physician with muscle cramps and weakness during physical exertion. He reports these symptoms started occurring with moderate exercise like brisk walking a few months ago. Normal creatine kinase. Muscle biopsy shows increased glycogen content. Exercise test is conducted and an increase in venous lactate levels is noted following ischemic form exercise. Genetic testing shows a mutation in the glycogen phosphorylase gene. The patient's enzyme kinetic analysis indicates that in the presence of an unknown compound, Km is decreased. Okay, so that's the first clue. Affinity is increasing for glycogen is decreased without an alteration in Vmax. Without alteration in Vmax. Okay, so we got muscle glycogen phosphorylase that is activated by AMP. And that's lowering the Km, which means that it's increasing its substrate affinity. So affinity goes up. We can acknowledge that. And it doesn't change the Vmax. And so that means the enzyme is more efficient at breaking down glycogen during exercise. And so there are a couple of answers. Everybody should be immediately thinking of like, what is a competitive inhibitor? That's what I always think of first. That increases the Km, and a non-competitive, that lowers the Vmax. And then covalent modifiers, like phosphorylation, alter the enzyme activity, but they typically affect the Vmax, not the Km alone. And then, so now we're down between these two, and it's going to be an activator. So it's an allosteric activator that increases, the inhibitor would increase the Km or decrease the Vmax. An allosteric activator is the correct answer. All right. So Km is the affinity, Vmax is the capacity. Here they are. Decreased Km, unchanged Vmax, myoglobinuria, muscle cramps, exercise intolerance, AMP allosteric activator. So muscle glycogen phosphorylase deficiency leads to impaired, so high yield, nice, yeah. Impaired glycogenolysis, exercise intolerance, and normally AMP binds allosterically, increases affinity. Inhibitors act as negative feedback. Covalent modification regulates activity based on hormonal signals. Okay, based on the hormonal signals, so decreased Km, unchanged Vmax, allosteric activator, AMP activates glycogen phosphorylase in the muscle. Nicely done. So yeah, allosteric activators, they induce conformational changes at the active site, and that increases the affinity. So the Km will drop. And Jeff says, gets better over time with activity because your body's just burning fat or other molecules. Yep, nice. So you nailed it. Yep, you get that second wind. So you struggle because the ATP is blocked by glycogen breakdown. And so you get all these cramps, fatigue, and myoglobinuria. But then after 10 minutes, then you feel better because the muscle switched to oxidative metabolism. They use free fatty acids instead. So the glycogen can't be broken down. So you have decreased glucose initially. Decreased glucose, decreased ATP. But then after a few minutes, now we have oxidative phosphorylation through the free fatty acids. Okay, nice. And see how there are these images here? I want to make them so that they cycle through like that. Let me do that right now. I'm just going to code a quick script that does this. Let's see what this gives me. Let's do that. Okay, next we have a 34-year-old woman who comes to clinic with 2-week history of persistent fatigue and intentional weight loss, frequent nosebleeds. Blood pressure is 110. She has petechia on her arms. Hemoglobin is 9. Platelet count is 40K. Leukocytes 28. 45% myeloblast with Auer rods. All right, well, the Auer rods gives it away. This is acute myelogenous leukemia, fatigue, bleeding, anemia, thrombocytopenia, leukocytosis, and greater than 20% blasts with Auer rods is acute myelogenous leukemia. Here are the trap answers. ALL, lymphoblast, not myelo, wrong lineage. APL is 15 to 17. CML would have basophilia and BCR-ABL. Too many blasts here for that chronic phase. Hodgkin's would be Reed-Sternberg cells and painless lymphadenopathy. So it's the Auer rods, blast greater than 20%, pallor, petechia, fatigue, bone marrow failure, left upper quadrant tenderness, splenomegaly. So myeloid progenitor mutation, failure to differentiate, accumulation of myeloblasts, bone marrow crowding, pancytopenia, symptoms like fatigue, bleeding, infections, increased blast in the blood, 20%, defines acute. Auer rods formation, aggregates at the MPO positive granule specific to myeloid lineage, complications DIC. Okay, so the pathophysiology here, we have the myeloid progenitor mutation, and then you have failure to differentiate, and then you get the accumulation of myeloblasts. This then crowds the bone marrow, and you get pancytopenia and symptoms like fatigue, anemia, bleeding, like thrombocytopenia, and infections. And you have increased amount of blasts, greater than 20%. And Auer rod formation, these are aggregates of the MPO positive granules that are specific to this lineage. DIC is a complication. So the triad is anemia, thrombocytopenia, and leukocytosis with blasts. So ALL has the lymphoblast, promolytic would have 15 to 17, CML has basophilia, and the BCR-ABL, and Hodgkin's has Reed-Sternberg cells, along with painless lymphadenopathy. Oh, got some good notes from Fatty here. I'll write these down. These are really good notes. ALL, childhood, CLL, adulthood. Yep. Here, let me make some room here. Okay, so acute lymphoblastic leukemia, the most common cancer in children, is what I think you were saying before when I saw the comment. This is the most common in children. This is the translocation of 1221. And obviously these numbers are just the same thing back and forth. Your sister had Hodgkin's lymphoma and she survived. Well, that's good. She survived. Holy cow. ALL has a good prognosis. And there are also some markers like TDT positivity, and also CD10. Liver King made a good point about the Robertsonian translocations, I think is what you're talking about, Down syndrome. For the Down syndrome, you also have the ALL risk sometimes with the 1221. Guys, all right, CLL. So back to chronic lymphocytic leukemia. So this is the most common in adults. Children, right? You'd think it would go with C, and you think A would go with A, but it's flipped. So just remember that they're flipped, right? So CLL, so I should eliminate that, goes with the adult one. Who know medical content can be so fun, right? Blast for young like kids, that's so much better than what I would do is to just flip them. Blast is acute lymphoblastic leukemia versus chronic lymphocytic leukemia. And so blast, you're having a blast if you're a kid. Yeah, I guess that's good. So CLL, these guys have smudge cells. Yeah, by the end of this, everybody's going to get their MDs. And so this is going to be CD20 and CD5 positivity. The smudge. Yeah, everybody forgets about the smudge. And this can often be asymptomatic. And then there are Auer rods in the AML and APLs. So Auer rods is the peroxidase positive cytoplasmic needle-like inclusions. And APL has the 15 to 17. It's that subtype there, the PML to the RA fusion genes. So I'll write that down as well, APL. All right, APL has those 15 to 17 translocations. And the Auer rods are at a high risk of DIC. Okay, so if it's a kid, blast, ALL. If it's Auer rods, AML. If it's APL, think 15, 17. Cool. That's the lay of the land, folks. Let's see if this is working now. Peripheral blood smear, Auer rods, acute myelogenous leukemia. There we go. Moving on to next question, 53. But first, I want to see if my overlay is working. No, it's not, but I'll get it working. We're making progress, don't worry. We're making progress. That's all that matters, as long as you're making a little bit of progress here and there. Thanks for spreading all the good vibes. So good to have you around. Itching your nose means there's an angel nearby? Well, there's certainly a lot of angels in this room, because I do be itching my nose a lot, because I got some allergies or something going on here. Okay, here we go. A 4-month-old is brought to the pediatrician by his caregiver for a routine checkup. Caregiver reports that the infant has started rolling over from front to back, but does not yet follow objects with his eyes or smile spontaneously at familiar people. He's on formula and feeds well. Caregiver is concerned that he is quieter than other babies his age. Currently sleeping 5 to 6 hours a night. Physical examination, his growth parameters are 50th percentile for weight, height, and head circumference. Neurologic examinations are remarkable. Which of the following best characterizes the developmental progress? Okay, what do you guys think? All right, so let's talk about what should happen at 4 months for those of you who don't have the babies. Delayed social. Yes, indeed, delayed social is correct. So at 4 months, the infant should be able to roll front to back, right? They should be able to smile socially and laugh, right? And here that's inhibited or delayed. And so they should also coo and vocalize as well. That's the verbal. And then visually track objects as well. And so this is going to be delayed verbal and delayed social. Missing social smiling and missing the cooing, right? So the cooing is the verbal. So this is going to be B. And look at those images they just generated. That's so adorable. Look at that little baby. Developmental delay. Yep. And soon I'll be making a carousel where those things will rotate through. That's my goal. All right. So they're developmentally normal for gross. They can roll over, but they can't do the other things. All right. Pretty easy. So here is the infant shows normal gross motor, but delayed social engagement, indicating potential developmental concerns. Moving on to the next one. So 28-year-old man goes to clinic, complaints of fatigue, shortness of breath on exertion. He also mentions some dark urine in the mornings. Vital signs are normal, and physical exam reveals mild pallor and scleral icterus. Lab studies show all of these things. What is the mechanism causing this patient's symptoms? Yep, so we have the most salient facts of this case right here is elevated LDH, decreased globin, increased indirect bilirubin, increased retic count, and that is going to be classic for hemolysis. So the dark urine in the mornings is the red flag for intravascular hemolysis, especially PNH, as fatty liver has said. And autoimmune hemolytic anemia. All right, nailed it. So this is textbook intrahemolytic anemia. There's dark urine because of the intravascular hemolysis, and there's increased retic count. That's due to the marrow compression or marrow compensation, and the increased indirect bilirubin all point to the red blood cell destruction. And so there's autoimmune hemolytic anemia. That's the most common in this age group. And there's a question in the chat. Fatty liver says, what is CD55 and 59? Yeah, so basically, those are definitely going to be positive in this mechanism. They're the surface proteins on the red blood cells. So like, here's your red blood cell, and they're just chilling here on the top. And their job is to protect the red blood cell from complement-mediated lysis. And so 55 and 59 especially, I'm not entirely sure on 55, but 59, these are MAC inhibitory proteins, and so they inhibit the formation of the MAC complex. And I think this one inhibits C3, and this one inhibits MAC. So they just inhibit that process. And so if they're missing, then the complement system attacks your own red blood cells. And that's obviously horrible, right? So the complement system is attacking you. And so it's a paroxysmal nocturnal hemoglobin. And this is caused by the PIGA mutation. And you have defective GPI, the defective GPI anchor. And the GPI normally anchors those CD55 and CD59 onto the red blood cells on the membrane. And without them, the complement just destroys the red blood cells, especially at night. And the low pH during sleep activates the complement system. And that's the reason why it's at night. And that's the reason why in the morning, you see that dark urine. So hopefully that makes sense. All right, so the bottom line is elevated reticulocyte count and low haptoglobin indicates autoimmune hemolytic anemia as the cause of fatigue and jaundice. And by the way, anytime you see low haptoglobin, what that means is that there's intrahemolysis. It's the mechanistic effect of the scavenging of the free hemoglobin. So haptoglobin is the glycoprotein that's made in the liver, and its job is to bind free hemoglobin. So it gets used up if there is a lot of that free hemoglobin, because the red blood cells are going to rupture. And so you get the free hemoglobin, so haptoglobin's binding, and so it's used up. All right, question 55. I think fatty liver will like this one. 64-year-old man is brought to the emergency department with sudden onset chest pain lasting 2 hours. His medical history is significant for hypertension and hyperlipidemia. You have ST elevations in the anterior leads, and the patient is administered a medication intravenously, after which the chest pain subsides and ST elevations resolve. The medication given to the patient works through which of the following mechanisms? Okay, so we have an ST elevation and myocardial infarction. This is a STEMI. Aspirin, ooh. So we're thinking C for aspirin. So this is a STEMI, and there's only one drug class that breaks down this clot, right? All right, so there's just one drug class that breaks this down. So ST elevation, myocardial infarction is a STEMI. We know that. It's a thrombolytic occlusion of the coronary artery. And fibrinolytics, like you mentioned, the TPAs, these guys dissolve the fibrin mesh and they lead to reperfusion and ST resolution and pain relief. Yes, indeed. You got it. And so it's the increase in the degradation of the fibrin by forming plasmin. Yep. So they've got the STEMI, they got the ST elevation, the chest pain, all that stuff. And he was treated with an IV thrombolytic, likely the alteplase is the TPA analog. And this activates plasminogen into plasmin and that digests the fibrin clots. And so his ST elevations are resolving, and that means the thrombus was dissolved instead of stabilized. And I like what you're thinking about aspirin. Aspirin prevents the platelet activation, but it does not reverse the existing occlusion. And so here he's administered this and then his ST resolves. So that would prevent more clots. And an aspirin is indeed, like you mentioned, it's inhibiting the platelet adhesion by the thromboxane A2. So you have the decreased thromboxane A2, which leads to decreased platelet activation. Whereas these the mechanism is increased plasmin to fibrin breakdown. And then heparin is going to activate antithrombin, and that stops the thrombin action. And then we'll go into these as well, these answer choices. So the glycoprotein 2B3A, platelet aggregator blockers, don't dissolve the clots, only prevent further, similar to this one. Does not lyse clots, is aspirin. That's why aspirin's not correct. Prevents fibrinogen to fibrin. Thrombin inhibitor, so agents like heparin and dabigatran reduce clot formation. And vitamin K, antagonist, warfarin impacts 2, 7, 9, and 10 formation. Takes a long time to work though. All right, ST elevation, reperfusion within 90 minutes, saves the myocardium, antiplatelet, anticoagulant, and the thrombolytic. And you mentioned the triple therapy, aspirin, nitrate, and analgesic. Didn't know the TPA was routine. Yeah, so aspirin, that's immediate, chewable. We like it, right? And then we give him like a clopidogrel or like any of the Ugrels, and that'll block the ADP receptor to prevent the platelet activation. And anticoagulants like heparin, that prevents the thrombin formation. And then reperfusion, that opens the blocked artery like the PCI or a TPA. So yes, aspirin, heparin, PCI. And if PCI is unavailable, aspirin, heparin, TPA. But yep, you're right. Emergency matters, morphine, oxygen, nitrates, aspirin. But, it's not going to fix the blocked artery. That's why you need the definitive therapy of a reperfusion. So that's a PCI is the best option. Give him some angioplasty and stenting, baby. And then the TPA as well. So yeah, TPA is pretty routine if the PCI is delayed or not available somehow. But there is this really cool management plan that you should remember. It's the Mona-Bash-C. Mona-Bash-C. It's morphine for the pain and also a decreased preload. Oxygen, that's only if it's less than 90. Nitrates, which cause vasodilation and lower the angina. And then A is aspirin, so it's antiplatelet, obviously. BASH, so B is beta blocker, that's decreasing the oxygen demand. A is A inhibitor, that's decreasing and prevents remodeling. S is statin, so that's lipid lowering. H is heparin, that's anticoagulant. And then C is clopidogrel, that's like an antiplatelet. And so this aspirin nitrate analgesic is part of an emergency symptom control, but TPA is the definitive treatment to reopen the artery. Nice. Cool beans. We kind of touched on that one a lot. But yeah, definitely got to give the right drug in the first 30 minutes when you give fibrinolytics like alteplase used in ST elevation myocardial infarction or a STEMI. Yeah, that was a good one. So the bottom line here, ST elevation treatment involves thrombolytics that increased fibrin degradation by forming plasmin. These are kind of cool AI images. Now it's generating 3 for each question, which is fancy. Hey, the timer is complete. Nice. Did everybody get tomatoes? Hey, David, how you doing? Good morning to you. I guess for you, it's good evening. Alrighty, question 56. Hoping to get through 200. So here we go. Here's our next one. A 65-year-old woman visits her primary care physician with concerns about urinary leakage that occurs when she coughs and sneezes. Valsalva stuff. Sensation of fullness in the vagina that has been worsening over the past year. Medical history is significant for 3 vaginal deliveries. And also a recent diagnosis of chronic obstructive pulmonary disease. Pelvic examination reveals a protrusion of the anterior vaginal wall when the patient performs a Valsalva maneuver. Which of the following is the diagnosis? Yeah, sounds like you got some salmonella. Jeez. Okay, so urinary leakage and coughing and sneezing. Think stress incontinence, right? And so the anterior vaginal wall protrusion tells you that the bladder has dropped down. If the bladder drops down, that is a cystic. And so the risk factors are going to be multiple vaginal deliveries, aging, chronic increases in abdominal pressure, like from COPD, and the Bartholin cysts, rusticeles, and the enteroceles all present differently, right? So let's look at all of them. Bartholin gland abscess, painful red mass near the vaginal. That's wrong because it presents acutely, unilaterally, and low in the vulva. Enterocele has a small bowel herniation, protrudes through the posterior vaginal wall. Rectocele, posterior bulge, difficulty with defecation. And urethral diverticulum is dysuria, post-void dribbling, and interior vaginal mass. All right, so it's the urinary incontinence, is the stress incontinence. Protrusion of the vaginal wall with Valsalva. It indicates pelvic organ prolapse. Anterior bulging with the bladder involvement, cystocele. Risk factors are going to be the vaginal births, age, obesity, COPD, and chronic straining. And the COPD, because of the coughing, and then that increases the pressure. Multiple births, stretch, and weakens the pelvic support. Mechanical strain on the pelvic floor. So pelvic floor damage. All right. Cystocele is characterized by urinary leakage with increased intra-abdominal pressure and anterior vaginal wall protrusion. Yep, Twitch is the gathering. It's the melting pot. People from all walks of life come to learn medical content. All right. So for this one, I want to talk about variable expressivity. So first of all, what is the inheritance pattern of neurofibromatosis? Well, that is going to be autosomal dominant. And let's say that we have a young kid and they have some seizures, and the mom has some neurofibromas, and also the brother and uncle, they also have some cafe au lait spots. Well, you should be thinking of neurofibromatosis 1. And variable expressivity is just a way of saying that you have different phenotypic presentations. So it can present differently in different people, and that's what variable expressivity means. Okay, kid is faking seizures. Well, there you go. We got to give Dr. David his time. All right, so here's the next question. A 55-year-old woman is admitted to intensive care unit with severe pneumonia and rapidly progressive hypoxemic respiratory failure. Arterial blood gas analysis reveals a pH of 7.34, PO2 of 55. She is intubated and placed in mechanical ventilation using a low tidal volume strategy. Ventilation settings include a fraction of inspired oxygen and respiratory oxygen rate or respiratory rate of 18 in order to improve oxygenation and prevent a specific complication associated with the PEEP, mechanical ventilation. The PEEP is initiated. What is the purpose of the PEEP? PEEP and ARDS, right? So keeping the alveoli open. So ARDS is a diffuse alveolar damage condition where you have decreased compliance and shunting and also severe hypoxemia. So PEEP prevents the alveolar collapse at end expiration, so that improves oxygenation and it avoids the electrotrauma. Preventing the collapse is the answer to this question. So the PEEP prevents cyclic alveolar collapse, improving oxygenation in patients with severe pneumonia and respiratory failure. And yes, you're right. David says harder questions. These ones are too easy. Yeah, that's fair. That's fair. VQ mismatch. David, you crack me up, dude. Yeah, so ARDS pathophysiology. Electrotrauma is the damage between the repetitive alveolar collapse and reopening, and in ARDS, hyaline membranes and the edema lead to reduced lung compliance and shunting. Okay, here we go. So in our next question, we have a 6-year-old girl who was brought to the clinic by her parents due to concerns about academic performance. She's been experiencing difficulties at school, maintaining focus and completing her assignments. The child complains of intermittent abdominal pain, and she's got all these labs here. So hemoglobin is a bit low, hematocrit low iron. She wants more iron because the TIBC is up. Which of the following is the cause of these lab findings? Okay, so she has microcytic anemia, so low hemoglobin, low MCV. Her serum iron is low, and the high TIBC, the iron deficiency pattern, is being demonstrated there. Neurologic symptoms, she has attention problems and school performance problems. And she also has basophilic stippling on their peripheral smear. And so this is lead poisoning. Lead inhibits the enzymes involved in heme synthesis, like your allo-dehydrogenase, and that causes microcytic anemia and iron trapping. And so decreased folate absorption, that would be macrocytic, not micro, and no neurologic or iron findings for A, so that's wrong. Decreased activity of pyruvate kinase, that would cause hemolytic anemia, so increased retic and also jaundice, which is not seen here. Iron malabsorption, that would cause microcytic anemia, but would not explain the basophilic stippling. Endocrine mutation, that causes hereditary spirocytosis, which is a hemolytic anemia with spirocytes, so that's wrong as well. And this is typically in children who live in older homes. They're exposed to lead-based paint and interferes with heme synthesis and causes anemia and degrades the CNS as well, so you have behavioral issues. You have those clumped RNA remnants in the red blood cells, which is the basophilic stippling, and poor academic performance as well. So old homes, increased free erythrocyte protoporphyrin, and you inhibit ALA, dehydratase, and ferrochelatase. So here's the bottom line. Chronic lead exposure causes macrocytic anemia and neurologic symptoms in children, evidenced by basophilic stippling. So here we have a 60-year-old man evaluated in the emergency department for progressive fatigue and pruritus for the past 6 weeks. He has a history of chronic kidney disease, stage 4, secondary to hypertension. He is on lisinopril and furosemide. BP is 155, pitting edema to the shins, serum calcium 7.2, serum phosphate is 6.8. Bone x-rays show subperiosteal bone reabsorption, which the following best represents the status of the parathyroid hormone, and serum 125. Okay, so here are the answer choices. The correct answer is going to be the increasing of parathyroid hormone because it's hyperparathyroidism, and also the decreasing of 125 dihydroxyvitamin D. So this is a compensatory overproduction of the parathyroid hormone in response to chronic hypocalcemia. So where calcium is going to be low, and the parathyroid glands themselves are normal, they're just responding to that low calcium. So it is the low calcium as the trigger. Chronic kidney disease is the most common, also vitamin D deficiency, malabsorption of just calcium generally, or chronic hypocalcemia from other causes like rickets, for instance. And so the kidney has a role in chronic kidney disease, right? And so when the kidneys fail, the phosphate secretion goes down, excretion goes down, and that causes hyperphosphatemia, right? And so the phosphate excretion, if this were excretion, would go down. And you have high phosphate, which then binds to the calcium, and that decreases the calcium, right? So you have too much phosphate, but again, this is excretion, phosphate excretion here goes down. And so all that phosphate binds to the calcium. Now, what about the 1-alpha hydroxylase activity? And that's not on this table, but that is decreased, right? And that decreasing also causes the decreasing of 125 OH2, right? The vitamin D calcitriol. And so there's less calcitriol. What does that mean? Lower calcium absorption. And so both of them lead to the hypocalcemia, and that chronically stimulates the parathyroid hormone secretion. So the parathyroid responds and the glands enlarge and you can have some hyperplasia, and the PTH rises to restore the calcium balance. And so you have increased bone reabsorption and release of the calcium and phosphate, also increased renal calcium reabsorption and phosphate excretion and activation of vitamin D if the kidneys can respond. But in chronic kidney disease, of course, these effects cannot fully normalize the calcium. And so the labs is calcium is going to be low, right? Because phosphate binds the calcium. Phosphate itself, not just the excretion goes down, but the phosphate itself is increased. And then PTH is going to be increased by compensatory mechanisms, and 125 is decreased, and ALP is increased. That's the ALK phos, and that's because of the increased bone turnover. All right, and so our answer is B for this question. So the bottom line in chronic kidney disease, expect to increase parathyroid hormone and decrease 125 due to the impaired renal function. Thanks, Puppetus. I look sad. No, I'm just tired. I've been up since about 2 a.m. doing a lot of coding sitting in this chair. I'm actually pretty happy that I have this all figured out now, this whole screen. How does this look, by the way? Do you have any thoughts on this new layout? All right, and our next question, a 55-year-old woman presents to the clinic with a 2-month history of persistent coughing and occasional hemoptysis. She also reports fatigue, unexplained weight loss, and joint pain. Her medical history is notable for chronic nasal congestion and repeated sinus infections. On examination, her temperature is 100, pulse is 92, respirations are 18, and blood pressure is 150/90. Physical exam reveals tenderness of the paranasal sinuses and bilateral crackles of the lung. Upon auscultation, lab tests show the following: 10 hemoglobin, hematocrit 30%. ANA is negative, MPO is negative, urine analysis has 30 to 50, protein is 2. Okay. Which of the following types of vascular injury is most likely responsible for this patient's symptoms? All right, so here we go. Question 61. One thing that's notable about this one is we have ANCA is positive and the MPO ANCA is negative. So here there's a triad, and they are presenting with an upper respiratory tract involvement. So that's the chronic sinusitis and nasal congestion. So they got the upper, lower, they have the lower respiratory tract involvement. So that's going to be cough, hemoptysis, and also cavitary lung lesions. That's a little bit lower, unlike the chronic sinusitis, which is upper respiratory, lower respiratory, and then renal involvement as well. There's renal involvement also. Okay, the renal involvement is like hematuria, proteinuria, and increased creatinine, glomerulonephritis. And this is known as GPA, right? So this is GPA. And the big lab finding here is the PANCA. And so this is necrotizing granulomatous vasculitis. This is going to be a small to medium-sized vessels. And the mechanism is these autoantibodies. They activate the neutrophils, causing inflammation and fibrinoid necrosis of the vessel walls. And granulomatous inflammation forms in the respiratory tract. So you have necrotizing granulomas. And you can distinguish this from a lot of different conditions, right? So we'll look at some of these here. But they have upper, lower, and positive CANCA. Cavitary lung, glomerulonephritis, all of that textbook GPA, and that ANCA is positive for GPA. Eosinophilic vasculitis would have asthma and all those other signs. This is going to point to Church-Strauss, but there's no eosinophilia and asthma. Leukocytoclastic vasculitis, palpebra purpura, skin-only involvement, wrong because this affects the small derma vessels. Polyarthritis nodosa, that'd be like hepatitis B, renal involvement without glomerulonephritis. This is wrong because it spares the lungs and also the glomeruli. And Takayasu, that'd be young Asian females, pulseless disease. That is a large one, it affects the aorta. Okay, so when you're approaching these vasculitis questions, you ask which vessels are involved, small, medium, large, which organs are affected, and are there autoantibodies? And so here we have small, medium vessels, lungs, kidney, sinuses, and the lungs and the kidneys, and also this ANCA keys you into granulomatosis with polyangiitis. So lungs, kidneys, sinuses, granulomatosis with polyangiitis is the answer. Here's the bottom line. Positive CANCA and lung cavitary lesions indicate necrotizing granulomatous vasculitides like Wegener's. All right, on to our next question. Question 62. All right, in our next question, we have a 45-year-old woman presenting to the clinic with a sudden onset of severe epigastric pain radiating to her back, nausea, and vomiting for the past 4 hours. She has a history of peptic ulcer disease, but has not been taking her prescribed medications regularly. Vital signs reveal a temperature of 38.2, heart rate of 110 per minute, blood pressure of 100/60, and respirations of 28 per minute. On physical examination, there is significant tenderness in the upper abdomen with guarding, and upright abdominal x-ray reveals free air under the diaphragm. Which of the following is a diagnosis? This is perforated peptic ulcer. So sudden severe epigastric pain, peritonitis, free air under the diaphragm, all of that is perforated. An anterior duodenal ulcer or a gastric ulcer that perforates into the peritoneal cavity. And then the gastric stuff, the acid, the enzymes, the bacteria, it all spills into the peritoneum, and it causes chemical peritonitis and bacterial peritonitis as well. And it accumulates below the diaphragm, typically on the right side. It can cause referred shoulder pain and also the phrenic nerve, C3 to C5 irritation. So typically it's that severe epigastric pain radiating to the back, and also the history of peptic ulcer disease and a rigid abdomen and guarding, which indicates peritonitis. Bottom line, free air under the diaphragm, a patient with epigastric pain indicates perforated peptic ulcer. All right, in our next question, we have a 27-year-old woman enjoying a campfire meal with her friends, but suddenly she inhales some smoke, and it causes her to cough vigorously. Hey there, Chess Noob. How's it going, Chess Noob? Anytime I see your name, I always think of the Rick and Morty, like Noob character, which just kind of cracks me up. Noob. All right, so here we go. See if you can answer this question. A 27-year-old woman is enjoying a campfire meal with her friends, but suddenly she inhales some smoke. Oh, it causes her to cough vigorously. Which of the following best describes the state of her vocal cords during the initial inhalation of smoke and the subsequent cough? Okay, what do you think? What happens when you cough? Seems like an easy question. There are actually 3 major phases of the cough. 1, inspiratory phase. You have a deep breath in, and then the state of the vocal cords when that happens is going to be open. That's stage 1. And then there's the compression phase. That's when the laryngeal closure occurs. You have contraction of the expiratory muscles, and you increase the intrathoracic pressure. And so there, the state of the vocal cords is going to be closed. So first it's open, and then the third phase is the expulsion phase. And there it opens expulsively, sudden glottic opening, and you have a rapid expulsion of the air and the irritants. So right before the cough, the compression phase, the cords are closed and that traps the air and allows the pressure to build up, and then it forcefully explodes out. So she inhales it, vocal cords are open, she coughs, right? The vocal cords close briefly to build up the pressure, and then it explodes outwards. So it's also closed when you swallow, and it's closed after the irritation, and while you're coughing is when it opens. So you close, compress, and you clear it. You've been okay? You're almost there, right? Graduation's coming soon. All right. Inhalation requires vocal cord abduction to allow airflow in the lungs. The cough reflex begins with deep inspiration, then closure of the vocal cords. Close inhalation. So to answer, you need normal vocal cord movement. Cough reflex is irritation, inspiration, vocal cord closure, and expiratory muscles. Buzzwords: cough reflex, Valsalva-like maneuver, and aspiration reflex. Inhalation reflex, compression phase, expulsion phase. That's the gist of it. Here's the bottom line. Vocal cords are open during inhalation and closed to initiate the cough reflex. That is a terrifying image. Images there. AI is spooky AF. Actually, 3 more questions I'm not realizing. Okay. This is a practice question for you guys to do if you feel like you understood the last one. This is about coughing again, but she's at a restaurant. She has the urge to cough. Cough reflex, what happens? The answer is going to be open, closed, open, right? And you have to know what's going on. Why blood cell count? Yeah, what do you think, chest noob? What's the answer? So here we have a 32-year-old woman, presents to the emergency department. She's got severe epigastric pain and nausea, began 6 hours ago. She's got some similar episodes of abdominal pain previously, often triggered after a large meal. And she has elevated serum lipase, and her fasting lipid profile shows elevated triglycerides, while total cholesterol and HDL cholesterol are within normal. Her plasma is turbid. Which of the following is most likely elevated? Yeah, that's a good answer. Well, here are your answer choices. So what do you think the correct answer is if you had to guess? C is a close answer. Super 1 away from the correct answer. So we have recurrent pancreatitis, severe epigastric pain, and there's also some eruptive xanthomas, and that's the small yellow papules. And also she has the milky appearance of the retinal vessels and the milky turbid plasma. Basically, these findings are familiar chylomicronemia syndrome. And so this is a type 1 hyperlipoproteinemia. And the cause is a deficiency of the lipoprotein lipase or its cofactor apolipoprotein C2. So chylomicrons, which normally carry dietary triglycerides, can't be broken down. They can't be broken down. And so instead they just accumulate in the plasma. They just hang out in the plasma. So the triglyceride levels are super duper duper high, often greater than 1,000. And the cholesterol is normal or elevated slightly, and HDL is normal, and the plasma is milky, and the major lipoprotein elevation is going to be the chylomicrons. It's all because that acute pancreatitis due to the high triglycerides and the toxic free fatty acids and the eruptive xanthomas and all that stuff. And why is it not ApoB 100? Well, that is found in very low density or low density cholesterol. It's not going to be elevated here. Chylomicrons have ApoB 48. How about LDL cholesterol? Well, that's normal. LDL is not primarily going to be affected here. LPA, that is a lipoprotein that resembles LDL. It's linked to atherosclerosis, not pancreatitis. And phospholipids, that's not going to be, no selective rise is going to be seen in these guys. They're general plasma lipid abnormality. It's not going to be diagnostic for anything here in this condition. All right, so type 1, familial chylomicronemia. That's an LPL or an LPL or an ApoC2. That's where you have the chylomicron presence, and that's in pancreatitis, xanthomas, and the creamy plasma stuff. Type 2, familial hypercholesteremia. That's going to be premature atherosclerosis. Type 4 is a very low density, and if it were type 2, it would be a low density. So there you have it. So here's the bottom line. Severe hypertriglyceridemia leads to chylomicron elevation, causing abdominal pain. All right, this is going to be our last question of the day. So here we have a 52-year-old woman visits dermatologist for a routine skin check. She has a history of significant sun exposure due to her occupation as a lifeguard. During the examination, a 1.5 centimeter asymmetric lesion with irregular borders and multiple colors is noted on her upper back. Dermatologist recommends a biopsy, which confers malignant melanoma. Prior to its malignant transformation, which of the following would this lesion most likely have been? The answer is going to be a junction nevus. So A, B, C, D, E is what I wrote down in my notes. Asymmetric border irregularity, color variation, D stands for diameter greater than 6 millimeters, and evolution. All of that is critical in melanoma screening. Asymmetric, border, color, diameter, evolution, all of that is critical. All right, now let's look at all these other answer choices. And in the future, all of these images are going to be reflecting this condition, not just the top one, but dermatofibroma is a firm, dimpled nodule on the legs, not melanocytic. Cafe au lait, light brown macules, and neurofibromatosis. They're pigmentary, do not transform into melanomas. Epidermoid cyst would have the cheesy keratin-filled nodule, unrelated to melanocytes, lentigo, without sun, flat pigmentation. So the nevi is benign melanocyte proliferation. They reside at the dermal-epidermal junction, and they're categorized by where the melanocytes are: junctional, compound, and intradermal. Junctional nevi are more likely to undergo dysplastic changes under chronic UV exposure. They can undergo BRAF mutations, and then they're malignant all of a sudden. Asymmetry borders color variation. Junctional nevus melanocytes at the epidermal junction, sun exposure causes the damage, especially in fair-skinned individuals. So remember your ABCD. Wear sunscreen. All right, for next practice question, we have a 35-year-old woman presenting to the clinic with a painful vesicular lesion on her labia that appeared 3 days ago. She reports a history of similar outbreaks that were treated successfully in the past. The physician prescribes a viral medication that targets the viral DNA replication for HSV is going to be one of the nucleoside analogs. And so for those, it's going to be acyclovir, valacyclovir, and famciclovir. And these inhibit viral DNA polymerase, but only after activation. So acyclovir and other similar drugs are prodrugs, and so they have to be phosphorylated so that they can become active. And so that's where viral thymidine kinase comes in, which is our answer. This is HSV reactivation, and these guys that treat it are activated by viral thymidine kinase. So it phosphorylates the prodrug in the monophosphate form and allows the further host cell metabolism to its active triphosphate form, and then inhibits viral DNA polymerase. Helicase is the unwinding, which is important in replication but not involved in drug activation. Reverse transcriptase involved with HIV and retroviruses. This is a DNA virus, not an RNA retrovirus. And DNA gyrase would be involved with prokaryotic replication that's targeted by fluoroquinolones in bacteria, not viruses, and integrase, viral genome integration found in retroviruses in HIV and HSV. So to answer, we just have to know HSV virology, a DNA virus that causes painful vesicles, and then acyclovir pharmacology is a guanosine analog that gets activated only in virus-infected cells, since the mechanism of selectivity, the initial phosphorylation by viral thymidine kinase, is the key. Oral lesions, temporal lobe encephalitis, HSV1, HSV2, genital herpes, and thymidine kinase allows for HSV to reactivate and also activate the drugs, and acyclovir resistance is due to absent thymidine kinase. Here is the bottom line. Acyclovir requires activation by viral thymidine kinase to inhibit herpes simplex virus replication. All right, everybody, hopefully you found this live stream helpful. We did 66 questions with full review. More questions are coming. Now, for everybody on Twitch, I'm going to raid a channel. Let me know if you have any suggestions. Let's raid this harpist. This seems interesting. There we go. Nice. Hey everybody, I was just editing all of this in Gling, but then it crashed on me and I lost all of the progress, but I was able to salvage the XML file. So some of the videos are a little bit zoomed in. I apologize for that, but in the future, hopefully it won't crash on me. But after 3 hours of editing, I just couldn't do it all again. And so anyways, if you're enjoying this, then like and subscribe. A 62-year-old woman presents to the emergency department with sudden onset, sharp abdominal pain localized in the left upper quadrant. She describes the pain as exacerbated by eating and accompanied by occasional nausea and no vomiting. She has a history of osteoarthritis in which she takes over-the-counter naproxen. She is a smoker and consumes alcohol regularly. On examination, her abdomen is tender to palpation in the left upper quadrant. Vital signs show normal temperature. Blood pressure is 138, elevated, and pulse of 80. Respirations are 16. Endoscopy reveals A, gastric ulcer. Which of the following is the most significant factor? Okay, so as we discussed here, it is going to be an NSAID. So this is naproxen as an example of what she's taking, because it impairs mucosal defenses by inhibiting prostaglandin synthesis. So here's the explanation right here. NSAIDs, as Clear Prodigy said in the YouTube chat there, it inhibits COX-1 and 2, and that reduces the prostaglandin synthesis. And the prostaglandin is protective because prostaglandins, they're normally going to help out the mucosa because they promote mucus and bicarbonate secretion, and they maintain that mucosal blood flow. And so also the absence of vomiting argues against an infectious or an acute inflammatory cause. Okay, so alcohol consumption, that's precluded by literally the question stem. They say that he's not drinking a lot. B is our correct answer. C, low dietary fiber intake. So fiber impacts the motility, not the ulcer formation. So not ulcer formation. D, occasional stress. That's going to be the chronic stress has been overemphasized and it lacks direct evidence here. Stress is not going to be the predominant risk factor if you are also taking NSAIDs habitually. Acute viral infection is our last answer choice. And that is wrong because they don't cause gastric ulcers unless they're immunocompromised, like you have CMV, HSV, and transplant patients. Okay, so this person does not have H. pylori and they use chronic NSAIDs and the pain worsens by meals. And so this is going to be NSAID use. And regarding the CMV and the HSV infections, it's important to bring these up in immunocompromised patients because these viral infections can cause gastric or esophageal ulcers if they are immunocompromised. And so often in transplant recipients or those with AIDS or those on immunosuppressants, these can be important. And so what you should know about these that are high yield for step one is that CMV tends to cause these linear, deep ulcers. HSV more often causes the punched out ulcers, and HSV is going to be typically seen in the esophagus. All right, so this person is not immunocompromised, so you don't think of these acute viral infections. Now, if that wasn't enough, we also have the lay of the land here. To answer the question, here's what you need to be able to understand these mechanisms that protect the gastric mucosa. And gastric ulcers result when the balance between these aggressive factors like acid, pepsin, and NSAIDs and H. pylori, and also protective factors like the mucus and the bicarbonates are disturbed. All right, so elderly patients taking NSAIDs, you should definitely be thinking of this because they inhibit COX, and that limits the mucus and bicarbonate, and it pain worsens with meals. As a gastric ulcer, duodenal is going to be improving with food. And left upper quadrant pain is an anatomical clue, and daily naproxen is going to be classic NSAID-related injury. Okay? And this point right now about the meals and where they occur is also high yield, so I'm just going to cover that really briefly. So there are two types of ulcers that you should be aware of. One is the gastric ulcer, and this one, the gastric ulcer, is pain that worsens with meals. This worsens with meals, and it stimulates acid secretion, so acid hits the already agitated gastric mucosa, and it causes more pain, and so you just avoid eating, and the causes, usually they're going to be presenting with weight loss because they don't like how it feels if they eat the food. Duodenal ulcers, however, the food in the stomach stimulates these alkaline secretions, and it buffers and it temporarily protects the duodenum. And so the pain returns hours later. So usually it's going to be 2 to 3 hours postprandial or at nighttime. And so they may eat more frequently, and so you can have weight gain for duodenal ulcers. Okay, and now I'm checking in the chat here, and it says, Sadal mentions volcanic eruption ulcer. That's how I remember herpes esophagitis. Nice, yeah, so the volcano-like ulcers, the punched out lesions, they're small, discrete, shallow to deep ulcers with raised edges. And that describes their like volcano eruptions. So immunocompromised people, this is also going to be in the distal esophagus. All right, now here's the bottom line. Daily naproxen use is the most significant contributing factor to this patient's gastric ulcer. All right, we're going to be moving on to the next question here. So question 68. Okay, now this is a very interesting question about twins. All right, so hopefully you're ready for this question. Here it comes in 3, 2, 1. A 29-year-old pregnant woman is undergoing her 29-week ultrasound that shows single placenta and 2 fetuses. Further examination shows that one fetus has developed heart failure and also ascites, while the other one seems small for gestational age, but is otherwise unremarkable. On delivery at 32 weeks, so which of the following is the most likely diagnosis? Now, this is a rare question here, but in certain pregnancies, one twin can actually steal the blood from the other twin, right? And so you have heart failure in the recipient and then anemia in the other one. And so this is twin-twin transfusion syndrome. I feel like that could be a band name, or rather, it's a complication of the monochorionic pregnancies where placental blood vessels connect the 2 fetuses abnormally. And so one becomes a donor and it loses the blood, and the other is a recipient and they're overloaded with the blood and they develop the heart failure. And so the plethoric twin has the hematocrit of 70%, and then the other one has the 22%. Okay, so what is the correct answer for this one? It is twin-twin transfusion syndrome. So they have the shared placenta, the recipient gets polycythemia, heart failure, and ascites. Twin-twin transfusion syndrome. So they have that shared chorionic circulation in monochorionic twins. It leads to these vascular anastomoses, which causes the unidirectional shunting from one fetus to another. The donor twin becomes hypovolemic and anemic and growth restricted. And then the recipient twin becomes hypervolemic and receives polycythemia and progresses to cardiac failure and also hydrops fatalis. Now, there are 2 topics that I think are worth diving into just a little bit here. And those 2 topics for this particular condition are 1, hydrops fatalis, and that is when you have abnormal fluid accumulation in at least 2 compartments. So hydrops fatalis, you're typically going to be seeing ascites, also pleural effusion, and pericardial effusion, and maybe a skin edema. So hydrops fatalis is a sign of heart failure in utero, and it's life-threatening if you don't address it. And there are 2 main types. There's immune hydrops fatalis, and immune hydrops fatalis is due to an Rh incompatibility. Like you have, let's say, an Rh mother that forms antibodies against the Rh positive fetus, so the negative mother to the positive fetus, And that causes hemolysis and anemia and high output heart failure, which is going to lead to hydrops. There's also non-immune hydrops fatalis, and that is actually more common today. And this would be an example is this particular question, which is twin-twin transfusion syndrome, where you have fetal anemia. Like the fetal anemia could be caused by, for instance, Parvovirus B19. You could also have cardiac abnormalities and chromosomal syndromes like Turner's or even congenital infections, the torch infections. So basically anything that causes severe anemia or heart failure can lead to decreased oncotic pressure. And that causes, and also maybe an increased hydrostatic pressure. And then that leads to the fluids that leak into the fetal tissues, right? And so you might be wondering, okay, how does that relate to this twin syndrome that I'm talking about? Well, here the recipient twin receives too much blood, so there's volume overload, and that causes heart failure and hydrops fatalis. And that's why there's ascites. And the other subject, there's a question in the chat. B19, is it CMV? Parvovirus B19, that's a non-enveloped, single-stranded DNA virus, and it infects the erythroid precursors in the bone marrow. Whereas I think your other question was about cytomegalovirus, and that is going to be an enveloped DNA virus from the herpes family. And that one would cause like sensory neural deafness, calcifications, blueberry muffin rash, right? So they're different. Yeah, they both can cause hydrops because less commonly, cytomegalovirus will cause hydrops fatalis in a baby. Parvovirus is going to be more common to cause it, but CMV can definitely cause severe anemia and hepatic dysfunction in utero, and that causes the fluid to shift, and then you get hydrops. So yes, that's a good distinction there, but they are separate, right? Because CMV is from the herpes virus family, and then Parvovirus B19, that's a single-stranded DNA virus. And the most common outcome, if you're taking from CMV, is periventricular calcifications and sensory neural hearing loss. So hydrops is possible, but it's less likely for cytomegalovirus. And also for B19, you should be thinking of the slapped cheek, the fifth disease. And CMV, this is usually just mono-like symptoms. So usually asymptomatic or just mono-like. So Parvovirus B19 is a top cause of non-immune hydrops fatalis, and CMV is mostly just going to be a congenital viral infection. So hopefully that answers your question. And then the last topic that I wanted to touch on this question with the twins syndrome is chorion. The chorion and the amnion, okay? The chorion is the placental structure. The amnion is the sac around the fetus. And there are two types of twin pregnancies, dichorionic, diamniotic. Di meaning two, so there are two chorion, two amnion, right? And there's zygosity. And the timing of the split is typically earlier on. This is lowest risk. But if you could also have a monochorionic, and mono meaning one, monochorionic and monoamnionic, and that can cause some problems, and that's day 8 to 12. And you can cause like cord entanglement. Okay, so basically in this question, we have a single placenta, and so it's monochorionic, and there are two sacs. Or at least like unknown. We don't know how many sacs there are, but I'm assuming there are going to be two sacs in this question. If I scroll up, these blood brothers, right? It's unknown, but one twin is overloaded, the other is anemic. So that's the twin transfusion syndrome. And so one has hydrops fatalis from that overload. Okay. So hopefully that answers all the questions. And Clear Prodigy in the YouTube chat says, I don't remember fully, but I think CMV in the first trimester can cause it. Yeah, definitely the first trimester is the most dangerous time for transmission for CMV. And you have, the reason why is the fetal immune system is going to be very immature at that state. And so that leads to more severe, manifestations. For instance, microcephaly, periventricular calcifications, which we talked about, sensory neural deafness. Hydrops fatalis is rare, but definitely possible if you have a very severe infection, and also, of course, fetal demise. And so, yeah, definitely early CMV, you can infect the liver and the bone marrow because they're still developing, and that results in anemia and hypobilirubinemia. The anemia is from bone marrow suppression, and the hypobilirubinemia is from the liver dysfunction. And all of these things are going to cause, and the mechanism is very important here, decrease oncotic pressure, right? And increase hydrostatic pressure. And that is what causes this fluid to leak into the tissues, which is hydrops. Okay, and then one last chat here. Clear Prodigy says he's right. CMV will cause the deafness and blueberry rash more common than hydrops. So I was just talking about the infectious causes. Nice. Yeah, very, very good then. You totally nailed that question, and you're orbiting around these more esoteric details, which events that you have a strong understanding of the mechanism of CMV. So you're absolutely right to say CMV, definitely think of hearing loss and neuro findings more often. Hydrops from CMV is rare, but it's possible, especially in early pregnancy, as you pointed out. So really impressed with your clinical knowledge there. Really good job. And here is the bottom line. Twin-twin transfusion comes from an unequal blood flow, leading to one twin in polycythemia and the other with anemia. Okay, so now we're on to our next question, and that question is 69, a completely random number. All right, so you get a little bit of a break here. But I think to set the stage on this one, I want you to be thinking about how tumor necrosis occurs in tuberculosis. That's how I want to prime this conversation. Okay, so here we go. Are you guys ready? In our next question, which by the way, every single question should have an AI patient, 4 diagrams that are AI generated, and also 3 images from Google Images that refer to the topics that are being tested here. So that's how this is all laid out. Right here, you're going to see the practice questions, which is literally what we're going to be going over, and I'll highlight with you. Here are the notes. A 48-year-old man presents to the clinic with persistent, non-productive cough, low-grade fever, and night sweats that have persisted for the past 2 months. He has also noted significant fatigue and 11-pound weight loss. Physical examination reveals mild pallor and bilateral crackles in the upper left lung field. Lab tests are significant for increased erythrocyte sedimentation rate and mild anemia. A computed tomography scan of the chest reveals multiple nodular lesions with areas of central necrosis in the upper lobes of both lungs. The patient reports working in a correctional facility. Which of the following mechanisms is responsible for the tissue damage in this patient? All right, so we have to know what he has first of all. So it seems like he has the hallmarks of some disease, and let's talk about the symptoms before we say what it is. He's got some low-grade fever. He's also got night sweats. He's also got weight loss. Does that make you guys think of anything? There's also, importantly, a cavitary lesion in the upper lobe. That's a big giveaway. His job is in a correctional facility, and that also increases his exposure risk, but it's not the bacteria that does the damage here. And this is asking what is the mechanism that's responsible for the tissue damage? This is actually going to be the T-cell driven type 4 hypersensitivity response. And so here with our granulomas, what's happening here? So CD4 positive Th1 cells, they're positive on CD4, they're Th1 cells. They, through interferon gamma, trigger granulomatous reaction. And so over time, these immune cells are going to break down the lung tissue and it causes mediating necrosis. And so when tuberculosis shows up, it's the immune system's attacking itself. It's not a toxin, right? And so the answer is actually a type 4 hypersensitivity reaction because Mycobacterium tuberculosis causes caseating granulomas through T cell, and this is delayed type 4. So delayed type 4. And so the pathophysiology here is you have an initial infection. So TB gets phagocytosed but not killed. Very important. And then the Th1 response, they release interferon gamma, which is what Clear Prodigy said in the YouTube chat. And then we have activated macrophages, which form epithelioid cells and multinucleated giant cells, leading to a granuloma. And that causes chronic activation and caseous necrosis of the lung. And so the key features here are the upper lung is going to be these cavitary lesions are present. Also, you have type 4 hypersensitivity reactions and granulomas and caseating necrosis. And so there are occupational risks as well. Anytime you see somebody, the risk would be like in your prison, or in a shelter, then that's going to point you toward tuberculosis. Okay? Now, bacterial toxin production, that'd be like diphtheria. This is not going to be exotoxin. Immunoglobulin E-mediated mast cells, allergies, urticaria, that would be associated with B. C immune complex, mediated vasculitis, that'd be like post-streptococcal glomerulonephritis and serum sickness. Type 3 hypersensitivity involves these complexes that form. And complement-mediated cytotoxicity would be a MAC attack. It's a MAC attack. Do what? It's a MAC attack due to tuberculosis. Type 4 hypersensitivity reaction. TB gets phagocytosed, and then Th1, CD4 positive cells release interferon gamma, activates to get caseating necrosis. That's the mechanism, folks. That's the MEC. All right. Just 1 second. We'll do another good question here. And in the chat, I see Clear Prodigy says, I don't know if this is high yield, but we always have to do a PPD test before we give TNF-alpha inhibitor. Really good point. I think that is high yield. That's definitely something they like to test on. And you're absolutely right. So why do we give a PPD, or I'll kind of zoom out so we can kind of see this a little bit better. Why do we give a PPD or an IGRA before we give TNF-alpha inhibitors? Well, the reason why is because TNF-alpha is essentially very, 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 very important for granuloma maintenance, right? And so why do we give a PPD? Because what's in a granuloma is the macrophages and the T cells and the cytokines from interferon gamma and TNF-alpha. And so these are formed to wall off the intracellular pathogens, right? So we want to keep the TB in a latent state. So what happens if you block the TNF-alpha? Well, then the granuloma breaks down and you get latent tuberculosis that's reactivated in a severe disseminated tuberculosis, right? So you always test for latent TB through the PPD or IGRA test. That way you can see if they have it. Otherwise, because if they have latent tuberculosis, and you give them a TNF-alpha inhibitor like infliximab, adalimumab, just etanercept, right? If you give them a TNF-alpha inhibitor, then these drugs are like used for, like rheumatoid arthritis, Crohn's disease, psoriasis, ankylosing spondylitis. You give them that, well, then you're going to destroy this granuloma integrity. And so the TB is going to reactivate. Whoops, not good, right? Not good. Yeah, otherwise the patient is done if they have latent tuberculosis. Well said, Sid, in the YouTube chat there. Well said. Yep. Also, it's important to distinguish between like TNF alpha and TNF gamma. And so TNF alpha is the tumor necrosis factor alpha, and then interferon is typically what people think of, the interferon gamma. And so the source for TNF alpha is the macrophages, and the source for the INF gamma is the Th1/CD4 positive T cells and the natural killer cells. And so these tumor necrosis factor alphas, these are pro-inflammatory granuloma maintenance molecules. And interferon gamma, these guys activate macrophages and then they enhance phagocytosis and they promote granuloma formation. So they're both promoting the granuloma formation. Interferon gamma does, and also tumor necrosis factor alpha does. So they're both relevant for this granuloma formation. And then the TNF inhibitors, like infliximab, specifically are going to impact the tumor necrosis factor. And so it's really, really relevant to TNF alpha, the reactivation of latent tuberculosis. It's less clinically relevant, the interferon gamma stuff, but it still is like a mechanism to be aware of. And the interferon gamma is also going to be associated, as this question tests, with a type 4 hypersensitivity reaction. All right, good stuff, good stuff. So in this question, we have a 60-year-old former carpenter coming to the clinic with a 6-month history of hoarseness and difficulty swallowing. Smokes a 1 pack of cigarettes daily for 40 years before quitting. He reports no significant alcohol use. Physical exam reveals cervical lymphadenopathy, and laryngoscopic examination shows a regular mass in the larynx. A biopsy of the mass demonstrates replacement of the normal respiratory epithelium with another cell type. Which of the following is going to be responsible? All right, folks, what do you think in the chat? So the big clues here is that we have this 1 pack of cigarettes daily. So we have chronic smoking, and that is going to destroy the respiratory cilia and the columnar epithelium. And so there's an adaptation that occurs here, and it's going to be squamous metaplasia. And indeed, you're right, Sid, 100% correct. Squamous metaplasia. So this is a precancerous change. Okay, so the answer is squamous metaplasia. We'll look at the other answer choices. Columnar is seen in Barrett's esophagus, caused by acid reflux, not smoke. Glandular hyperplasia. This refers to the increased gland number, not involved in the hormonal context here. Hyaline cartilage formation is not going to be epithelial replacement, and transitional metaplasia is specific to the urinary tract. So the respiratory epithelium is normally pseudostratified columnar ciliated epithelium with goblet cells. And you have irritation that causes metaplasia, and squamous metaplasia is commonly seen in the bronchi, larynx, cervix. These are high yield bronchi, larynx, and the cervix in response to the chronic injury. Metaplasia can be a precursor to dysplasia and cancer, particularly the squamous cell. Here's the bottom line. Hoarseness and difficulty swallowing in a smoker with laryngeal mass suggests squamous metaplasia due to chronic irritation. Squamous cell carcinoma. That's the big takeaway from that one. Larynx, cervix, moving on and up in the world, folks. Question 71. All right, ready for this question? Here we go. 3, 2, 1, blast off. Here we have a 52-year-old man presenting to the emergency department with sudden onset chest pain radiating to his left arm, accompanied by shortness of breath and diaphoresis. His past medical history is significant for hypertension and hyperlipidemia. An echocardiogram shows ST elevation in the anterior leads. Troponin levels are elevated, indicative of myocardial injury. Despite prompt treatment with revascularization, the patient's echocardiography shows mild reduced ejection fraction. An autopsy specimen from an unrelated study in myocardial ischemia shows early stages due to the ischemic event. Which of the following cellular changes is most likely to be seen first in these cardiac myocytes? All right, so here you are. It's a Saturday morning. This is the question that you see on test day. What are you thinking and what are you going to choose? Okay, so we'll talk about this. Within minutes of ischemia, first you have a lack of oxygen, and that disrupts the oxidative phosphorylation in the cardiac myocytes. Okay, and so that leads to your decreased ATP production. Coagulative necrosis is what I'm seeing in the chat, says Iqbal. Also, Iqbal, welcome. Hopefully you're doing well. Thanks for joining us this Sunday morning. So without ATP, the sodium-potassium pumps are going to fail, and that leads to intracellular. So you have sodium and water influx. And then Seidal says they'll go with cellular swelling. Okay, we have 2 answers in the chat. So we got some division, and we'll talk about this. I love that because that means we're all learning together. So sodium and potassium pumps are going to fail, and that leads to the sodium and the water, right? Especially inside of the mitochondria. Okay, and so that the pumps shutting off causes swelling. Can we all agree about that? And that's the earliest morphological sign of cell injury. And this is actually still potentially at this point reversible. And if the ischemia persists, then it progresses to irreversible injury. And the irreversible injury is where membrane damage and necrosis kicks in. Okay, so fibroid necrosis, this is going to involve the immune complexes in the vessels. For instance, PAN or malignant hypertension, right? This is not seen in the myocardium. This is in the vessel walls, not the myocytes. And so not fibrinoid necrosis. Mitochondrial swelling is indeed the correct answer, as we've discussed. Coagulative necrosis is a good choice there. Iqbal. However, coagulative necrosis is what we think of with, like, an infarction, but it's delayed, okay? We're talking about the very first one within minutes. Okay, so this is power failure at the cellular level. Mitochondrial swelling is the first sign of reversible cell injury. Loss of ATP leads to pump failure and cellular swelling. Okay, the first observable change is mitochondrial swelling, a hallmark of reversible cell injury. This occurs minutes after loss of oxygen due to ATP depletion. Those are the trap answers as we discussed, so feel free to pause this. Here's the lay of the land, guys. You need to know the timeline and morphology. The buzzwords ST segment elevation is the transmural myocardial infarction, and it's going to involve the anterior wall as the LAD. Mitochondrial swelling is the first sign. Coagulative necrosis is irreversible and it's later. Aging is lipofuscin, and apoptotic bodies are not involved in ischemia-induced necrosis. Okay, here's the pathophysiology, and here are the key features for this particular question. And now here is the bottom line. Mitochondrial swelling is the earliest cellular stage in cardiac myocytes following ischemic injury. So we have the swelling of the endoplasmic reticulum. Okay, that was a good question. Okay, for our next question, I want you guys to think about sodium. Sedal says there's a change in the camera angle. Yeah, that's right. I have 3 cameras, and I'm thinking about using them more. All right, folks. 3, 2, 1. New question. Here it is. A 45-year-old man with a history of hypertension is placed on a low-salt diet to help manage his blood pressure. Okay, so low-salt diet. That's why I prompted you to think about sodium. After 2 weeks on this diet, lab studies show an increase of a particular hormone. His blood pressure reads 130/85, and he reports feeling lightheaded. Which hormone is likely elevated in response to these changes? What do you guys think? Aldosterone, says Sedal. And yes, indeed, the answer is going to be aldosterone. You have it correct. So there's a hormonal response to sodium depletion. We get aldosterone increase of the sodium reabsorption. And so low salt reduces the extracellular fluid volume. Renin is released from the juxtaglomerular cells to increase angiotensin II, which stimulates the zona glomerulosa of the adrenal cortex to make aldosterone. And that enhances sodium reabsorption of the distal nephron, promoting water retention and helps to maintain the blood pressure. And then that lightheadedness comes from compensatory mechanism and early volume depletion. Cortisol is not going to be affected here. Parathyroid hormone secreted in response to hypocalcemia. Insulin responds to hyperglycemia. And thymosin is involved in T cell maturation in the immune. So here's how the blood pressure is balanced. Renin, angiotensin, ADH, natriuretic peptides. Here are the associations. And Kohn syndrome is the opposite scenario. That's where you have high aldosterone without the renin activation. Low sodium intake means that the extracellular or the ECF volume is decreased. So the effective circulating volume is decreased. Even though the total blood volume may not drop dramatically, the kidneys are sensing lower sodium content. So it's kind of like pseudo-hypovolemia. And the sodium is sensed by the macula densa and the distal tubule. And that's what leads to the renin release through the juxtaglomerular cells. Okay, macula densa. And then renin cleaves angiotensinogen into angiotensin 1. And then that leads to angiotensin 2 through ACE. And that causes vasoconstriction. And it stimulates aldosterone release from the zona glomerulosa. So it's the macula densa that senses the sodium in the distal convoluted tubule. And then the ENaC channels are inserted by aldosterone. And remember that wherever sodium goes, water is going to follow. Right? Sodium is the major extracellular cation. And so you lower the sodium intake, then you're reducing the total extracellular sodium content. And so then you have less osmotic pull on the water. And so the extracellular fluid volume, the ECF, the extracellular fluid volume goes down. All right, here's the bottom line. Aldosterone levels rise due to low salt diet, causing lightheadedness from potential orthostatic hypotension. All right, this should say 73. Here we have a 68-year-old man is evaluated in the emergency department after experiencing sudden onset of severe right shoulder pain and shortness of breath. The patient is a longtime smoker with a 60-pack year smoking history and has been experiencing hoarseness and weight loss over the past 2 months. Physical examination shows ptosis, meiosis of the right eye, decreased breath sounds, and clubbing of the fingers. He has a large mass of the right lung apex. Which of the following is the diagnosis? So this is Horner syndrome and also shoulder pain, which makes us think of an apical lung mass. And so smoking and hoarseness and clubbing leads us to think that this is probably a paraneoplastic concern. So what are you guys thinking in the chat here? Smells like a Pancoast tumor, says Sedal. Very nice. And you can see actually in the chat, in fact, if I can grab that real quick and refresh, there we go. I've made it more opaque. So now you can see Sedal's chat in the top left. Later, I'm going to add the YouTube chats as well, so you guys can all kind of talk to each other. But indeed, this smells like a Pancoast tumor, and it is. This is Pancoast tumor, superior sulcus tumor. And so they have the Pancoast tumor, which is a carcinoma on the lung apex, which invades local structures. Ptosis meiosis suggests Horner syndrome due to the sympathetic chain compression. The shoulder pain and decreased breath sounds are due to the brachial plexus or rib involvement. And hoarseness is the recurrent laryngeal nerve impingement. Smoking history and systemic symptoms of weight loss and clubbing support a diagnosis of lung cancer. Okay, why is it not the other ones? Adenocarcinoma would be in a peripheral location in non-smokers. Large cell, poorly differentiated, and also aggressive, could be both, but does not classically invade the sympathetic chain or cause Horner syndrome, should not be associated. Small cell lung cancer. This is a paraneoplastic syndrome, central tumor known for SIADH and ACTH production. Paraneoplastic syndrome does not cause an apical mass or Horner syndrome. Squamous cell carcinoma has a central location in cavitations. Central, and it may present with hypercalcemia due to the parathyroid hormone-related peptide, but not Horner syndrome or shoulder pain. Can cause hypercalcemia, though, is what's important about squamous. So Horner syndrome, there's that triad of ptosis, meiosis, and hydrosis, and that causes the disruption of that sympathetic chain. And apical lung tumors like the Pancoast are usually non-small cell, they're often squamous cell carcinoma, and these are located at the lung apex, which is like the superior sulcus, Horner syndrome. And so our next question that we're on is question, well, I guess 23, this one was on the squamous, right? So we already covered this. And hopefully I'll be able to stream for another good like 8 or 9 hours today. Squamous cell. So that is centrally located. And for centrally located, you should think of squamous and also small cell. And squamous cell is the more common subtype, and it's associated with these polygonal and keratin pearls. All right, here we go. On to our next question, which is almost ready. Our next question is 74. And for this question, I want us to think about the kidney and all of the pathologies that are common and heir that the kidney is heir to. So let's say we had some ischemia, and I know we can't see the question yet. I'm just priming you guys. Let's say we have some inflammation, and let's say you have some infectious etiologies. Okay, what should that make you think of? Now, without further ado, let's dive into this question. So you walk into your clinic and you see this woman up here, and a 35-year-old woman has a history of type 2 diabetes, and she has sudden onset sharp flank pain and also visible red urine. She has no history of recent infections or trauma. Her medications are metformin and aspirin, and her temperature is at 98.6. Blood pressure is 130/82, and a pulse is at 85, and a respiratory rate is at 16. Lab tests reveal a creatinine level of 1.2 and a blood urea nitrogen at 15. Hemoglobin level is 13.5. Urinalysis shows hematuria and the absence of these red cast cells. A non-contrast CT scan of the abdomen shows an area of low attenuation in the renal. Which of the following is most likely the cause of her hematuria? What do you guys think? Basically, we got some important facts, which are, yep, Sadal is saying renal papillary necrosis. Why do you think that? You're absolutely right. Renal papillary necrosis, this is when you have an ischemic injury at the papillae. This is often in diabetics, and she does have diabetes. That's why we highlighted that. So it's in diabetics, also sickle cell patients, and also NSAID users. All right, so those are some important risk factors. Also, what you should know about other associated conditions like pyelonephritis is an infectious inflammation with white blood cell casts. And stones, that causes like the hyperdense calcifications, and polycystic kidney is inherited cystic expansion. And then we have to know all of those things. But here, diabetic patient. Oh, and then Sadal is giving us a cool mnemonic. And let me actually expand the chat here so you guys can all see the chats as they come in, like that maybe. Let me change the properties. So as Sadal said, there's a mnemonic for, I'll write this out. This is a really good mnemonic. Sad Papa, okay? With 2 A's. So this is going to stand for sickle. Yeah, the sickle cell trait or the disease. A stands for acute pyelonephritis. The next A stands for analgesics, especially NSAIDs. So sickle, analgesics, acute pyelonephritis. D stands for diabetes mellitus. P, I guess, does the P stand for like a really old analgesic? And then A stands for acute obstruction. And then P stands for the papillary necrosis. Is that right? PA, papillary necrosis. Okay, the PAP stands for papillary necrosis. Because there's this old, which is like an analgesic, so maybe it relates to that. But yeah, sickle cell, acute pyelonephritis, analgesics, diabetes, and then PAPA. Sad Papa. Sad Papa. Sad Papa. Sickle cell, acute pyelonephritis, analgesics, diabetes, and then PAPA is papillary necrosis. There's also like analgesics for acute obstruction, but this is just PAPA. PAPA stands for papillary necrosis. And so diabetes has painless hematuria and flank pain, and there's also low attenuation in renal medulla. It's the hallmark of renal papillary necrosis. So diabetes is a well-known cause as well. due to the microvascular compromise and increased susceptibility to, okay, so that fever and white blood cell cast is going to be the key. Afebrile, they lack the renal artery stenosis, hypertension, and atrophic kidney, and bilaterally enlarged would have multiple cysts for autosomal dominant polycystic kidney disease. Ureterolithiasis would have colicky pain. Also, yeah, that's crazy. Crescent donated $50. That was so nice of him. Like, unbelievably kind. Okay, and so just to kind of parse out, or just to clarify anything here, why the answer is renal papillary necrosis and not pyelonephritis? Like, why is it C over A here? And especially because we just listed out this awesome mnemonic, right, as causes of papillary necrosis, but these are not necessarily like alternative diagnoses, right? So acute pyelonephritis can cause renal papillary necrosis, especially in diabetics. But when you see pyelonephritis as an answer choice, you should think, is this the infection itself, or is this like a complication of it, right? And this person has no signs of infection. Their temperature is normal, white blood cells normal, urine analysis has no white blood cell casts, right? And there's no pyuria. And so this is not an infection, right? And pyuria is like the presence of pus in the urine. And so therefore, this is acute pyelonephritis it's going to be ruled out. Acute pyelonephritis is ruled out here. All right. And also the imaging has that low attenuation in the medulla. And so papillary necrosis is ischemic coagulative necrosis in the papillae. And pyelonephritis is a neutrophilic infiltration in the cortex in the medulla. It's often wedge-shaped and does not have low attenuation in the papillary lesions. So diabetes is a major predisposing factor for papillary necrosis, is the most important thing to think about here. All right. I caught my iPad before it just fell. You probably saw that when I shifted scenes here. But basically, a sudden flank pain and hematuria in a diabetic patient suggests renal papillary necrosis due to ischemia. Okay, so that's what's going on in this particular question. And now we will go to our next one, which is question 25. Let me just sit up differently in my chair here. Question 75. Here we go. Wait a second. The overlay still has not refreshed. I just ran a command to try to get a better photo. Just give me 1 second, guys. Let's do a quick lock-in for 10 minutes while I fix this bug. And whoever comments in the next 10 minutes is going to get a tomato. So this is potentially Fatty Liver King has an opportunity to get to 10, which is exciting. Sedal is going to get a tomato. I love this community that we're building together. This is so fun. Sedal, I'm really grateful for you. It's made this whole enterprise just so much more fun having you around. Hey, Clear Prodigy, listening to the stream in the gym. I'm glad you had a good exercise. Thank you for saying I'm a great teacher. I appreciate that. I'm really, really happy that you had a good workout and were able to spend some time with us. So hopefully you have an awesome Sunday. Thanks for joining. 3, 2, 1, blast off. So a 25-year-old man presents to the emergency department. And I recognize this is not a man, but I'm doing some coding and the next one will hopefully be amazing. They have recurrent bouts of nosebleeds and small red spots in the skin. They have a medical history of recurrent upper respiratory infections. On examination, he exhibits several petechiae over his arms and legs, the significant difficulty of coordination that he reports being worsening over the past few years. His pulse is 80 per minute, blood pressure is 118 over 75, and he has a clear young lung fields. Lab studies reveal mild thrombocytopenia and low serum immunoglobulin levels. Imaging studies show mild cerebellar atrophy. His younger sister is also noted to have similar symptoms. Given the clinical presentation, a defect in which of the following processes is most likely responsible for his condition? Okay, so in this particular condition, we should know about Ataxia-telangiectasia, and that is an autosomal recessive disorder. A is what David says. Why do you think that it's A? I love that you're positing out there. And for those on YouTube who are watching later, David is actually not a medical student, but David is here to learn. So A, activation of proto-oncogenes. Let's talk about that one. So a proto-oncogene, if you have an activation of a proto-oncogene, then that's going to be a gain of function mutation. And so typically proto-oncogenes are like RAS or MYC, right? And these guys promote cancer, essentially. But this particular patient's underlying issue is defective DNA repair that leads to instability, not proto-oncogene activation. Yep, David's going to be an MD in several years. And then DNA repair is what Sedal says. Ragnamori says C. You're right on the YouTube. Sorry if I botched your name on the YouTube. David, you will get the MD soon, but today is not that day. You have misdiagnosed somebody and now they have died. But good try. Good try. The answer is DNA repair. Yes. So this is ataxia-telangiectasia, and this is an autosomal recessive disorder that's caused by mutations of which gene? The ATM gene. Yeah, A is the new C, says Sedal. I love that. Guys, I love how supportive this is. I love it. Ataxia-telangiectasia, autoimmune recessive disorder caused by mutations of the ATM gene. DNA double strands break repair. And so it says in the name, right? Ataxia-telangiectasia is in recurrent sinopulmonary infections, and you have increased risk of malignancy. Okay, so this is a DNA repair mechanism. And what else gives this away? Basically, they have a triad of cerebral ataxia. They've got ataxia and telangiectasias, which are like the spider angiomatas. And so the ATM gene is going to cause the failure to repair the DNA. All right. So moving down here are the trap answers. We discussed this one. Cancer proliferation predominantly causes the cancer. Immune system activation. Autoimmune diseases, overactive immune response. This patient is immunodeficient, not hyperimmune. Apoptosis regulation. So that's the BCL2, cancer cell survival. Lipid metabolism, Niemann-Pick, and Tay-Sachs are going to be associated with those. All right. And RAG is saying non-homologous. Yeah, very nice. Non-homologous end joint repair. Very good. So you're exactly right. Ataxia-telangiectasia is going to be a defect in the non-homologous end joining. And so this is the DNA repair mechanism that fixes the double strand breaks. So basically, normally when the DNA strands are broken, like let's say, for instance, we have ionizing radiation, then the ATM protein is going to activate 53, right? P53, and that recruits the DNA repair mechanisms. So ionizing radiation, oh no, here's my DNA, it's broken. Now we're going to activate P53, and this recruits DNA repair mechanisms. Well, this non-homologous repair, this stitches the broken ends back together without needing the homologous template. And so this is super fast, but it's error prone. And so it's essential for making genomic stability in non-dividing cells. And so in ataxia-telangiectasia, you have an ATM mutation, and then there's a failure to detect that double strand break. And so you have defective non-homologous end joining. And so there's an accumulation of mutations, neuronal death, chromosomal instability, and you get ataxia-telangiectasias, immunodeficiency, and cancer risk as well, like lymphomas and leukemias, right? So ATM, it keeps the DNA in one piece, right? If you lose it, then the ends aren't going to join anymore, and you get ataxia-telangiectasias, recurrent infections, all of that stuff. So really, really good job, Rag, Seidal as well, and David. Really good job, everybody involved. Okay, let's see our bottom line. Recurrent nosebleeds, cerebellar atrophy suggests hereditary condition likely due to DNA repair. You guys ate that question up. Really good job. Nom, 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 nom. Very good job. All right, now on to our next one. We're on 76, guys, and only 24 more questions until the end, until we have a little break, right? To do more, we can do 100 more questions after this. I plan on streaming the large portion of the day. So here we go. Almost ready for our next question. The topic on this one is going to involve a little bit of anatomy, and particularly we're going to be involving the bursa. All right. And to give you the lay of the land here, we're going to talk about hip pain as well. How do we localize hip pain? And also we're going to talk about some neurologic findings. And guys, fingers crossed here, because I just changed the code, so it might have broken. And if it broke, then that's not good. Oh my gosh, it worked. Now my question is, do we have two images for a man though? We don't. There's only one image. So let me try to fix this. Nice, guys, look at that. Look, the code worked. Oh, that's so cool. Do you guys think that we should have them all going together, like changing, transitioning at the same time? Or should they be going like asynchronously? With that, I'm really pleased that that worked the first time. So here we go, guys. We have a 54-year-old man presenting to the clinic with a 2-week history of localized pain. Seidal says, awesome. Yeah, I'm glad it's working. Localized pain on the outside of his right thigh, which gets worse when he lies on that side of the bed, okay? So that outside of the right thigh is what you can see on the second image, and you can see that it's a 54-year-old man. And he denies any history of trauma or overuse. And on examination, there is noted tenderness and palpation of the lateral aspect of the right hip, which you can see in these diagrams here. And so the patient exhibits pain during hip abduction against resistance. Okay, so that's important. Abduction, and his hip joint range of motion is normal and not associated with pain. There's no warmth or erythema over the affected area. Based on these findings, which of the following is the most likely diagnosis? Okay, what do you guys think? So we have lateral hip pain. There's tenderness to palpation over the greater trochanter. So that should help. Basically, if the hip pain is lateral and it hurts whenever you lie on that side, then you should definitely be thinking of the bursitis, right? Trochanteric bursitis, which is the answer to this question. So they have point tenderness over the greater trochanter, and there's normal joint motion, and there's pain there's pain whenever you resist the abduction. So all these hallmarks are of a swollen bursa under the gluteus medius. And so if this were osteoarthritis, the pain would be deep. And where would it be? It would be in the groin, deep in the groin with stiffness. If this were myalgia paresthetica, then there would be numbness and tingling. And so this is just like basically an extra articular inflammation. It's not a joint or a nerve problem. And let me know if you guys like this new format. Seidal says the normal joint motion and tenderness is a big clue. Yes, indeed. So pain when you're lying on that side is trochanteric bursitis. Hip osteoarthritis would have morning stiffness and the pain that worsens with activity. Myalgia would have the burning. A radiculopathy would have the shooting electrical pain, and that would have the positive straight leg test. It's like pain that radiates down the leg. And the iliotibial band syndrome, this guy right here, that would be involving the lateral knee, not the hip. And also there's pain during like running and cycling. So this is like the runner's knee, is the iliotibial band syndrome. David says he'll participate in the next question. Sounds good. Also, feel free to lock in if you need to lock in and do your own stuff. You don't have to learn all this medical content. You're just becoming a doctor for fun, which is crazy. I love it. So hips don't lie. Shakira, right? Trochanteric Bursitis, inflammation to the bursa, presents with lateral hip pain. Tibial is the runners, as we talked about. Neuralgia. Paresthetica is the burning of the lateral thigh. And that's due to compression of the lateral femoral cutaneous nerve, sensory only, no tenderness or weakness there. And just to kind of highlight what neuralgia paresthetica is, this is a mononeuropathy that's caused by compression of the, as this says here, the lateral femoral cutaneous nerve, and purely sensory, and it's over the anterior lateral thigh. And because it's sensory only, there's not going to be any muscle weakness, just burning and tingling and numbness on the outer stuff. So that's the reason why that's the wrong answer. All right, here's the lay of the land. So your range of motion and focal tenderness, sensory changes would be neuropathic, lateral hip pain, bursal involvement. Okay, so here's the pathophysiology. Repetitive friction of the gluteal tendons over the greater trochanter, inflammation, unpressure abduction of the gluteus medius, stretches over the inflamed area. All right, here is the bottom line. Trochanteric bursitis is characterized by lateral hip pain and exacerbated by lying on the affected side and hip abduction. Okay, on to question 77. Now, this is going to be an ethics question, still very important, but we're going to hit at the general principles here. And just to orient you guys on this question before we dive into it. And honestly, I used to not like these ethics questions. I used to think, okay, they're just so silly, but now I'm actually realizing they're very important. And also they're good for relationships too. And here's the principle that I want you to follow on this question, because you should always load your head with a principle and then pick according to that principle. Don't just try to adjudicate based on the particulars of like some weird scenario, unless there's actually like a rule that you have to abide by, but rather think about like a general principle and then aim for the correct answer choice that way. And so here, think about being direct and also being compassionate. So she noticeably is anxious and requests immediate reassurance. She has no significant past medical history, and there is a 2 centimeter firm non-tender mass, and she asks, is it cancer? Okay. Yeah, this is a good question, right? Because does she have cancer or doesn't she? And David's asking a lot of really good questions here, which I'll cover on. And Sedal is asking David to respond. You guys can see the chats. This is really funny. Sedal is actually in our program here, and David is doing his best to kind of grapple with this as a physician. So let's ask David what he would do. David, I'm not going to tell you the answer yet. Let's ask David what he would do. Okay, David says not A. Okay, David says D. Sedal says D is the answer. Okay, yes, it seems like it could be cancer, but we'll have effective treatment options. Okay, let's look at what the answer is. Real talk, reassuring medicine. It is actually A. We need to perform a biopsy to get more information, but it is possible. So we need honest yet non-alarming response that respects their anxiety. Biopsy is the gold standard for breast mass evaluation, which we have to do. They have to get the truth. Saying don't worry, that's false reassurance. Also, you mentioned D seems like a cancer. We need the biopsy to have confirmation, lest we have the undue anxiety. It's okay, David. It's okay. I love you're trying to reassure the patient. And I think that's a beautiful trait that you have there. Yes, it likely is cancer. That's a definitive statement. It's unlikely to be serious. That's premature minimization. Basically, we can't make any claims about it until we actually have the full data. Clear Prodigy says they're going with A, and Clear Prodigy is indeed right. Very nice, Clear Prodigy. And you guys can't see the YouTube chats up there yet, but they'll come eventually. And so imaging insights for this particular condition, right? Mammography, that detects the microcalcifications of the irregular densities. There are limitations though. This is less sensitive in dense breast tissue like menopausal women. And if it's inconclusive, then we'll need a core needle biopsy or an ultrasound, right? Mammography is a screening tool. Biopsy is the diagnosis, right? Mammogram is a screening tool. And so the buzzword kind of thing here is that firm, immobile, non-tender mass in the upper right quadrant, you should think it's malignant until it's proven otherwise. And a mammogram inconclusive, the next step is definitely going to be a core needle biopsy. And so you have to have diagnosis of breast cancer with histological confirmation. And so the patient reassurance, you have to be honest. You can't say yes or no. You have to be empathetic, and you have to explain the next steps, right? Paul says, at least you didn't spend money on med school. I did and still got the wrong answer. That's so funny. That is actually really, really funny. And now David is asking, why can't a mammogram be inconclusive? Excellent. Yeah, that's a good question. So a mammogram is essentially just an X-ray of breast tissue. And its ability to distinguish between abnormal structures depends entirely on the differences of tissue density. And so those contrasts are kind of harder to read, I guess. And so it's inconclusive or indeterminate because dense breast tissue in younger women, and sometimes older women who naturally have more like fibroglandular tissue, it can kind of give you like a false positive, I guess. So like on X-ray, fibroglandular tissue and tumors, they both appear white. And so how do you know that it's not just blending in with the background density? And so in contrast, fatty tissue is dark, and that's like better contrast, right? And so decreased mammographic sensitivity in dense breasts, you have to ultrasound. So if they have dense breasts, you might have to ultrasound and get an MRI. That's the reason why. David also asked another great question. Is there a world in which the mass could not be cancer? Yes. 100%. And that's the reason why the answer is not telling them that it is cancer or that it's not cancer, right? Because even though you hear the words, you're like, oh my gosh, I have a breast lump. That sounds super ominous, right? And the majority is non-malignant. The majority are non-malignant, which is why it's unlikely to be serious, is what Seidel was saying. What matters, though, are the clinical features, right? So the age, pain, mobility, borders, and histology. So fibroadenoma is the most common benign tumor, and this is typically in women who are under 35 years of age. So looking at her age, she's 45 though, right? And so fibroadenoma is the most common. It's super benign, so it might be nothing, right? And that's a firm, mobile, well-circumscribed. It's just a rubbery mass if they're under 35, fibroadenoma, and this is hormone sensitive. So this can enlarge with estrogen and during pregnancy. And so if this woman were in her 20s or her 30s, then yeah, that's our topic differential. It's like no big deal, no problem. But then if we're in 30 to 50 range, these are the fibrocystic change ranges here. So this is premenopausal still. You have cyclic breast pain and the lumpy nodules. Here it's like cysts, fibrosis, right? That kind of stuff. It could also be a fat necrosis, right? Any age, firm irregular mass, right? It could totally be that. And intraductal papilloma, that could also be like a small tumor in the lactiferous ducts near the nipple, and that causes bloody discharge, and that's benign. So to answer your question, David, yes, it could be a whole host of non-problematic or benign things. And you also asked, is biopsy cutting her open? Not usually. Modern biopsies are actually pretty minimally invasive, and there are different types, right? So there's fine needle aspiration. That's where you use a little thin needle, and you suck out a few cells for cytology. And this is quick. You can do it in the office, right? It's just minimally, it's not even it does not cause a lot of discomfort. And this is really good for simple cysts and nodules. But the problem is you can't access the tissue architecture, and so you can really miss these early cancers. There's also a core needle biopsy. So juxtapose the fine needle with the core needle, and this is going to be the most common step in this particular case, right? And that's where you use a larger spring-loaded hollow needle, and you remove tiny tissue cores. And this is done under local anesthesia and imaging guidance with ultrasound. And this provides the actual tissue architecture, and so you can actually see if it's benign or malignant. So you need a core needle biopsy that's definitive diagnosis for breast cancer, not mammography. And you actually do have to have a tiny puncture wound for this one. So you're right about that, David. It is operating to some extent. But what you're probably thinking about is the excisional or surgical biopsy. And that's where you have a small open surgical incision and you have to remove the entire lump or the suspicious area. And that's usually done after you do a core needle biopsy and you're like, oh my gosh, this is malignant. And that requires minor sedation and anesthesia and it leaves a small scar. That's probably what you're thinking of. And that's what like on house, that's what they always do, right? And what else? Seidel says, yeah, they call it a breast mouse because it moves. Yeah, that's true. Breast mouse is a fibroadenoma. That's benign, and biopsy is definitely needle-based usually. Does that answer all these questions? Now let's go to the bottom line. Biopsy is essential to determine if it's a breast lump is cancerous despite inconclusive mammogram results. Okay, moving on. 78. I want to draw this one out. Who knows what this is? Seidel Khan. Seidel says, well played. Lips. David is correct. These are lips. David, you have redeemed yourself. David has redeemed himself. Do you see what I've drawn on said lips? What have I drawn? Seidel, do you know what this is? Do you want to hazard a guess? Got some spots? Maybe what if I said they got some polyps? What if I said we got a little bit of a risk of a cancer? Are you thinking of anything? Herpes? Pease-Jager. Yeah, you got it. 100%. Pease-Jagers. Nice. Well done. Well played. Well played, good sir. Well played. Okay, let me refresh this page. I got them moves like Jagger. Nice. Yes, it looks like HPV. Okay, we'll talk about HPV and we'll talk about Pease-Jager after this, but you're right. I did not do it justice. Guys, look at this. Isn't that cool? You can see the patient over here, and then you can see it zooms in on her diagnosis. There it is. Boom. Kind of cool. All right, so we have a 24-year-old woman visiting her primary care physician with a 3-month history of intermittent abdominal pain and also some constipation. She's got the dark spots on her lips, as I've drawn there, and inside her mouth that have been present since childhood, but they now have become more prominent. And her family history is significant for an uncle who has a GI cancer at a young age, and they have multiple pigmented macules and buccal mucosa and fingertips that have the multiple pigmented macules there. And she's got some small polyps in the small intestine. Which of the following does she have? Okay, so this is a young woman. She's got the mucocutaneous hyperpigmentation, so the dark macules in the lips and the mouth and the fingers. And she has multiple hematomatous polyps in the small intestine. That's Pease-Jager's. All right, so there's autosomal dominant condition, and this is caused, you don't really need to know this, STK11. David's going to go ahead and say C. You're right, David. Nice. Well done. Good. After we've said it. But you're so right. Familial adenomatous polyposis, that has hundreds of thousands of polyps in the colon. Just tons of them, right? Hereditary non-polyposis colorectal cancer is Lynch syndrome. So that's like fewer polyps and endometrial cancer due to DNA mismatch repair. And Korsakoff syndrome, juvenile polyposis syndrome. This is hematomatous polyps in the colon and the rectum. This is age less than 5, and there's no mucocutaneous spots. Okay, there we go. So now we got some questions in the chat that I want to hit, but here are all the answer choices that you can kind of choose between. The lay of the land, here are all the buzzwords, here are the associations, here's the pathophysiology and the key features. All right. So Peutz-Jeghers can present in childhood with nothing more than freckles, but they're not freckles, right? They appear on the lips and the mouth and the fingers, and they're also paired with hematomatous polyps in the GI tract. Okay. And so the clinical management of this is you just kind of have surveillance for GI polyps and cancers, and also pancreatic cancer screening starting at age 30. And you have regular breast and gynecological exams for women and genetic counseling. And yeah, you're right. Seidel says this is indeed relevant. What you should know for step 1 is that Peutz-Jeghers is going to be harmless spots and benign polyps, but there are some dangerous, cancer risks that you should be aware of. Basically, they're hematomatous, right? And that literally just means benign overgrowth of normal tissue. They're not true neoplasms in the sense of the word. It's all the same tissue elements that are present. They're just arranged abnormally and they're growing in excess. So they're like, for instance, the hematomatous polyps, they're normal mucosal glands and connective tissues. They're just disorganized. And so they don't actually invade the surrounding tissue, right? They don't cause metastasis. They don't cause local problems. So in that sense, they're not dangerous, but it still does matter, right? Because even though the polyps are hematomas, the gene defect, the STK11 defect, acts like a tumor suppressor loss. And that actually raises the cancer risk throughout the GI tract and other organs. So yes, you're right, it is benign, but the genetic cancer predisposition is still there. And so that's why you have to screen with increasing regularity. So yes, they're benign, but Peutz-Jeghers is a cancer predisposition syndrome. All right, here's the bottom line. Patients' lips and mucosal pigmentation with intestinal polyps suggest Peutz-Jeghers syndrome. All right, moving on to 79, we'll go to 80 and we'll have a quick break. Just a tiny little break. Gotta move around in my chair, good for my health. Are you ready? 3, 2, 1. All right, in this question, we have a 28-year-old woman presenting to the clinic with a prolonged fever, night sweats, and weight loss over the past 2 months. She has a history of intravenous drug use, but is currently in rehabilitation. Physical exam shows generalized lymphadenopathy. Lab tests show CD4 positive T lymphocyte count of 320, and her viral load assay is positive for HIV-1. So she has HIV. And cytometry shows the predominant strain of HIV in her blood binds to the CCR5 receptor. Given the trajectory of HIV infections in the past, which of the following cell types is most likely serving as a major reservoir for the virus? What do you guys think? So I've already highlighted this important word here. All right, so HIV, how does it work? Autoimmune condition that's transmitted sexually and through infected blood. Nice. HIV, C. Yeah, you nailed it. Good job. Yeah, David got it even before Seidel. So HIV, human immunodeficiency virus, is what we need to know about this is that it's enveloped, single-stranded, positive sense RNA virus. And it belongs to the lentivirus genus of the Retroviridae family. It's a virus that causes AIDS, is acquired immunodeficiency syndrome. And if HIV is untreated, it causes AIDS. HIV-1 is the most common worldwide. 2 is mainly in West Africa. Okay, so there are some genes that you have to know. There's one gene, which is ENV. And the product of the ENV gene is you get GP160, which is then cleaved into GP120 and 41. And the function of GP120 is that it binds to the CD4 co-receptors and it mediates fusion. Okay, so the ENV is for attachment and fusion. All right, attachment and fusion. Harold, hey, thank you so much for the gifted subs. I really appreciated that. Discord, yeah. You can use the command Discord and it should pop it there for you. And we're setting up the Discord too. David is actually a mod on the Discord. So David can help you navigate that as well. Okay, so ENV is for fusion, and it's through those GP160s, the GP120s, and the 41s. And then here's the GAG. GAG, okay? I don't know if David likes this one. P24 and P17. And this is for the caspid and matrix proteins, and this is the diagnostic antigen, P24, diagnostic. And you can remember this diag for GAG. Diag for GAG. P24, diag for GAG. You have to attach and fuse so you can get into the environment, and it's diag for GAG, okay? That's how you remember those. And then there's also the POL, P-O-L. David, you crack me up, dude. POL, reverse transcriptase integrase protease, right? These are viral replication enzymes. They are the target of ART, so protease inhibitors. Okay, so how HIV works is that the GP120 from ENV binds to the CD4 receptor on a host cell. And these host cells are, you already said the correct answer, macrophages, predominantly T cells though, and dendritic cells. But in order to do that, it needs a co-receptor, right? And so you have CCR5, which is a macrophage trophic early infection. or a CXCR4, which is a T cell, trophic, late infection. So early macrophage, late is going to be the T cell, tropic, not trophic. And so GP41 right here facilitates the fusion. So it fuses and then it enters the cytoplasm. And then reverse transcriptase converts single-stranded RNA into complement DNA. And then this cDNA is double-stranded and ready to integrate. And then viral integrase inserts into the viral DNA in the host genome, and now it's inside the nucleus. And this is called a provirus, right? Because it can stay latent for years in macrophages and memory CD4 T cells. And so when the host cell is activated, the proviral DNA is transcribed and the new viral RNA and proteins. And then you get AIDS. And this is when you have your CD4 count all the way below 200, okay? And so now it's AIDS-defining illnesses, opportunistic infections, cancers, Kaposi, NHL. Very, very sad. Okay, so the treatment targets different steps. We have reverse transcriptase inhibitors. These block the RNA to DNA conversion. There are integrase inhibitors. They block gene integration. There's protease inhibitors. They block the maturation. There's fusion, and that blocks the GP41s and the CCR5 interactions. And so typically what we recommend is a combination therapy. HAART, usually 3 drugs, and that suppresses the viral load and it restores the CD4 count. Okay? Everything you need to know about AIDS, and then macrophages shares this receptor in common as well. Okay, here's the bottom line. Macrophages serve as a major reservoir for AIDS, especially in patients with CCR4 tropic stains. Hopefully this was a good overview on AIDS. Yes, always wear condoms. I have to go back just so we can see that comment. David says always wear condoms. Good, David. That is our public service announcement from David. And then don't share needles. CBFA1, what is that associated with? And here, just by knowing the associations, you could probably guess what I'm going to be asking you. So I'm putting this on the screen so you guys can guess beforehand. You see this word on test day. What are you thinking? Which words are kind of radiating in your mind right now? Panic, says David. Panic is radiating in the mind. There's one word that should definitely be present. Yep, the word that David is thinking is, oh, I'm in the wrong class. That is funny. Yes, I feel ya. All right, so here the word that I'm looking for is osteoblast. And the image for the AI patient has not changed for this one. I apologize for that. But the word associated with one is osteoblast. Hey, Purple Perps. Hello, good morning all. Hope everybody's doing well. Hope you're doing well. It's been a wonderful morning. All right, so here we have a 35-year-old woman presented to the clinic with pain and recent fracture of her left forearm following minimal trauma. She reports a history of frequent bone injuries over the past few years. So she has frequent bone injuries. Okay, so 35-year-old woman presents to the clinic. She has pain and recent fracture of her left forearm. History of frequent joint bone injuries over the past few years. Physical examination reveals blue sclera. And now also we have the DEXA scan reveals low bone density. And genetic testing identifies a mutation affecting the transcription factor involved in bone formation. Which of the following types is most directly impacted by this genetic mutation? Okay, so blue sclera, all this stuff makes us think of osteogenesis imperfecta. And we have to know that that's associated with osteoblasts. All right, so the patient has osteogenesis imperfecta, a collagen synthesis defect. Osteoblasts derived from mesenchymal stem cells are the primary bone-forming cells and are directly impaired. The transcription factor here, RUNX2 and CBFA1, are essential for osteoblast differentiation. Mutations impair osteoid production and lead to fragile bones. Normal calcium and phosphate distinguishes this from metabolic bone disease. Myoblasts involved in muscle, not bone. Fibroblasts may connect to tissue. Osteoclasts reabsorb the bone. And chondrocytes regulate cartilage growth. So to solve this, you have to recall bone forming and bone reabsorption, osteoblast build, osteoclast take, and collagen 1, brittle bones, osteoblast activity, blue sclera, and underlying chorioid. Okay, and here is the takeaway. Osteoblasts are directly impacted in mutations affecting bone formation, leading to low bone density and frequent fractures. I know. Okay. So basically the notes here is blue sclera, scleral thinning and collagen defect is important, and low ALP, because that means you have decreased osteoblast. So ALP is connected to the osteoblast formation. Are we familiar with Kaplan-Meier estimates? It's for prognostic data for people who have new diagnoses, okay? So basically how this looks is you have some sort of a chart, and on this chart they'll say like, okay, in this first year, and then like the second year, or like I guess it'd be 1 to 2, and then 2 to 3, and then 3 to 4. And basically all you have to do is look at each year individually. That's the secret to all of these questions. So the probability that somebody with a new diagnosis like lives or dies, you just have to look it up in the actual graph. And so let's say here that we have a probability, and I'll actually share this image now, and we'll see if this is correct or not. Here we go. All right. So we have a study assessing the survival rates of patients undergoing a new treatment for chronic lung disease. I'm going to turn my microphone up just a smidge. I think that's better. The participants are followed over a 4-year period, and the following data is gathered. So after 1 year, we have 600 patients that started. And then the next year we have 480. And then we have 480 survived, 432, 388, and everybody's just dying. They're dropping like flies. So what is the probability that you survive through the entire year period? And here are the answer choices. So typically the way that this works is you have the percent survival in this interval. And so this is going to be 480 over 600. And that's going to be 432 over 480, so on and so forth. And what you do is you multiply these down, and that'll give you the probability of surviving all of the 4 years, right? So this is the cumulative probability. So cumulative probability, you have to multiply each probability by itself. So here are the probabilities that I was listing over there. This one's 0.8, this one's 0.9, that one's about 0.9, that one's about 0.9 as well. And so that all is going to multiply, and our answer is going to be D right here. If those answer choices are actually correct. Like if these are, that divided by that is actually 0.9, then literally what you do is you just multiply them across, and our answer is D. All right, some distractors, some partial revivers. Okay, sounds good, David. David's retiring from medicine today. David, our resident doctor, is now finished. So thanks for stopping by, David. Good seeing you. Good talking with you. Hopefully you have an amazing rest of your day with all of your sociology homework that you have to do. Thanks for stopping by. Good to see you. All right. Lay of the land. Survival probability is calculated through the 4-year period. Longitudinal study, data collected over time. Kaplan-Meier curve, stepwise. Biostats, vital for analyzing treatment and efficacy. Minimized survival rates are correctly conditioned per year. David's key takeaway is on HIV, Jaggers, and also the biopsies. Nice. Yeah, let's go. And then David's going to do surgery on somebody on the way home. All right. So the pathophys. Here we don't have any pathophysics really to kind of evaluate, but just knowing the probability is multiplied year by year. But I'm glad you're a subscriber now. Thanks, David. Hopefully you have a great day, man. A great rest of your 6 or 7 hours before you retire to bed. And here's the bottom line, folks. Let me just set up. Here's my laptop camera. Okay, so the bottom line is calculate survival probability by multiplying the survival rates year across year for the 4-year survival. We have a 52-year-old woman come into the clinic with fatigue, joint pain, and darkening of the skin over the past 6 months. She also reports increased thirst and frequent urination and fasting glucose level of 240. Liver biopsies performed, and we have which in a histological examination is most likely to demonstrate the excess of which of the following. And ferritin is at 1,200. Normal range is way, 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 way lower. Yeah, this is how you get the dopamine hits, man. You nailed it. You nailed that question. Holy cow. So this is indeed going to be iron, hyperpigmentation, diabetes, elevated ferritin. These are the classic signs of hemochromatosis, hemosiderin laid, and this is the Prussian blue stain. You completely ate that question up. So alpha, 1 antitrypsin, that's a pass positive globules in the liver. That'd be early onset and liver disease associated. Amyloid would be Congo, red stain, apple green bifringence, and copper is the Kaiser-Fleischer rings, neurologic symptoms, and triglycerides, macrovesicular steatosis, the fatty livers. Yep, so this is just hereditary hemochromatosis, excess iron deposition, so the Prussian blue positive, leading to cirrhosis and diabetes and skin pigmentation. All right, bronze diabetes, hyperpigmentation, and that's diabetes caused by iron deposition in the skin of the pancreas. And okay, the chats, this is how dopamine hits. I thought PAS was only carbs and lipids. Didn't know it did the proteins as well. Yeah, PAS staining, that's a periodic acid Schiff stain. And so it does detect the carbs in the carb-rich molecules, but it doesn't iron, I guess. The PAS, what was the PAS talking about for this one? It's talking about something else, right? Yeah, PAS positive is alpha-1 antitrypsin. So it definitely wouldn't stain the iron, but to visualize the iron, we need the Prussian blue stuff because it binds to the ferric iron, like the 3+, and it turns it blue. The PAS stuff is just talking about these globules in the liver, which is probably what you were talking about, actually. I thought for a second we were talking about the PAS positive with iron deposition. Lay of the land, iron metabolism storage, the clinical signs of iron overload, connect them with diabetes and skin changes. Yep. Usually misfolded, we go Congo red, 100%, absolutely. Yep, so those PAS reactions are going to be for polysaccharides. So you could think of anything that has sugar residues is going to be PAS positive stained. So there's glycoproteins, glycolipids, and basically all things that contain sugar, right? Glycogen, for instance, is PAS positive. So like the liver, the muscle, glycogen storage disorders, all that stuff is going to be the PAS staining positively. Mucopolysaccharides like goblet cells, basement membranes like glomerular and epithelial basement membrane, fungal wall stuff like Candida aspergillus, and also other bacteria like the classic one is the Trophorema Whipple, the Whipple disease. That's PAS positive. Other than that, super low yield. But yeah, glycoproteins with carbohydrate groups attached. Okay. Bronze diabetes, hemosiderin, HFE mutations, hypogonadism, and hepatocellular carcinoma, and there's a mutation in the HFE gene causing decreased hepcidin and increased intestinal iron absorption. So you're increasing the iron absorption in this condition, which is super important. Maybe alpha-1 antitrypsin is a glycoprotein IDK. Yes, indeed, it is a glycoprotein. That's 100% for sure. It's produced, the alpha-1 antitrypsin is made in the liver, the hepatocytes, and also by macrophages. And so it's secreted in the blood and it's synthesized in the liver, and it undergoes that N-linked glycosylation in the rough endoplasmic reticulum and the Golgi. And so that's what makes it the PAS positive. Yep, it's a glycoprotein. So it's the carbohydrate content inside of it. All right, what else is there on this question? Organ dysfunction, pancreas, diabetes, skin pigmentation. Typically, it's like later onset. You have the diabetes later on in their life. Now let's do our key takeaway, bottom line. Histologic examination in hemochromatosis reveals excess of iron accumulation in the liver and the tissue. There we go. Also, hepcidin is another thing that's worth talking about here. It's the peptide hormone that's made by the liver. It's a master regulator of all things iron. Iron homeostasis is the gatekeeper, and it's produced by the liver, and it is inhibited by hypoxic conditions and increased erythropoietic activity. So it controls how much iron leaves the storage sites and enters into the bloodstream. That's what it does. You're increasing the absorption there. So on to our next question, which is kind of like a design question. For question 3383. All right. So here we have to know the difference between, everybody knows precision and accuracy. So we're not even going to talk about those. I mean, accuracy, like, is it spot on? Precision, is it consistent? And then validity. So what's the difference between face validity? Face validity and external validity is what this question's going to be about. So face validity is like, hey, does this measure what it's supposed to? So like basically, is the test suitable to its aims? Is it valid at face value? Excuse me. And then external validity is whether or not this can be generalized. All right. So now let's pop into our question at hand. Here we go. A health department. Oh wait, there's a question. Is face validity internal? And if so, then external validity measure generalizability. External validity measure, you're asking about the difference between them and validity. Basically, validity is just, are we measuring what we think we're measuring? And so internal validity is indeed face. So you're right about that. And I think that's what you're asking, right? Is internal validity face validity? Yes. And that's like, hey, does it actually look at what we think, like superficial appearance? Okay, measures, yeah. Makes total sense. So internal validity is going to involve face validity and also construct validity and content validity and criterion validity. External validity is generalizability every single time. So to your question, is face validity internal? Yes, 100%. Yes, face validity is definitely a form of internal validity. It's a subset of the construct validity. So it's basically how believable or appropriate the test appears to the people who are using it. And you're totally right, generalizability and the external validity. Nice. Okay, so here's our question. Here we go. The health department evaluates the impact of a new statewide initiative to reduce the incidence of asthma exacerbations among school-aged children. Okay. Community health across diverse urban and rural areas are selected to participate. Each center is matched in terms of its patient's population age, socioeconomic status, and ethnic background. Half of the centers implement asthma education program over a period of 5 years, while the other half continue in the standard care practices. The study shows the centers with the education programs have significantly fewer emergency visits for asthma. Based on these findings, the department recommends expanding the program to other regions. Which of the following characteristics of the study most directly supports this recommendation? Expanding to other regions. Okay, so here are all of our answer choices that we got here. Okay, so we're matching the demographics across different environments. And so external validity is what I was looking for, but it doesn't appear here. And so the answer is generalizability, which is the same thing as like external ability. Generalizability, external validity, those are the same thing. Nice, nailed it. Fatty liver found it so quick. Yep, so here we go. The department's recommendation to expand asthma is based on the assumption that it's extrapolable to other environments. Internal validity is the match center. So internal validity ensures the observed effect is due to the intervention itself, not the confounders. Sample size, multiple centers. Large sample boosts the power and precision, but not the extrapolability to other locations, not the external validity. In the study design choices, education program versus standard care, good design. And so it's not going to be associated with the study design choices. Here's the bottom line. So the bottom line is education programs significantly reduce asthma exacerbation, supporting generalizability of the findings for broader implementation. It's about how broad our implementation can be. That's the external. And I wonder if there's a way that I could make this generate even more quickly. In fact, let me do that in my next code break. Oh my gosh, this is frightening. Look at that AI image. All right, so a 42-year-old man presents in the clinic complaining of persistent diarrhea and abdominal discomfort over the past several months. He's diagnosed with ulcerative colitis 5 years ago and has been on a consistent medication regimen. Okay, so ulcerative colitis. And he reports that his symptoms have worsened despite compliance. During evaluation, a sucrose permeability test is performed and it has significantly elevated levels of sucrose in the urine compared to tests performed a year ago. Which of the following intestinal epithelial structures is most likely compromised leading to these findings? Okay, what are we thinking? Basement membrane is what we're thinking. And what is the rationale behind the basement membrane? Because here we're talking about sucrose permeability, right? And so when sucrose starts leaking through the gut wall, it means that the epithelial seal is starting to fail. And so in ulcerative colitis, the chronic inflammation damages the tight junctions. That's like the zona occludens. And that normally forms the barrier between intestinal cells. And these junctions are made out of the claudins and the occludens, and they seal that paracellular space. And so when they're disrupted, you have the large molecules like sucrose is a big old boy, and it can pass freely, and it leaks out, and that causes the worsening of the diarrhea. So it's going to be the tight junctions that are involved here. The tight junctions. I like how you think about the toxic megacolon. For sure, for ulcerative colitis. So the barrier is the tight junctions, the proteins are the claudin, and it's the sucrose permeability test is what demonstrates that to us, because the tight junctions keep it tight. When they loosen, even the big boys like sucrose are going to get through. So it's the tight junctions that are involved here. Now let's look at all of these other answer choices. Desmosomes, that's mechanical strength, not involved in permeability here, more of like a derm thing. Adhesion junctions, actin cytoskeleton, involved in the cell shape for adherens junctions. Hemidesmosomes, that's the basement membrane anchoring. They link the cells to the basement. And then the basement membrane itself, structural support. Below the epithelial cells, permeability testing reflects the paracellular, not the trans-epithelial changes for the basement support. Maybe I overthought this one. Yes, that's probably the case, because I like what you're thinking about the toxic megacolon, though. That was like super smart. So I like that, where you're going with that. But essentially, yeah, it's the loss of the tight junctions, and that leads to the disrupted epithelial barrier, and that causes the leaky gut. So the sucrose permeability, that tests the barrier function and the tight junctions integrity in a chronic process, not like a rupture, right? You're just testing the integrity with that test. And now I like what you're saying about the toxic megacolon, because if it's like super acute and like life-threatening complication of UC, then, I don't know, maybe weird other things can happen. Like you're totally right in UC to think of a toxic megacolon, and because that can cause a whole host of problems. Because ulcerative colitis causes these continuous mucosal inflammation issues all over your body. And so you have damage to the muscularis propria and also the myenteric plexus. And so you have the smooth muscle loss, there's colonic dilation, that's the megacolon. And you have a massive nitric oxide release, and inflammatory cytokines worsen that paralysis. You get all that dilation and all that stuff going on. So very, very good. Very nice. Alrighty. And regarding what you said about the basement membrane is a non-cellular, extracellular matrix layer that anchors the epithelial cells to the underlying connective tissue. So this is going to provide you with a lot of like mechanical stability and also tissue organization, but it's not going to actually regulate your paracellular permeability. And the paracellular is just the transport between the cells, right? So sucrose permeability test measures the leakiness between the sucrose. Oops, I have to let go of my iPad so I can write on it. Sucrose permeability tests measure leakiness between epithelial cells. So the paracellular route, which is going to be tight junction involved. Sedal says, interesting. It's very, very, very interesting. Oh, and then fatty liver says, how is excess sucrose ending up in the urine, though? That's a good question. The paracellular space is opened, and the intact entire sucrose molecules pass between the epithelial cells. Not like through them, they pass between them into the lamina propria. And then they go into the capillaries and then into the systemic circulation. And once they're in the blood, the sucrose is then going to be filtered by the kidneys, and that's why it appears in the urine. Does that answer the question? But yeah, lamina propria, that is basically is what carries the blood supply to the epithelium while holding the cells in place, and it binds them to the smooth muscle. Very, very, very nice. Okay, I just changed everything to parallel processing, so hopefully it's going to be a little bit more quick that way. Okay, for our next question, do we know all of our phases? The phases, let's name the phases of the clinical trials. Phase uno. I don't have to write phase over and over. You get the idea, right? You know what I'm saying? Okay, here we go. All right, 60-year-old man has well-controlled type 2 diabetes, visits his primary care physician for a routine checkup. 6 months ago, he started taking a new oral hypoglycemic agent that has recently become available on the market. During his visit, he explains unexplained fatigue, nausea, and dark urine. Lab tests reveal elevated liver enzymes, and they suspect a drug-induced hepatotoxicity. The physician decides to discontinue this and submit the report about the adverse reaction. Which phase of clinical drug testing are they participating in by reporting this? Okay, what are we thinking here? This is post-market surveillance, right? So it starts off, yep, you nailed it, Sedal, nailed it. So it starts off small, right? Not a lot of people. And then it grows and you're analyzing the dosing. And then afterwards, you have the random blind trials with like 1,000 people. And then it's post-market surveillance. So that's post-market surveillance. This is phase 4. Nailed it right on the money, my friend. So here's the bottom line. Reporting adverse effects post-marketing indicates participation in phase 4 clinical drug testing. Bada bing, bada boom. That's all she wrote. That is all she wrote. Moving on to 86. All right. Here's the next question. We have a 30-year-old male presenting to the clinic with infertility concerns. He's been trying to conceive over a year without success, and he's been using testosterone supplements and for bodybuilding purposes. Gynecomastia and decreased testicular volume are present bilaterally, low serum levels of luteinizing hormone and FSH, but elevated testosterone, which is what matters. Okay, what is the explanation for this? Testosterone. This guy's taking testosterone exogenously. So that's causing a suppression on his LH and F. So he's got reduced gonadotrophins and testicular atrophy. There's our gonadotropins. Anything secreted by the pituitary. So the answer to this question is C, increased negative feedback on the hypothalamic pituitary gonadal axis. So we got secondary hypogonadism due to exogenous anabolic steroid or testosterone use. Elevated T comes from supplementation, increasing the negative feedback on the hypothalamus and the pituitary, suppressing the GnRH and the LH and the FSH. This shuts down the testicular axis, causing decreased intratesticular testosterone and also testicular atrophy, and impaired spermatogenesis. Low LH and FSH reflects the central suppression despite high systemic testosterone. Decreased production of the sex hormone binding globulin. It does not cause gonadotropin suppression. Increased conversion of testosterone to estradiol, cause of gynecomastia, but does not explain the infertility. Inhibition of aromatase enzyme, like that would be present in PCOS and aromatase inhibition, that would reduce estrogen, leading to increased gonadotropins. Upregulation of androgen sensitivity would not impact the axis there. All right. And so one thing that's important here is aromatase converts androgens into estrogen, aromatase. And granulosa cells are the site of that aromatase activity. They're stimulated by FSH. And adipose tissue and the placenta is the peripheral site as well of estrogen formation. And aromatase inhibitors like anastrozole are used in estrogen receptor positive breast cancer. Usually there's increased aromatase activity. It's seen with obesity. Yeah, you have the adipose converts androgens into estrogens. That's a little bit about aromatase. Yeah, men can also make estrogen as well, right? Aromatase, it's found in your ovarian granulosa cells, and also the placenta. Allows estrogen to drive the female sex characteristics and regulate bone growth, and also to close the growth plates. Hypothalamus releases GnRH, stimulates anterior pituitary to release the LH and the FSH. LH acts on the Leydig cells, FSH on the Sertoli cells. Here's the bottom line. Testosterone supplementation increases negative feedback, leading to low LH and FSH, resulting in testicular atrophy and gynecomastia. Okay, here we go. Purple Burp says, I think C. So 48-year-old woman, emergency department, she's got tremors, palpitations, blood pressure is 160, heart rate is 110, diaphoretic, symptoms begin 48 hours after she's admitted, community-acquired pneumonia, and she confesses to drinking a few beers every night for the last decade. She experiences a generalized tonic-clonic seizure, which the following is most likely the cause of her symptoms. So what does she have? Yep, you're right, Sedal and Burble. This is definitely delirium tremens, right? This is a life-threatening complication of alcohol withdrawal. And symptoms usually are going to appear in the timeline is going to be 47 hours, 48 hours to 72 hours afterwards. So she's got classic alcohol withdrawal, tremor, tachycardia, hypertension, diaphoresis, agitation, and seizure after 2 days after she stopped drinking. Chronic alcohol use leads to downregulation of the GABA and upregulation of NMDA in the back garden, as Lorde says in her song. And when alcohol stops, then the GABA tone disappears, while the excitatory glutamate activity is unopposed, and that leads to CNS excitability. Alcohol withdrawal. Yep. Hypoglycemia due to poor oral intake. Hypoglycemia can cause confusion and seizures, but not explaining the tremens, delirium tremens. Withdrawal from benzos, sedative hypnotic withdrawal, mimics alcohol withdrawal, but there's no history of chronic benzo use. Local, that would be like a nerve block that's acute, not after 48 hours, and acute viral encephalitis, HSV encephalitis, no fever, focal deficits, or altered mental status. So alcohol withdrawal, frequently tested, clinically important, stems from chronic CNS adaptation to ethanol. Ethanol is a GABA agonist and NMDA in the back garden antagonist. Removal of alcohol after dependence leads to unchecked excitatory neurotransmission. And so you have tremors, they have seizures, and then here you have autonomic instability, delirium tremens, disorientation, and agitation. So all of that stuff is present in this patient. Here's the pathophysiology. Chronic alcohol stimulating GABA-A. So the brain adapts by downregulating GABA-A and upregulating NMDA, and then it's unopposed. So that's the most dangerous substance to withdraw from. It's literally alcohol. She's been nightly drinking for a long, long, long time. Okay, and here is the bottom line. Agitation, tremors, and seizures in a hospitalized patient after alcohol cessation indicates alcohol withdrawal syndrome. Nailed it. You sure nailed it. Treatment for her condition. Okay, what are we thinking, guys? Purple says, you mean like you input heuristics on how you want it to appear and then it creates it? Not too familiar with coding? Yes, pretty much. But there are a series of other functions which are occurring in the background. And so I'm trying to do them all at the same time and making sure I eliminate any redundant downloads. Fatty liver says, gonna be cholinergic neurons in the mesolimbic pathway. Nice. I like these thoughts here. Fatty says she has Alzheimer's. I agree with that. You're too fast, man. I agree with your agreement. Very, very nice. So we'll scroll down so you can see these answers. The basal nucleus of Maynard. Oh, yeah. Now we're getting down to the granule. Look at this stuff. Yep. So by the time Alzheimer's appears, we have 60% of the cholinergic neurons in the basal foramen are already gone. 60% by the time Alzheimer appears. And so the main treatment is going to target that acetylcholine, and it's the neurotransmitter of the memory and attention. And so like donepezil is what you're going to be using here. Classic symptoms of Alzheimer's disease. Donepezil, it works by blocking acetylcholinesterase, which keeps the acetylcholine around longer in the synapses. And it doesn't cure the disease, but it slows down by enhancing the communication between the nucleus bacillus and the cortex. So acetylcholine saves when the memory fades. Oh no, Fatty, I'm so sorry to hear that. Sorry, Jeff. That's really unfortunate. This is a bad way to go. But yes, how about increased GABAergic transmission of the amygdala? Okay, so that would be involving GABA in the amygdala. And that's the wrong system because GABA is inhibitory, not memory decline in Alzheimer. Enhanced dopaminergic signaling of the nigrostriatal pathway. Nigrostriatal, that's related to motor control, not memory loss. Augmented serotonergic activity in the RAF nuclei. That would be serotonin RAF nuclei. And this is depression, not dementia. Modulated glutamatergic input into the hippocampus. That's glutamate in the hippocampus. And so memantine works here, but acetylcholinesterase inhibitors are first line. So we kind of gave the breakdown there. It's basically just atrophy of like diffuse cortical and hypothalamic or hippocampal atrophy. And the lesions are going to be beta amyloid plaques and tau tangles. And the treatment is acetylcholinesterase inhibitors, like that one, like memantine. You basically have less acetylcholine in the basal forebrain of the cortex. In the clinical courses, you have this insidious memory loss and language defects, and then the loss of the executive function comes later. So well-groomed, no motor deficits rules out the Parkinson's, repetitive questioning, poor recall signs. Medial temporal lobe is early hippocampal involvement. ApoE4, increased Alzheimer risk. Down syndrome, increased risk on chromosome 21. Amyloid plaques, extracellular neurofibrillatory, intracellular tau, and low acetylcholine in the cortex and the hippocampus is the target for the key drugs. All right, so it starts in the hippocampus. That's where the memories are first formed, and then amyloid plaques and the tau tangles are the two pathological hallmarks that you need to be aware of. And then deep in the cortex, you have the loss of cholinergic neurons. ApoE4 is late onset. Is it the presenilin 1-2 mutations? Is that what you're talking about, fatty liver? Oh, presenilin? Okay, sounds good. You're talking about presenilin. Man, I gotta fix the latency so that I can get like real time with you guys. But yeah, early onset Alzheimer is not going to be ApoE4 related. That's late onset. The early onset has a couple of them, but usually it's the presenilin like 1 or 2, like on chromosome 14 and chromosome 1. And also APP, which is amyloid precursor protein, that's on chromosome 21. So for the amyloid precursor protein, it's usually Down syndrome. And so Down syndrome, definitely is going to increase the proclivity for early onset Alzheimer disease. So A4 is late onset. As you guys mentioned in the chat there, E2 is protective. And then also APP, presenilin. So APP is seen with Down syndrome, presenilin 1, and then presenilin 2, 21 and 1, respectively, early onset familial forms. Yeah, very, very nice. Okay, so next little bottom line here. Alzheimer's disease treatment targets boosted cholinergic transmission from the basal forebrain to the cortex. Very, very nice. All right. So now we have a 25-year-old man presenting to the emergency department with a pulsating headache on the right side of his head for the past 2 hours. He describes the pain as severe and notes that it worsens with bright lights and loud sounds. He also reports feeling nauseated and mentions that he had brief visual disturbances described as zigzag lines, and so that aura. And physical examinations are remarkable. He has no significant medical history, does not take any medications, with the following receptors is targeted by the most appropriate medication for treating his disorder. Okay, so driptins, yeah, nice. Cluster headache, I'm thinking D, serotonin, or is it a migraine? What are you guys thinking this is? Migraine, cluster headache? So migraine presentation is a unilateral throbbing headache, and you have aura, photophobia, unilateral, which sounds like what this guy is suffering from. If you look, it's me over there. Just kidding. Anyways, yeah, so triptins are first line abortive therapy. The 5-HT stuff, heard pulsating and you ran with it. Yeah, that's totally fair. So migraines, about 14% of the population, 1 in 7. And serotonin is the key player behind that pounding pain, right? So they have migraine with aura, unilateral throbbing pain, photophobia, phonophobia, nausea, visual aura. Most appropriate treatment is serotonin. And the mechanism is the action of triptans, main state of abortive therapy. Dopamine receptor is Parkinson's, antipsychotics. Not relevant to migraine here. Acetylcholine receptor, myasthenia gravis, parasympathetic activity. No role in migraines. GABA, benzodiazepines and seizures and anxiety. Not first line for migraines. And glutamate, cytotoxicity and NMDA. So migraines, neurovascular disorder involving trigeminal nerve activation, inflammatory peptide release, vasodilation of the meningeal vessels. Serotonin modulates these pathways. You got to reverse the vasodilation, inhibit the nociceptive transmission through 5T. Pulsatile headache, hallmark for migraine, photophobia, phonophobia, aura, triptans, abortive therapy. All these things are associated. So we have a trigger, which activates the trigeminal afferents, releasing substance P and CGRP. Then you have neurogenic inflammation, vasodilation, and visual or speech disturbances before the headache are going to be seen. Avoid opioids for the migraine, risk of medication, first-line prophylaxis, beta blockers, topiramate, and valproate if it's frequent. Cool, got some good things in the chat there I'm seeing, and I think those all displayed on the screen so you guys can read those there. Cluster versus migraine headache, right? So the cluster headache is sharp and it's going to be strictly unilateral, whereas the migraine's usually unilateral, so that's not going to be distinguishing between them. The location is the periorbital, like the temple for the cluster headache, and also it's like temporal, so retroorbital for the migraine. And there are also some autonomic signs that are going to be seen 100% in the cluster. So the cluster is going to have lacrimation, rhinorrhea, ptosis, meiosis, and the duration for the cluster is just like 15, 90 minutes max. Whereas a migraine, it's all day long, baby. It could be hours, it could be days. And migraines are triggered by like hormonal problems, stress, and foods. Whereas clusters, typically it's like sleep problems, alcohol. And the treatment is triptans and NSAIDs for migraines. And for cluster, it's going to be 100% oxygen and triptans. And so with cluster, you can give them preventative treatment would be verapamil. And for the treatment of migraines, the preventative treatment that is beta blockers and also topiramate. Important point is estrogen can cause vasospasm because it acts on nitric oxide. Did we talk about that in another one of our sessions? The cluster prevention is verapamil and lithium. Understanding the mechanism there is important too, but the bottom line is going to be severe unilateral headaches with aura suggest migraine, treated with serotonin receptor agonists. So the migraine and the clusters, oxygen and verapamil is the best treatment. Okay, let me load up the next one here. Stroke lesions. Okay, I'm going to make a beautiful drawing here. So here's a nice little spinal cord, as you can see. See if I can make a little butterfly. By the way, the word for butterfly in the ancient Mayan dialect is pinpin, which I think is a beautiful name for butterfly. Oh, Fatty Liver has a question. Did not know CCB for cluster. What's the mechanism of action there? Yeah, that's a good question. In terms of stopping a cluster. So cluster headaches are hypothalamic triggered, so vasodilation, trigeminal activation, and verapamil is going to block the calcium entry, right? So it prevents the vasodilation. So verapamil works best because it crosses the blood-brain barrier and acts centrally and peripherally. And dihydropyridines like amlodipine, those guys mostly act on the peripheral vessels, and so they're not going to be as good. So verapamil works best as opposed to other CCBs. How did I learn that? I lived in the mountains of Guatemala for 2 years. Yeah, you guys are unlocking new Blake lore. I lived in a very foreign part of the world called Rakana, and I spoke Quiche for like a year. So I'd knock on people's doors and be like, hey, do you guys want to hear a message about the gospel? Because I used to, as I mentioned before, I was a missionary, and I got sent to the farthest place in the world, which is known as Rakana. Y ahí es donde se habla español. And that's how I learned how to speak Spanish, is what I just said. Okay, and then there's another question here. Okay, so we want to cause vasodilation or vasoconstriction? That's a good question. So the acute treatment is vasoconstriction, right? So triptans, those guys cause constriction of the cranial vessels, and 100% oxygen. What is that going to do? Vasoconstriction 100% of the time. NBME 26 has a good question about this, where you have CO2, which dilates, right? And so obviously if you're giving them 100% oxygen, we want vasoconstriction. And preventative treatment though, there we don't want don't think about constriction versus dilation, think about vascular stabilization. So between attacks, the hypothalamus and the vessels are unstable and they're overreactive, right? And so verapamil is a calcium channel blocker, and that prevents the excessive dilation from happening in the first place. Don't think of it as vasoconstriction. Think of it as keeping the vessel just calm and steady. Not tightly constricted, just stable. Just stable. Yeah, I will tell you how old I am. But first, how old do you think I am? I'm very curious to see how I'm perceived. I would love to know, and I will tell you if you're right or wrong. I graduated from Harvard in 2022, if that gives you any clue there. Okay, and then I also see a question in the chat here, because my logic is calcium will cause smooth muscle contraction. So why would CCB cause constriction? Yeah, that's fair. So I guess calcium does cause contraction, you're totally right about that. But what happens when we block these things though, right? Because calcium constricts, and calcium channel blockers block the L-type calcium influx. And that causes less calcium, right? So then you have less MLCK activity, and that means there's relaxation and vasodilation. Calcium channel blockers cause vasodilation. So under normal circumstances, verapamil causes vasodilation, not constriction. Cluster headaches involve abnormal vasodilative bursts of cranial vessels that are triggered by hypothalamic activation, right? Very vasodilated bursts. The goal is to stabilize the vascular tone and to prevent those huge, huge swings. So I don't even like thinking about it in terms of vasodilation. It's really just prevention. It's stabilization of the vascular tone. And so verapamil reduces the ability of the vessels to overdilate. That's what I mean. It reduces the ability to overdilate. It makes the smooth muscles less responsive to triggers that would normally cause strong dilation, right? Because if you give somebody nitric oxide, it's just going to be dilated. But verapamil reduces that ability. It's like, hey, smooth muscles, stop responding to nitric oxide. And so it dampens the hypothalamic and the trigeminal neuronal firing. Yeah, it inhibits vasospasm. That is a much better way of saying it. It inhibits vasospasms. Thank you. That is the way that I should have said it. Cluster headaches are like, it's like shaky vessels. And they keep swinging and they're like a bridge, just shaky vessels. Verapamil doesn't tighten the bridge, it just stabilizes it. Triptans, though, those definitely cause vasoconstriction and like 100%. And they reverse the active dilation during an attack. Verapamil prevents excessive vasodilation. It prevents excessive vasodilation. And we'll say this is 1, 2, 3, 4, 5, 6, 7, 8. All right, and here's our next question. A 29-year-old woman is admitted to a hospital after a car accident in which she sustains a significant whiplash. She whips her hair back and forth. Complains of weakness in her left upper and lower limbs. Neurological examination, there's increased tone and brisk reflexes in the same extremities. Sensory examination reveals decreased proprioception and vibration in the sense the right side of the body starting at the neck, but the pain and temperature sensations are intact. That's important. MRI of the cervical spine shows dislocated fracture at the C4 level, which the following best describes the motor deficits in this patient. Motor deficits. Okay, so unilateral spinal cord injury, and we have our motor and dorsal column loss with contralateral pain and temperature loss, right? That's what we're reading, right? Pain and temperature sensations are intact, so I have to know where this is going to strike. D, B, what are you guys thinking? I believe in acting upon whatever natural gifts you have. Nice. Fatty Liver says D. I like your thinking. The lateral coracospinal decussation occurs in the medulla. I like these thought processes here. So this is Brown-Séquard, lateral coracospinal tract damage. And the answer is B, damage to the left lateral coracospinal tract at C4. So they have left-sided spastic weakness and right-sided loss of proprioception and vibration at the level of C4. Left-sided spastic weakness, right-sided proprioception. We'll walk through this and kind of explain this more simply. Oh, D doesn't even say coracospinal. Yeah, spinal thalamic. Okay, so here's a lay of the land. Let's just do this first. Understanding spinal cord syndromes, you have to know lateral coracospinal tract. That's a voluntary movement because the cortex to the spine, right? It's a cortex spine, so it's voluntary. Decussates at the pyramids, descends ipsilaterally in the spinal cord. Dorsal columns, fasciculus, cuneus, gracilis, carry proprioception and vibration. These decussate at the medulla and they ascend ipsilaterally. In the spinal thalamic carries pain and temperature. Decussates immediately in the spinal cord and then it descends contralaterally. So we have a hemisection, there's trauma at C4, and we have the same side, vibration, but contralateral pain and temperature, 1 to 2 levels below. Yeah, this is reading comprehension. That's good though. That's good. Spastic and brisk reflexes, upper motor neuron damage caused by the cortical spinal tract injury. Vibration and proprioception, dorsal column, fasciculus cuneus, upper body. Pain and temperature, spinal thalamic tract, not involved. All right, so here's the pathophysiology. We have whiplash at C4 causing unilateral spinal cord compression. There's a left tract that's damaged. You get spastic paralysis on the left below the lesion. There's right dorsal column disrupted. That's a loss of proprioception on the right. So notice this. This is what I'm going to highlight on these questions. I think I need to update my algorithm here. But see how this says right, and then on the right side of these dorsal columns, and then left, but on the left side, and then whiplash causing unilateral spinal cord compression hemisection. Then the spinal thalamic, pain and temperature is spared intact. And so ipsilateral paralysis below the lesion, and contralateral vibration begins at the level of lesion, and there's no pain and temperature defects. Okay, so is this all good for everybody? Left-sided spastic weakness on the left side, right-sided loss beginning at C4. Let's do the bottom line on this one. Yeah, straightforward. Got it? Okay, cool. Left motor defects with right-sided sensory loss indicate damage to the left lateral coracospinal tract. A woman has a neck injury, the C4, and now she can't move her left arm and leg, right? They're stiff, overreactive reflexes. And so now she feels less vibration on the right side of her body, and pain and temperature is totally fine. Okay, coracospinal, because it's the motor. And if you're hurt on the left, you get left-sided weakness because it's down the same side after it crosses your brain. Vibration sense is in a different pathway. It's the dorsal, also on the same side. You feel vibration loss on the right, the damage is probably on the right side of the dorsal column, but they're only asking about the motor here. And so it's a left motor pathway. There we go. All right, on to our next question. 91, guys, only 10 questions left. Can we do it before our little break? 10 questions? You guys ready? Let's do it. Let's do it. Let's do it. Let's do it. Do it. Do it. And do it. Okay. In this question, I think we're going to have an elderly patient, 81-year-old woman, presenting to the clinic after experiencing brief loss of consciousness while combing her hair. She regained consciousness quickly and reports feeling lightheaded before fainting. Her medical history includes well-controlled type 2 diabetes, mellitus, and hyperlipidemia, for which she takes metformin and atorvastatin. Physical exam shows a heart rate of 50 beats per minute and blood pressure is at 130. Neurological exam is unremarkable, which the following is most likely the cause of her syncope. Okay, Fatty Liver says, I don't know why this would be orthostatic because she didn't get up fast enough. Fair enough. What are you guys thinking for this question? What do you guys have to say? Okay, so she's combing her hair. This is important, actually. I should have highlighted this. She has a transient loss of consciousness and is triggered by pressure on the neck, right? And that's like here. She goes here, she's combing her hair. Oh, right? Maybe you didn't make that sound effect. But that's the bradycardia, and that's the signs of the carotid sinus hypersensitivity. So in older adults, it's like exaggerated baroreceptor reflex in the carotid sinus that's near the bifurcation of the common carotid artery, and that causes the reflex vagal activation, and that leads to bradycardia and hypotension. And so that transient cerebral hypoproduces the syncope without the postictal confusion. Okay, so orthostatic hypotension, what do we think about that one? That's caused by a sudden standing, not triggered by neck problems, right? Epileptic seizure, Sadal is saying D for sure. Anybody else? B, epileptic seizure. That would feature your postictal confusion and tonic-clonic movements, and that's absent here, right? There's no tonic-clonic movements. How about vasovagal syncope? Well, that's triggered by emotional stuff, right? Not mechanical neck issue. How about carotid sinus hypersensitivity? Yes, indeed. You're 100% correct. Yes, Sadal said until you mentioned that there was some pressure on the neck. And I see that question there. Sasson, welcome also. Sasson is on YouTube, by the way, guys. If you want to say hi to Sasson, he's on YouTube. You like the ones where you can logic through it? But yeah, you're combing your hair, you faint from there. Syncope while combing your hair, bradycardia, preserved BP. Carotid sinus is common in those with reflex syncope in elderly individuals. Orthostatic hypotension, standing up, not relevant here, right? That's when you're standing, but she's seated, and so it's not that. Epileptic seizure, postictal confusion. She's quickly regaining her consciousness. Vasovagal syncope, emotional distress. So this is exciting to see. Here's the pathophysiology, mechanical stimulation of the carotid sinus, exaggerated baroreceptor response, decreased cerebral perfusion, transient syncope. And this part's important too, the decreased perfusion, because you have the parasympathetic vagal tone. And Sadal is right. Subclavian steel can have a patient complaining of arm weakness and vertigo after some exercise. Yep. And this is crazy, guys. This is actually super common. This is like 1 out of every 3 elderly patients is going to have some sort of unexplained syncope after carotid sinus hypersensitivity. And a lot of people just don't even know it, right? It's usually combing your hair, doing something like that, but the baroreceptor is just really, really sensitive in these individuals. All right. And then orthostatic hypotension, that's when you stand up suddenly after you're lying down and sitting. And that's when the blood starts to pool to the legs. And so the decreased venous return, then it causes transient decreased cerebral perfusion. And then you have volume depleted. So, dehydration, diuretics, autonomic neuropathy, something like that is probably precipitating this. And the timing is usually going to be seconds within standing, not like with neck movement or anything like that. So that's how you differentiate orthostatic hypotension. Also, regarding subclavian steal syndrome, this is actually one of my favorite conditions that's tested on step 1. So it is really kind of worth parsing out. So here's the combing hair, it's the bradycardia, it's the equal arm pressure as well, because the unequal arm pressure is subclavian steal, right? So this is obviously carotid sinus hypersensitivity. But when it's subclavian steal, the question would be something like this. They'd say, okay, we got like an elderly patient. They're dizzy, they have syncope, and when they're using their left arm, they have the syncope and stuff with lower blood pressure and weaker pulse in this arm, right? Because the blood is literally being stolen from the vertebrobasilar circulation to feed that arm. So that's kind of cool, right? That's kind of cool. Also, carotid sinus hypersensitivity and vasovagal symptoms are interesting. The baroreceptor reflex is inside the carotid sinus, so at the bifurcation between the common carotid artery, that's where you have the baroreceptors, the stretch-sensitive nerve endings. And these guys constantly monitor the arterial pressure. And if they sense like a stretching, like in a high blood pressure, then they send signals through the glossopharyngeal nerve, cranial nerve 9, to the nucleus tractus solitarius and in the medulla. And then the NTS responds by activating the pre-sympathetic, the vagal system, and it inhibits the sympathetics and to lower the blood pressure. So that's the mechanism. And then in hypersensitivity, the baroreceptors are overacting to everything. So you have decreased cerebral perfusion. Vasovagal is too much sympathetic stimulation. Orthostatic is too little sympathetic stimulation. Nice. Orthostatic is not enough gas pedal. Orthostatic, the vessels just aren't constricting, the blood pressure is just dropping when you're standing. Not enough gas pedal. Whereas vasovagal syncope is just, too much of that reflex. All right, bottom line, folks. Here's the bottom line. Bradycardia in an elderly patient suggests carotid sinus hypersensitivity as the likely cause of syncope. Nailed it. Good job, guys. All right, guys, 8 more questions and then we're donezo. Bedtime for Bonzo. You love it. Let's talk about the theoretical causes of male infertility. Okay, what can you guys think of that causes male infertility? Just a bunch of feedback loops, right? Nothing to worry about. All right, the causes of male infertility that I want you guys to think about are going to be Klinefelter syndrome, increased testicular temperature, and gonadotropin releasing hormone deficiency. Yeah, good. Nice. Steroid use. Nice. Okay, Klinefelters, yes. Okay, here we go, guys. As you can see here, we've been denied on one of our images because anytime they talk about repro, content policy is going to kick it out. Okay, 30-year-old man. Yeah, heat to the Sertoli. Nice. 30-year-old man presents to clinic, testicular pain, swollen scrotum, denies any trauma, physical exam shows enlarged right testicle, ultrasound performed, and they have patchy regions of decreased echogenicity through the right testes. Lab studies show elevated levels of anti-sperm antibodies. Damage to which of the following structures is most likely associated with this guy's condition? What are we thinking here? Epididymis, Leydig, seminiferous tubules, prostate, bulbourethral glands. Okay, what are we thinking? No clue? The correct answer is seminiferous tubules. Your immune system does not know your sperm. Isn't that crazy? It has no idea who it is. It's like, who dat? That's because the Sertoli cells, which are part of the seminiferous tubules, they built a tight barrier called the blood-testes barrier. The blood-testes barrier, which, by the way, the Trump administration, they blocked scientific papers on the blood-brain barrier because they had the word barrier and they said it was too woke, which is crazy. But yes, Sertoli cells in the seminiferous tubules build a tight barrier called the blood-testes barrier, and it hides the sperm from the immune surveillance. And if that barrier breaks, let's say there's trauma or surgery or inflammation, then the immune system sees the sperm. And it's like, what the heck is that? And so the antibodies form. And inflammation follows and the testes starts attacking itself. That's autoimmune. And that's when you have the anti-sperm antibodies and testicular pain. And the structure to blame is in the seminiferous tubules. Cool beans? Why am I cooked? You said Sertoli cells and flipped it to Leydig, but that means you got it right. You always got to go with your gut. Chitis is the inflammation of one or both testes. So you get the pain, the swelling, the tenderness, and usually from viral infections like mumps, bacterial infections like urinary tract, and sexual transmitted infections can be responsible for this as well. The man anti-sperm antibodies due to disruption of the blood-testes barrier, tight junctions between the Sertoli and seminiferous tubules. Everyone's on fire today. All right, next we have the the bottom line. Elevated anti-sperm antibodies indicate damage to the seminiferous, affecting spermatogenesis and causing testicular pain. And yeah, guys, huge dubs all around. W's for everybody. And our next question, we're talking about some thyroid stuff. Yeah, that's right, Sidal. That's right. So this is one that confuses me because when I was listening to Daddy Goljan give his lectures, I remember him saying at one point, nobody talks about subacute thyroiditis, except for David. We need to limit his tomatoes. That's true. Everybody but David gets one. Oh, I'm just kidding. David, if Flake could teach me sociology like medicine, I wouldn't need to study ever. I would just watch the stream. I wish, my friend. I wish. Don't worry. We'll do a sociology stream eventually. But I'm glad. That's very flattering of you to say. Like, you're very nice to me. All right. So what was I talking about? Oh, yeah. Daddy Goljan used to say that the USMLE and NBME never test you about subacute thyroiditis. That's not true. There's so many questions about it. So, like, actually, maybe the reason why he said that is because those recordings were like many years old. But guys, I tell you, subacute thyroiditis is all over. There's a dude and he's got difficulty swallowing and he reports blah, 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 blah. Look at that. This is like a hack, guys. Look at this. You've wronged every question on subacute. Okay, you have to know for subacute is that it hurts. That's it. Like if you see a question stem and it's remotely about the thyroid and it hurts, subacute, Dequavian, done. This is the easiest. And everybody makes it out to be so hard and complex and it's like, oh, it'll never be tested. It's like, wait, guys, look at the charts. And one time I did this, I drew out a whole chart of all the thyroid conditions. And I was like, wait, all you need to know is that it hurts. Because there's no other step one condition that hurts in the thyroid. David says they chose C. Yeah, for that, David gets his tomato. Yep. Self-limited hyperthyroidism, viral trigger, followed by thyroid pain. Subacute, super easy. Give this man an MD. Give him an MD already. All right, subacute is characterized by tender thyroid enlargement, elevated T4, T3, low TSH, and low radioactive iodine uptake. All of that should make total sense here. And we're going to move on to the next question because this is just super easy, right? It's just tender. That's all you have to know. Everybody tries to make that one so complex. Maybe there's something that I just don't fully understand and appreciate about it, but like I've always thought that's just like, it hurts. I don't know. Because I don't know. I think of the Q as like a letter that hurts. Like it just like, look at that. It's like a circle with right? Gradient. Hurts. Okay. Next question. 5-month-old girl, pediatrician, due to muscle weakness and developmental delay. She's never been able to lift her head. Seems floppy. She's only 5 months. On examination, hypotonia, hepatomegaly, long-chain fatty acids, cholesterol, liver transaminases are elevated. Genetic testing reveals a mutation associated with disorder affecting specific cellular organelle responsible for beta oxidation of long chains. Which of the following is absent in this patient? We're thinking peroxisomes. What are we thinking? Let's start there. What is the syndrome called? I'm not going to give you the first letter because that'll give it away. But you're so right. This is Zellweger syndrome, peroxisome problem, right? This is the peroxisomes. You got it. The reason you know is because the beta oxidation to the long fatty changes. Got to revise this biochem vignette. Yeah, that's fair. We all do, my friend. Okay, so the peroxisomes. Those are the small organelles that have the oxidative enzymes, right? What do the peroxisomes have? Everybody forgets about them. They're so slept on, right? Peroxisomes, if you look deep inside, and maybe our MCAT friend is still around, because this is actually important for that. Less important for them, but more important for us. Catalase, right? We have the catalase. Also, the peroxisomal beta oxidases. Beta oxidation of very long chain fatty acids, like greater than 22 carbons. Also, alpha oxidation of the branched chain fatty acids, and the synthesis as well of the plasmalogens. These are the myelin membrane lipids, and detoxification of hydrogen peroxide. So the loss of the peroxisomes leads to a toxic accumulation of all of the fatty acids and the ROS, the reactive oxidation species, into the brain and the liver. And so you have somebody with hypotonia, developmental delay, hepatomegaly, elevated VLCFAs, and also defective peroxisomal function, Zellweger syndrome, peroxisomal absence. Yeah, absent of the peroxisomes, neurologic problems, early death, adrenal leukodystrophy. All these things are associated, right? Like Refsum's disease is associated with like impaired alpha oxidation. But so the pathophysiology for this one is you have that PEX defect. That's the absent or non-functional peroxisomes. And you have impaired beta oxidation of the long fatty acids. So you have lipid accumulation in the liver, the brain, and also the adrenal glands. And you have toxic fatty acid accumulation. So that causes neuronal problems. You get hypotonia and all that stuff. Okay, here we go. Bottom line, absence of peroxisomes leads to the elevated very long chain fatty acids and Zellweger syndrome. Alrighty. This, my friends, is a toothbrush. What condition am I going to talk about? There's another hint. Yep, a toothbrush. Yeah, you nailed it. Say it all. How'd you do it? See, you guys are just way too good. It's like I mentioned one thing, you already have it. Trigeminal neuralgia. Nailed it. 45-year-old man presents to the clinic with a 2-week history of severe episodic facial pain on the right side. He describes the pain as an electric shock-like sensation localized on the right side of his face and jaw. Pain episodes last for a few seconds, can be triggered by things like shaving or exposure to cold wind or toothbrush, right? No sensory defects. Touching of the right side of the face elicits pain. MRI shows no abnormalities, which the following is the most likely underlying condition. Trigeminal neuralgia is what we got. So what is the correct answer? Is it compression of this nerve? Yes, it is. Sudden shock-like pain, vascular compression of the nerve. Oh, I realized there are two of the trigeminal ones. E is not the right answer. And the reason why is because that's the HSV, the vesicles. Those guys always have the eruptions, the volcanic eruptions, herpes, zoster, and sensory changes. Not purely neurologic. It's purely a neurologic problem. You have that compression of the trigeminal nerve, the cranial nerve 5. It's only pain. It's just pain is all. Oh, and Fatty Liver says, does HSV not cause trigeminal neuralgia? Yeah, so it's not a true trigeminal neuralgia, but it does cause herpes zoster neuralgia. And so the difference is it's the burning versus the electric pain, but it's a type of neuralgia. It's just herpes zoster neuralgia. Sidal says trigeminal neuralgia caused due to the bobbing blood vessel. Trigeminal neuralgia is a vascular compression and it causes demyelination. And the pain you feel is an electric shock. Whereas for herpes zoster neuralgia, it's like very similar, but it's burning. And so also it's usually spontaneous, whereas trigeminal neuralgia has to involve like a touch, light touch, the wind, chewing, brushing your teeth, things like that. And usually for herpes zoster, you have a vesicular rash. Like that's the big thing I would focus on. And the treatment is acyclovir and corticosteroids for herpes zoster. And the treatment for trigeminal neuralgia is carbamazepine. Electric shock pain, not burning pain, vascular loop compression, cranial nerve 10 of the pons, focal demyelination, neuronal excitability, and trivial stimuli. And there's actually a way to remember the herpes zoster, even though it's like less important for step 1. HSV, hot, slow, vesicular. Trigeminal neuralgia is going to be triggered. Trigeminal for triggered. Sedal knows. Trigeminal neuralgia due to the bobbing blood vessel. Yeah, the bobbing artery. And chronic compression and demyelination. So you have ectopic discharges and peroxisomal facial pain. So carbamazepines, these are sodium channel blockers, right? And they stabilize the hyperactive nerves. And so the refractory causes are microvascular decompression, and that physically moves the bobbing blood vessels away from the trigeminal nerve root. So physically moving them in refractory cases. So blobbing, how do you even say that? It's like a tongue twister. Bobbing blood vessels bangs on the trigeminal nerve, causing the shocking pain. All right. The trigeminal neuralgia is common in the vascular compression of the trigeminal nerve root. Guys, we're almost there. We're so close. 4 more questions. And guys, I'm going to work on this algorithm so that it's a little bit quicker and also prepare some notes ahead of time. Hopefully you guys can just bear with me as we have these 4 last questions together. And then we'll do a little break. And I have a book club today. I'm reading Pillars of Earth with 2 of my friends from Harvard. And so I got to read up on the chapters before that happens. Ready? A 2-month-old infant boy is brought to the clinic by his parents due to persistent mild fever and oral thrush. He was born full term, normal delivery to a 28-year-old woman. The mother's blood group is AB, Rh positive, while the infant's blood group is B, Rh positive. And his birth weight is this. He has been feeding well, but has been irritable for the past few days. 100 is the temperature. Respirations are 32 per minute. Physical examination reveals oral candidiasis, mild pallor, and no megaly. MCV is normal. ANC is 850. Which of the following is most likely diagnosis? Look at that. It's actually AB, the mother's blood, and the infant's is B. Okay, what are we thinking for this condition? Yeah, you got it. Congenital neutropenia. And what is the reason why? Yep, good. ANC is less than 1,500. I would say it's even less than 1,000, right? And normal cells, platelets, there's neutropenia, obviously. And so the key here is there's a maternal blood type of AB and the infant type of B. And so maternal IgG anti-neutrophil antibodies cross the placenta and they destroy the baby's neutrophils. Maternal G anti-neutrophil antibodies. And so this is transient neonatal or autoimmune neutropenia. It's a self-limiting condition that usually resolves within about 2 to 3 months as the maternal antibodies clear. What about this transient neonatal neutropenia versus congenital neutropenia? Which one is it, C or is it A? What do you think? Is it transient or is it going to be congenital? Is it going to be persistent neutropenia from like the myeloid mutation? What is it going to be? Do you guys think it's A or do you think it's C? C has another name to it. It's Kossman syndrome. Okay, so you'd still go with C? Well, this is transient, isn't it? This is transient. It occurs and it goes away. It resolves itself automatically. IgGs. Unlike congenital neutropenia, there's no marrow failure as well. So the way to think about diseases that are congenital is they're usually intrinsic, right? And this is no exception. The bone marrow failure would be intrinsic congenital. It's like, oh man, that baby's got a problem. It's in the baby. It is intrinsic to the baby. Whereas transient is like, hey, mom, thanks for all those IgGs. Not, right? And so the baby's marrow is normal. It's just peripheral destruction by the maternal IgG. That's the only thing that's happening. Yeah, it makes sense. If it's IgG, it sounds like A. Yep, you got it right, fatty. Nice. Yep, you got it right. Oral thrush, mild infections, right? And I saw a question in there that you guys in the chat said about Candida and other infections. So yeah, there's neutrophils, right? And those kill bacteria and fungi like Candida. So neutrophils do help with Candida. And also macrophages, they eat the debris. And then there's lymphocytes. Those are like the T cells. Those guys handle the viruses and the intracellular pathogens. There's B cells. B cells neutralize extracellular bacteria and toxins. And so why does Candida need neutrophils? Well, Candida albicans lives harmlessly in your skin and the mucosa in very, very, very small amounts. And normally the neutrophils just patrol the mucosal surfaces, right? They're moonwalking across the mucosal surfaces, right? And they phagocytose the fungal cell walls before they invade deeper. So you have this like arms race going on. Candida albicans is you got it, I got it, everybody's got it. It's like Oprah's bees, right? Candida albicans lives harmoniously in your skin. It's like, yay. But then the neutrophils go away and now the Candida starts to party, especially in the mouth where it's disgusting. It's disgusting there. And so neutropenia, you lose your first line and you get the fungal overgrowth. And then what about HIV? What about HIV candidiasis then? So that's like a T cell deficiency, viral infections and Candida, but that's like especially mucocutaneous, I guess. So the way to think about like your neutrophils and how they handle Candida in different locations, the neutrophils work best in the blood. Neutrophils work best in, ready? The blood. And also the deep tissues. And if it fails, you get invasive like candidiasis. Now, what about the CD4? What about our CD4 T cells, especially the Th17s? These guys work on the mucosal surfaces. So the mucosal surfaces are like the mouth, esophagus. Can you think of one more location? The vagina. Mouth, esophagus, and the vagina. And that's where CD4 T cells and the mucosal surfaces work, whereas neutrophils are in the blood and the deep tissue. And so you get mucocutaneous candidiasis like oral thrush and vaginal yeast. And so usually HIV knocks out your mucosal T cell defense, right? Yeah, the tongue, good. HIV knocks out the mucosal T cell defense. And so HIV is destroying all the CD4s, especially the Th17s. And then these normally recruit the neutrophils and stimulate the epithelial cells to release that antimicrobial peptides like the defensins. And without those T cells, mucosal immunity collapses, right? But the neutrophil count is still normal there. And so Candida is sitting harmlessly in the mouth and is no longer restrained. And so you get overgrowth and you get thrush. Okay, so why would you not get systemic infection in an early HIV? Because the neutrophils are intact. They still patrol the deep tissue, right? That's why you don't get systemic infection in an early HIV, because the neutrophils are intact. So the neutrophils, neutropenia, in the deep tissue, you don't have phagocytes, and so you have invasive fungal infections. HIV is decreased to the Th17, and so you have no T cell coordination, so you have mucosal overgrowth. Okay, oral thrush, neutropenia, infant suggests transient neonatal neutropenia as a likely diagnosis. 3 more questions. Okay, 3 more questions. 50-year-old man presents to the clinic with fatigue and shortness of breath during exertion that has worsened for the past 6 months. He also reports intermittent palpitations. Undergoes physical examination, we get irregular rhythm and diastolic murmur at the base of the apex in the left lateral decubitus position. An echocardiogram is performed and shows left atrial enlargement and thickening of the mitral valve leaflets. History reveals multiple episodes of fever and joint pain. What is the most likely underlying cause? And yes, you're 100% right, rheumatic fever. Hey, Isaiah is joining from YouTube, by the way. D, correct. Yes, he has rheumatoid. Yes, rheumatoid fever. Good. Okay, really good. You guys totally crushed that one. Yep, Jones criteria. Very, very good. So let's break down the mechanism real quick. Shortness of breath on exertion. So there, mitral stenosis causes an obstruction of blood flow from the left atrium to the left ventricle during diastole. And so the pressure builds up in the left atrium, and that's transmitted backward to the pulmonary veins, and that causes pulmonary capillaries and pulmonary congestion, right? And then you have dyspnea on exertion and orthopnea, and eventually paroxysmal nocturnal dyspnea. And then you also have palpitations. So you have chronic left atrial pressure overload, so you have left atrial dilation. And that stretched tissue causes disorganized electrical activity, which causes the atrial fibrillation. And atrial fibrillation presents with palpitations and irregular pulse. So it's that big left atrium because of that mitral stenosis and the irregular stuff that's AFib, no organized P waves, variable R to R intervals, and then diastolic murmur at the apex. The mitral stenosis produces a low-pitched, rumbling diastolic murmur. And it's best heard at the apex and the left lateral decubitus. And that's the reason why is because the mitral valve there is closest to the chest wall if you're in that position. And so that's preceded with an opening snap, and it's caused by sudden tensing and thickening of the mitral leaflets. And the echo findings, the thickened mitral leaflets and the left atrial enlargement is classic for rheumatoid mitral. And the fish mouth, as you guys were talking about, appearance, is going to be the fused chemistures due to the chronic inflammation and fibrosis. That's the fish mouth thing. Yep, nicely done. Here's the bottom line. Prior rheumatic fever is likely the cause of mitral valve thickening and left atrial enlargement in this patient. All right, and that's my little fish mouth impression here. I should make a little fish. Okay. Question 98. John Jones criteria, niche cow cells. Those are the macrophages in rheumatic heart. Yep. John Jones, baby. Yep. That's the presentation of the disease. You got it. You got it, fatty liver. You nailed it. All right. Here's the next question. So here we have a 34-year-old woman presenting to the clinic with fatigue and mild right upper quadrant discomfort. She has a history of chronic Hep B, diagnosed with routine blood screening when she was pregnant 6 years ago. Managed with the antiviral therapy, but adherence has been bad. Lab tests show AST levels of 75. ALT of 92, hepatitis B virus DNA level of 3 million. A recent liver biopsy shows distinct cellular changes. Which of the following histological features is most commonly associated with this patient's condition? Hep B, ground glass. Yep, you nailed it. That's Hep B. Hundo P, that's Hep B. Nicely done. Yep. Councilman bodies are eosinophilic hepatocytes, frequently seen in chronic hepatitis. Ground glass opacities. Hallmark histological finding of chronic Hep B infection. Ground glass hepatocytes. Lipofuscin, wear and tear, pigment in elderly. Megamitochondria, alcoholic liver disease, alcoholic hepatitis. Amyloid deposits would be Congo red stain, apple greens, neutrophil infiltration is alcoholic hepatitis and abscesses. Ground glass hepatocytes. So when the virus infects these hepatocytes, then it floods the cell's endoplasmic reticulum with surface antigens. And all that protein overload is what gives it the smooth, glassy kind of look under the microscope. This is the ground glass, is all that protein. It's just the viral antigen that fills up in the liver cell. And Councilman bodies would signify hepatocyte death, like apoptosis is a marker of acute liver injury. And ground glass hepatocytes is a viral protein buildup and it's a marker of chronic HBV. Here's the bottom line. Ground glass, hallmark of histological feature of chronic hepatitis B infections. Question 99. 99. 99. Yeah, we got. So in this one, what if I give you a calcium level, and I give you an albumin level, and I give you a phosphorus level, and I give you a parathyroid hormone level? And let's say the parathyroid hormone level is super duper duper high. That's all I'm giving you for now. Let's say the calcium actually is low and phosphorus high. And let's say we have creatinine is elevated. Guys, look at all these inside jokes we have. Cacophony with 99. That's funny. 100%. 45-year-old woman presenting to the clinic. Complaints of fatigue, bone pain, and occasional muscle cramps. History of poorly controlled type 2 diabetes. Physical examination has a blood pressure of high. Dry mucous membranes. Look at all that good, juicy calcium being low. And phosphorus being high, and serum parathyroid hormone being off the wazoo, and then serum creatinine is elevated as well. What is the diagnosis? Is it secondary? Is it primary? Is it tertiary? Well, we have chronic kidney disease, right? And that's secondary hyperparathyroidism. So is it this one or is it this one? Is it B or is it C? Well, we have chronic kidney disease, don't we? Ain't we? We does. Secondary hyperparathyroidism with chronic kidney disease. Yeah. You read the C and you were excited. The creatinine, 100%. Low calcium. High phosphate. Let me just take a screenshot of this chat real quick because I want to add your guys' profile photos is the goal. Oh, I lost it. Oh no, there it is. So yep, they have low calcium, high phosphate, elevated PTH, and elevated creatinine, all pointing to secondary hyperparathyroidism from CKD. we have the impaired phosphate excretion leading to hyperphosphatemia, which then binds the free calcium while decreasing renal 1 alpha hydroxylase activity, which then reduces active vitamin D, which makes it so you have less calcium, which drives the PTH up. PTH is like the last thing to be driven up, and that's why it's secondary. All right, that's the explanation. Now here is the bottom line. Secondary hyperparathyroidism due to chronic kidney disease is indicated by low calcium, high phosphorus, and elevated PTH. Guys, last question. Everybody needs a little bit of break. Today's been a good day. It's been a very good day so far. About to be an amazing day. Got to go down and say hi to my family before they leave to church. Leave to church without me, the agnostic boy. I have a wonderful family. Okay, here we go. A 3-year-old boy is brought to the clinic by his mother because he's been complaining of pain. And look at that kiddo, so cute. That's going to change over. Look at that. Look, he's complaining of pain on his right arm though. Earlier today, his babysitter pulled him up by his left forearm when he tripped on a step. On examination, the boy appears reluctant to use his left arm and holds it slightly flexed and close to his body. There is no swelling or bruising. Palpation of his forearm and shoulder elicits no tenderness, but he winces and pulls when his elbow is examined. What is the diagnosis? Okay, would it help if I said this is nursemaid's elbow? Nursemaid's elbow. Because the babysitter pulls him by his left forearm when he tripped on a step. Classic presentation right here. A couple more sounds good. Perfect. Okay, this is a traction injury. Subluxation of the radial head. 100%. You got it right. Radial head slips out of the annular ligament. And I wonder if I could just show you guys an image of that happening. Check out this view. Haven't seen this view in a while, have you? Look at all these images. Okay, annular ligament. Look at that. Chunk, 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 chunk. Hey, babysitter, why don't you pull me up? And I feel bad because like I did that to my little brothers all the time, but they all seem fine. Displaced annular ligament. Whoop, whoop, whoop. Nursemaid's elbow. Here's another example. This is exactly what happened in this condition. Oh, you can't see because my pesky notes are in the way. This is like a perfect demonstration of what happened there. Cool, guys. Cool. And so, classic nursemaid's elbow. Fracture of the humeral shaft. That'd be crepitus and deformity. Dislocation of the elbow joint. High energy trauma. Obvious deformity. Tear of the biceps tendon. Popeye deformity. And this one actually is interesting. We'll take a look at this for sure. Popeye deformity right here. Deformity is called Popeye deformity due to the rupture of the long head of the biceps, the shoulder area. Ouch magouch. Look at that. Papa Sailor Man. Toot toot. That was out of key. All right. But yeah, rare in children, seen in adults with lifting injuries. And septic arthritis of the elbow, fever, erythema, effusion, limited range of motion would be septic arthritis of the elbow. All right. So pulled by the arm, traction injury. Well, guys, here's the bottom line. Radial head subluxation is common in young children after pulling injury present with reluctance to use the affected arm. The random medical fact is that erythropoietin and renin are both secreted by the peritubular interstitial cells and the juxtaglomerular cells of the kidney, respectively. So low oxygen, your kidney is like, I need more blood, EPO, and raise the pressure, renin. So there you go. 7, 9, 10, 12. Very nice. It's hot in here. So during the study session, there was a question. It was, how can we differentiate in the vignette Wegener's granulomatosis versus good pastures? And so I want to hit on that right now, and then I'm going to give you guys a practice question. So there's some key distinctions between these two diseases, even though they both are going to involve the small vessels, the capillaries. GPA affects the upper airway. Good pasture does not. The antibodies for good pasture is anti-GBM, and for GPA, it's Cianca. In the renal, it's posse immune for GPA, and you're going to have crescentic. And then for good pasture, we have linear IgG deposition and also C3. In the lung, for GPA, we have nodules, whereas for good pasture, we do not have any granulomas. For GPA, we do have granulomas. You can even remember the G for granulomas. And for good pasture, you should think of really only depositing in the kidney and the lungs, whereas GPA can also deposit in the joints and the skin, as well as the lungs. And that's how to distinguish them. So now let's do practice question together. So a 35-year-old woman presents to the emergency department with worsening shortness of breath and productive cough. She has a history of recent fatigue and malaise. On examination, her vital signs reveal a low-grade fever and tachycardia. Lung auscultation reveals bilateral crackling. Her extremities are notably pale, with mild pedal edema. Lab test shows hemoglobin of 9, elevated creatinine of 3.2, that's cueing us into the renal involvement, and urine analysis reveals red blood cell casts. A chest x-ray shows bilateral diffuse patchy infiltrates. Further testing reveals a positive cytoplasmic staining pattern on the indirect immunofluorescence of the patient's neutrophils. Which of the following serological markers is most likely elevated in this patient? What do you guys think? Now, I made this question specifically as a kind of difficult practice question that gets at the details so I could answer the question in chat. So let me know what you think. Yep. Here's the question again. All right, so both of these are going to cause pulmonary and renal syndromes, right? So they can present with like hemoptysis or hematuria. We see that here, the red blood cell casts. However, they are different Onca possibly C, and then I have to scroll down so you can see D and D as well. Somebody's saying maybe C. I like the Onca. So GPA vasculitis, and then good pasture is autoimmune type 2 hypersensitivity against the basement membrane. Myeloperoxidase Onca. Okay, nice. Okay, so we're thinking C and D, and that is completely what you should be thinking. In fact, for step 1, that's all you're going to need to know. I decided to throw in a little bit of more esoteric detail, and that is involving the proteinase. And so let's talk about it. The correct answer to this question is actually going to be D, the proteinase, and also your 3 Onca. And so let's talk about the mechanism here. So first of all, we have to know what it is GPA. That's the first step. We know this because, yes, we have all these things, but also we have the C-Onca positivity, and that means that it's GPA. So looking at the positivity of C-Onca, that was a tough one, but Burhan asked a really specific question, so I wanted to give him a hard one. And so the antigen target of the C-Onca, and this is where it gets esoteric, you won't be tested on this specifically, is proteinase 3. But I did want to kind of hint at the difference immunologically between these two conditions, right? The C-Onca is what actually does the damaging, because the target of C-Onca is actually the proteinase 3. And so you have the small to medium vessels that are necrotizing and granular mass. Now, obviously, our basement membrane and the linear is good pastures. Anti-DS is lupus. Myeloperoxidase, that's what a lot of us were thinking here. The P-Onca pattern, that's in microscopic polyangiitis and Church-Strauss, but this is a C-Onca pattern. Yeah, of course. Happy to help. Okay, so hopefully that was a nice, challenging question. Let me know if you guys have any other questions you'd like me to go over. And if you're watching later on YouTube, then like and subscribe. Now we'll go back to our study page. Yeah, I know these work study sessions can be a little bit like, wait, what's happening? But just think of it as a nice place, like a kind of like a tutoring session where you can just kind of sit down and ask whatever questions you'd like, join a community of workers and lock in, right? Because like you're not alone. Dedicated period is a long, hard grind and you're not alone. It feels like you are, but you're not. There's so many med students all across the world, and you guys should connect. How to get published, how to get sponsored, all that stuff. So more to come, but for now, just one step at a time. Yeah, it'll be exciting. I'm excited. Let's see how long your message stays on the screen. Okay, long enough. That's good. All right, I think we're ready for review, aren't we? So I'm going to record this for YouTube, but you guys can have the privilege to, yeah, we're doing them, hematopoiesis, we're doing them. Let's go. We might go a little bit slower just because I actually haven't taken all the notes on these yet. For instance, like I usually like to go through each one and kind of tailor them and specify them, but these ones, and then I will kind of like preview the next one. So it might take a little bit longer, but feel free to do some work in between. So here we go. Let's see, what should I say? Question 101 is where we're on. So hello everybody, this is a continuation of our YouTube series of NBME. Right now we're on question 101. We plan to get through all the way to 200, hopefully on this stream. We might only get through 50, but we'll see how we feel after that. Live. If you'd like to participate in these If you'd like to participate in these live streams, then you can just turn on the notifications and you can interact in Twitch or on YouTube. So without further ado, let's get started. I think for this, it's better if I have my green screen up. So let me do that now. There we go. And I'll turn on this button. 3, 2, boof. Look at that. Okay, everybody watching on Twitch and YouTube, feel free to answer in the chat. We'll be doing this question. Sid L says magic. Yep, this is magic. A 35-year-old woman with a history of prescription opioid misuse presents to the emergency department seeking help for withdrawal symptoms. And upon follow-up, she mentions that using opioids no longer gives her the same level of euphoria, which the following describes how the prescribed medication interacts with the opioid receptors. Okay, she's given a medication that binds to opiate receptors and alleviates the withdrawal symptoms. Hey Junebug, thanks for the subscription. Hematopoiesis thinks that it's partial agonists at the mu receptor. Anybody else agree? First of all, what is the medication? Did they mention what it is? Buprenorphine, naloxone, most probably. Anybody else want to hazard a guess? Okay, so far we just have the partial, and so here we go. The patient is given buprenorphine, and that is a partial mu-opioid receptor. A partial mu-opioid receptor. It reduces withdrawal symptoms while blocking the euphoric high of the full agonist. You block the high of the full agonist. And so you are indeed right. This is a partial agonist of the mu receptor. And how would this look on a graph? Yep. Hematopoiesis says that this is buprenorphine because it's addiction treatment. And we'll cover that in a second. I love these intuitions. This is good. So buprenorphine binds strongly to the opioid receptors, but only partially activates them. And this prevents the severe withdrawal while also limiting the euphoria. And that explains why they no longer have the same high. Okay, so a competitive antagonist would be like naloxone, right? A competitive antagonist. And so I took some notes over there, and that would look like this. You shift it to the right on these graphs. If we were to say that this is, the potency and here's the concentration, you're just shifting it to the right. The Vmax can still be achieved. It's just going to take a little bit more concentration. All right. And so we need to know about mu receptors, what they do, kappa. Also, methadones are going to be mu agonists. Buprenorphine is a partial one. And then the difference here, and this is what I wanted to hit on, is naloxone, full antagonists. All right. So why would a full antagonist be wrong here? So essentially, we need to parse out the difference between naloxone and buprenorphine because this is addiction treatment. Yeah. And more specifically here, it's a difference between competitive antagonism and also partial agonism. So naloxone is a competitive antagonist at the mu, and you do not have any euphoria whatsoever. And in the question stem, it's just blunted. And so blunted tells us that it's a partial agonism, whereas a full block would be naloxone. It's like stopping cold turkey would be naloxone, yes. And there's no help with withdrawal. The question asked specifically about withdrawal, and naloxone's not going to help at all with that, right? It induces withdrawal. Whereas relieving withdrawal, that's certainly going to be buprenorphine. Naloxone is good for overdose, but buprenorphine would not be used for overdose reversal. Additionally, buprenorphine has a very long half-life, whereas naloxone is a very short half-life, right? So naloxone, you should really think of that as an opioid overdose reversal. And then for buprenorphine, that's kind of the drug, as hematopoiesis was saying, that you use for opioid use disorder. Okay, does that make sense, everybody? Everybody vibing with this question? Okay, often combined with naloxone to prevent abuse, less risk of overdose. It's binding to the mu receptors with high affinity and displaces the other opioids. You have partial activation preventing withdrawal, but not causing euphoria, and you're going to stabilize the patient. Okay, and this is important because opioid overdose kills more Americans than car accidents in the United States. And so that's why buprenorphine is like a huge, amazing drug. So there you have it. And like methadone is a full agonist, but buprenorphine is going to be a partial. So here's the bottom line. Buprenorphine is a partial agonist of the mu receptors, alleviating withdrawal while reducing overdose risk. Now give me a moment while I pull up the next question. Also, let me know if you guys have any follow-up questions about that. We can do that in between questions. And if not, we'll go on to 102 and we'll try to finish all the way to 150 and maybe even 200. Hematopoiesis says big W. Speaking of which, I have to add the chat so that YouTube can see the chat here on this page as well as the other pages. So you guys go. Your comments will now live in infamy. Okay, hopefully you guys know your type 1, type 2, type 3, type 4, because that's about to come in clutch. Here we go. Look at that photo of the guy's nose. A 28-year-old man presents during the summer with a 2-week history of itchy eyes, runny nose, and a mild cough, as you guys can see in those images. He mentions that he experiences these symptoms every single year. Physical examinations shows conjunctival injection and pale, boggy nasal mucosa. His temperature is 98. He denies any fever or purulent nasal discharge. Which of the following cell types is most likely elevated? Hematopoiesis got the answer. Look at that, guys. You saw how quick hematopoiesis got this answer. Yes, 100%. So the answer is eosinophils. You can pause this and look at this answer. Basically, allergic rhinitis is what they have. It's a type 1 hypersensitivity, and this is caused by the environment. So you get some trigger, in this case, it's pollen, and all of a sudden you have the itchy eyes, pale, boggy mucosa, all that stuff. I feel like I have perpetual pollen around my nose at all times. And the hallmark of eosinophilic infiltration in nasal secretions is going to be these seasonal recurrence, like the pale, boggy mucosa, and these eosinophils that are recruited by what? The IL-5 from the Th2 cells. And so that plays a huge role in allergic reactions. So eosinophils. What about the basophils? We'll look at why each answer choice is wrong. Now, basophils would be associated with histamine release in the blood. You'd have the circulating, these are like the circulating cousins of the mast cells, and they're not going to be really predominant in the nasal secretions. The neutrophils, that'd be involved with purulent discharge and bacterial infection, not going to be seasonal allergies. Lymphocytes would be involved in viral infections, like viral rhinitis. That's the common cold, would be lymphocytic. And usually lymphocytes will present with a fever, not seasonal allergies. And macrophages are going to be involved in phagocytosis, chronic inflammation, and granuloma formation, but not in seasonal allergies. Okay, so look out for that boggy nasal mucosa, seasonal symptoms, conjunctival injection, itchy eyes, all that good stuff. Okay, so here's the bottom line. Eosinophils are elevated in nasal mucosa during allergic rhinitis, characterized by seasonal symptoms and non-purulent discharge. Yep. And I'm seeing in the chat as well that it says, Luisa says, IL-4, 5 are your allergy-relevant cytokines. Very nice. I would add to that list IL-13 as well. So IL-4, IL-13, and your Th2 cytokines. Why? Because as you mentioned here in the chat, very nice, IgE, class switching, and eosinophilic recruitment. That's what those are involved in. Also, it's notable that nasal polyps can form as well in allergic rhinitis. Time to move on to the next question. Let me know if you have any questions about that one. And really quickly, while we're thinking about the next question, I think it's worth just making sure you have down pat all of your type 1 through 4 hypersensitivities, just the most high yield kind of topics on each one. So 1 is going to be anaphylaxis, right? And it's IgE mediated that has the mast cell degranulation within minutes. Type 2 is going to be the binding and cytotoxic. This would be like IgG and also IgM. And this binds to the cell surface antigens and it causes destruction within hours or days. Type 3 is the complex immune, the immune complexes. And these guys are the actual complexes that are going to deposit in the tissues. And so this is going to be like about 1 to 2 weeks. And then the type 4 is delayed, and that's T cell activation with cytokine release and inflammation. And that's going to could be about 2 to 3 days. Okay. So really fast, hives, bronchospasm, sneezing, type 1. And also type 2 is cytotoxic, and basically the antibody is going to bind to the cell and destroy them. And there you think of the Coombs test. All right, here's our next question. Let's see if you guys can answer it. Say it all. You guys are such a good community. All right, here's the next question. A 32-year-old woman comes to the clinic with progressive shortness of breath and occasional wheezing over the past 2 years. She has never smoked, drinks alcohol occasionally, and works as a librarian. Oh, those librarians be drinking. She mentions her father has a history of lung and liver problems in his 40s. On physical examination, you have mild hepatomegaly and distant breath sounds. Which of the following is the underlying cause of the patient's findings? Looks like she has decreased forced expiration volume in 1 second and a reduced FEV1 FVC ratio. And we have hyperlucent lung fields with changes predominantly in the lower lobes. Okay, there's the question. Feel free to pause. Take a look at this. What is this condition? Hematopoiesis is saying E. E, says Sedal. Any other contrarian takers here? Somebody want to disagree just for the heck of it? Yeah, okay, we got a lot of E's in the chat. So alpha-1 antitrypsin, it normally inhibits the neutrophil elastase. That's also important. So inhibits neutrophil. And so if it's not there, then you have way too much elastase, right? So this is protective to the alveolar walls. And without it, the elastase breaks down the elastin, and that causes the emphysema in non-smokers and librarians. You also get amyloidosis in the liver. Yep, that's right. So it leads to hepatomegaly and also liver dysfunction, as hematopoiesis said. Yeah, let's look at these answer choices. Connective tissue disorder. Yeah, they're trying to say that she's not a party girl. And exposure to environmental toxins, infectious lung pathology. So D is infectious lung pathology. That's getting at the fever and infiltrates. There's no signs of acute and chronic infection here. And so here, this is COPD and emphysema in young non-smoking individuals. Every single time you see COPD and emphysema in a non-smoking young individual, always think of alpha-1 antitrypsin, right? It's the pan-acinar, which means pan-lobular emphysema that destroys the entire acini and primarily in the lower lobes. And you can contrast this with the centralobar upper lobe that's seen in the smoking-related diseases. But this is non-smoking and it's lower. And so, yeah, this is an allelic defect, right? And so you don't have to know all of the genotypes here. But the pathophysiology is essentially the biggest thing is that there's decreased alpha-1 antitrypsin in the lungs that causes increased neutrophil elastase activity. And there's elastase destruction in the alveoli that causes emphysema. And so there's misfolded alpha-1 antitrypsin that accumulates in the liver. And so when you guys are mentioning it's because of the accumulation of those misfolded proteins that accumulate in the liver, causing hepatocellular damage. So everybody feeling good about that one? Anybody have any questions about pan-acinar emphysema? Thanks. Okay, there's the pathophysiology. It's a little bit lower yield. And maybe one question that's commonly asked here is like, why is it pan-acinar? Like, what's up with that big old fancy scary word? Well, pan-acinar just means the entire acinus is destroyed, right? So an alpha-1 antitrypsin deficiency, all of the parts of the acinus from the respiratory bronchial to the alveolar sacs are equally vulnerable because there's no protective alpha-1 antitrypsin there. And so you have uniform destruction all over. Yep, the genetic mutation of the PIZ, alpha-1 antitrypsin misfolded. And why is it the lower lobes too? Like, what's the reason that it's lower lobes? Well, good question. Perfusion is greater in the lower lobes. So there are more neutrophils that migrate there. Neutrophils release elastase. Neutrophils release elastase. And so more blood equals more neutrophils, equals more elastase, equals more need for antitrypsin, right? Alpha-1 antitrypsin, because alpha-1 antitrypsin inhibits elastase, right? But if it's deficient, then it can't. And so more neutrophils, no protection, destruction of the lower lobes. That's the reason why. Kind of cool, I think. Kind of fun, kind of quirky. So if they don't smoke, if they're a librarian and they're having COPD problems, you know what to do. You know what to do, guys. All right, bottom line, progressive dyspnea and liver disease in a young non-smoker librarian suggests inherited alpha-1 antitrypsin deficiency as the underlying cause. Okay, any other questions on that one before we move on? Speak now or forever hold your PIZZ. Oh man, anatomy is right. Gotta know them. Do we know our retroperitoneal structures? Let's go through one by one. Probably psoas abscess. All right, well, Sedal is usually right. So A is what we're thinking. Iliacus fascia. Let's go through each one. Let's start with sartorius at the very bottom, work our way through. Sartorius. That would be if they cross the thigh obliquely, right? That's the sartorius muscle. And that's the superficial anterior thigh, not part of the deep retroperitoneal tract, right? That's pretty superficial. Yep, super surgeon Sedal. I like that. It rolls off the tongue. I would love for Sedal to give me surgery, provided that I needed surgery, not just for fun. How about the iliotibial band? What is that all about? Well, that is the lateral thigh stabilizer, right? And so that's not contiguous with the retroperitoneal spread. So that's not the right answer. How about gluteal muscles? The big butt, posterior hip, the buttock, that is not connected to the anterior psoas pathway. How about rectus abdominis? Well, that's the anterior abdominal wall. That's not retroperitoneal. Okay. So now we're cueing ourselves into the answer. And in order to answer this one too, we have to know what's going on with our kidney. The kidney is retroperitoneal. Sad pucker. That's a P. And so if you have an abscess in your kidney, that'll spread inferiorly via the psoas muscle. And I think it's important that I show a picture of this. Otherwise, we're just talking in circles about it. Okay, so the kidney is retroperitoneal. And if you have an abscess, it spreads inferiorly to the psoas muscle. And that lies deep and it travels between the iliacus fascia. And so as the psoas continues into the iliac fossa and the thigh, the infections will spread along that fascial plane. And so that's why the patients are going to have groin pain and thigh pain from what's essentially just a posterior infection. So the key takeaways from this one are that we have groin pain, right? There's worsening groin pain. I'm going to highlight the most important parts that key you in immediately to this answer. Recurrent renal stones, and there's a perinephric abscess. Perinephric, and there's psoas muscle involvement. So our answer is the iliacus fascia. That's the highway for this condition. And there are some other associations that we'll talk about here, but that is the correct answer. Sedal surgeon got it right. The kidney is retroperitoneal, closely abuts the psoas muscle, right? Very close by, at the lower pole especially. And we went over all of these conditions, and so I think we're ready to move on. Sedal, thanks for that high-yield fact. That's awesome. Now, the bottom line is that renal abscesses commonly extend to the iliacus fascia, leading to potential complications. But more importantly, retroperitoneal structures will spread through that iliacus fascia highway. I really feel like I should emphasize that this is a P. Sounds great. Thanks for stopping by, Crescent. Good to see you. Enjoy. Now, there's a very interesting formula, and that is that prevalence is equal to incidence times duration. That's a very interesting idea, right? The prevalence is equal to the incidence times the duration. So here we go. A recent study reveals that a particular chronic condition is observed more frequently in urban population than rural. Despite the rates of new diagnosis being similar across both settings, which of the following factors could best account for this observation? Let's just say that. There's higher prevalence in urban settings. What does that mean? But there's similar incidence. Maybe C? Yeah, this is a tough question. And I do think it's important that addendum that I give is stated. They have identical incidence, but there's higher prevalence in urban settings. So prevalence is the number of cases of disease at a time. Incidence is the number of new cases as a fraction of the total population over time. Very good, Sedal. They're either being treated well or are dying quicker. Yeah, let's look at this one. The answer is D. Duration is density. Oh, duration is destiny. All right, there's our formula. Incidence is the new cases over a period of time, and prevalence is all of them at a specific time. And the best way to teach this concept, hold on one second, is there's this image, which is the best image ever. Incidence, prevalence. It's the bathtub one. You know that one? Here is the best way to teach it. There's a nice image. Incidence, prevalence, mortality is the way that it gets out. So basically, this is the model of disease prevalence. And in the question that we had, the urban and the rural areas had the same incidence, and the incidence is the faucet flow, right? But the urban populations had higher prevalence, and that means that the tank level is higher in the urban populations. And so in the urban populations, they have better healthcare, so they have longer disease duration, and so they have slower drainage. They're plugging that mortality. Do you see how they're like plugging it up? And so the disease stays in the tank longer. That's the way to think about it. Remember how urban had bigger prevalence? It's because they're plugging up the mortality leak. That's the way to think about it. They've got good healthcare, slow drainage, slow mortality, and remission. Whereas the rural populations, they have worse access, right? So they have higher mortality or faster resolution, right? And so basically, the disease leaves the tank faster. That means that there's a lower prevalence, even with the same incidence. Yeah, this can be tricky, but the bathtub is the best way. Just think of the bathtub. Think of incidence, because this is like a stream of water coming in. The I looks like the stream of water. The prevalence starts with a P, so it's the pool. And M is the leak, because we all have to die. And there we go, Sedal. just made an awesome comment. It's like incidence increases prevalence. If you treat the disease, the prevalence disease, even though the incidence, the new cases, remain same. Now, if you manage disease, not treat it, you get good healthcare and reduce mortality, the prevalence increases. You're just managing the disease. You're just reducing mortality, but more people are sick, they're just not dying. So really, it's all about death is the way to think about this. Don't just think bathtub, think death. And then hematopoiesis says, yeah, if you have healthy people, leave the population. Okay, here we go. Chronic conditions may appear more prevalent in urban areas due to longer disease duration among residents. So the duration of the disease is important to think about here. Because if you increase the duration, you're going to increase the prevalence. Any questions on that one while we load the next one? Okay, ready for the next question? Here we go. A 64-year-old man presents to the clinic with a 6-month history of progressive deformity and intermittent pain in his left leg. He mentions that he struggles to fit in his shoes. His left leg feels heavier. He denies any history of trauma. On examination, there is noticeable bowing of the left tibia with no erythema or warmth. Lab studies show elevated alkaline phosphatase with calcium and phosphorus levels remaining normal limits. On X-ray, the left leg shows thickened cortices and a mix of lytic and sclerotic bone changes. What is the diagnosis? He has Paget's disease. Very, very good. All right. So our answer is indeed C. Very nice. We have a progressive bone deformity with elevated alkaline phosphatase and normal calcium levels. So what happens here is we have first increased osteoclast activity. That's important. They like to ask that, right? And that is resulting in the synthesis of sclerotic woven bone. Okay. So it's characterized by excessive disorganized remodeling, and the hallmark is imbalance between osteoclast and osteoblastic formation. Over time leads to structural weakness. All right, and hematopoiesis has a question. Is treatment for this bisphosphonates? Good question. So Paget's disease is overactive osteoclasts, and bisphosphonates directly inhibit osteoclast activity, and so it helps with the normalizing of the bone modeling and all that good stuff. And so definitely we're going to block that breakdown with bisphosphonates for sure. Let's look at these other answer choices and see why they're correct or incorrect. Osteosarcoma, that has the sunburst pattern, typically younger demographic Codman's triangle. Bone metastasis is associated with multiple punched out blastic lesions. Osteogenesis imperfecta, that one has the blue sclera, hearing loss, and frequent childhood fractures. And fibrous dysplasia, ground glass, McCune-Albright. Do we know the mechanism of each of these? So first of all, osteoclasts break down the bone, releasing calcium and also phosphorus. Osteoblasts build the bone, increasing the AL. Paget's disease is overactive osteoclasts, and then you get disorganized osteoblasts. You have the woven bone stuff and elevated ALP without the calcium and phosphate imbalance. So you have that initial lytic phase, and then you have the mixed phase afterwards. Also, if you guys want, I can include treatment in all of these as well. So here's the bottom line, and hematopoiesis says lion-like facies is also high yield. We'll talk about that for sure. So elevated alkaline phosphatase and mixed lytic sclerotic changes on X-ray is Paget's disease of bone. Okay, and while we go on these next questions, let's talk about the lion-like facies and also the hearing loss stuff. So yeah, the hearing loss can present because you have the thickening of the skull bones, and that can compress the cranial nerve, the vestibular cochlear nerve, 8. And so then you get conductive and sensorineural hearing loss, and you have hearing loss in the elderly with the thickened skull is going to be Paget's. So really that skull thickening is huge. They'll have different hats, things like that. Elderly patient typical for Paget's as well, yeah. So in the sclerotic phase, osteoblasts are going to lay down that bone, and then you have a cotton wool appearance in the advanced disease. For the lion-like facies, you should also be think of beta thalassemia major, and that's typically going to be in like a child. It's transfusion dependent. They have frontal bossing, and then they have that lion-like face. But also you have like that facial bone overgrowth stuff. So the frontal bossing, like the big old forehead, the maxillary overgrowth, the protruding jaw, flattened nasal bridge, the prominent zygomatic bones, that kind of look. Yep, so bone remodeling. But the beta thalassemia incidence of that, the beta thalassemia major, is that you actually have extramedullary hematopoiesis in the facial bones. But you can also see like lion-like facies in fibrous dysplasia and rickets and syphilis. Nice. Thanks for these little nuggets there, Sadal. And hematopoiesis, risk factor for osteosarcoma. On to our next question. Here we go. A 33-year-old woman presents to the emergency department with fatigue, gingival bleeding, and petechiae on her lower extremities. She reports upper respiratory tract infection 2 weeks ago, but denies abdominal pain, diarrhea, and recent travel. She has not been taking medications. Physical exam shows scattered petechiae on the legs and mucosa bleeding. Blood smear shows large platelets. Coagulation studies include normal PT and PTT. What's the most likely diagnosis? And I'll keep the labs on the table there. And we have thrombocytopenia. Everything else is normal. So she's tired, petechiae, mucosa bleeding, only thrombocytopenia. This is normal hemoglobin, totally normal. White count is fine. Creatinine's normal. Clotting tests are fine. Sounds like TTP, you think? TTP. I made a video about this before, the difference between TTP and ITP. And what you think of is, I don't know, for ITP. If you're like, what's the exact diagnosis? TTP is the terrible pentad, right? That has different presentations. Yes, it is a woman indeed. This is ITP. Yep, ITP. And so they have just isolated here. The reason why it's not TTP is that would present with fever and neurologic signs. Also, you'd have schistocytes and renal failure. But here, there's no neural problems or renal problems. Also, I don't even think she had a fever, did she? So here's the pathophysiology. Immune dysregulation against the platelet surface glycoproteins. You opsonize the platelets, and then the spleen is like chomp, 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 chomp. Thrombocytopenia leads to mucosal bleeding and petechia, and then marrow response, large platelets to compensate. So ITP involves those splenic macrophages, and you get thrombocytopenia because of the immune against the platelet surface glycoproteins. Seidel is saying for HUS and TTP, remember the triad of anemia, uremia, thrombocytopenia. Now you add diarrhea to HUS because of E. coli, and for TTP, add fever and neurologic symptoms. Very good. Very, very nice recap. Now, almost all of the ITP cases in children are going to follow some sort of a viral illness. But yep, it's just platelet-type bleeding problem with fatigue, petechia, and mucosal bleeding. That's all she's got, just like platelet problems. Okay, here's the bottom line. Low platelet counts with normal PT and PTT and large platelets suggest immune thrombocytopenia, purpura. All right, folks, let's do 3 more questions, and then we'll take a quick break, if that sounds good to you guys. And then we'll come right back. But just a quick break, because I got to respond to some employees. Some of my tutors are messaging me. Got to attenuate to that. Any questions before we go into the next one? Just put it in the chats. Okay, hopefully you guys know all of your tumor suppressor genes for this next one. Here we go. 3, 2, 1. A 68-year-old man with a history of long-term tobacco use presents to the clinic with difficulty swallowing and also recent weight loss. A CT scan of the chest reveals a mass in the distal esophagus. A biopsy of the lesion shows poorly differentiated adenocarcinoma. Immunohistochemistry is positive for cytokeratin 20. Genetic analysis demonstrates alterations that are commonly associated with tumor suppressor genes. Which of the following additional findings is most likely associated with the alterations of similar tumor suppressor genes? Okay, so I listed out some of these, and while you guys are thinking, okay, so not B, we're saying it's not B. Okay, what is it? Well, let's start listing these out, okay? APC, I like to think of that one as the starting one because it's a pulled carrot. You pull a carrot out of the ground, all right? A pulled carrot is colon cancer. TP53, what is that one? Lee from many syndrome. And that's where you have tons of solid tumors all over the place. What is that? Well, that tells us it's a GI epithelial marker. Okay, Barrett's esophagus, that's found and mutated in almost every single solid tumor, especially definitely colonic adenocarcinoma. And so the APC is the Wnt pathway, FAP, colon, adenocarcinoma. TP53 is the DNA repair pathway found in esophageal, colon, breast, brain tumors. Whole bunch of them. That's why they call it the garden of the genome. Yeah, this one's tough. Yeah, that's fair. Tumor suppressor gene. That's the inactivated, the 2-hit theory, the 2-hit hypothesis. So a pathophysiology that's common here is you have Barrett's esophagus, and then you get metaplasia from chronic GERD, and then you get the genes have like an APC loss that causes crash activation, that causes TP53 inactivation, and then you have esophageal adenocarcinoma. And that same progression is mirrored in colorectal carcinoma as well. All right, so esophageal carcinoma has a tumor driven by the tumor suppressor mutation. Okay, so the answer is multiple polyps in the colon. Answer is E. How about persistent leukocytosis? Not associated with tumor suppressors. It's due to cytokine driven like JAK2. Increased, you guys got that one right, pheochromocytoma, associated with MEN2. Increased urinary metanephrine levels. Early onset Alzheimer's, presenilin mutations early on. Elevated serum alpha protein would be hepatocellular carcinoma. Yeah, what Seidel said is right. CMYC is usually Burkitt's lymphoma. You can remember that because kids, you give a McChicken to the kids if you guys have McDonald's where you're from. Okay, there are the associations. Here's the pathophysiology if you guys want to pause and go over those explanations. But yep, you just lose 2 copies of one gene, you get cancer. And those are the tumor suppressors, APC, TP53, RB, all that good stuff. All right, so let's do the bottom line here. So the bottom line is alterations in tumor suppressor genes are associated with familial adenomatous polyposis, leading to multiple colon polyps. And I see there are a lot of questions in the chat about MYC and about RET and all that stuff, right? And yeah, you guys got it right. B is not it. So the RET is a proto-oncogene, and that's seen with MEN2A and MEN2B, not a tumor suppressor. And then, of course, we know like the MEN1 tumor suppressor with the menin gene, and then MEN2A and 2B is caused by RET, which is a proto-oncogene. And then a pulled carrot, that's the tumor suppressor. MEN1 is a tumor suppressor. CMYC is an oncogene seen in Burkitt's lymphoma. Okay, any questions about that? Maybe we could talk about CMYC a little bit while we conjure up our next 2 questions, then we're donezo. Take a little break for a second. So what is c-Myc? I should just write this down. Okay, c-Myc is a transcription factor, and it promotes cell proliferation. And there's a translocation associated with it. It's the 814. And that's when c-Myc is going to be placed under heavy chain enhancing. And then you have, I don't know of any s-Myc though. I think Sedal said s-Myc is for small cell. I thought it was l-Myc is for small cell. And so there's a Myc family. Myc chickens. There's a Myc family, and they're oncogenes. They're gains of functions. There's only one allele that's needed versus tumor suppressor genes. That's the two-hit hypothesis. You need two of them. That's the difference. That's what's going on there. So c-Myc is going to be B cell. N-Myc is neuroblastoma. L-Myc is the lung. Sedal says, mnemonics got me wrong. Yes, L-Myc for lungs. Got it. Okay. A 45-year-old woman is admitted to the hospital with severe pancreatitis. She is 170 centimeters tall and weighs 70 kilograms. Over the last 48 hours, she has been on nothing by mouth, NPO, and receives intravenous fluids. On examination, she appears ill. Her vitals have a heart rate of 110. Blood pressure is this. Lab still elevated serum. Oh, amylase and lipase. What's going on here? What is this? Compared to healthy, which the following describes her caloric and fluid needs. What's going on? Okay, we got some metabolic stress going on, right? She's got necrotizing pancreatitis. She looks bad. She looks like a great person, but she looks bad, right? She's febrile. She's tachycardic. She has low albumin. Her body is just breaking down tissue. She's losing protein and she's pushing fluids into the third space. She needs decreased fluid and elevated nutrition, says Hematopoiesis. I love that name, by the way. You really just went out there onto Twitch and made your name Hematopoiesis. And I love that. What's your dad's name? Ipo? All right. So her body needs more energy to heal. It's losing fluids. And so both caloric and fluid replacements are needed. And so we just got to increase those requirements, nutritional requirements, and also increase the fluid requirements. Yep, say it all, 100%. Nailed it. Okay, that's our answer. It's pretty obvious. Hypermetabolic catabolic state characterized by systemic inflammation and capillary leak. The third spacing of fluids into the retroperitoneal and the peritoneal cavity, increased caloric demand. And so that supports the healing and increased fluid requirement to replace the losses and prevent hypovolemia. All right, all these other ones just kind of don't really make sense. In acute necrotizing pancreatitis, inflammatory mediators. Oh, Hematopoiesis has a question. We'll definitely hit on that. And I'm going to put the questions kind of toward the end so that while I'm making the next question, I can answer those. In necrotizing pancreatitis, inflammatory mediators, so TNF-alpha, classic, and IL-1 and 6, trigger a systemic inflammatory response. The body is then hypermetabolic. Large amounts of all this stuff is consumed. Capillary permeability increases and you have fluid loss in the third spaces, interstitial spaces. The patients are MPS but require aggressive hydration. Okay, SIRS. They got that SIRS going on. Systemic inflammatory response. Third spacing is the loss of the volume, hypovolemia, fluid depletion, loss of albumin. Okay, some associations. Hypokalemia due to fat necrosis, binding of calcium. ARDS from systemic cytokine spillover, increased BUN for inadequate resuscitation. Here's the pathophysiology. Here are the key features as well. Hypermetabolic state, increased caloric needs. And so what's happening is there's severe pancreatitis, and so the body is burning energy at double its normal rate. And the pancreas just floods the bloodstream with enzymes, and it triggers like a super massive inflammation. And cytokines open up the capillaries, causes leakage, and that's a process known as third spacing. And regarding your question, wouldn't increased fluids cause edema due to loss of albumin? Yes, that's exactly what happens. That's one thing Step 1 loves to test. Edema does not mean hypervolemia. You can have total body overload and also be intravascularly depleted at the same exact time. And so that's kind of a paradox here, right? Because especially in burn, sepsis, or in this case, pancreatitis, what's actually happening in necrotizing pancreatitis, by the way, is we have increased TNF-alpha, increased IL-6, increased permeability. Albumin leaks out, decreases the oncotic pressure, that causes the fluid to flow, right? It's the inflammation. TNF-alpha is IL-6, increasing permeability, fluid flow. And so that's what causes the edema and the low intravascular volume, even though they have that really swollen appearance. They still have that low kind of volume. And so even though the patient looks, they're all red, their circulating volume is low, which means they still need aggressive fluid resuscitation, right? Burns, for instance. They love to test on this, by the way. Burns, lots of edema, still need fluids. Nephrotic syndromes, total body edema, low plasma volume, still need fluids. Pancreatitis, retroperitoneal third spacing, right? Decreased albumin, leaky vasculature, still need it, right? So give IV fluids to maintain the perfusion. Also, you got to correct the albumin loss, only in selected cases though, like cirrhosis or massive leaking. Okay. And by the way, thanks for the sub, Martins. Thanks for the sub. Appreciate it. All right. And I love this concept, by the way. Third spacing just seems like such a cool name. I like that idea. Third spacing. It's the fluid that shifts out of the vascular space into the non-functional compartment, and it can't even be used for perfusion. It's not in the cells, right? It's not intracellular. It's not in the blood. That's intravascular. It's in the third space. It's in the twilight zone, interstitial peritoneal or retroperitoneal. One of those places, the third space. I get goosebumps just talking about it. Look, the third space. I got to write a poem about that. Oh, life is so good. Okay, on to our bottom line. In necrotizing pancreatitis, patients require increased nutritional and fluid support due to metabolic stress and fluid loss. Cool beans? Are those beans cool? I think they're pretty cool. I think they're cool. All right, any questions? Any questions before we move on to the final question before our little break? I'm already scaring people just by writing electrodes. Even worse. This one's going to be about sensory neural and conductive. Hey, Saswan. Ooh, good question. Good question. How do we know? So for those of you who are on YouTube watching this later, Saswan just asked, how do we know it is necrotizing, not just pancreatitis? That is a good question. So I'll answer that one before we do this next question. Necrotizing versus panc, right? Just basic panc. So there are a couple types of pancreatitis. There's acute pancreatitis, and that's just inflammation. Right? Just inflammation, not very severe. There's necrotizing, that's inflammation and also tissue death. And that's severe, it's life-threatening, right? And so the clues from the vignette, that's how we know. One, they tell us that the CT scan says so. In that question, they said the abdominal imaging confirmed it, right? That's the most direct confirmation. They're just going to show, if the CT shows non-enhancing pancreatic tissue, then it's necrosis. Okay, so that's like the first thing. That's always the most definitive diagnosis. And they just told you that in the question stem. Also, low albumin. They told us that there was a capillary leak, right? And that's more severe. If it's more severe, it's going to lead to necrosis, not just acute. Also, there's hypotension, there's increased heart rate, there's tachypnea, and there's fever. And so that's going to be severe inflammation, so it's SIRS. Elevated BUN as well, so that's catabolism and fluid loss. So like all these things are indicating that it's necrotizing. But the biggest thing is they just tell you on the CT. Cool? All right, on to our next question. Here we have a 42-year-old woman with progressive loss of hearing over the past 5 years. Examination reveals no abnormalities in the external auditory canal and tympanic membrane. Audiometric testing suggests sensory neural hearing loss. She is scheduled to undergo a procedure and improve her hearing. For the procedure to be successful, which part of her auditory system must remain functional? What has to remain functional for this to work? Ooh, we're going to have some good discussion on this one because there are two answers that should definitely be coming to mind. Let's talk about, before we answer this, hearing loss. The problem is beyond the middle ear, right? The cochlear hair cells are going to be damaged or the auditory nerve is damaged, one or the other. Right? And so if it's the cochlear hair cells that are damaged, that's usually just like aging or noise trauma. My brother had this happen to him. And anyways, auditory nerve is damaged, vestibular schwannoma, but he doesn't have full deafness, but he has tinnitus, which is terrible. So wear hearing protection if you go to concerts. Please do it. But yes, vestibular schwannoma, neuropathy, that stuff for the auditory nerve. And then a cochlear implant, what that does, by the way, is it bypasses the cochlea entirely. And so you have an external microphone that picks up the sound, and then the internal electrode sends the electrical impulse, and these impulses stimulate the auditory nerve directly, okay? It stimulates the auditory nerve directly. And they're doing that to improve her hearing. So yeah, no cochlea is required, but the nerve must work. Bottom line, has to. But I did like how you were thinking about cochlea. So now we know our answer is auditory nerve, right? It has to work. Sensory neural damage to the cochlea or the auditory nerve. And cochlea is a great answer. It's a fine cell. It's a fine answer. Cochlear implants. But like the true best answer is if it's going to be an improvement that's going to help her out, then it's going to be the auditory nerve. Because this is going to be hair cell damage, but this bypasses the cochlea with the actual procedure. And so I liked that you were thinking about cochlea because it tells you you're thinking about the two ways that you could damage and sensory neural hearing loss, which we've talked about. Central processing for auditory cortex, it'd be independent of that. Tympanic is otitis, not needed. Similarly, tympani and stapedius involved in sound dampening, not essential. Cool? Okay. Any questions on that one? Here's the bottom line. Cochlea must remain functional for successful hearing improvement and sensory neural hearing loss. All right, guys, we're going to take a quick break. Take a break. I am on my way. There's a little surprise before supper and I cannot wait. Let's dive right in. A 30-year-old man presents to the emergency department with confusion, abdominal pain, and vomiting. For the past day, he has a history of type 1 diabetes and admits to missing his insulin doses for the last few days. On examination, his blood pressure is 100/70, his heart rate is 10 beats per minute, respiratory rate is 24 breaths per minute, and we have blood glucose of 550. Serum bicarb is 12, and positive serum ketones. After starting fluid and insulin therapy, his condition significantly improves. Which of the following pathways is most likely activated as a result of insulin administration? And I know here we can kind of see the answer. But what's happening here is that without insulin, the body thinks that it's starving, right? And so diabetic patients, they break down fat and then they make ketones. And then because of all those ketones, they go into acidosis. So if we give insulin, then the metabolism, it flips into storage mode. It's like, oh, finally, we got some glucose. And so the first thing it does is promote glycogen synthesis in the liver and also in the muscle. And also it's going to shut down lipolysis and gluconeogenesis. So glycogenesis, make the glycogen. That's our correct answer. So they have DKA, and how do we know this? Polyuria, abdominal pain, small breathing, high glucose, ketonemia, metabolic acidosis. Insulin therapy rapidly reverses DKA by suppressing ketogenesis, halting gluconeogenesis, and promoting anabolic pathways. Glycogenolysis would be glucose release, so it's the opposite of storage. Same thing here. Hepatic gluconeogenesis, that's the glucose production that occurs during DKA. Protein catabolism is a breakdown process that's inhibited by insulin. So when DKA insulin's low, body turns to gluconeogenesis and ketone production. So the bottom line is insulin administration activates glycogenesis, promoting glucose storage and reducing hyperglycemia in diabetic ketoacidosis. If you wanted to make this question harder, you could say, what is increased in the liver cells? And the answer would be glucose, because that's stimulated by insulin. These two guys are elevated in DKA. You're so right. Yosemite loves that glucokinase factoid. You love it. Yep, glucokinase is involved in the sensing in the liver and the pancreas. It detects the high levels of glucose in the bloodstream, and it catalyzes the phosphorylation of glucose to glucose 6-phosphate, which is the first step in glycolysis, which converts the glucose into energy, which you don't need. Also, another thing with diabetes is the small breathing. That's when you have the deep, labored, rapid breathing, hyperpnea. Small breathing is air hunger because your body has too many hydronium ions, and so it compensates by trying to blow off the CO2, which is acidic, through hyperventilation. Got to raise that pH is what the body thinks. Okay, on to our next question. A 50-year-old man with a history of hypothyroidism presents to the clinic for a routine follow-up. He has been taking levothyroxine for the last 5 years with stable thyroid function tests. Recently started experiencing fatigue and weight gain despite unchanged medication adherence. On examination, his blood pressure is 130/80. His heart rate is 72 beats per minute. BMI is 28. Lab tests reveal the following. TSH is going to be elevated. It's normally 0.5, or rather, TSH is normal between 0.5 and 4.5. Free T4 is normal, and newly elevated cholesterol levels. He mentions he started taking a new calcium supplement daily, which the following is the explanation for his current symptom. So he's taking calcium. Hey, he's got some kind of almost normal thyroid labs, but it seems like he's got some absorption differences, and he has hypothyroid symptoms because of the weight gain. So what's going on in your boy? What does your boy have? Well, calcium actually interferes with levothyroxine absorption. And so TSH can appear normal, but they're functionally hypothyroid. And so it's the decreased absorption of levothyroxine. Because calcium supplements are the cause of malabsorption of levothyroxine by binding the drug in the gut. Nice. Yeah, you nailed it. Good job, Sedal. Nice. Sedal says calcium usually decreases levothyroxine, recyclings, and fluoroquinolones. Nailed it. Nice. 100%. That is beautiful. Yeah, and this is actually interesting from an evolutionary perspective too, because the thyroid hormones like T4, for instance, they evolved to be very potent metabolic regulators. They're like highly protein bound, low concentration, very slow acting, but they have some interesting feedback loops because early on when we were evolving, we had rapidly changing environmental conditions like food scarcity and cold weather, things like that. And any slight disruption to bioavailability, like for instance, if you all of a sudden you have calcium competing, that could mimic a famine, right? Or illness. And so if you're in a famine or an illness state, that triggers a metabolic slowdown to conserve your energy. And so that's why it's so responsive. That's why gut absorption matters so much. Because from an evolutionary perspective, the GI, your gut, is the primary way that you interface with your environment. And so regulating like hormone activation and absorption in the gut gave organisms that were in the early stages of evolution a way to adapt to food presence or absence, and also mineral composition changes like calcium changes or toxins and stuff like that. So if iron is all in your gut, thyroid absorption is going to be naturally inhibited because you're going to be like, oh my gosh, this environment may not be optimal. Let's not ramp up the metabolism too much. So it's that feedback loop that was evolved for millions of years, which I think is fascinating. Yeah, it's like, that's why humans today, we have to take oral synthetic hormones because we're still relying on a system that wasn't designed for this new delivery route. It's crazy. So the body basically interprets failed thyroid hormone absorption as a signal to conserve energy because of the survival mechanism there. All right, I go on diatribes here just because I love evolutionary biology. Calcium supplements bind levothyroxine in the gut, impairing absorption. Levothyroxine must be taken on an empty stomach for reliable absorption. Calcium, iron, and all these things can bind and interfere with it. And so all this fatigue Change in environment is the body saying, hey, chill. It's time to chill. Daddy, chill. It's like that Vine or whatever. Thyroid is interesting, says Hidal. Low iodine, low thyroid. Very high, still low thyroid. Yes, agreed. Very much agreed. So it's the calcium supplement. Binds levothyroxine, decrease in the absorption. Lower availability of T4 at tissues despite the normal levels. Super sensitive to changes in the gut. Yep. And like you said, there's this little tight, like nice little sweet spot, right? Low iodine, hypo, because you can't synthesize T3, T4. And then high, the body's like, oh my gosh, there's too much. Let's shut the thyroid down. Okay, got a question from YouTube. DT, should I be annotating UWorld notes in my first aid book? I would. That's a great use of it. I think you should totally have a fully annotated UWorld by the time that you finish your first cycle. Like fully annotated. I think you should have a fully annotated first aid by the time you finish your first UWorld cycle. I think it's a great way to learn, 100%. All right, the bottom line is calcium supplements can decrease intestinal absorption of levothyroxine, leading to hypothyroid symptoms despite normal TSH and T4 levels. Very cool. What a privilege it is to be alive. How rare and beautiful it is to even exist, right? Okay, so calcium binding, levothyroxine issues, hypothyroidism. On to our next one. Okay, next question. A 45-year-old woman presents to the emergency department with a sudden onset of vision loss in her right eye and difficulty distinguishing colors. Examination, she has relative afferent pupillary defect in the right eye. Her medical history is unremarkable. She denies any trauma. Fundoscopic examination reveals optic disc hyperemia. MRI is unremarkable. Genetic testing is pending. Laboratory analysis includes assessment of mitochondrial function, revealing decreased activity in the complex responsible for transferring electrons from NADH, while activities of other complexes are within normal limits, which the following complexes is most likely dysfunctional in this patient. Sedal says A, very nice. Why do you think A? Nice, optic neuropathy. Yep, it is indeed complex 1. So that's the first complex in the electron transport chain, and it accepts the electrons from NADH. NADH has that electron. Whoop, let's pass it on. And it pumps the protons into the intermembrane space that drives ATP synthesis. And so high energy tissues like the retina, ding, 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 like the retina and also the optic nerve are super sensitive to electron transport chain dysfunction. And so you have some sort of mutation, you get a mitochondrial energy failure and optic neuropathy. You got it right. And Libra was a really, really good call out there as well. Okay, now let's see the other ones. Libra hereditary optic neuropathy, an inherited mitochondrial disorder, decreased activity of the electron transport chain that accepts the NADH. That's just complex 1. It initiates the electron transport chain by oxidizing NADH and transferring electrons to ubiquinone. Complex 2, FADH to CoQ, bypasses NADH. Complex 3 transfers electrons from CoQ to cytochrome C. And then complex 4 reduces oxygen to water, cyanide poisoning. So complex 2 is going to be like, succinate dehydrogenase accepting the electrons from FADH2, not NADH. And then complex 3, that's the cytochrome BC1 complex that transfers the electrons from CoQ to cytochrome C. And then 4, this one's going to be more in like cytochrome C oxidase. It's the final electron acceptor, donates the electron to oxygen. And so mutations here would be like Leigh syndrome, MELAS, and myopathy. Then complex 5 is the global disease problems, ATP synthase. There's the pathophysiology, key features, blindness in a 45-year-old woman. Here's the bottom line. Decreased NADH transfer indicates complex 1 dysfunction and mitochondrial disease causing vision loss and relative afferent pupillary defect. Sedal says, adios, time to sleep. See you tomorrow. Super good talking with you today. Have a great night. Next, we have a 29-year-old woman presents to primary care clinic with complaints of increased irritability, muscle aches, and diarrhea that has persisted for the past 2 days. She states that she also feels unusually cold despite warm weather. She has had episodes of involuntary yawning. On physical examination, she is anxious, diaphoretic, and has goosebumps on her skin. Her vitals are as follows. Temperature, 98.6. Heart rate, 88. Blood pressure, 124/80. Respiratory rate, 16. Patient reports no significant medical history, except for a recent period of stress after losing her job. She denies alcohol, but admits to occasional substance use. Based on this, which of the following? She's most likely experiencing withdrawal from which of the following substance? Yep, you got it, Sedal. Sounds like opioid withdrawal. Sedal's last comment from the deep, dark depths of the bed. It does sound like opioid withdrawal because check it out. Here it is. I've highlighted some aspects of this question, but just on hearing the presentation alone, you're able to diagnose this as opioid withdrawal. Very good. It's the yawning, the chills, the goosebumps, opioid withdrawal. You have autonomic symptoms as well. Diarrhea, sweating, myalgias. Hey, Razan, how's it going? I usually start the live streams around like 4 or 5 a.m. Depends on what I've got going on. But Today, I think I started around 1 or 2, and I'm going into the evening for the first time ever. So yeah, there are people all across the world. And so lately we've been doing morning sessions, but we can do afternoon as well. I think I'll start doing them more throughout the day now, but it's always fun to catch up with my friends from Pakistan. Okay, opioids. And I'll try to put on a more tone so that I can be a little bit of a bedtime influence for those of you across the world who are needing to sleep now. But opioids, right? So muscle aches, diarrhea, and cold intolerance, yawning, diaphoresis, and anxiety, and piloerection. So it's that GI distress, sympathetic overdrive, and the yawning. Okay, nicotine withdrawal would cause irritability, craving, and insomnia. Cocaine withdrawal, crash, hypersomnolence, depression. Pretty much the opposite of cocaine, right? Methamphetamine, depression, psychomotor slowing, hypersomnolence. That's what we're wishing for Sadal right now, hypersomnolence. Cannabis causes irritability, insomnia, and also decreased appetite. Okay, so there are distinct withdrawal symptoms for a variety of substances. Cannabis withdrawal can make you tired. Methamphetamine withdrawal can cause hypersomnolence and depression. Hypersomnolence and depression. Cocaine, hypersomnolence, depression as well, and also crash. So the yawning is the parasympathetic tone rebound. Piloerection is a non-adrenergic excess. Diarrhea is due to a loss of that opioid-induced tone, hyperactivity, loss of analgesics and muscle aches. Okay, and this is the pathophysiology, which I think is most important. You have chronic opioid use, leads to an activation of the mu-opioid receptors, and then causing decreased CAMP and decreased norepinephrine. And then you abruptly cease and you have a rebound in CAMP. So the CAMP is going to be elevated. It's used to being down, so now it's going to go up. Also norepinephrine. That causes some autonomic symptoms. So you have a loss of CNS suppression. You're no longer suppressed. And so instead you have anxiety, irritability, and insomnia. Also you have a loss of GI regulation. So there you go. Goosebumps, yawning, diarrhea, opioid withdrawal. Okay, so here's the bottom line. Opioid withdrawal is characterized by irritability, muscle aches, diarrhea, and autonomic symptoms like yawning and also goosebumps. Reminds me of this comedy sketch where you're like, what's your favorite book? Goosebump. It's called Goosebumps. You mean there's more than one? I have no idea where that's from. Yeah, I do actually. I think it was like some comedian. Okay. And while we're loading this next question, non-adrenergic. That's a kind of a weird word, right? Noradrenergic means that it's related to norepinephrine, like noradrenaline. Nor is short for norepinephrine. Adrenergic is anything that's related to the adrenergic or the sympathetic nervous system. And so if we say noradrenergic, then it means it uses norepinephrine. That's all it means. All right, on to our next question here. A 55-year-old woman visits her primary care clinic because of progressively worsening fatigue and also unexplained bruising for the past 4 months. She reports gradual weight gain and facial swelling. On examination, the patient is noted to have central obesity, a rounded face, and purple striae. This is Cushing, or some form of like ectopic ACTH. We have increased serum glucose and hypertension. Overnight low-dose dexamethasone suppression test. That makes sense. There's no suppression of cortisol levels. So that means there has to be some sort of an ectopic source since there's no suppression and there's no pituitary involvement. A high dose similarly shows no suppression. Well, hypertension, glycemia, striae, all that shows you that there's like cortisol excess. That's what's happening here. And so they have the signs of Cushing syndrome. They have central obesity, facial rounding, and all of the faces and the purple striae, all that stuff. And they have elevated cortisol on ACTH that fails to suppress with both high and low. So that means it's atopic ACTH. And so now you have to decide which of these causes ectopic ACTH. Is it the adrenal adenoma? Well, an adrenal adenoma would cause more cortisol, which would decrease the ACTH. This person has high ACTH, so that's not right. Is it bronchial carcinoid tumor? Well, these guys actually can cause ectopic ACTH secretions, but usually it's partial suppression whenever you do a high-dose dexamethasone test. So that's not it. How about primary adrenal hyperplasia? That would suppress ACTH through feedback, and so does not fit the high ACTH profile. Small cell lung carcinoma, that's the correct answer, because that can secrete ACTH. It's a perineoplastic Cushing syndrome. And pituitary microadenoma, that's just Cushing disease. That's a suppression with high-dose dexamethasone. But we didn't observe that in this patient, so that's why E is not the right answer. Okay, here's the bottom line. Elevated ACTH and cortisol with lung mass indicate ectopic ACTH, likely from small cell lung carcinoma. Nice. All right, let's quickly do this question. 55-year-old woman, primary care, worsening fatigue. Oh, I already did this one. Okay, a 45-year-old woman presents to the clinic with a complaint of fatigue and joint pain in her hands and knees over the past 2 months. She notices that her symptoms are worse in the morning. Okay, well, if it's worse in the morning, it's rheumatoid arthritis. That's easy. Oh my gosh. And they tell you they have anti-citrulline peptides and they ask what the diagnosis is. The world's most easy question. This is rheumatoid arthritis. Bilateral joint pain, prolonged morning stiffness, osteoarthritis is going to worsen with use. Lupus has other symptoms. Infectious arthritis would have monoarticular, acute onset. Gout, podagra, and tophi, the tophi. Here's some associations. HLA, DR4, has an increased genetic susceptibility to RA. Smoking is an environmental trigger, and also the female sex can contribute to autoimmunity because of estrogen. So your anti-CCP is most specific for rheumatoid arthritis. Elevated ESR and CRP means there's inflammation, anemia of chronic disease, normocytic, symmetric small joint arthritis, MCP, PIP, and RIS, improved activity unlike osteoarthritis. Morning stiffness greater than 1 hour. Here's the bottom line. Positive anti-peptide antibodies in morning stiffness indicates rheumatoid arthritis. Easy. Looks like Razan. Okay, a 66-year-old man is brought to the clinic by his daughter due to forgetfulness and balance problems over the past several months. She knows that he often repeats questions and has been unable to continue his daily walks at the park because of tripping. She also mentions that he has had urinary accidents, which is unusual for him. Shuffling gait, poor heel-to-toe walking, MRI shows enlarged ventricles and no signs of increased intracranial pressure. Which of the following is the most likely diagnosis? This is a triad, folks. What's the triad? Wet, wobbly, wacky. Let's see if we can highlight the wet, wobbly, and wacky. Okay, there's the wobbly. And here's our wacky, repeating the questions, neurologic problems. So, which of the following is the most likely diagnosis? It's normal pressure hydrocephalus. Woo! Subdural hematoma would be an elderly with a trauma. That one would have a crescent-shaped lesion, but the MRI would show blood, so it's not that. Alzheimer's disease, early memory loss, cortical atrophy would be seen there. Progressive supranuclear palsy. That would not explain the urinary symptoms. Multiple system atrophy, like Parkinsonism, and autonomic failure. There's no tremor, there's no rigidity, there's no orthostatic hypotension that's described here. And there's also no MRI evidence for any cerebellar brainstem atrophy, so that can't be right. The answer is indeed C. Here's the bottom line. Normal pressure hydrocephalus is characterized by the triad of gait disturbance, cognitive dysfunction, and urinary incontinence. I love this chair, but I think it needs more lower back support. All right, on our next question, a 40-year-old man presents to the primary care physician with frequent episodes of abdominal pain and hematuria. He reports a history of multiple kidney stones. Urinalysis has microscopic hematuria and hypercalciuria. A CT scan of the abdomen confirms multiple small renal caliculi composed of calcium oxalate. His serum electrolytes, including calcium and phosphate, are within normal limits. The physician prescribes medication to prevent future stone formation by reducing the amount of calcium excreted in the urine. What's the mechanism? Okay, so it's thiazides, because they decrease the urinary calcium excretion. And thiazides are designed to treat hypertension, calcium stones, and osteoporosis by conserving calcium. Loop diuretics cause hypocalcemia and increase the risk of stones. And the low sodium diet would enhance thiazide effect of calcium retention. Here's some trap answers and why they're wrong. Citrate actually inhibits stone formation by binding calcium. So if you increase the reabsorption, it would reduce the urinary citrate and worsen the stones. Let's test this out. So as it says here, citrate and oxalate can bind to dietary calcium in the GI tract, forming insoluble complexes, preventing calcium absorption, which can lower systemic calcium levels. So the thiazides inhibit the sodium chloride in the DCT, so you have less absorption in the distal tubule, and you have decreased intracellular sodium, and that increases the activity of the sodium-calcium exchanger on the basolateral side. And then calcium reabsorption from the tubular fluid is going to be increased, and then you have decreased urinary calcium. And so then the result is decreased stone formation. Thiazides, they're good for preventing kidney stones. Here's the bottom line. Thiazides reduce calcium excretion in the urine, preventing calcium oxalate stone formation. Was interesting. All right, here we have a 57-year-old woman presents to the emergency department with a shortness of breath and fatigue that has been worsening over the past month. Her medical history is significant for rheumatoid fever during childhood. Physical exam reveals a diastolic murmur, or rumble, best heard over the apex of the heart on one of the cardiac valves. The patient is diagnosed with valve stenosis. A surgical intervention is planned. Which valve is affected? Okay. Well, mitral stenosis is the sequelae of rheumatoid heart disease. And a diastolic rumble over the apex is going to be mitral valve pathology, so the answer is mitral. They had rheumatoid fever and diastolic, so it's mitral stenosis. Now you can pause and read all these other answers. Rheumatoid fever is an autoimmune attack on the valves. It's a type 2 hypersensitivity reaction. Here's the bottom line. Diastolic rumble at the apex indicates mitral stenosis, often due to rheumatoid heart disease. All right, a 36-year-old woman undergoes an elective laparoscopic cholecystectomy under general anesthesia. Propofol is used, and succinylcholine is administered to facilitate the intubation. Surgery is uncomplicated, but in the recovery room, the patient remains paralyzed and cannot breathe spontaneously, even though she is fully aware and following commands approximately 90 minutes after surgery. Vital signs are stable, and no abnormalities are noted. Family history reveals her mother experienced similar things. What explains this? This is a deficiency in pseudocholinesterase. So they wake up from anesthesia, but they're paralyzed. They can't breathe either. That's because of this enzyme deficiency. So they receive succinylcholine, which is a depolarizing paralytic. Normally that's cleared within minutes by the plasma pseudocholinesterase. And if that's deficient, it's not cleared. So she's paralyzed even after an hour. So succinylcholine is a depolarizing neuromuscular blocker metabolized by pseudocholinesterase. It's inherited enzyme deficiency. Should be about 5 to 10 minutes. This is 90 minutes. So the bottom line is prolonged paralysis after succinylcholine suggests pseudocholinesterase deficiency. 28-year-old male presents to the clinic with painless swelling of the left testes. Then they're just going to ask, hey, which group of lymph is going to be the first site of metastasis? The answer is always the periaortic. Super easy. Pair of testes, periaortic. Testicular cancer stops there. Retroperitoneal, you have a painless testosterone mass, hypoechoic solid. Think of a testicular germ cell tumor, periaortic, because the testes develop retroperitoneally as they descend. And so they're going to drain upward to the periaortic. Very easy. Here's the bottom line. Testicular cancer typically metastasizes first to the periaortic lymph nodes due to its lymphatic drainage and embryologic origin. Paratestes, 122. All right, 65-year-old woman presents to the clinic with complaints of urinary retention following abdominal surgery. She's got a distended bladder, and you're initiating pharmacotherapy to address her symptoms. How do you do that? It's a direct muscarinic end agonist that targets the M3 receptors to stimulate it. Now, notably, atropine is a muscarinic antagonist, so it inhibits the muscarinic receptors, and that causes urinary retention. Ipratropium is for asthma. Pralidoxime is an organophosphate antidote. Reactivates acetylcholinesterases. And cholinergic toxicity doesn't stimulate muscarinic receptors directly. And muscarinic receptors are a type of acetylcholine receptor, part of the parasympathetic. So it's the rest and digest. Activated by acetylcholine, and it's blocked by atropine and scopolamine. Those are anticholinergics. They're found on organs, not muscles. Sasan says, I remember it. Bethanechol for bathroom call. That's awesome. I've never heard that before. Bethanechol for bathroom call. That is so good. Wow. I'm going to remember that forever. That is amazing. Yeah. What's crazy is so many elderly patients develop some form of urinary retention after surgery. So you got to stimulate the parasympathetics, especially the M3 muscarinics. So bethanechol effectively stimulates bladder function by acting on muscarinic receptors in post-surgical urinary retention. Now watch this. I'm going to type in the chat IV tutor with an exclamation mark, and then I'm going to say, explain simply what is muscarinic. And now the chat will appear up here, and then you'll get a response as well from an AI agent that is trained to help you on step 1. Here it is. There's the response. Type of acetylcholine receptor found in the body. G protein coupled receptors responding to acetylcholine. Activating muscarinic receptors. They have a variety of effects depending on their location. M2 on the heart stimulates glandular secretions. M3 on salivary glands, and M3 receptors in gastrointestinal tract. Very cool. So you have your own IV tutor here in the Twitch chat. You guys can try out that function if you'd like. X IV tutor space, whatever your question is. Now we have a 36-year-old man brought to the emergency department by the police after being involved in a physical altercation at the bar. This is his third arrest in the past 6 months, with previous offenses including stealing from a convenience store and damaging property. The patient is notably unconcerned. What does he have? He's antisocial, 100%. He's a bad, bad boy. Antisocial involves pattern of disregard for violation of rights of others since age 15. Yeah, all this stuff is just totally antisocial. Borderline unstable relationships. I knew somebody with borderline. She is not good. Narcissistic, grandiosity, need for admiration. Dependent, clinging, fear of separation. Obsessive compulsive is perfectionism. Weird, wild, worried. This is wild. Truancy, aggressive behavior. In a team would be conduct disorder. No remorse or empathy is antisocial. Multiple arrests, antisocial traits. Expelled from school, early onset. So, antisocial, characterized by disregard for others, lack of remorse, and repeated legal issues. I think it's wonderful. It's an interesting illustration of how our will is limited and constrained by our biology, which should be obvious to anybody who is familiar with neuroscience. Multiple arrests is literally one of the factors which sways you toward thinking it's antisocial. Yet we stigmatize so heavily in our society. I'm going to do this one really quickly. It's just saying, hey, intention to treat, what's that all about? And that's where you measure the results, not by anything other than if they signed up and started to do it. So you can get some wacky results that way, but it's a way of preserving the randomization process. This is super easy. Basically, you just include every participant, regardless of if they finish it all. It's just the intention to do it is what seals the deal. Super easy question. Not going to spend a lot of time on it. I'll do one more, and then we'll have another quick break. 22-year-old woman presents to the emergency department with a 24-hour history of high fever, severe headache, and generalized muscle pain. She reports recently returning from a hiking trip in the Rocky Mountains. Her vital signs show a temperature of 101.8. Heart rate is 105 per minute. Respiratory rate is 20 per minute. Blood pressure is 115/75. On physical examination, she appears uncomfortable and is diaphoretic without any rashes. The physician suspects infection transmitted ticks native to the region. What's the treatment? Was it a tick-borne illness from the Rocky Mountains or ehrlichiosis? Saswan says A, binding to ribosome RNA and interrupting aminoacyl tRNA attachment. Any second guess and still you with doubt? Rocky Mountain. You're 100% right. Binding the ribosomal RNA, interrupting the aminoacyl tRNA attachment. Very, very good. So Rocky Mountains and fever and headache and leukopenia, transaminitis, ehrlichiosis. This is ehrlichiosis or anaplasmosis. Tick-borne. There's no rash. The treatment is doxycycline. And doxycycline, the mechanism of action is it binds to the 30S ribosomal subunit and it blocks aminoacyl tRNA attachment. That's what it does. Inhibition of the cell wall synthesis through the beta-lactam. That's the mechanism of fluoroquinolones. Interference with bacterial folic acid metabolism. That's the sulfonamides, trimethoprim. Not going to be used for ehrlichiosis. Inhibition of bacterial cell membrane function. If you're inhibiting the bacterial cell membrane function, that's going to be like daptomycin. It's used for gram-positive infections like MRSA, not tick-borne pathogens. So it comes from the Rocky Mountains. Treat with doxycycline. Ehrlichiosis chafensis. Transmits ehrlichia, which infects the monocytes. Lone Star tick. You got to avoid TMP MSMX. Causes worse outcomes. Ehrlichia and anaplasma are their obligate intracellular bacteria. And so they do not reliably, TMP and SMX are not going to be able to reliably penetrate the intracellular compartments. And so it can't actually reach the bacteria inside of the monocytes and the granulocytes. And so it interferes with the host immune response. It's just bad. Don't use TMP SMX. All right, here's the bottom line. Rocky Mountain spotted fever requires doxycycline for effective treatment targeting bacterial protein synthesis. And that's ehrlichiosis. Well, I think this is a good stopping point for now. Hopefully you guys have enjoyed this 5-hour stream. I might be logging on later, but in the next live stream, I'll definitely be covering 125 onwards to 150 and then 150 to 200. So thank you everybody for joining. If you're watching this on YouTube later, then please be sure to like and subscribe. It really helps out the channel. Once we get to 1,250, I'll be releasing IV Meds Medical Library. And then once we get to 1,500, I'll be releasing the first bit of the question bank. Again, all of that is going to be free. Very exciting. If you want tutoring, visit ivtutoring.net. And that's all I got for you. Hopefully you guys have an amazing rest of your day. Bye Twitch. Bye YouTube. Hopefully you guys enjoyed the video. Please like and subscribe. We'll see you guys in the next 50. Today we're going to be starting with question 126 and going all the way to 200. So, get a bag of popcorn and get your study notes, first aid, and let's just dive right in. So our first question, we have a 35-year-old woman presents to the dermatology clinic with concerns about her skin. She has multiple small scaly patches on her upper back and shoulders over the past few months. The lesions have not been itchy, but she is worried that they have become more noticeable after sun exposure. She has no other significant medical history and takes no other medications. A wood lamp examination reveals yellow-green fluorescence in the affected areas. Which of the following is most likely the causative organism? Okay, we got a couple of options here. So there are a couple of things to note. First of all, it's not itchy and it's well demarcated and it's scaly. And not itchy, scaly should make us think of maybe a fungus infection. And the yellow-green stuff on the wood lamp, that's just a diagnostic clue, but this is Malassezia furfura, and this is going to be tinea versicolor. All right, now here's the explanation. Tinea versicolor, caused by Malassezia, a lipophilic yeast. Manifests as hypo and hyperpigmented scaly macules, commonly found on the back and the chest after sun exposure. Trichophytes rubrum is associated with dermatophytes that causes tinea corporis or pedis, athlete's foot. That would cause a pruritic, itchy, ring-shaped lesion. Aspergillus would have a fungal ball, but this is not a skin pathogen. Microsporum, involved with tinea capita, and histo would be in this region, Ohio River, with bird and bat droppings, and also pulmonary symptoms. Now, this is caused by Malassezia furfura, which is a normal part of the skin flora. It's pathogenic in hot and humid environments or when the patient is on immunosuppression. The organism damages melanocytes and inhibits tyrosinase. So the pathophysiology is that it's normally in the stratum corneum, and then it's triggered by heat and humidity. And then all of a sudden, we get this acid production that inhibits melanin synthesis, and you get the pale or variably pigmented macules on the front or the back. They're the features. So basically, it's yeast on your skin that glows under UV light as well, and it's non-itchy, scaly pigments on the back that is more obvious after sun exposure. So these tineias, the dermatophytes, they're mold infections that can eat keratin, ring-shaped and itchy, and tinea versicolor is Malassezia yeast overgrowth. So you have color change, not infection, and it's not itchy, is Malassezia. That's how to distinguish between them. So here's the bottom line. Yellow-green fluorescence under wood lamp indicates Malassezia furfura as the causative organism of tinea versicolor. And you have to know how to distinguish tinea from other types of tinea. Versicolor is non-itchy, different pigmentation, non-infectious, and caused by Malassezia. And our next question is, 70-year-old man is being evaluated for worsening low back pain and generalized weakness. His medical history shows that he's been treated for CLL. Over the past 5 years, recent lab shows elevated serum calcium level. As part of the management, he has started on glucocorticoid therapy, which alleviates some of his symptoms. Glucocorticoids exert their effects primarily through a receptor that binds to which of the following locations? Glucocorticoids. That's a nice, easy way of framing this. There are different ways that we could kind of have made this question much harder, which I'll get at soon. But glucocorticoids, these are going to be going straight into the cytoplasm because they are steroid hormones. They act as intracellular receptors, not cell surfaced ones. So it's not A, and they're typically going to be in the cytoplasm. So it literally diffuses across the plasma membrane due to their lipophilic nature. And then they bind to these receptors, and then they get translocated into the nucleus. The cell surface, that would be like peptide hormones. For instance, insulin, which uses membrane-bound receptors. Glucocorticoids are lipophilic. They go straight through that membrane. Mitochondria is involved with apoptosis regulation, and it can influence the mitochondria, but it's not the primary receptor for glucocorticoids. The Golgi is for post-translational modification and involved in protein trafficking. And then RUF is involved in protein synthesis. So here are some associations. Steroid hormones, think cortisol, aldosterone, testosterone, all the ONs, estrogen, and cytoplasmic or nuclear receptors. Also for steroid hormones, you can think of tamoxifen because it's lipid soluble and it can cross the membrane freely and it'll just go straight to the nucleus. So tamoxifen is kind of another intracellular receptor agent. So here are the key features. Lipophilic hormones cross the membrane. They bind to the intracellular receptors. Glucocorticoids decrease inflammation, and you get lower immune response and less vitamin D-mediated calcium absorption. Sadal says, another good day to lock in and study. Amen to that. What a beautiful day for that. Cytosol, also known as intracellular fluid, is the liquid component of cells. It contains water, dissolved substances. Clinical outcome, disturbances in cytosol lead to cell dysfunction, and it'll respond to you in the chat. So that's a new feature for everybody on Twitch. Right now, it's just free for everybody to use. Oh no, it's already being used for different purposes. How can I get more tomatoes in Blake's stream? Your question seems unrelated to step 1 content. That's funny. Yeah, I guess it's only good for step 1 content, but let's dive into our next question, shall we? A 35-year-old man presents to the clinic with fatigue, unintentional weight loss, and recurrent fevers over the past 2 months. He has a history of untreated HIV infection. Physical exam reveals generalized lymphadenopathy and oral thrush. Lab testing shows a CD4 count of 150 and viral load exceeding 100,000 copies. In addition to CD4 positive T lymphocytes, it is most likely to serve as a reservoir and site of HIV replication in this patient. Okay, yeah, we'll deal with that question as soon as we finish this one. So macrophages is correct. Very nice. HIV targets the T cells and also in the macrophages. They're both reservoirs and replication sites for HIV. So HIV primarily affects the CD4 T lymphocytes, but also can affect the macrophages. Epithelials are barrier cells. They don't have that CD4 and CCR5 expression. B lymphocytes, antibody-producing cells, there's no major reservoir there. Red blood cells do not have a nucleus, and so the red blood cells can't harbor or replicate the virus. And eosinophils, parasites, and allergic responses are not involved. Less than 200 is going to risk the opportunistic infections. Acid fast, like Mycobacterium, is seen in HIV when macrophage immunity is impaired. Acid fast. And our receptors here are the co-receptors on the macrophages and the T cells, which are needed for HIV entry. So CNS, HIV infects the microglia, leading to HIV-associated dementia. That's how it gets. HIV can cause dementia in your brain through microglia. Pulmonary disease, the alveolar macrophages can be sites of it. Here's the pathophysiology. Here are the key features. And here is the bottom line, my friends. So macrophages serve as the key reservoir for HIV replication in patients with advanced immunosuppression. Okay, now let's check out Hematopoiesis's question. Because Hematopoiesis gave a question to my bot, and they said that they got it incorrect. So let's see. We have a 25-year-old presenting with palpitations, sweaty palms, and tremors. They have past medical history of thyroid cancer. Serum calcitonin is notably elevated on the labs. What is the diagnosis? Medullary thyroid carcinoma as a part of MEN2A, MEN2B because of the concurrent catecholaminergic symptoms. Medullary thyroid carcinoma as part of MEN2A and 2B because of the concurrent catecholamine symptoms. Nice. Very cool stuff, guys. Very cool. It's partially right. We give GPT a partial correct. I like that. That was a good question to test how far it can go. Okay, guys, here's our next question. A 25-year-old graduate is working on a research project involving genetic mutations and their effects on protein synthesis. During an experiment, the student observes that a mutation has changed the third nucleotide of a codon, O, but the resulting is the same as the wild type. This observation prompts discussion with the supervising professor regarding the nature of the genetic code, which explains this finding. So we have a synonymous or a silent mutation that is occurring at the third base of a codon, and this is probably due to some sort of a redundancy, as Hematopoiesis said. Very nice. A redundancy in the genetic code because multiple codons are encoding for the same exact amino acid. This genetic code is redundant. And that's the correct answer. It's C. And it is indeed redundant. Most of the amino acids are encoded by more than one codon, And so this redundancy is especially prominent at the third nucleotide position. This is known as the wobble position. Wobble, baby, wobble, baby, wobble, baby. Right? Yep. Very, very relevant. I love all the salutations in the chat. That's so fun. Universal, shared across species. That's not relevant here. It's that wobble protein, the redundancy. Yep. Built-in backup mechanisms to prevent against small mistakes. Here's the bottom line. The redundancy of the genetic code allows for mutations without altering the resultant amino acid sequence. Yes, David, I'm talking about you. You're pregnant. Hopefully you guys know type 1, type 2 errors, because that's what this next question is going to hit on. Here we go. And I've drawn this out because I think it's a fun way of remembering type 1 errors is if you call a man pregnant. And so type 2 errors are if you call a woman who clearly is pregnant, not pregnant. Yeah, hypothesis testing. So in a clinical trial, we are comparing two medications for lowering blood pressure. We determine we need a sample size that will give them 85% power to detect a 10 milligram mercury difference in systolic pressure, with two-sided significance level set at 0.05. Assuming there's truly no difference between the medications, what's the probability that they will conclude a difference does exist? Well, that's it. Basically, there is no difference. There is no pregnancy, but you're saying that they are pregnant. And so this is a type 1 error. So we know our type 1s are going to be the correct answers. And then it's going to be a 5%. Because 0 would not make any sense at all. A 5% significance level says there's a 5% chance of falsely concluding that a difference does exist. When no true difference exists, only one kind of error can be made, type 1. The alpha, type 1 error, we say that there is a difference when there isn't one. And the beta, type B, is a false negative. We say there's no difference when there is. And then the power is 1 minus beta. The ability to detect a true difference when it does exist is the power. Yeah, David W. We call him David W. With no true difference, the study has a 5% chance of a type 1 error concluding significance. David is pregnant, everybody. That's what we've learned. What are you going to name the baby, David? Blake Jr. All right. In our next question, a 60-year-old man presents to the emergency department with shortness of breath and persistent diarrhea. His symptoms have been progressively worsened over the past 6 months. He also reports several facial flushing episodes and has recently been diagnosed with new onset heart failure, affecting the right side of his heart. His past medical history is significant for hypertension managed with lisinopril. On examination, he's found to have hepatomegaly, and cardiac auscultation reveals a loud systolic murmur over the right sternal border. Which of the following is the most likely primary location of the underlying mechanism? We're thinking carcinoid. We have some flushing. See that? Flushing. Why do we highlight flushing? And the right-sided valvular disease. What is this? We got some fibrosis, probably. Some serotonin-induced fibrosis in the small intestine, we're thinking. Man, Sadal is unstoppable. We got to find one question that can stump him. Indeed, this is correct. This is carcinoid syndrome via Sadal, indeed. So they have carcinoid syndrome, a paraneoplastic syndrome caused by a neuroendocrine tumor that secretes serotonin and other vasoactive substances. We get diarrhea, flushing, bronchospasms, right-sided heart failure, especially tricuspid regurgitation. Appendix for asymptomatic carcinoid. Lungs would involve bronchial carcinoid and be without liver metastasis. The pancreas has lipoma, insulinoma, gastrinoma, and the stomach, type 1 and 3 gastric carcinoids. Hematopoiesis. Diarrhea is going to be persistent and watery in carcinoid syndrome. And also you have a shortness of breath and right-sided heart failure. So there's fluid buildup that causes a loud murmur and hepatomegaly. So these are going to be a classic triad of the carcinoid syndrome. Flushing, diarrhea, shortness of breath. And so that's carcinoid. And what causes carcinoid? Well, carcinoid syndrome happens when a carcinoid tumor is a neuroendocrine tumor and it makes way too much serotonin. Way too much serotonin, 5-HT, right? And other signaling molecules like bradykinin and also histamine. Histamine is going to be present there too, and bradykinin. And that causes the flushing, the vasodilation. The diarrhea is the increased motility, and the fibrosis of the heart valves, especially the right-sided fibrosis, causes heart failure and a murmur, which was in this patient. And so why right-sided as opposed to left? Do you guys know? So serotonin is going to damage the try before you buy, and the pulmonary valves, not the left side, because serotonin is inactivated by the lungs. That's the lungs inactivate serotonin. And so it's like it purges it so the left side is not going to experience those serotonin side effects. So serotonin reaches the lungs, boom, it gets neutralized, and the left heart never sees it, right? And so even if somebody has carcinoid tumor in their gut, the symptoms don't appear until the tumor spreads and metastasizes to the liver. And the reason why is if you have a tumor in your normal small intestine, then the serotonin will go to the liver first through the portal circulation, and then the liver destroys it and you have no symptoms. But after you have metastasis to the liver itself, then the tumor is inside of the liver. And so it'll bypass liver metabolism and you get systemic symptoms. Okay, David, that's an interesting question. Isn't serotonin a love hormone? How do the lungs flush it out? That is a really, really good question, but it's actually not. It's oxytocin. It's probably what you're thinking about, right? Oxytocin is going to be like the whole bonding, social attachment hormone, and also childbirth and trust. Like literally you can't give birth without oxytocin. The love hormone, right? So serotonin, on the other hand, is a neurotransmitter that's involved in mood regulation. So typically you give somebody an SSRI, that's serotonin. Depression, you give them fluoxetine, that is a serotonin reuptake inhibitor. So it's involved in mood regulation, sleep, appetite, other bodily functions, right? So serotonin is involved in that is involved in that stuff. But romantic love, serotonin actually does play a little bit of a role in the romance, right? But it's not the being in love, right? The studies actually show that in an early stage of romantic love, serotonin levels can actually decrease, interestingly enough. I don't know why, but yeah, so serotonin is not the love hormone. You're probably thinking of oxytocin. But then you asked another question. You asked, how do the lungs flush out serotonin? Well, in carcinoid heart disease, right, from the mid-gut neuroendocrine tumor that produces a whole bunch of serotonin, the lungs and the liver metabolize the serotonin before it can actually reach that side of the heart. And so the mechanism is basically the lungs metabolically inactivate the serotonin as the blood passes through the pulmonary circulation. And that stops the 5-HT from ever reaching the left side of the heart. So it metabolizes 5-HT into the inactive metabolite. Wait, Seidal, you activated push-ups? All right, push-up time. Here we go. All right, thanks for the push-ups. That was nice. That was great. No, David was inactive. Nothing like logging onto Twitch and watching people do push-ups. All right, let's do our next question. If I'm a little bit out of breath, it's because one of our viewers just made me do 20 push-ups. So a 47-year-old worker presents to the clinic with complaints of numbness and tickling in her right hand that began a few weeks ago. She states the symptoms are worse at night and after using the computer for extended period. On physical examination, there's mild atrophy of the thenar eminence on the right side. The patient has weakness with thumb opposition and positive sign at the wrist. Sensory examination reveals decreased sensation to light touch on a specific area of the hand. Which area is most likely affected in the patient? Okay, so you got thenar atrophy and also nighttime worsening. That's carpal tunnel syndrome, if that helps. Yep, you got it, Seidal. So carpal tunnel results from the compression of the median nerve within the carpal tunnel of the wrist. And so you get weakness in the thenar eminence. And the answer that David said is true. Palmar surface on the thumb, index, and the middle fingers. So they have classic carpal tunnel, compression of the median nerve. Hallmark involves the palmar surface of the lateral 3.5 digits, the thumb, the index, and also the middle, lateral half of the ring. And the motor symptoms are a weakness of the thenar muscles, especially thumb opposition. The pathophysiology is you have repetitive wrist motion, you increase pressure on the carpal tunnel, compression of the median nerve. You get sensory loss in the palmar, thumb, and the radial half of the fingers. David says, me after playing Minecraft for 8 hours. Yes, indeed. No wonder all you millennials have carpal tunnel. Here's the bottom line. Carpal tunnel syndrome affects the palmar surface of the thumb, index, and middle fingers due to median nerve compression. All right, in this one, we have a 78-year-old man presenting to the primary care physician with concerns about spots on his forearms. He has noticed several red and purple blotches developing on the dorsal surfaces of his forearms over the last several months. Upon examination, large non-blanching purpuric patches are observed on both forearms, with no signs of trauma or laceration. His medical history is notable for well-controlled hypertension, and he takes lisinopril daily. He denies any platelet-taking or anticoagulant medications. Lab tests, including complete blood counts and coagulative profile, are within normal limits. Which of the following is most likely the cause of the skin findings? So he's got some old skin. So aging and chronic sun exposure can lead to dermal collagen and elastin atrophy. And that causes the fragile blood vessels to rupture, and you get large, flat, non-blanching purpura on the dorsal forearms with normal lab tests. So this is just senile purpura. Vitamin C deficiency would cause perifollicular hemorrhaging, gum bleeding, and poor wound healing. So that's not it. Von Willebrand causes mucosal bleeding like nosebleeds, menorrhagia, and prolonged bleeding time. ITP, that would show low platelet count on the CBC with petechia and also mucosal bleeding, not just the forearm bruising. So ITP has to have thrombocytopenia. It's in its name. Low platelet counts and also petechia and mucosal bleeding as well. HSP is going to be more commonly in children. Presents with palpebral purpura, arthralgias, abdominal pain, and renal involvement. Not seen in the elderly though. So younger kid, cytopenia, thrombocytopenia is going to be seen there. No bleeding issues, different presentation. So it's senile. Here's the bottom line. Senile is common in elderly patients presenting as non-blanching purpura without trauma. All right, on to our next question. So here, a 29-year-old man is undergoing evaluation for hypertension. Imaging reveals unilaterally absent left kidney. Further investigation does not indicate prior surgical removal. Why is his left kidney not developed? Renal agenesis? Well, the answer to this one is renal agenesis happens when the uteric bud stops inducing the metanephric mesenchyme. So it's the metanephric mesenchyme that's the embryologic origin of the kidney's nephron structures. So it's unilateral renal agenesis. And so the answer is A, failure of the uteric bud to invade the metanephric mesenchyme. And because this is not due to surgery, it must be embryologic, and there's something wrong in the kidney development. And normally, There are 3 stages of kidney development. There's the pronephros, that's early, right? And then it degenerates. There's the mesonephros, that is temporarily the kidney for the first trimester, the mesonephros. And then it becomes part of the male reproductive duct. Then it becomes part of the male reproductive duct via the mesonephric, the Wolffian duct. And then you have the metanephros. And that is the permanent kidney that forms starting week 5. And there are 2 simultaneous structures that need to be in order for this to happen. So one is the uteric bud, and that's also called the metanephric diverticulum. It's an outgrowth from the mesonephric or the Wolffian duct, and it forms a lot of things: the ureter, renal pelvis, the calyces, the collecting ducts. And the metanephric mesenchyme, that gives rise to like the glomeruli, the proximal tubule, the loop of Henle, the distal convoluted tubule. And the uteric bud has to go invade the metanephric mesenchyme to induce nephron formation. If that fails, then the nephrotic tissue can't differentiate, and so no kidney is going to form. Okay, there we go. So unilateral is caused by that failure there, but then bilaterally, you could have like oligohydramnios and Potter sequence, things like that. And then unilateral renal agenesis is usually asymptomatic and involves other kidney hypertrophies. Congenital absence of a kidney is typically due to failure of the uteric bud to invade the metanephric mesenchyme. All right, here we go. A 26-year-old professional soccer player presents to the sports medicine clinic with swelling on his right knee following an injury at the game. He reports that he was running when he suddenly decelerated and twisted his knee awkwardly. On physical exam, there is significant joint effusion and tenderness along the joint line. Lockman's test is negative, but the posterior drawer test is positive. What does that mean? All right, so MRI of the knee is obtained, and we have to know which structure is going to be injured. I wanted to draw out some of these structures and have that be the kneecap, but alas. So the drawer sign, what does that tell us? The positive posterior drawer sign. Positive posterior, that tells us that it's posterior cruciate ligament tear. And so it's sudden deceleration, David. So the answer is B, posterior. So the posterior drawer test is positive, so it's the posterior cruciate ligament. So this is diagnostic for a PCL injury. It prevents posterior displacement of the tibia relative to the femur. So they're decelerating and then twisting, and that's a very common kind of cause of this. And the posterior drawer, the Lockman's test is going to be negative. That means that the ACL is intact. And the posterior drawer is positive, so it's a PCL injury. Yes, Lockman would be the ACL injury, and the posterior drawer is the PCL. And usually that can be caused by several things. You have to know, USMLE loves asking everything about pregnancy, which physiological changes are going to be seen. So here, I'm just going to write this one out. So let's say that we have a 30-year-old woman. David's water is breaking. Yep, it's a 30-year-old woman. She's 32 weeks pregnant, so she's in her 3rd trimester. And let's say she feels well. She has virtually no problems, and she has normocytic anemia. So her MCV count is at 85, and her hemoglobin has dropped from 12 to 10.8 over 8 weeks. All right, so is this pathology? Is this pathological anemia? What happens here? Well, what's happening is that the plasma volume is going to change during pregnancy. Plasma volume increases by like 40 to 50%, and that will dilute the blood. And then you have red blood cell mass is also going to be increasing by about 20 to 30%. And that helps with the oxygen supply to the fetus. And so the net effect is you have a plasma increase, and the plasma increase is usually greater than the red blood cell increase. And so that causes hemodilution, which is physiologic anemia of pregnancy, which is exactly what this patient's undergoing. Physiologic anemia of pregnancy. Yep, Dr. Kawasami got it. Delusional anemia. Nice. Hey, music playlist. Hey, tomorrow's my step 1 exam. My scores on NBMEs have been low, and I have only passed free 120. What should I do one day before the exam? I'm going to send you an article. The big thing that I would say, though, is pretend that it's test day. Try to get to bed as early as you can while feeling normal. Get a good night's sleep, right? And also get a good breakfast as well today. Just try to mimic testing conditions as much as you possibly can today, and then take it easy on your brain. Maybe some light review. I would say just don't really study much at all. Maybe just memorize it, all like the low hanging fruits. Like if you want to just hang out on the stream and just have a good time, eat some food, have a good time, like just chill. Just stick to your normal diet though. Yes, good luck indeed. Good luck. Yep. Organize your documents, right? Get everything ready that you need. Eat, hydrate, try to relax, sleep. Yep, just get your mind and your body ready, right? Take the day off of studying and really just get yourself prepared mentally. If you want to just hang out in the live stream, that's cool too. Just whatever makes you feel, just chill. Okay, here we go. Next question, and very good luck. You're going to kill it. 42-year-old man visits the neurologist due to persistent muscle stiffness and cramps in his lower limbs for the past 8 months. He has occasional tremors and involuntary muscle spasms, which have made it difficult for him to perform daily activities such as walking or standing for extended periods of time. I'm glad the NBME reviews have been helpful, man. Thanks. A therapeutic intervention that targets which of the following mechanisms is most likely to alleviate the patient's muscle spasticity? Okay, so we're alleviating the spasticity, so we need some sort of an inhibitory mechanism. And so spasticity is caused by the loss of the descending inhibitory input. That's why you're spazzing up, your loss of the inhibitory. And what are the key inputs there is glycine and GABA. They're the key neuroinhibitors of the spinal cord. And so it's going to be the glycine receptor-mediated chloride ion influx in the spinal internal neurons. So they have muscle stiffness and also cramps, and they have involuntary spasms and increased tone. So they have like spasticity, and they have hyperreflexia and a positive Babinski sign bilateral. So all of that tells us that they have an upper motor neuron lesion. And so that's seen in a lot of disorders like multiple sclerosis, spinal cord injury, stroke, and also like ALS, right? These are all upper motor neuron kind of diseases. So MS, spinal cord, stroke, ALS. And the question is like, what mechanism would reduce the spasticity? And so spasticity occurs because of the loss of inhibition. And so normally the inhibitory interneurons in the spinal cord, especially the Renshaw cells, are going to release glycine and GABA. Go GABA, GABA. And the upper motor neuron is damaged. And so you have inhibition is decreased and alpha motor neurons are going to become hyperactive. Alpha motors are hyperactive. And so you have spasticity, hyperreflexia, and clonus. And so there are a lot of drugs that actually reduce spasticity. One of them is baclofen, right? The mechanism is GABA B. And the target for baclofen is going to be the spinal cord. And the net effect is you have increased potassium outflow, which hyperpolarizes and causes decreasing of the motor neuron firing. So there are some drugs that do this, and they usually interact with GABA. So GABA glycine is what you should be thinking of. Like diazepam, for instance, that's GABA A receptor agonist, and that's for the spinal cord of the brain, and that causes a chloride influx. Dantrolene blocks calcium, and that's decreasing the contractor strength. And glycine agonists, those glycine agonists increase the chloride influx in the glycine receptor, and it causes a decrease in the alpha motor neuron firing. And so here we're doing glycine receptor-mediated chloride influx in the spinal interneurons. That's our correct answer. All right, so spasticity, buzzwords, you have the increased tone, you have velocity-dependent resistance, Babinski signs, hyperreflexia. Give them some baclofen, GABA B, act similar to glycine, and glycine through the chloride channels. It'll open those chloride channels, right? You want to hyperpolarize the motor neurons, so that'll reduce the spasticity. Here's the bottom line. Targeting glycine receptor-mediated chloride influx alleviates muscle spasticity in conditions like upper motor neuron lesions. 12 more questions until our break. All right, in this question, we have a 25-year-old male who's brought to the emergency department collapsing while jogging. They're unconscious and complains of weakness and shortness of breath. Vital signs show a heart rate of 78, blood pressure of 92/60, oxygen sat at 97% on room air. Cardiac auscultation reveals a faint S1 and S2 with no murmurs. Jugular venous dissension is noted. Lung examination is clear. Echocardiogram shows a normal-sized heart with ejection fraction of 30%. Lab shows normal electrolytes and negative troponin. Based on these findings, which the following mechanism is most likely responsible for his symptoms? So this ejection fraction is low. He has a normal-sized heart, and he has low blood pressure as well. Low blood pressure. So there's like some sort of a pump dysfunction. It's not volume problem, it's a pump problem. So what do you guys think? Hypotension. Let's say there's also elevated central venous pressure, right? Because of that jugular venous distension. His lungs are clear, right? So that's not left-sided or fluid overload. Because if it's fluid overload, then it's going to back up into the lungs. So he's severely reduced contractile function because of that ejection fraction. And so the answer is going to be decreased cardiac contractility. Here's the brief explanation. Here's what he's got. Hallmarks of systolic failure. He's got decreased contractility. It's not, if you're on the left side, you'd have pulmonary symptoms. Decreased afterload, that would help the failing ventricles. Nice. Increased preload, more filling. That would help with the cardiac output. But the JVD is a result of poor forward flow. There's a nice equation right there. In young people, think viral myocarditis, inherited cardiomyopathy, or toxin-induced injury through alcohol and drugs. If it's less than 40, think systolic dysfunction. Here's the bottom line. Patient symptoms indicate decreased cardiac contractility due to low ejection fraction despite normal heart size. Normal heart size, decreased fraction. Okay, on to our next question. Oh, there's a question in the chat from Dr. Kawasami. Wanted to ask about GABA B and GABA A in terms of their function and uses. Yeah, let's add that to the community questions pile here, and let's hit that. GABA A and GABA B. We can do that now. Okay, so answering a question in the chat, GABA A and GABA B in terms of function and uses. So let's do a quick overview on this. So GABA, which is gamma-aminobutyric acid, that is the main inhibitory of the central nervous system. And so this is going to decrease the neuronal excitability by hyperpolarizing the postsynaptic membrane. It hyperpolarizes, and it acts through two receptor subtypes, which is what this question is about. The first one is the A one, and that's ionotropic. And so that's throughout all of the CNS, especially the cortex, the cerebellum. Yep, it's ionotropic. GABA A is ionotropic. And the ion signaling mechanism is ligand-gated. It's a ligand-gated chloride channel, and that causes, ligand-gated ionotropic. That is GABA A. Now, GABA B, this is not going to be as everywhere as A. This is involved in the spinal cord and also the brainstem. And this has a different mechanism as well. This is a G protein coupled reaction. GABA B is. And so that opens up the potassium channels and it inhibits the calcium channels. Opens up the potassium and it inhibits the calcium channels. Okay, so the GABA A, this is like very fast inhibition. This is right. So GABA binds and then it causes the chloride to just flow in. And then the membrane becomes hyperpolarized and now the neuron just can't fire. That's why it's inhibitory. And this is like milliseconds. This is like super, super quick. And there are a ton of drugs that act here. Benzodiazepines are the most high yield. So diazepam, lorazepam. The mechanism is increasing the frequency of the chloride channels. And that's used for like anxiety, for seizures, for muscle relaxation, and also insomnia. Barbiturates also, like phenobarbital, that increases the duration, barbiturations, right? And that's increasing the duration of the chloride, but it's still chloride, you know what I mean? It's still hyperpolarizing inhibition. And that is used for like seizures, anesthesia induction. Also alcohol, right? Alcohol potentiates GABA A, and that's used for, well, sedation. Especially in the olden days, they used to give alcohol for that. And then also the Z drugs, those are also used for insomnia. And then the anesthetics like propranolol or propofol, and that enhances GABA as well. That's used for sedation. So you can use this for sedation pretty well. And GABA B, that's slower inhibition. So GABA B is slower inhibition, and that is a G protein coupled receptor. And so that activates the potassium efflux and the calcium influx. And so you get hyperpolarization and decreased neurotransmitter release. And that's slower. That's like 100 times slower. But it's still like milliseconds or maybe like a second. And this is mainly in the spinal cord. And the drugs there is like baclofen. So baclofen, GABA B for baclofen. Yeah, you're right. GABA B for baclofen. And so that's used for muscle spasticity and spinal cord injury or multiple sclerosis. And then baclofen's like the most high yield because baclofen for back, B for back, right? Spinal muscle relaxation, B for the back. And that's pretty much all there is to it. You know, B is slower, has potassium efflux, there's calcium influx, and it's slower. Baclofen, GHB, spasticity. So really the time course is one of the biggest differences, but also the physiologic kind of mechanism at play. And then you said the previous question was about GABA A. Yeah, the previous mechanism was about glycine receptors, right? Glycine receptors and chloride influx. And that is functionally analogous to GABA A, not GABA B, because they both cause, rapid neuronal inhibition through the chloride entry. But glycine acts mainly on the spinal cord, while GABA A acts throughout the brain. All right, so hopefully that clears things up. Great question. Thanks for asking it. Now let's dive into this one. So here we have a 47-year-old woman presenting to her primary care physician with a complaint of tingling and burning sensations on both of her hands that began 6 months ago. Thank you, Dr. Kawasami. I love your questions. They're always really insightful. Okay, so she's got the tingling. Her spider senses are going off. Sensations on both of her hands that began 6 months ago. She has a history of poorly controlled hypertension and hyperlipidemia. Her occupation involves constant typing, relatable, but she denies any acute injury to her hands. She's like, nah. Physical examination shows normal strength and reflexes with decreased sensation to light touch and pinprick. Which the following mechanism explains her symptoms? Okay, what is explaining her symptoms? Hypertension, hyperlipidemia, a glove-like distribution of both hands. Diabetic neuropathy. Okay, so the correct answer is D. Persistent activation of voltage-gated sodium channels and peripheral nociceptive pathways. Okay, she's got the glove-like burning. That's diabetic peripheral neuropathy, just as Dr. Kawasami said, 100%. This is chronic hyperglycemia leads to axonal damage in the unmyelinated C fibers, the stocking glove. This pain is mediated by the persistence of these sodium channels and producing spontaneous depolarizations and neuropathic pain. The large fibers remain relatively spared, and that explains the preserved strength and reflexes. Okay, so decreased expression of voltage-gated calcium, that's Lambert-Eaton syndrome. Proximal muscle weakness, that's improved with activity. Increased density of L-type. L-type is linked to smooth muscle contraction and cardiac function. Increased synaptic release of GABA in the CNS. That would cause sedation, as we've talked about before, or inhibition, right? It reduces. These are inhibitors, and I think we've made that really, really clear. The keyboard got stuff, gotcha. Reduced conduction velocity in a delta fiber due to demyelination. That's Guillain-Barré. Sufjan Stevens had Guillain-Barré. I always like to remember that. One of my favorite artists of all time. A chronic demyelinating neuropathy, which causes weakness and are not length-dependent sensory neuropathies. So peripheral neuropathies and diabetes are length-dependent. The longest are damaged first. That's why it's the stocking glove, which should key you into this. And then you just have to know the mechanism is going to be with that sodium and the nociceptor pathway, hyperexcitability of the sodium, which causes that pain. All right, so there's the pathophysiology of hyperglycemia. Glucose is converted to sorbitol in the Schwann cells, the peripheral nervous system. You don't want the sorbitol in the peripheral nervous system, right? So yeah, that causes the stress and the oxidative injury. And now you have microangiopathy and you have endoneurial ischemia, which causes axonal degeneration. And you have the loss of the unmyelinated C fibers, and that causes the burning. There's also that persistent sodium channel activation. All right, so half of diabetic patients are going to develop some form from the sugar alone. You still answered so quickly. So chronic hyperglycemia batters peripheral nerves, especially the long ones in your feet, in your hands. So glucose builds up in those Schwann cells, converts it to sorbitol, drains the water, stresses and damages the cell. That's what's going on, folks. Here we go. Bottom line, glove-like sensory loss in the hand suggests peripheral neuropathy, likely due to reduced conjunction velocity for demyelination. Yep, we're on to our next question, 140. Hey there, study partner. How you doing? There's always a little break before the next question just because it's got to load. But if you have any questions in the meantime, happy to answer them. And then typically I like to go to this page right here, take some notes on the next question to kind of gather my thoughts. But yes, we're doing the next question. We have 10 more. 10 more to go. And then we're taking a break, and then we're going to do 50 more. Also, good to see you. I think that's the first time I've seen in the chats. Welcome. Awesome. And then Dr. Kawasami has a question. Let me go over here to the community poll, and I'll write that down. And I'll be releasing this document to you guys afterwards as well. So I'm going to copy your question here. Copy, and I'm going to do text. Oops, text. Paste. Oh no. Let's try that again. Paste. Yeah, that's good enough. Tell us about micro versus macro angiopathy complications as quick as you can. Okay, I just realized. Okay, sounds good. So you're asking about some complications of diabetes then and the small vessels. So basically what I would say is like the micro vessels versus the macro. So the micro, you have the small vessels, right? And so that's going to be like the retina, the kidney, nerves, right? The brain, and also the limbs. So that's like for very, very quickly, like that's what's most high yield. You're asking about the diabetic complications, right? From chronic hyperglycemia. And basically all these problems are caused by non-enzymatic glycosylation and then sorbitol accumulation, right? And so there are different types. There's microangiopathic, and there's also, right? So microangiopathic, which is this one right here. Microangiopathic, that's non-enzymatic glycosylation of the vessels. So capillaries, arterioles, and the basement membrane thickening. And that causes like the leaky stuff, and it's really ischemic, that kind of stuff. The targets are really the main difference there. From micro, it's the retina, the kidney, and the nerve. And so some examples of that are like retinopathies, microaneurysms, hemorrhages, neovascularizations, and then also neuropathies, like basement membrane thickening, expansion, the chemostem-Wilson nodules. All of that stuff is associated with micro, the retina, the kidney, the nerve. And the neuropathy is caused by ischemia plus sorbitol accumulation, and you get the glove stocking pattern. That's micro, right? And then your other question is about the macro, right? And that's the coronary, the cerebral, the peripheral, the limbs, right? And myocardial infarction is most common. And then the stroke, you could have like a stroke, you have like peripheral vascular disease. And a big thing to think about for like macro is like gangrene is one that comes to mind with macro. Other than that, I don't really know what else I would say. I guess just you have accelerated atherosclerosis in their large vessels, and that's due to like the macro endothelial injury and also like the LDL glycation. So hopefully that makes sense. Okay. You're preparing for the AIMS exam. You wanted to solve a few? 100%. Yeah, we'll be here all day, man. If you want to just like mute the stream and then hang out, and then you can just join in whenever we have them. That way it's like super efficient for you. Whatever works best for you, We're here for you. As Tom Wambsgans says in Succession, we here for you. All right, folks, here's our next question. A 6-year-old boy is brought to the clinic by his mother due to a 2-day history of fatigue and bluish discoloration of his lips and fingertips. Cyanosis, anybody? The symptoms started a day after attending a family picnic at a countryside park where he drank from a nearby well. Classic. His medical history is unremarkable. There are no known allergies. On examination, the boy appears in mild distress with tachypnea and central cyanosis, but his heart and lung sounds are normal. A blood sample appears chocolate-colored and does not change upon exposure to the air. Lab results reveal a normal pH, partial pressure of oxygen within reference range, but the oxygen saturation is low. Which of the following is the most likely cause of this patient's condition? All right, chocolate-colored blood, right? Chocolate-colored blood. Cyanosis. What do you guys think? Okay, so he's been exposed to some oxidizing agents. Normal pH, partial pressure of oxygen, but the oxygen saturation is low. He has been exposed to some oxidizing agents, right? So our answer is C. And yes, you're right. Study partner got it. Methemoglobinemia. This is a condition where the iron becomes ferrous. So you get the 2 to 3. It's like leveled up, right? And that impairs the oxygen delivery. This is the chocolate-colored stuff that does not improve if you give it more oxygen. And also normal PO2, but low oxygen sat tells you this, and it's the well water. It's the ingestion of nitrates. That's an oxidizing agent. that is contaminated in water sources, especially in rural areas. It's not defective heme synthesis. That'd be like sideroblastic anemia, porphyria. That's a chronic issue. Impaired oxygen unloading. That's left-shifted oxygen dissociation curve. Proliferation of the mutant erythrocyte precursors. That's like polycythemia vera. And decreased affinity of hemoglobin would be the Haldane effect. Okay, so we have to understand the difference between PaO2, which is the dissolved, and then the oxygen sat, which is the binding. So methemoglobinemia affects the ability to bind and release oxygen. And so it's normal, PaO2, but you just can't bind and release that oxygen. And so it's nitrates, benzocaine, dapsone, sulfonamides, all of that stuff used in pediatric and rural cases. And you have that chocolate-colored blood because the methemoglobin does not carry oxygen well, and that's why you have that little color to it. Okay, chocolate rain. Bottom line, chocolate-colored blood and low oxygen sat indicate methemoglobinemia, likely due to exposure to oxidized agents. Nice, Dr. Kawasami. All right, here we have a 28-year-old man presenting to the clinic with a 2-month history of increasing joint pain and stiffness, particularly affecting his hands and his knees. He reports occasional low-grade fevers and fatigue. On examination, he has swelling and tenderness of his phalangeal joints and knees bilaterally. Okay, we have elevated ESR and C-reactive, but negative for rheumatoid factor and anti-cyclic citrinucleated citrullinate peptide antibodies. Synovial fluid analysis from an affected joint shows an inflammatory process with increased white blood cells, but no crystals. Which cytokine is most likely playing a central role in the inflammation in this patient? All right, what do you guys think? So we have symmetric polyarthritis in the hands and the knees, morning stiffness, swelling, tenderness. All that stuff is pointing us toward like rheumatoid. And there's inflammatory synovial. There's increased white blood cells, but no crystals. And there's also negative RF and also anti-CCP. That's seronegative rheumatoid arthritis. So this is some sort of rheumatoid arthritis-like disease with autoimmune inflammation of the synovium. It's just seronegative. And so the pathophysiology here is weird, right? But this is cytokine-mediated chronic inflammation. And this is an interesting question because we have tumor necrosis factor and interleukin-1. So tumor necrosis factor, that's the master cytokine. This promotes inflammation, activates your macrophages and fibroblasts, and induce other cytokines like IL-1 and IL-6. It stimulates the osteoclasts. And then there's IL-1, right? And that works with TNF-alpha to increase the synovial inflammation and the cartilage destruction. So really, this question would involve both of these. And then IL-6, this promotes the acute phase reactants. That's increasing the ESR. But here they're saying playing a central role here. So I think we're more partial to TNF-alpha. IL-10 is anti-inflammatory, so it inhibits the Th1 response. And then IL-2 promotes T-cell proliferation, not primarily inflammatory in rheumatoid arthritis. So the main driver in this cascade is TNF-alpha. Because TNF-alpha inhibitors are super important in rheumatoid arthritis treatment and also other issues as well, like etanercept is a TNF receptor fusion protein. And so it's used in rheumatoid arthritis, psoriasis, ankylosing spondylitis, all those. Infliximab is anti-TNF-alpha monoclonal antibody, and that's also used in rheumatoid arthritis, also IBD and psoriasis. And so that's the main cytokine that's kind of responsible for all this stuff. Now, IL-1 is also a really good one because that promotes inflammation, but it's going to act like synergistically with TNF-alpha. It's not the primary driver. Okay, Dr. Kamisami says for the previous question about methemoglobinemia, O2 saturation and O2 content is down. However, HP concentration and PaO2 is unaffected. Yeah, so for methemoglobinemia, the PaO2 is the partial pressure of the dissolved O2 in the plasma. And that's, dissolved O2 isn't affected. The problem is the hemoglobin, right? It's not the lungs. So PaO2 is fine. The hemoglobin concentration is normal. The total hemoglobin amount in the blood is unchanged. It just is chemically altered so that it's 3, instead of 2, it's 3. The oxygen saturation, which is the SaO2, that's decreased, right? It's the fraction of the hemoglobin that's bound to O2. It'll drop because Fe2 can't bind O2, right? Fe3 can't bind O2. And so the pulse ox is usually 85%, and they're unresponsive to oxygen therapy. You give them oxygen therapy, it doesn't work. And also the oxygen content is decreased as well. And that's because the oxygen content depends on how both the hemoglobin and its saturation as well. So yeah, that's the lay of the land there. And that's all because the Fe3 plus can't bind to oxygen. And so the functional oxygen carrying capacity is lower. But the remaining Fe2s and hemoglobin have increased oxygen affinity. And so they're less likely to release it. And so they're hypoxic even though PaO2 is normal. You have that chocolate brown stuff, right? Good recap. All right. Here is the bottom line. Negative RF and anti-CCP with inflammatory suggest seronegative spondylo. And so TNF-alpha is the key inflammatory cytokine. Or tumor necrosis factor is key for inflammation. All right, a 35-year-old woman is brought to the clinic by her sister due to progressive drowsiness and confusion over the past 48 hours. She has a history of chronic hepatitis C, diagnosed 5 years ago, and she has not been adherent Her sister notes that she's been frequently disoriented and now she's confused. She has scleral icterus and several spider angiomata on her upper chest and back. Her abdomen is distended with a fluid wave, and there is tenderness on the right upper quadrant. Neurologic exam reveals positive estrixis. Lab sites show elevated ammonia level. What is the following most likely diagnosis? So the estrixis is the flapping tremor, and that's metabolic encephalopathy. And there's elevated pneumonia, and that's the hepatic dysfunction and CNS effects. This is hepatic encephalopathy. The trap answers why they're wrong. Alcoholic hallucinosis, that's vivid hallucinations. There's no recent alcohol use. Korsakoff confabulation and irreversible memory loss due to thiamine deficiencies. Alcoholic hepatitis is that ratio of greater than 2 to 1. Wernicke's encephalopathy is going to involve confusion, ataxia, and ophthalmoplegia. That triad is absent here. Cis is due to the tremor from negative myoclonus due to CNS toxicity. Elevated ammonia is the hallmark. Spider angiomata is from estrogen excess from the impaired liver metabolism. Too much estrogen going on. Fluid wave, portal hypertension. So you're flapping the hands is the sign of the brain poisoning by the gut. It's estrixis. Here's the bottom line. Hepatic encephalopathy is characterized by confusion, estrixis, and elevated ammonia in patients with liver dysfunction, liver disease. All right, next question. We have a 59-year-old woman presents to clinic with swelling in her legs and abdomen. She has history of rheumatoid arthritis and methotrexate. She has periorbital purpura and glaucia. Creatinine level and proteinuria is elevated. Eosinophilic amorphous material, and the Congo red and apple green. So we know this is amyloidosis. We just have to figure out what type. So there's primary, and that's involved in your plasma cell disorders like multiple myeloma. And then there's secondary, which is chronic diseases like infections like tuberculosis, IBD, things like that. And then there's familial, that's hereditary. And then there's senile, which is in the elderly. There's also dialysis related. And there's the islet amyloid, that's type 2 diabetes. And also the atrial amyloid, that's in depositions of the elderly as well. And so now we have to apply all of that to this patient. So they have chronic rheumatoid arthritis, that's chronic inflammation, and there's elevated serum amyloid, and that's an acute phase reactant that's made by the liver. Right? Elevated serum amyloid A, acute phase reactant made by the liver. And that causes persistent elevation, and so you have that misfolding, and then you get the amyloid depositions, the insoluble fibrils in the organs, especially in the kidneys. And that leads to proteinuria, nephrotic syndromes, renal failure, all that stuff. And so her amyloid fibrils are derived from amyloid A protein, from serum amyloid A. So I'd say because this is a chronic inflammatory disease, that's going to be pointing more towards secondary, not plasma cell. And in secondary, you have serum amyloid A protein, whereas for primary, you have the immunoglobulin light chains. So that's plasma cell dyscrasia, multiple myeloma, that kind of stuff. And now, if this patient presented differently, then I could have a different answer. Like if she had heart failure, then you could think of the atrial neuritic factor. Since this one was amyloid A, we know that it's going to be associated with the kidney, nephrotic syndromes, and chronic disease. Beta 2 microglobulin, that's associated with hemodialysis. And the transthyretin, that's going to be more of like a family history associated. So recognizing this is secondary, recognizing secondary goes with amyloid A is important. We'll go on to our next question. All right, we have a 17-year-old male, visits an adolescent health clinic, and he confides he's been sexually active and inconsistent condom use. He's concerned that his parents will know, but somebody else was diagnosed with an STI. And indeed, it's gonorrhea. So he's diagnosed with gonorrhea and he requests confidentiality. And so this is a minor with a sexually transmitted infection who is capable of understanding his condition. And so confidentiality and minors in sexual health in the US, minors have a right to confidential diagnosis and treatment for sexually transmitted infections, contraception, pregnancy, substance use, and also mental health. Confidential. And that means that parental consent is not required to test or treat an STI. And the provider can maintain confidentiality unless there's some sort of risk of harm or abuse. And so the next step is going to be confirming the gonorrhea. So you got to treat the infection with ceftriaxone and also doxycycline, especially if chlamydia is not ruled out. And you educate the patient. You say, hey, you got to have consistent condom use and also partner notification and treatment as well. So you got to avoid sexual activity until the treatment is complete. And so conduct a discussion about safe sex and the importance of informing sexual partners. Now, A, insist on obtaining parental consent is not necessary because as we discussed in the US, this is one of those conditions. So don't tell mom, tell the partners. So yes, discuss the safe sex practices and partner notification after confirming Neisseria gonorrhea in sexually active adolescents. All right, here we have a 3-month-old infant brought to the pediatrician by her parents due to persistent diarrhea and recurrent respiratory tract infections. They report that their daughter has been hospitalized twice for pneumonia since birth. That's a lot. Child appears thin, signs of dehydration. Evaluation reveals a profound lymphopenia, and we show accumulation of DATP and a deficiency and lymphocyte DNA synthesis. Which of the following enzymatic deficiencies is most likely responsible for this? You can see it's highlighted. Adenosine deaminase deficiency is what's going on. This is profound lymphopenia in patients. So this is SKID. Down on Skid Row. Elevated DATP points directly to this. So they had the severe immunodeficiency, recurrent infections, diarrhea, lymphopenia. That's all hallmark of this. Adenosine deaminase deficiency is going to be associated with SKID. It's essential for purine metabolism. And so without it, you have the toxic levels of DATP. And so you get apoptosis of T and B cells causing profound lymphopenia. What about the others? Purine nucleoside phosphorylase deficiency. That would be a T cell deficiency only. Adenine phosphoribosyltransferase transferase deficiency would cause hyperuricemia. Hypoxanthine, HDPRT would have self-mutilation. Xanthine oxidase, renal stones not linked to immune defects. SKID's life-threatening. DNA synthesis associated, DATP buildup. Bottom line, adenosine deaminase deficiency causes severe combined immunodeficiency leading to lymphopenia and recurrence infections at birth. All right, here we go. A 55-year-old man presents to the emergency department after experiencing sudden onset of weakness and coordination difficulties. His wife reports he's been complaining of double vision earlier that day. On examination, the patient exhibits weakness of the right upper and lower extremities and increased muscle tone and burst reflexes on the right side. He's got ptosis, mydriasis on the left eye, and it's down and out. What do we got? All right, right-sided weakness, hyperflexia, spasticity, and so we have contralateral to the brain lesion. So the left corticospinal tract is going to be involved. We know that for sure. And he's got the down and out. So he's got ipsilateral, it's the left side, ocular motor, that's cranial nerve 3, palsy. And there's a lesion on the left midbrain. That's where the cranial nerve 3 exists. And so there's a lesion on the left midbrain, especially basis, so the crus cerebri. That's Weber syndrome. It's a type of a midbrain stroke. And so there are some findings. Usually the corticospinal, let's say it's on the left side, would cause contralateral hemiparesis, so right-sided weakness. Also the cortical bulbar findings, they're going to be damaged on the left side. And so the finding is going to be contralateral lower facial weakness. And sometimes that's going to be seen in this patient, it was contralateral facial weakness, which I guess they actually didn't mention in this. But the corticobulbar findings are going to, if it's on the left side, cause contralateral lower facial weakness. And then ocular motor nerve, if it's on the left side, you'll have ipsilateral cranial nerve 3 palsy, so ptosis, mydriasis, the down and out look. So the question's saying there's increased tone and burst reflexes on the right side. So there's corticospinal involvement and there's a left cranial nerve 3 palsy. So that means there's a midbrain lesion on the left side. All right, so what about this one? Hyperacusis of the left ear. That'd be a facial nerve lesion. And so facial nerve would be involving the pons, not the midbrain. Loss of pain and temperature sensation on the left side of the face. That'd be like a spinal trigeminal nucleus lesion. Lateral medulla and pons are associated with that. Ataxia of the left arm. Here, this is pure hemiparesis. Cranial nerve 3 palsy, so it's Weber syndrome, not that. Loss of proprioception and vibration sensation on the right leg. That's the medial lemniscus involvement, so contralateral dorsal column pathway. And then the weakness of the left lower face be ipsilateral. And so our answer is a D, because you have the medial lemniscus involvement, contralateral dorsal limb. You have the loss of proprioception and vibration on the right leg. Because the lesions are happening in the left midbrain, so Weber syndrome with a medial lemniscus involvement is what's going on. And there's damage to the corticospinal tract, there's corticospinal weakness, and also damage to the medial lemniscus, and that causes contralateral loss. So here we go. Weber syndrome, right-sided spastic weakness, down and out. Hyperacusis is facial. Loss of pain and temperature is the trigeminal nucleus. Ataxia cerebellar. Lesion associations there. Weakness of left lower face. Corticobulbar tract. There's no facial weakness in this one, actually. No facial weakness in this stem. So it's the midbrain. Makes the eye go down and it paralyzes the opposite side of your body. Oh, 20 push-ups. All right, let's do 20. Let's do 20. I need an animation to play. Good call. Here's the bottom line. Right-sided weakness with left eye ptosis suggests right midbrain stroke affecting the corticospinal and sensory pathways. Push-up time, folks. It's push-up time. Oh, and then we got 3 more questions, and then we're have a break.
The zones of the open sea.
Oh, yeah.
Here we go. 2, 5, 6, 7, 8, 12, 14.
Easy work. Oh, yeah. I needed that. Thank you. Oh, after so many hours of sitting down, you're like, it's good to get the blood flowing again. So a 35-year-old woman presents to the clinic with a 3-day history of watery diarrhea, abdominal cramps, and mild fever. She returned from a trip to Southeast Asia a week ago where she enjoyed various street foods, and she's now got non-typhoidal salmonella. And this isn't fair. I'm going to tell you why in a second. This isn't fair because I haven't given you all the answers. Do you want another answer? Or are you fine with just these 4? What if I said the other answer was prolonged fecal carriage of the organism? Would you choose it then? So she's been eating the food in the streets, right? And we know it's non-typhoidal salmonella. And so she's got watery diarrhea, stable vitals, she's hydrated, and this is a self-limited case. And so they're asking about antibiotics. And so let's say option E is prolonged fecal carriage of the organism. What we need to know for this one is about non-typhoidal salmonella, because this is caused by Salmonella, oh geez, what's the name? Typhimurium. Still ARB, are you sure? Okay, we'll break this one down for sure. And so basically you have undercooked poultry and eggs and contaminated food and water. And so it infects the intestinal mucosa and you have inflammatory diarrhea is what's happening in this girl. And usually this type of salmonella is just going to resolve on its own. Usually it's within 4 to 7 days and you're totally fine again. Oh man, do some good stretching. And so antibiotics are not routinely given actually for this particular case because in immunocompromised adults with mild disease, antibiotics aren't recommended because they don't shorten the illness duration and they prolong the bacterial carriage in the intestines and the stool. And so they remain a long-term carrier and they can transmit the infection to other people. So the answer is E. And the reason I couldn't tell you is because they bolded it, right? So it doesn't shorten the duration. Now let's talk about the other ones though, because there's some good distractors as well. So like C. diff, increased risk of C. diff infection. That's possible with many antibiotics, right? Many of them, but not the most characteristic risk in this patient, just because with salmonella, it's going to be the fecal association is super important. And so I like that answer choice. It's a good one and it's really buzzy. And so I can see why you picked it. Antibiotic resistance, that's general, right? And so that's also another good answer. There are a lot of really good answers to this one, but it's a little bit too general, especially when compared to E, which is very, very specific to this particular condition, because this is what happens when you give antibiotics to Salmonella gastroenteritis. So this is just uncomplicated non-typhoidal Salmonella. Antibiotics are avoided because they don't even shorten the illness and they prolong the intestinal carriage of the bacteria. Yeah, very tough to logic through for sure. Yeah, you want me to explain E more? Let's see if there's a better explanation down here. Okay, so the best way to explain it is the carriage, that just means that the person continues to harbor the pathogen in their body, even though they don't have any signs of it. And so in this particular case, Salmonella bacteria remains in the intestines and it keeps being excreted in the stool long after. And the way this happens is usually after there's an infection, after the infection clears, the immune system in the gut microbiota eliminates the pathogens. So the infection's gone and now the immune system in the gut eliminates it. Antibiotics, however, disrupt that normal gut flora. And so now the Salmonella finds a niche to persist, right? Because it's the immune system in the gut eliminate this pathogen after it's cleared. And it's going to be cleared in 4 to 7 days. And normally the gut is like chomp, 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 chomp. Antibiotics disrupt that normal gut flora. And so the Salmonella finds that little place. It's like, hey, I'm going to keep going. And so that allows the bacteria to survive and also be shed for weeks to months, sometimes even years. Yeah, exactly. Same mechanism for original pathogen. And so they feel healthy, but they're still shedding the bacteria in the stool, and that can cause outbreaks if the hygiene is poor. That's why we avoid antibiotics in non-typhoidal Salmonella infections, because they can turn an acute infection into a chronic carrier state. Does that make sense? I wonder what else this thing says. Here's the pathophysiology. Invades intestinal mucosa through the M cells in the Peyer's patches. You have an inflammatory response, and antibiotics disrupt the microbiota, reducing the competitive inhibition, longer persistence. And then you can spread it to everybody else. Here's the bottom line. Antibiotics are a no-go because you can prolong it. All right, so this one's actually pretty easy, but we'll wait for the questions to load. Yeah, you actually gave me this vignette, didn't you? That's funny. Okay, sounds good. Thanks for withholding the secret. So we got a 22-year-old woman, got some dizziness. She's a collegiate runner, athlete, systolic murmur, best heard on the left lateral sternal border of the apex, and increases when she stands quickly. That's interesting, right? Because that normally shouldn't happen. Her father is also diagnosed. So this is like the world's most buzzy question ever. There's a murmur that's increased by standing and decreased by squatting. And so that's some sort of an outflow obstruction. And there's a familial link. What is the answer? I know that hematopoiesis knows this. Okay. So this is hypertrophic cardiomyopathy. Alrighty. So she's got it. All right. There you go. So yeah, like the sudden death change there is good. It worsens with decreased preload of sudden death in young athletes. So hypertrophic cardiomyopathy is suggested for systolic ejection murmur that increases with standing and decreases with squatting. There you go, folks. On to 149. 2 more questions, then we're done. We have a little break. Then we have a break. So for this one, we have a 28-year-old man. What happens immediately after he stands? So standing will definitely cause a decrease in venous return, right? Okay, so hematopoiesis is saying, I don't know, but the stroke volume would reduce. Okay, so I like that. Decreased stroke volume. What happens to the heart rate? So there's a 28-year-old man. You're saying C is most likely, and C is correct indeed. So the baroreceptors are going to detect, they're like, oh my gosh, that blood pressure is low, and they're going to stimulate the heart rate to compensate, to maintain the perfusion. So the answer is indeed C. Heart rate increases, it's compensatory. Frank-Starling mechanism, you knew this, that the stroke volume decreases. There's a baroreceptor reflex, the decreased pressure sensed by the baroreceptors, increasing the sympathetic tone. And the sympathetic compensation, the heart rate and the contractility, it needs to increase the heart rate and the contractility to maintain that same cardiac output, right? We have to maintain the cardiac output. And so the stroke volume is, so the cardiac output is equal to the stroke volume times the heart rate. And so we have to maintain it. And so what needs to rise is the compensatory contractility and heart rate. Most commonly in the elderly, yeah, you got it, hematopoiesis. So when you're standing, you have decreased venous return. That causes decreased stroke volume. That causes a baroreceptor reflex, and that causes the heart rate to increase to maintain that cardiac output. Because you can't change, it's like primary low volume is a way to think about it. And so you have to maintain that cardiac output. And so you have to, the secondary kind of compensation for the heart rate is a good way to think about this. So upon standing, heart rate increases to compensate to decreased stroke volume due to the orthostatic hypotension. Hey, Sadal, how's it going? Yeah, you guys got it. Nice. I love the chat discussion that's happening here. This is nice. All right, you guys ready for the last question of this until we have a little break? All right, so 62-year-old woman, she's vomiting a lot. She had a stomach bug, and now look at that, 85 over 55 is her blood pressure. And BUN is 24-1. Okay, so she's vomiting, and that means there's a loss of tons of fluids and also electrolytes. And so now she's hypotensive, and she's also tachycardic. She's going, that's 130 a minute, right? And so that's hypovolemic shock due to volume depletion, right? The lab clue as well of this 24-1, this is pre-renal azotemia. So that's hypovolemia due to increased urea reabsorption by the kidneys trying to conserve that water, trying to conserve the water. So there's lower blood volume and there's lower venous return and there's lower cardiac output, right? Lower cardiac output. And there's low tissue perfusion, there's tissue hypoxia. And that means tissue hypoxia is what's happening in this person. Now, there are compensatory mechanisms whenever we have tissue hypoxia. There's an increase in sympathetic tone, right? And so the heart rate is going to go up. You're going to have vasoconstriction. You're going to have renin-angiotensin-aldosterone syndrome is going to be activated. You're going to have increased of antidiuretic hormone, right? So this has to be increased. Agreed? So let's analyze these are the parameters. We have arteriovenous O2 difference, okay? That is going to be increased, right? Or O2 difference. Because the tissues extract more oxygen because of delivery, blood flow is low. And so you have to extract more, right? And so there's a wider difference. Okay, so that's going to be increased. What about the plasma lactic acid? Well, that's also going to be increased. The reason being there's poor perfusion, right? And so that causes anaerobic metabolism. And anaerobic metabolism increases the lactic acid in the plasma. Okay, that should make sense. There's ADH obviously increased. And then systemic capillary fluid transfer is also going to be increased as well. You're going to have, I think it's a good question too. Good one to end on for this stream, at least until we take a break. So increased reabsorption. And so you have decreased hydrostatic pressure. It's not pushing as much as it otherwise would. So the fluid is moving from the interstitial to the capillary. And so the Starling forces favor reabsorption because you're trying to preserve that volume. You're hypovolemic. So you're preserving the volume. So there's reabsorption. ADH, reabsorption. Lactic, you don't have that oxygen. And so you do lactic acidosis, right? So your lactic plasma goes up. And there's that big old difference because you have to go chomp up that oxygen. Hopefully that's a decent explanation. I used a lot of sound effects. And so the answer to this question is C. Increase reabsorption. There's an explanation. We kind of already talked about most of the stuff. Hypotension tachycardia, BUN 20-1 is pre-renal. All right, guys, there we have it. Hypoperfusion, tissue hypoxia, increased difference, all that other stuff we talked about. And here's the bottom line. Increased BUN to creatinine ratio indicates pre-renal azotemia due to dehydration and likely increased plasma ADH and lactic acid. If you guys found this helpful, please be sure to like and subscribe. I'll be editing these now. We have 50 questions to go. So like, subscribe, hit the bell so you can be notified when those come out. Hopefully you guys have an amazing rest of your day. And now for the rest of you guys on Twitch and YouTube, time to take a little bit of a break, but don't go anywhere yet unless you do want to just go somewhere. We just borrow from the Federal Reserve. Okay, that's my tune from Toontown, by the way, if you want to know what that is. The chicken dance. Oh, people on YouTube can't see the emoji. That's sad. Okay, here we go. Got to refresh this real quick. There you go. Should see it now. Hey, hematopoiesis. Thanks for the T1. I've got to make some really cool animations, by the way, for subscriptions, because right now it doesn't do anything. Thanks for the tier 1 hematopoiesis. Really appreciate it. Okay, do you want to take a stab at this question now? Now that you have the no ads? Thanks so much. Nice. Phototoxic due to tetracyclines. Nailed the question too. My guy. Well done. All right, so in this question, as hematopoiesis said, we have a 25-year-old woman, intense redness, pain over the lower legs, and she was at the beach the previous day, several hours in the sunlight, and she's on doxycycline. And so she has a phototoxic reaction. Very nice, quick, easy, beautiful. Vesicular arithmetic skin lesion, classic setup here. Allergic contact would be nickel poison ivy new soap. Chemical burn is associated with an accidental spill or some sort of a chemical exposure would be mentioned, which it wasn't, obviously. Mallow rash, DS, antibody, butterfly-shaped, mallow rash, lupus. And then psoriasis has that silvery scale on the extensor surfaces. Nailed that one, 100%. Okay, here's the bottom line. Phototoxic reaction is likely due to doxycycline and sun exposure, causing erythema and vesicular lesions. I think what I'll do now is I will put the questions up so you guys can see them, but then I'll wait until all of the diagrams load so that YouTube can have the full experience. Good intuition, somatopoiesis. I love this train of thought. This is really awesome. And definitely feel free to lay bare whatever you're thinking. It really helps the stream and the quality. Sounds good. I love the guess. Really, really good. All right, so there's a 67-year-old woman with a history of hypertension and atrial fibrillation, and she's undergoing a postoperative recovery after cardiac surgery. And now she's got rapid palpitations and is found to have a heart rate at 180 beats per minute. The medical team decides to administer a medication for rapid control of her heart rate, which can be quickly adjusted as needed. Which of the following medication is mostly appropriate? A lot of beta blockers. Okay, so quickly adjusted is Esmolol, is an ultra short-acting beta blocker for rate control. Super good for rapid titration and acute arrhythmia management. So Esmolol is used in acute settings because of its extremely short half-life. It's like 9 minutes, very, very short. And so that allows a very precise control of the heart rate. And you administer it through, so it quickly titrates and it makes it super good for postoperative supraventricular tachycardia and also atrial fibrillation or SVT. And so this patient is hemodynamically stable, but they have dangerously fast heart rate. And so Esmolol is going to provide rate control without prolonging the beta blockade. Atenolol is longer acting, atenolol, and carvedilol is for chronic heart failure, and that's a mixed alpha and beta. This is a mixed alpha and beta. And labetalol, which was one of the answers that you guys mentioned there, that is used in hypertensive emergencies. And yes, it's available IV, but it's mainly used for blood pressure control, not for heart rate and arrhythmias. All right. And then carvedilol, it's for chronic heart failure mixed. And oops, I highlighted Esmolol, but I meant carvedilol. And amiodarone, that one is for an antiarrhythmic for refractory or unstable arrhythmias. So it's antiarrhythmic and it works very, very slowly for rhythm control, and it's not for rate. Okay. So not for rate. This is a rhythm control. All right. So that's the lay of the land there. You have surgical stress in this patient that causes a sympathetic surge and atrial irritation. Then you have increased automaticity. So you have ectopic foci that are firing rapidly in the atria. And then there's AV node that conducts very rapidly, causing like an SVT, supraventricular tachycardia, or rapid AFib. And then you have short-acting beta blockers which then slow that AV node conduction. And there's rapid rate control without the long-lasting hemodynamic suppression. All right. So like 30% of cardiac surgery patients develop some sort of an arrhythmia during recovery. And so we got a 67-year-old. She's got SVT 2 days after surgery. And so she's in that demographic. And the rhythm is super fast, but she's stable. And now we're like, hey, we got to slow that heart rate as quickly as possible. So Esmolol is just a beta-1 selective blocker with a super short half-life. Esmolol E for extremely fast. And now there's also this alphabet mnemonic, right? There's an alphabet trick. A through M, these guys are just beta-1 selective blockers. And then N to Z, these guys are non-selective. Non-selective for N, non-selective beta blockers. So it's beta-1 and beta-2. And so A through M, that primarily acts on the heart, B1, right? Beta-1. And that makes them safer in asthma and COPD and better for rate control. So atenolol, bisoprolol, Esmolol, metoprolol, right? All these lols, right? They're used for supraventricular tachycardias, but Esmolol is the fastest acting. So post-myocardial infarction patients, they're just beta-1. The non-selectives are the heart and the lungs, right? Non-selectives are the heart and the lungs. And so they're going to be used for not ideal for asthma and COPD due to their bronchoconstriction risks, like nadolol, propanolol, timolol. Those are used for portal hypertension, like propanolol, and essential tremor as well, and migraine prophylaxis, and also thyroid storm. And hopefully you guys can see there, hematopoiesis just left a recapitulation on what we discussed. You're definitely hitting on the points there, for sure. So Esmolol, you should think of as beta-1 selective, ultra short acting, used in SVTs, is beta-1 selective. And that one has oral and IV moderate onset. So yep, Esmolol is for an emergency. Carvedilol carves down the afterload. Labetalol lowers with blood pressure in labor. Atenolol is long acting. I don't know. Nolol, I don't know. Whatever memory drugs get you there. But yes, you got the ideas. Here's the bottom line, folks. Rapid control Esmolol. AEOlol. Nice. Adol. Beta adrenergic blockers. AEI lol is mixed. Nice. Okay, this question is actually wrong. but maybe it'll be helpful to do it anyways, and we can talk about the mechanisms. Okay, so in this question, it says there's a 2-week male, which is why I take umbrage with this question, because this is impossible. But they prevented the pediatrician for a routine checkup. The parents expressed concern about a soft, non-tender swelling on the left side of their neck. And like the guys are saying, what this is, a cystic hygroma, yeah? And so on examination, the mass is compressible and transilluminates brightly. The child has puffy hands, and cardiac examination has crescendo, decrescendo, systolic murmur, best heard at the upper right sternal border. And so we have this analysis, which of the following conditions is most likely responsible for these symptoms. Okay, so we have a transilluminating neck mass, which means that it's going to be a cystic hygroma from lymphatic malformation. And there are puffy hands and feet, and also heart murmur, right? And so this question is wrong because it can't be, it's Turner syndrome, but it's in a male, right? And Turner syndrome cannot happen in a male. So it's 45X, which is phenotypically female. And so it's wrong. Maybe what happened, let's just try to massage this into existence here. What if in real life, sometimes infants with ambiguous genitalia are assigned male at birth? So Turner syndrome could be discovered after genetic testing. So maybe they're just testing your knowledge on syndrome features over the assigned gender. But yeah, wide space nipple, streak ovary. Yep, that's really buzzy for it as well. And you have rare mosaicism, maybe, but that's like for true intersex condition. But yeah, you're right. Like there's no sense in massaging this like crazy. But the bottom line here is if you see cystic hygroma and lymphedema and bicuspid aortic valve murmur, then it's Turner's or Turner's variant. That's what takes precedent. And so you do a chromosomal analysis. Maybe that could be like, hey, let's do a chromosomal analysis. Are you sure this is a male? But yeah, I don't like this question for that reason. But I did preface beforehand that it's a little bit off. But hopefully this is still beneficial in recognizing the cystic hygroma associations with Turner syndrome. Lymphangiomas, or the cystically dilated space, it's filled with the lymph fluid. Okay, kind of fun, kind of tricky, kind of quirky. Here, hematopoiesis. Why don't you do ! IV tutor, space, and then type your question. I want to see if it works. There it is. Maybe I can make that even more concise. Yeah, I'll work on that prompting. Hopefully the tutor will be more efficient in the future. What do you guys think for this one? So here we have a 52-year-old woman presenting to the clinic with a 6-month history of persistent cough and hoarseness. She reports her symptoms are worse at night, and occasionally she wakes up with a sore throat. She also experiences a burning sensation in the chest and acidic taste in her mouth. Obesity, type 2 diabetes. She denies smoking or alcohol use. Physical examination, her vital signs are within normal limits, despite the use of over-the-counter antacids. Her symptoms persist. Upper endoscopy reveals hyperemia and mild edema of the lower esophagus. Biopsy of the esophageal mucosa shows basal cell hyperplasia, elongation of the lamina propria, and eosinophilic infiltration. What is the diagnosis? We're thinking B or C. I like the discussion here. This is good discussion. And there's like 1 in 5 of adults in the US have GERD symptoms. So here she's got some GERD symptoms: burning chest pain, sour taste, hoarseness, cough, worse at night. She's got reflux problems. Endoscopy is showing erythema. And so the biopsy has basal cell hyperplasia, elongated papillae, and also eosinophils. So this is reflux esophagitis. So it's not candidiasis, right? The histology is exactly what we would expect from chronic acid reflux. And the pathophysiology here is important. You have lower esophageal incompetence and also transient relaxation, right? And then you have chronic injury over time, which causes the metaplasia, which then leads to an adenocarcinoma risk. And so heartburn, regurgitation, cough, and hoarseness, all that stuff. All right. And then regarding all the comments there, you're asking, does reflux esophagitis show eosinophils? Yes, it can. There are some differences though, right? Eosinophils are present. They can be present in both, but reflux esophagitis has scattered and mild presence of eosinophils, whereas eosinophilic esophagitis is dense and it's layered and it's patchy. And on histology, you have eosinophilic microabscesses and degranulation in esophagitis, eosinophil esophagitis. But in reflux, you have basal cell hyperplasia. And so that really keys you into the diagnosis of reflux esophagitis, is that basal cell hyperplasia and the papillary elongation. Clinically, you see this in older adults, and then younger males would be more eosinophilic. And then in an endoscopy, you have the rings and the furrows in eosinophilic, and hyperemia and edema are going to be seen in esophagitis. And the location is different too, because, well, they can both affect the esophagus, right? But in eosinophilic, it's often the proximal or it's more diffuse. And also, one more important difference here is that how they respond to PPIs. Reflux esophagitis responds really well to PPIs, whereas eosinophilic esophagitis is characterized by eosinophilic infiltration and is often associated with atopic conditions. And I might have to go after this one because I realize I have to get my flu shot. I still have not got my flu shot yet, so I forgot I had to do that today. So I might go head on over to like a Walgreens and make that happen for myself. Don't worry, hematopoiesis, we'll be back. If not like immediately back when I get back from getting my shot, then we'll be back either later tonight or tomorrow as well. And we'll hit all of these though. Yeah, big sad. Okay, let's do this. Let's finish 10. So 5 more after this, and then we'll call it like another little break here. So here's our next practice question. Boom, shaka boom. 30-year-old construction worker presents to the clinic with pain and weakness in his right arm. Yeah, let's go. He mentions that he tried to catch a falling metal pipe with his right hand. See, that's where you messed up. Since then, he struggled to lift objects and twist his forearm. There's noticeable swelling and bruising of the anterior part of his upper arm. He demonstrates difficulty with his forearm supination and elbow flexion against resistance. Okay, against resistance. That right there should tell us our answer. What is it? What do we got? Difficulty with forearm supination and elbow flexion. Okay, so add the anterior arm bruising and the lateral forearm sensory loss. It's going to be the biceps. Yes, the biceps and brachialis and sensory to the lateral forearm. All of this is super duper musculocutaneous. You guys are too smart. Can't trick you up. You got it. Biceps tendon rupture injury leading to damage of musculocutaneous nerve, innervating the biceps brachialis, and choriobrachialis. Hundo P. You got it. Axillary deltoid paralysis, median, apan, carpal tunnel associations. Radial has wrist drop. Ulnar has the claw, hand, and loss of sensation in the medial fingers. All right. You have to know the C5, C7, musculocutaneous, elbow flexion for the biceps and forearm supination in the biceps. And here we go. Here is our bottom line. Musculocutaneous nerve injury causes weakness of the elbow flexion and forearm supination, often after trauma to the upper limb. All right. That's some good stuff right there. That is some good stuff. Ooh, we got a challenge. We got a question about this question back at me. What special exam for biceps tendon rupture? Okay, Popeye sign? I don't know. Did you have something in mind? Is it the hook test? You go like this, you tell the patient to flex their elbow to 90 degrees, and then you supinate the forearm. Is that what you do? The speed test. Oh yeah, the speed test. That makes sense. That's for the long head of the biceps tendon, right? That's like the hook test, except like you tell them to put their palm up. So they flex their shoulder to 90 degrees, and then they put a palm up and they extend their elbow, right? There are a couple of these to test different things, but either pain or rupture. Okay, nice. That's a good question. All right, on to our next one. Here we go. So a 52-year-old woman presents to the clinic with a 3-week history of dry cough and mild exertional dyspnea. She was diagnosed with heart failure with reduced ejection fraction and started on new medication. Now she's on furosemide, carvedilol, spironolactone, and also an antihypertensive. Her vitals are within normal limits, and her chest examination reveals clear breath sounds bilaterally without crackles and wheezes. Which of the following most likely explains her symptoms? Hematopoiesis, lisinopril ACE inhibitor. Nice. Switch her to NARB and she'll be okay. This is really good stuff. Yep, lisinopril. Nailed it. ACE inhibitors and dry cough. So bradykinin builds up in the lungs, causes irritation, dry, non-productive cough. Lisinopril is an ACE inhibitor, most likely the cause of the dry cough. They present the breakdown of bradykinin, which is a vasopeptide. Increased bradykinin leads to persistent dry cough. All that bradykinin causing that coughing. Switch them on over and she'll be okay. I love it. There we go. The ARB, that would prevent this. Same thing with this guy. Amlodipine causes peripheral edema. Digoxin, positive inotrope, arrhythmic risk, a risk of arrhythmia. Okay, bottom line. Newly added amlodipine can cause cough and dyspnea due to peripheral edema. Amlodipine? I should say lisinopril. Okay, ignore that. Basically, we switch her to an ARB and she'll be okay, like hematopoiesis said. Sorry, guys. Sometimes the AI lets me down. Pretty frequently, actually. Okay, so we just jump to the very end for this one, and we read, what supports the diagnosis of inflammatory bowel disease over irritable? Well, inflammatory bowel disease, that's structural and a systemic disease, and so you have things like anemia and weight loss. Whereas the pain being relieved here, IBS is just a functional disorder with no inflammation or systemic symptoms, right? So none of that. That's all IBS. Soon we'll be letting the AI down. That's funny. Very soon. It's already happening. Okay, the postprandial, that's postprandial bloating is going to be definitely with some IBS, but this is also non-specific. Yeah, so this is common in both the bloating, constipation, the pain and stuff. But the anemia and weight loss, that's actual, legit, true mucosal inflammation kind of thing. Those systemic findings in the labs. Bottom line, anemia and weight loss strongly indicate inflammatory bowel disease over irritable bowel syndrome. All right, so this is the same exact question. And so the presence of the blood in the stool could be another example there. Metagesia, blood in the stool. points to IBD. Crohn's or ulcerative colitis. Mitochezia in 65 is colon cancer unless ruled out otherwise. Nice. Okay, 8, 9, 10. Then we take a break. Go to Walgreens, get my shot. No, flu shots don't give you autism. No. You hate to see it. 67-year-old man is brought to the emergency department with a sudden onset weakness in the right side of his body and difficulty speaking. A history of hypertension and hyperlipidemia, but is otherwise healthy. On examination, he is alert, but aphasic, with a right facial droop and right-sided hemiplegia. On contrast, CT shows evidence of an acute left middle cerebral artery. The underlying mechanism of neuronal injury is primarily due to excessive stimulation of certain receptor, causing accumulation of the calcium. Which intervention would most directly mitigate this mechanism of injury? Calcium. We actually went over this recently, if you guys remember. We talked about this one, antagonism of the NMDA. So excitotoxicity is the main primary mechanism of neuronal death and ischemic stroke. NMDA, antagonism, ischemic stroke. So it's the neurotransmitter. Ischemia causes ATP depletion. And so then we depolarize the neurons, causing excessive glutamate release in NMDA and AMPA receptors. And these are overstimulated, and you get large amounts of calcium, activating proteinases, lipases, and nucleases, causing cell death. NMDA in the back garden of her parents' house. Glutamate, gated calcium channel. Glutamate. Okay, ischemic stroke. The blood flow to the brain is cut off. And no ATP, the ion pumps fail, and sodium rushes in, and water follows, and the neurons swell. Calcium overload causes the apoptosis and necrosis. NMDA blockers are potential neuroprotective events. Okay, on to our next question. Oh, but first we have a question from Seidal himself. Seidal asks, which drug is given to prevent vasospasm after a subarachnoid hemorrhage? Ooh, good question. Nimodipine. That's the one that crosses the blood-brain barrier. Okay, let's do this question, shall we? 35-year-old woman with a history of panic disorder. Prescribed lorazepam. Medication acts by enhancing inhibitory effects of the neurotransmitter in the central nervous system. Which of the following descriptions best explains the mechanism by which lorazepam acts in the neurotransmitter system? Ooh, we talked about this one, right? Benzodiazepines like lorazepam, they're enhancing the activity of GABA-A. So GABA-A. You thinking D? Dr. Sasson says D. Augmentation of chloride with postsynaptic through the receptor modulation. You are indeed correct. This is GABA-A, right? Lorazepam. And this is D. So lorazepam is a benzo that potentiates GABA-A and ligand-gated chloride channels. And so it opens the channel and allows chloride influx. Okay. Activating the channels would cause excitation. That's the opposite. An atropic chloride channel. Benzos increase GABA receptor activity, causing hyperpolarization, and it has sedative effects. Flumazenil is a benzodiazepine antagonist that's used in overdose, and alcohol acts on the GABA-A's as well, causing downregulation and withdrawal. Okay, open those channels, get that calcium influx, hyperpolarizing, causing increased opening, and you have the sedative effects, anticonvulsive effects. There's the bottom line. Lorazepam. GABAergic activity by augmenting chloride influx in postsynaptic membranes. Hey guys, last question before I go get my flu shot. Let's see if we can get everybody to respond to this one. Here we go. Everybody in the YouTubes and the Twitch, we're all going to come together and try to answer this question here. And going to make it a good one. You got a surprise? Okay, I'm excited. I'm excited for the surprise. Okay, here we go. This is going to load, but I hope that I don't get flagged by the AI generating algorithms that I'm using because, well, you'll just read this and find out. Oh, okay. On examination, there is a tender bluish purple nodule at the anal verge. So hopefully it's not too graphic when it depicts this. If it is, I'll have to switch scenes. But there's a 30-year-old man. Emergency department has severe pain in the anal region. The pain is constant, throbbing sensation that began earlier in the day and has worsened with movement. He denies anal bleeding, but reports some itching and discomfort for the past few days. He has no significant past medical history, and he reports engaging in receptive anal intercourse. Yeah, I'm really glad that these are being blacked out over there. Okay, good. Good. Nothing crazy. So what's going on here? Is this a hemorrhoid? Do we have a hemorrhoid here? Sudden onset anal pain. And it's a vascular issue, right? That tells you there's not like an infection or a viral thing. Metapoiesis had a patient with this a week ago. Fun day for you. Yep. This is a hemorrhoid. Severe anal pain, tender bulging stuff, the blue stuff. And so we use analgesics and steroids. And so exact presentation minus the intercourse. Wow, that's crazy. External hemorrhoid is the answer. Hematopoiesis is correct. External hemorrhoids are dilated branches of the inferior rectal vein located distal to the dentate line. Distal to the dentate line. When thrombosed, they present with a sudden onset, exquisitely painful, bluish-purple perianal nodules. The pain worsens with pressure or sitting and often follows straining or trauma. No, 20 push-ups. All right, we'll do 20. I'll do 20. Unlike internal hemorrhoids, which are painless, external ones are highly innervated. Internal is painless. Anal fissure has the pain with defecation. There's no tearing pain here. Perianal abscess, red, warm, fluctuant mass. Human papillomavirus infection cauliflower-like, painless. Skin tag, soft and painless, fleshy outgrowth. K, straining constipation trauma increases the venous pressure, causing hemorrhoid formation. Elevated venous pressure dilates the venous plexus around the rectum. Thrombosis in external hemorrhoidal veins causes the acutely tender, palpable mass. Resolution can be spontaneous. All right. So just the last thing about hemorrhoids, they're the swollen veins in the hemorrhoid plexus of the anal canal. So they're like varicose veins, but for the anus due to increased pressure. And there are two types that occur above the dentate line and then below. Internal is above, below is the external. And the externals are painful because, they innervate the somatic, the pudental, right? And then the internal is the visceral, autonomic stuff. And the internals bleed, but they rarely bleed if they're on the outside, external. And so it's just the increased venous pressure and venous dilation and hemorrhoid formation. So you're straining during defecation, right? Prolonged sitting also can cause this. Obesity, low fiber diet, heavy lifting, all that stuff can kind of cause this. It's the pressure, the pelvic pressure, the venous pooling, and all that stuff. So here is the bottom line. Severe anal pain with tender bluish purple nodule suggests perianal abscess. All right, guys, hopefully you enjoyed this live stream. I have to go to Walgreens to get a shot. Be sure to like and subscribe if you found value in this. I appreciate the T1 subscription from Hematopoiesis and also the push-up reimbursements. I will admit that the former is a welcome present, but I will definitely do push-ups now. But thanks, and we'll see you guys in the next video. Here we go. Hi, Dr. Moise. Good to see you. Thank you. Very nice of you. Nice work, say it all. Hopefully that block went well. Okay, guys. Ready to do some questions? Okay. So here we go. We got 40 questions or so to do. So here's the first one. A 35-year-old woman, history of well-controlled type 2 diabetes, presents to the emergency department with confusion, sweating, and palpitations. She is found unresponsive at her workplace, and now her glucose is really low. She's given oral glucose gel, and her symptoms improve. Later that day, the blood glucose is 200. What's the mechanism for rebound hyperglycemia? Blood glucose is going up. So originally she has her hypoglycemia, and then it goes way up. So what's happening is the hypo turns into counter-regulatory hormone responses. So you get cortisol, epinephrine, glucagon, and that leads to rebound hyperglycemia, and that is known as the Somogyi effect. The Somogyi effect. And so our answer is going to be increased gluconeogenesis because of that hypoglycemic phase. Here's the explanation. Their hypoglycemic state triggers a stress response, and that tells the body, hey, we need more gluconeogenesis. And so this is the Somogyi effect. Would it be decreased renal glucose reabsorption? That's what the SGLT2 inhibitors do. How about inhibition of gluconeogenesis? What inhibits gluconeogenesis? That'd be insulin and metformin. That would prevent the rebounding, induce it. How about the inhibition of hepatic genolysis? That's von Gierke disease. We're impairing the glucose release. Hey there, Crescent. Good morning. I think today I have to lock in and do a solo today, but whenever I play Toontown, I'd love to do a collab. Well, at some point we should join a just chatting at some point, but for the next couple hours, I'm locked in. But good to see you. How about decreased muscle glucose utilization? So that's true in chronic diabetes, but it's not the cause of acute hyperglycemia. Okay, so the confusion, the sweating, the palpitations, that's hypoglycemia. Low to high is the rebound pattern, and this happens because the epinephrine causes the increased glucogenolysis. Cortisol causes gluconeogenesis and insulin resistance, and then glucagon increases the hepatic glucose output. All right, so there's the pathophysiology. And here is the bottom line. Rebound hyperglycemia after hypo primarily is due to increased hepatic gluconeogenesis. Now, just based on what I've written here, I wonder, can you guys guess the correct answer to this next question? Burkitt lymphoma is a really good guess. Really good guess. There's one other that affects the jaw. I'm glad you said Burkitt lymphoma because that is perfect. There's one more. So we have a 45-year-old man with a history of diabetes. He's got chronic non-healing ulcer on his right foot, and he's had it for 2 years. And the ulcer is located on the plantar surface. The foot is swollen and warm to the touch, but there's no systemic fever. X-ray reveals peripheral bone erosion, suggesting osteomyelitis. Which of the following organisms is responsible? Okay, so the osteomyelitis and diabetes, that's an interesting complication there. There's the filamentous gram-positive. If we say this is a gram-positive rod, and it has aerobic growth, and also there's no jaw in this one, so it's not actinomyces, even though that's what I wanted you guys to think about. Mass on jaw, right? Usually it progresses to osteomyelitis of the jaw. And so actinitis Israeli should be one thing that comes to mind, along with Burkitt lymphoma, and things that are associated with the jaw. And actinomyces Israeli particularly is where you can get osteomyelitis of the jaw. Typically they have poor dentition and multiple cavities. And just to give you a hint on this particular question, the answer to this question is going to resemble actinomyces Israeli a little bit. So nocardia is a little bit more commonly on the skin and soft tissue infections if the patient is immunocompromised. And so the answer to this question is actually nocardia. So it's the chronic foot ulcering, the biopsy of filamentous gram-positive rods, and the lack of growth in anaerobic conditions makes this unlikely. Nice, very good. You got it right. Israeli, anaerobic filamentous, and also that's more predominantly going to be on the jaw, and this is in anaerobic conditions, not aerobic. So a couple of reasons why actinomyces is wrong. Mycobacterium tuberculosis involves caseating granulomas and pulmonary symptoms, which we don't see here. Streptococcus pyogenes, acute cellulitis is associated with that, and also necrotizing fasciitis. Definitely not filamentous. E. coli is gram-negative, associated with UTIs. So both nocardia and actinomyces are filamentous gram-positive bacteria, but they differ in oxygen requirements. Anaerobic culture is not working, and that means it's not actinomyces, which is a strict anaerobe. Nocardia is aerobic. The pathophysiology is you have trauma and ulceration and diabetes, and so you have a breaching of the skin barrier. And then nocardia enters the tissues, and you have a slow progression due to the immune dysfunction, and you get osteomyelitis formation. So if this involved the jaw and they had different oxygen requirements, I would have said actinomyces is really for the answer. All right, for this question, we have a 4-year-old girl brought to the pediatrician by her parents due to concerns about slow developmental progress. She's got coarse facial features and a prominent forehead, distended abdomen. The girl has a history of frequent upper respiratory infections and joint stiffness, thickened calv on x-ray, abnormal long bones, enlarged epiphyseal plates. She's got elevated lysosomal enzyme activity in the leukocytes. So she has mucopolysaccharidosis, and this comes from a deficient lysosomal enzyme, some sort of a disease there, and it causes the accumulation of some undegraded substances with downstream tissue damage. And so we know that the organism that's affected is pretty easy on this one just because they tell us. She has elevated lysosomal activity, and so it's going to be the lysosomes that are damaged, right? The mitochondria, that would be associated with like energy failure, lactic acidosis, and these are typically going to be associated with like poor energy, neurologic signs, maternal inheritance. Endoplasmic reticulum, that's associated with protein folding and secretory pathway stuff. And then why that's wrong is there's an endoplasmic reticulum dysfunction, like protein misfolding or glycosylation defects. That'll cause different syndromes like congenital disorders of glycosylation without the classic coarse facies and organomegaly pattern. Peroxisomes, those are very long chain fatty acid metabolism diseases. And so for that, you should think of like Zellweger syndrome that's present with hypotonia, seizures, liver dysfunction, and also some developmental arrest. But these bone deformities that we see and the coarse are going to be typical of mucopolysaccharidosis. The Golgi apparatus, that's the trafficking post-translational modification center. And those Golgi defects like the M6P tagging errors and eye cell disease can secondarily affect the lysosomal enzyme targeting, but the primary organelle responsible for the clinical substrate accumulation and degradation is going to be the lysosome. So that's our correct answer, lysosome. Okay, we talked about the mannose-6-phosphate defect for Golgi apparatus, but it's not lysosome. So these are lysosomal storage diseases. The coarse facial features from the glycosaminoglycan deposition that distorts the connective tissue. The clouding would be Hurler, not Hunter. Frequent respiratory infections. You have an airway narrowing from mucopolysaccharide accumulation. We have to know these deficiencies. The alpha L deficiency is Hurler's, and Hunter's it's just the iduronate sulfatase deficiency. Would be a glucocerebrosidase deficiency, crinkled paper, Niemann-Pick, sphingomyelinase deficiency, foam cells, cherry red macula. So we got to know all those. Know the enzyme that's deficient and the pathophysiology. All right, so the bottom line is lysosomal enzyme elevation indicates a lysosomal storage disorder, like Hurler's, in this child. All right, so here we have a 60-year-old man presented to the clinic with progressive breathlessness over the last 3 weeks. He has a history of hypertension, managed with amlodipine, and is a former smoker with a 40-pack-year history. And the patient is afebrile. His blood pressure is 135/80, heart rate is 78, and respiratory rate is 18. Lung auscultation reveals bilateral basal crackles. Jugular venous pressure is elevated. Mild peripheral pitting edema is present. The chest X-ray shows bilateral pleural effusions and significant cardiomegaly. Echocardiography reveals a normal left ventricular ejection fraction. Lab tests show a low serum albumin level. Which of the following is the most likely mechanism behind this patient's condition? All right, so let's break this one down. So here we can have some chronic increased systemic vascular resistance. That's
pressure, taking medication.
Okay, Siri was somehow activated there. That was not what I intended. So you have chronic increased systemic vascular resistance. That's hypertension. To work against higher, and so the body's going to adapt. And so you have adaptive concentric hypertrophy. The sarcomeres are going to develop in parallel. And that causes wall thickening and increased stiffness. And you have that low albumin that can cause the transudative effusions as well, but that would not explain the cardiomegaly and the elevated filling pressures as cleanly. So the reduced plasma oncotic pressure, that would be hypoalbuminemia, and that would be the transudative edema. But here, low albumin can actually cause peripheral edema. and pleural effusions, but that would not explain the cardiomegaly and the elevated JVP, and also the pulmonary edema from the elevated left-sided filling pressures that are seen. And so that's actually not the right answer. The correct answer is going to be E, the elevated vascular resistance. All right. So here's the next question. We have a 22-year-old woman comes to the emergency department with complaints of fatigue and also muscle weakness. She has lost 10 pounds over the past month despite maintaining the same diet. She missed using a weight loss product. And she is 5'7", weighs 114 pounds, BMI of 18. Physical exam shows dry, brittle hair, lanugo. So what has she been abusing? Okay, so looking at her labs, she has hypokalemia and she has metabolic alkalosis. So you have to think what causes low potassium and metabolic alkalosis. It's going to be a diuretic. A diuretic would cause both of those symptoms. So she has the unexplained weight loss and also the hypokalemia and metabolic alkalosis. Insulin causes hypoglycemia and hypokalemia, but does not cause metabolic alkalosis. You would see the hypokalemia though. Corticosteroids can cause Cushingoid features. That would be with hyperglycemia and truncal obesity. Beta blockers can cause bradycardia and fatigue. Growth hormone causes acromegaly. So diuretics increase the sodium reabsorption. Volume contraction causes RAS activation, and aldosterone drives more hydronium and potassium secretion. You get chloride loss or chloride depletion and metabolic alkalosis. So she's taking the water pills, making the kidney dump the sodium, potassium, and chloride in water. And so you get rapid weight loss from fluid, but not the fat. And you got to watch out for that potassium loss and metabolic alkalosis. Really dangerous. So bottom line is low potassium and muscle weakness suggests diuretic misuse, commonly seen in weight loss product abuse. Okay, a 36-year-old woman has a 5-year history of HIV. She has used combination antiretroviral therapy regimen that includes efavirenz. Her most recent viral load was undetectable. Her CD4 count is stable. Genotypic resistance testing reveals a mutation that decreases susceptibility to efavirenz. Which of the following proteins is most likely affected by this mutation? The answer is reverse transcriptase. You have to note that efavirenz is one of the NNRTIs. These are the guys, the GAG precursors used for virion assembly. And to answer this question right, you have to know the HIV life cycle, how reverse transcriptase allows the virus to integrate to the host DNA. The mechanism is an NNRTI, mechanism of drug resistance. Yep, HIV works through reverse transcriptase. And oftentimes in monotherapy, you can get some resistance to mutations in the reverse transcriptase gene. Here's the bottom line. Efavirenz resistance mutation affects the reverse transcriptase, which is crucial for HIV replication. All right, so this is just a Hardy-Weinberg question, so pretty simple. We have an autosomal recessive disorder like cystic fibrosis in 1 of every 2,500. And so we take the square root so that we can get Q, and then we use the Hardy-Weinberg equation, which is P squared plus 2PQ plus Q squared is equal to 1. And we know the Q now is going to be the square root of both sides, so it's going to be 1 over 50. Now P is very small, or rather Q is very small, and so P is very large, approximately 1. And so you just multiply by 2, and you get 1 out of 25. And so the carrier frequency is 2PQ in this Hardy-Weinberg equation right here, because that would be the incidence of the autosomal dominant, and this is of the 2 little q's, autosomal recessive, full-blown cystic fibrosis. And so 2PQ is that carrier frequency. So it's 1 over 25. Very simple. So the heterozygous carrier frequency is approximately 1 out of 25. All right, here we have a 23-year-old man presenting to the clinic with complaints of muscle weakness and a cramping during exercise. He mentions that he feels fatigued shortly after starting any strenuous activity, and sometimes he notices dark urine afterward. His medical history is otherwise unremarkable. Physical examination is normal at rest. Blood tests taken after a short exercise session show elevated creatinine kinase with no significant rise in blood lactate levels. A muscle biopsy is performed, revealing an accumulation of glycogen with periodic acid shift positivity. These symptoms are associated with a deficiency in which enzyme? Well, he has muscle weakness and cramping, feeling fatigued, dark urine. That's all pointing us toward McArdle disease, which is a type 5 glycogen storage disease. So this seems like he has exercise-induced muscle cramps, and there's no rise in lactate, so there's a failure of anaerobic glycolysis due to the blocked glycogenolysis. And so it seems like the correct answer is going to be glycogen phosphorylase because it's McArdle's disease, glycogen storage type 5. And this is caused by deficiency of the muscle glycogen phosphorylase. And that's essential for breaking down the glycogen in the skeletal muscle during anaerobic activity. And if you don't have this, then the muscles can't access the stored glucose during exercise. And that leads to early fatigue, muscle cramps, rhabdomyolysis, which is why he has the dark urine. And also there's no rise in the blood lactate levels post-exercise. Now, acid maltase, that's going to be Pompe disease. Hey-oh. Exercise intolerance and elevated creatine kinase. All right, this is the buzziest question ever. 15-year-old male, concerns about his testicle, one feels heavier, and he's uncomfortable after standing for long periods, and he's got the bag of worms texture. This is a varicocele. It's the dilated pampiniform plexus. Left side is most often affected, and the reason is that left-sided gonadal vein drainage to the left renal vein. So the answer is a varicocele. Painless bag of worms, enlarging. Hydrocele transilluminates with light. They're fluid-filled, not vein-related. Inguinal is a reducible mass, where the bulge increases with coughing. Torsion, acute pain, high riding. Epididymal cyst would be a smooth, well-circumscribed mass. So that bag of worms is due to the dilated veins. The increased temperature impairs spermatogenesis. Here are the key features. So the bottom line is varicocele presents with a bag of worms texture, with heaviness in the scrotum, especially on the left side, because of the left renal vein situation we got going on there. All right, for this question, I'm just going to explain basically a minor change in the radius can cause an extreme change in the flow, and it's to the fourth power. You should have to be aware of that when answering questions. So resistance increases exponentially as the radius drops, increasing the pressure needed to maintain the flow. And so kidney microcirculation is sensitive to the radius changes. So if it starts at 4 milliliters per second and you cut it by half, it's going to go down to 0.25. All right, so it's a factor of 16 there. So if you shrink a blood vessel's radius by half, then the blood flow gets cut by 16, a factor of 16. That's Pacelli's law, because the flow is proportional to the fourth power of the radius. All right, here we go. A 30-year-old man presents to the emergency department with repeated episodes of sudden palpitations, sweating, and overwhelming sense of doom. The episodes last 10 to 15 minutes and occur approximately 2 to 3 times a week. He's been experiencing this for the past several months, and these episodes occur without warning and are not associated with any specific triggers. Between episodes, he feels relatively normal, but is constantly worried about the next attack. All right, so this is the sudden doom stuff. That's like panic disorder. It's the fear, the autonomic hyperarousal, the sense of impending doom. So he's got a panic disorder. Feels like you're about to die, so your body is telling you, and you have palpitations, sweating, sense of doom. It usually lasts for about 10 minutes, happens 2 to 3 times a week, isn't triggered by anything else. And between, you always worry about the next one. For treatment, you give them an SSRI or CBT, and the attacks last minutes, not hours typically. It's just a surge of norepinephrine from the locus coeruleus that leads to autonomic hyperactivity, and you misinterpret those body senses, and your body's like, oh my gosh, I'm going to die. And you have a fear of future attacks, and that causes more of a panic disorder. So acutely, you can actually give them benzodiazepines. Long-term, you give them SSRIs and CBTs. And you have to also rule out any medical causes as well. So the answer is C, panic disorder. Trap answers by the wrong. Thyroid toxicosis. That can cause palpitations and sweating, but it would show up with systemic signs like weight loss, tremor, heat intolerance, also like abnormal TSH and T4 levels, and the labs here were normal. Social anxiety disorder, that attack would occur only in social situations with a fear of embarrassment. But here they're just random. Generalized anxiety disorder. So anxiety is chronic and pervasive here. There's worrying most days for greater than 6 months, not episodic. And then cardiac arrhythmia, that would cause palpitations, but not like a sense of doom, and sweating and episodic anxiety. So the bottom line is panic disorder is characterized by the recurrent, unexpected panic attacks and persistent worry about future episodes. All right, so here, our next question, we have a 7-year-old boy brought to the pediatrician for a routine checkup. His vaccination record shows he's due for updates on several vaccines. And so they give him inactivated influenza intramuscularly. Which of the following immune responses is directly responsible for the protectiveness there? Well, it's not going to be CD8, right? Because intramuscular influenza vaccines, they do not replicate inside of the cells. And so they can't stimulate MHC class 1. Instead, they have to activate the MHC class 2. And that would activate the CD4 positive T helper cells, which then stimulate the B cells to produce the neutralizing antibodies. Because they're processed extracellularly and presented on MHC class 2 molecules. And then the B cells come in and do their thing. Okay, so that's the reason why CD4 helper T cells that facilitated cytotoxic response, while CD4 T cells help the B cells not kill the infected cells directly. CD8 would be only activated by live attenuated or intracellular pathogens on MHC1, and that's not the right answer. Induction of the cytotoxic memory T cells. So again, the cytotoxic T cell responders require intracellular antigen processing, and that is not going to be triggered by inactivated vaccines. How about mucosal? Robust mucosal response? Well, IgA is important for intranasal vaccinations, like live attenuated flu mist, but intramuscular vaccinations primarily triggered the systemic IgG, not IgA. And so production of neutralizing antibodies is correct. Shots fired. Okay, there's the mechanism that we just kind of discussed, and we also discussed a lot of these things as well. Inactivated vaccines cannot replicate in the host. They're phagocytosis presented on MHC2, stimulating CD4 positive T cells, which then help the B cells make antibodies. Okay, here's some inactivated vaccines like polio, hepatitis A, rabies, and the intramuscular flu. Live vaccines like MMR, varicella, intranasal flu, and B cell deficiencies are poor response to inactivated vaccines. IgG is systemic protection, long life, and best for long-term defense. And CD8 positive activation with inactivated vaccines cannot enter the cytoplasm and process on MHC1. Mine and activated vaccines primarily provide long-term protection through the production of neutralizing antibodies by B cells. All right, so there's our hippocampus. Give us a little bit of a better look here. You can see the hippocampus right here, and the blue as well. There's our hippocampus right there. There's the thalamus. I can see the amygdala. There's the cingulate gyrus, the hippocampus, the seahorse of the brain. Corpus callosum right there. There's the cingulate gyrus, our little baby pineal gland. Again, our hippocampus. Starting to see that trend. Here's the mammillary body. There's the hypothalamus right there. The fornix, the corpus callosum, pineal gland, cingulate gyrus. There's your hippocampus right there. There's the amygdala. There's the basal ganglia. Here's what happens when you see a spider. It goes up to the visual thalamus, into the visual cortex, into the amygdala. All right, so that's so fun. The brain is so fascinating. Early this morning, I just sat up in my bed thinking. Much the same way we're not capable of shutting off our own breath, we can't stop thinking. We can't stop experiencing the world through our lens, whatever our means. And yet it seems like there's a way that you can detach the entity of self from that ongoing onslaught of cognition. And it's a strange meditative experience to sort of like a ghost sink through the command chair in your own brain and allow the autonomous machine to continue without you. That was a surreal experience that I had this morning as I was meditating. Sadal agrees. The brain is awesome. Blows my mind. All right, 68-year-old man, history of chronic obstructive pulmonary disease and coronary artery disease, is undergoing a cardiac bypass surgery. He experiences unexpected drop in blood pressure due to anesthesia complications, resulting in prolonged hypotension that resolves after 10 minutes. 2 weeks later, he presents with memory difficulties and inability to recall things. MRI of the brain reveals damage consistent with hypoxic injury. This is just asking us about hypoxia in the brain. It's a very simple question. This is about the hippocampus, which is the most sensitive region of the brain to hypoxic ischemic injury. And so that causes selective memory loss. That's anterograde amnesia, and that's after global hypoperfusion. And that's kind of all there is to it. There are a lot of other answer choices, and we have to know a little bit about each one. So the caudate nucleus, for instance, here you would see the basal ganglia lesions that cause the movement disorders, not isolated memory stuff, so it's not that. The thalamus, the thalamic infarcts can cause sensory and consciousness changes, but memory loss is not going to be seen there. And the occipital and the brainstem would cause autonomic and vital function failure, not selective memory impairment. So there you have it, folks. Particularly the CA1 pyramidal neurons are vulnerable to ischemia and hypoxia. Step 1 loves asking about all these areas of the body that are vulnerable to hypoxia. So the bottom line, memory impairment after prolonged hypotension suggests hippocampal damage due to hypoxic injury. All right, in our next question, we have a 55-year-old man presented to the emergency department with complaints of severe non-bloody diarrhea and abdominal cramping for the past 4 weeks. He reports significant fatigue and has noticed his skin feeling dry despite drinking ample fluids. He has lost approximately 13 pounds. Physical examination reveals dry mucous membranes and decreased skin turgor. Blood pressure is 90/60. Temperature is 98.1. Lab studies reveal hypokalemia and metabolic acidosis. Stool studies are negative for blood and white blood cells and infectious agents. A CT scan of the abdomen identifies a 3-centimeter mass in the small intestine. Administration of octreotide has been shown to alleviate his symptoms. Which of the following substances is this tumor likely secreting? Sadal, you are literally just too good. Guys, Sadal is like so freaking cracked. It blows my mind, man. Sadal should be teaching the class. I swear. I am so impressed. And by the way, this is actually my favorite syndrome. I love, well, maybe that's a bad thing to say, but I love the WADA mnemonic. I love that. Sorry, I was helping a client. He's wondering how to access the Twitch. But yes, okay, so non-bloody chronic watery diarrhea, hypokalemia, and metabolic acidosis. There's octreotide that relieves the symptoms, neuroendocrine tumor. This is the vasoactive intestinal polypeptide. Yeah, dude, I'm so impressed, Sadal. You're just super cool. All right, so glucagonomas would be caused by necrolytic migratory erythema and diabetes and anemia, not water stuff. That's not watery diarrhea, not glucagon. But you would see that necrolytic migratory erythema and diabetes. Insulin, that's insulinomas, recurrent hypoglycemia with relief on eating. You eat and you're fine, right? So no, not an insulinoma. Somatostatin, that would be like a somatostatinoma. And that's seen in like diabetes, diarrhea, gallstones, hypochlorhydria, but not severe watery diarrhea. And then vasoactive, yep, that's the correct answer. Watery diarrhea, electrolyte wasting, right? Gastrinomas, those would be ulcers, diarrhea due to acid hypersecretion. Insulinomas, Whipple's triad. Glucagonomas would have necrolytic migratory erythema, and somatostatinoma would have diabetes and gallstones and CF. So the watery diarrhea, the hypokalemia, achlorhydria, that's a vipoma. Octreotide is a somatostatin analog, and electrolyte loss is going to be seen here in metabolic acidosis, and so you have massive secretory diarrhea. Burhan, yes, this is really live. Yes, it is. Hello, Burhan. How can I prove that it's live to you? Ready? Watch this. Live. Burhan. There we go. Although I am curious, what would it be if it weren't live? Like, is there a way to do this not live? Asking for a friend. But yeah, VIPoma, chronic watery diarrhea, hypometabolic acidosis, WADA syndrome, right? WADA. By the way, Burhan, if you want to join the Twitch, you can interact with the chat. Oh, thanks, Burhan. That's super nice of you. Live in a good mood. I felt a little bit not as like chipper this morning, so I'm really happy to hear that. Yep. All right. So WADA, what does the WADA syndrome mean, right? So the WADA syndrome, and it's not like water, right? It's WADA. You have to say it cool like that. WADA, right? WADA stands for watery diarrhea, hypokalemia, and achlorhydria. That's what's going on there. All right. So achlorhydria is when the stomach does not produce hydrochloric acid. And let's do the bottom line. Small intestine mass likely secretes vasoactive intestinal polypeptide, causing severe diarrhea and metabolic acidosis. All right. All right. This next one is easy points. Easy points. What do you think of when you have a blunt, penetrating abdominal blow? You're playing football or something, and you have a blunt or maybe even a penetrating abdominal trauma. What should you think of? Here we go, folks. I'll let you guys see the question. You nailed it, Seidal. Nicely done. All right. So yes, 28-year-old man admitted to the hospital after a car accident. He was a restrained driver and hit a tree while traveling at high speed. And he's going to shift a mediastinum to the right. And you have fluid collection in the left upper quadrant. And so which of the following organs is most likely injured? Okay. So the answer is going to be the spleen, as Seidal said. Very, very nice. So you have that left-sided rib fracture and left upper quadrant pain and hypotension. You should think of a splenic rupture on the left side. You have the hemothorax opacification and mediastinal shift. That means there's a massive hemothorax from the intra-abdominal bleeding that crosses over. So it's the spleen. Why is it not the diaphragm? Diaphragmatic rupture. You'd see the abdominal contents in the thorax. That's wrong because there's no bowel sounds. It's due to blood, not organ herniation. So basically, if it were something with the diaphragm, then an injury would cause bowel sounds in the chest and you'd have an elevated hemidiaphragm and also herniation and not large volume hemithorax. The left kidney, that's a retroperitoneal hemorrhage. And so that would cause flank pain like hematuria, not intrathoracic blood with a mediastinum shift. So the bottom line, left rib trauma with hemithorax suggests splenic injury with a high impact abdominal accident. Okay, this is actually a really good question right here. So a researcher is interested in assessing the relationship between daily screen time and the prevalence of dry eye in a corporate office building. And so what he does is he surveys on a single day the average hours spent and also the dry eye-ness at the same exact time. So what's the answer if it's the same exact time? Kind of give it away with the way that I phrased the question. I apologize for that, but what do you think? Seidal says cross-sectional. You were 100% right. Cross-sectional. That's exposure and outcome at a single point in time. 100% right. Nailed it. Yep, really good. So the data is collected once on a single day. The exposure and the outcome are measured simultaneously. Incidence goes into the bathtub of prevalence, and then mortality drains it out. All right. There's a 45-year-old man presented to the clinic with a history of recurrent fevers, flank pain, and episodes of hematuria over the past 10 years. He has been treated multiple times for urinary tract infections. On physical examination, blood pressure is 150/95. Wow, that's high. Ultrasound of the kidney shows bilateral renal scarring and also calyceal dilation. Which of the following is most likely the underlying cause of this renal condition? So we have some recurrent UTIs and also some scarring, and there's nephropathy. And there's the calyceal blunting and the hypertension and elevated creatinine. So what's happening here in this question is we have a 45-year-old man. He's got some flank pain, episodes of hematuria. He's been treated multiple times for urinary tract infections, and his blood pressure is 150/95. And we have some scarring and a lot of problems there. And so what's happened is he's got some vesicular reflex going on. He's got some nephropathy. It's a form of chronic tubulointerstitial nephritis that's caused by long-standing VUR. Fibromuscular dysplasia would be the string of beads. Polycystic kidney would be multiple bilateral renal cysts, and diabetic nephropathy would be the Kimmelstein-Wilson nodules. So the bottom line is vesicular reflex is most likely associated with UTIs and renal scarring in this patient. And by the way, these vesicular reflexes, these are congenital, and so they can be congenital or they can be acquired, and they're defects in the uterovesicular junction and allows the backflow of urine from the bladder into the ureters and the kidneys. And so over time, that causes a chronic pyelonephritis, and that leads to interstitial inflammation, renal fibrosis, and also scarring. And it's particularly going to happen in the upper and the lower poles of the kidney. It also presents with recurrent UTIs and flank pain and hematuria, and also some hypertension in adults. A 5-year-old girl is brought to the clinic by her mother due to difficulty walking and frequent falls over the last month. She also has difficulty with tasks and fine motor skills like buttoning her clothes, and there's a vitamin deficiency. All these neural things are going to make you think of vitamin E, except this is not ADAK actually. This is macrocytic anemia. And so there's actually ataxia. So there's actually going to be a B12. If it were ADAC, then maybe the neurological symptoms would make you think of vitamin E, but this is B12, looks like, because of macrocytic anemia. That's why you always read the full question. typically a vitamin E would be like they have cystic fibrosis, pancreatic insufficiency, and then they have some sort of like muscle weakness, and maybe they even have some spinocerebral tract demyelination. But if you read macrocytic anemia, and that's the cause, then vitamin E is probably off the table. Instead, it's going to be vitamin B12. So it's the posterior column signs. Different sign. Okay, so vitamin B12 deficiency, it results from malabsorption in the terminal ileum resection. And so you have like associated with Crohn's disease, pernicious anemia, pancreatic insufficiency, and that leads to megaloblastic anemia and neurologic findings like subacute combined degeneration. And the neurologic findings are due to impaired myelin synthesis from methylmalonyl-CoA buildup. And so you have wide-based gait and also falls and difficulty walking, which leads to ataxia. And there's also loss of vibration, proprioception because of the dorsal column damage or dysfunction. There's also absent reflexes, which indicates peripheral neuropathy. There's macrocytic anemia, megaloblastic due to B12 or folate deficiency. And there's a history of bowel resection. That's going to be a loss of your terminal ileum and a B12 malabsorption. So here's the bottom line. B12 deficiency causes ataxia and macrocytic anemia, especially in patients with a history of bowel resection. All right, so in this question, we have a 33-year-old woman, presents to the emergency department with heavy menstrual bleeding 3 days after a menstrual period starts. She has no significant past medical history, and she has no medication, takes no medication. Physical exam shows mild pallor and a pelvic exam with enlarged boggy uterus. Lab studies show hemoglobin of 9.5. Normally, it's 12 to 16. An ultrasound of the pelvis reveals uniformly enlarged uterus. The gynecologist starts treatment to decrease the bleeding by enhancing uterine contractions. The medication administered acts through which of these following mechanisms? Okay, so first I want to talk about why is it boggy, right? Got this uterus, enlarged boggy uterus. So it's soft and spongy on palpation. That's what it means by boggy. And there's the infiltrating endometrial tissue bleeds that occur cyclically in the muscle wall, and that causes edema and also that boggy texture, right? So that's the reason why it's boggy in the first place. Why is it uniformly enlarged? Well, unlike fibroids, which cause asymmetric and firm, irregular enlargement, the adenomyosis, that spreads diffusely through the entire myometrium. That causes symmetrical hypertrophy of the uterine wall, and that's why the uterus becomes globally enlarged, not nodular or lumpy, right? So it's different than fibroids. Fibroids are irregular, asymmetric enlargement, and they have firm consistency, and they're discrete masses, and the symptoms are similar, but the pain is less cyclical, and the age differences, so they're still going to be like 20 to 40, but maybe adenomyosis can be like 35 to 50. All right, so what causes the enlargement is the repeated cyclical bleeding inside of the uterine wall, and that causes inflammation, hypertrophy, smooth muscle, hyperplasia, and over time you get thickening and the enlargement of the uterus. So boggy, adenomyosis, uniformly enlarged, not fibroids, right? So basically adenomyosis is diffusely invasive endometrial tissue, soft, uniformly enlarged uterus due to the chronic bleeding and also all the inflammation. So that's why it's boggy. That's why it's uniform. Okay, so we talked about this, the boggy uterus stuff, why it's adenomyosis, we know that. Inhibition of calcium channels. So the smooth muscle relaxation would be associated with that, but this is wrong because that would reduce the uterine tone. We want the opposite. Blockade of potassium antiarrhythmics class 3 would do that. Stimulation of beta-adrenergic receptors, that's smooth muscle relaxers. Wrong because beta-2 stimulation causes uterine relaxation. And inhibition of cyclooxygenase enzymes, that would be like NSAIDs, COX inhibitors, reduce prostaglandins and decrease uterine contractions. There's the bottom line. Heavy menstrual bleeding is treated with oxytocin, which activates the G protein coupled receptors to enhance contractions. All right, so here we have a study of incidence. That's the new cases. And at the start, 80 out of 1,200 were diagnosed. And over the next one, 60 additional ones. So what percentage is it going to be? Well, what we do is we go 60 divided by the 80 there, minus the whole 1,200. And then we just divide, and we get around 5.5. So incidence is just going to be the new people who get the disease. So you have to not measure all the old ones. Incidence is the new cases as a fraction of the total population. So here's the bottom line. Annual incidence of influenza in this population is 6.5, calculated as 60 new cases over 1,200. Okay, here's a medical fact. Every individual has a unique tongue print, just like your fingerprints. That's an interesting medical fact. Also, the fastest growing nail is on the middle finger. Yeah, that's right. If you think about breathing, you'll have difficulty breathing. That is very true. Also, when you sneeze, it's greater than 100 miles per hour, whereas coughs are just 60 miles an hour. All right, hopefully that was a fun medical fact. On to our next one. A 35-year-old male construction worker falls from scaffolding and lands on his back. He is brought to the emergency department for evaluation. On arrival, he is alert but complaining of severe lower back and abdominal pain. Good to see you. So he's complaining of severe lower back and abdominal pain. His vital signs show blood pressure of 100/60. Heart rate is 120 beats per minute. Respiratory is 22 beats breaths per minute. Physical examination has ecchymosis of the lower back and flanks and diffuse abdominal tenderness, and the FAST reveals presence of free fluid in the abdominal cavity. During exploratory laparotomy, initial inspection of the abdominal viscera shows no overt injuries, but upon palpation beneath the liver, a sudden gush of blood occurs. The patient's blood pressure drops precipitously despite resuscitative efforts. Which of the following is most likely the source of the hemorrhage? Okay, so this is a pretty crazy accident here, right? Landing on your back, and then blood pressure's like low, you're losing blood, and you've got all this ecchymosis, so tons of hemorrhaging. And so what is this? This is like the most lethal intra-abdominal vascular injury that you can possibly get from blunt trauma. The most lethal, what is it? Okay, so there's a collapse. And so this is going to be a avulsion of the hepatic veins from the inferior vena cava. Avulsion from the inferior vena cava. All right? So there's the sudden gush of blood on palpating along the massive intra-abdominal hemorrhage. That suggests there's injury to the retrohepatic vena cava, and these veins are really thin-walled. The vena cava and the hepatic veins, and they have high-volume conduits that connect the liver to the IVC. And there's trauma-induced avulsion. In this case, it's rapid, catastrophic bleeding. It's difficult to control surgically. All right, so it's avulsion, which is like the ripping out, right? It's just like disconnecting those veins from the inferior vena cava. So bad. Very, very, very bad. Okay, let's look at these other ones. Rupture of the renal artery would cause retroperitoneal, not intraperitoneal bleeding. Avulsion of the inferior vena cava from the right atrium, that would be rapidly fatal, but it's not associated with liver manipulation, and so that wouldn't present as a free intraperitoneal blood alone. So that's the reason why that's wrong. Avulsion of the superior mesenteric artery from the aorta. So that one causes bowel ischemia, not sudden hemorrhaging through liver manipulation. And then the rupture of the spleen, that would cause left quadrant hemorrhaging. It'd be visible on the initial inspection and not triggered with palpating beneath the liver. Alrighty, so blunt abdominal trauma with initial hemodynamic compensation followed by rapid decompensation during exploration. Retrohepatic venous injury, specifically the hepatic vein avulsion from the IVC. It's impossible to control surgically. Most lethal vascular injury you can possibly get. Here's the bottom line. Avulsion of the hepatic veins from the inferior vena cava is likely the source of hemorrhage in blunt abdominal trauma. And I see a question in the chat from Zishan. One day before the exam, you're taking it tomorrow? Good luck to you, my good friend. Yeah, I would say take it easy. Relax, rest, have a good day. Just chill for a second. Don't do tons of practice questions. Rise just like you would at the time you would for the exam. Get a good night's sleep. That's the biggest thing you could do. Best of luck to you, my friend. Best of luck. Yep, everybody wishes you good luck, Zishan. You're going to nail it. Alrighty, so here we go. The photos will catch up soon. We have a 28-year-old woman visiting the clinic. She's in her second trimester of pregnancy. She mentioned she's been feeling well with no significant fatigue. Her pregnancy has been uncomplicated and her pulse is at 78 beats per minute. Her blood pressure is at 110/70. There's no enlargement or tenderness. Lab work shows this. The increased, which of the following is responsible for the observed findings? All right, so thyroid pregnancy stuff. Let's talk about it. So the total thyroid hormone level is going to go up, but the free levels stay normal, and that's all because of estrogen. Estrogen boosts the thyroxine binding globulin production in the liver. And that binds more T4 and that raises the total levels, but the body compensates to keep the free T4 and the TSH in check. So if you see a pregnant woman, she has high total T4, but normal free T4 and also TSH, it's literally just estrogen. No big deal. Just the estrogen is all that it is. I don't know what accent that was, but so the answer is estrogen. All right, so during pregnancy, estrogen stimulates the liver to produce more thyroxine binding globulin. Yes, that's what Sadal said. Good. Yes. Nice. This leads to increased T4 since more is bound, but free remains normal because you're just binding more of it because of estrogen. Insulin doesn't affect thyroid binding globulin, ionizing hormone suppressed during pregnancy. Human chorionic gonadotropin, it's a TSH mimic. It can cause transient low TSH, but they have normal, and so they don't have human chorionic gonadotropin mimicking. DHEAS would be the adrenal androgen, and that is involved in fetal adrenal development, not the thyroid stuff. Not the thyroid stuff. So basically, estrogen increases the thyroid binding globulin, which then increases the total T4. So estrogen rises significantly during pregnancy, especially from the placenta. And then estrogen stimulates the liver to increase synthesis of thyroxine binding globulin. And you have more thyroxine binding globulin, that means there's more binding sites for the thyroid hormone in the blood. And so as more T4 binds to thyroid binding globulin, the free T4 transiently drops, and the pituitary senses that drop in the T4, and it increases the TSH ever so slightly to restore that balance. And you get more T4s produced to saturate the extra thyroid binding globulin. And then you get a normal or restored free T4. And so you can have elevated T4, normal free T4, and then TSH is normal, but maybe dipping slightly early on from the HCG, and then it will normalize afterwards. So pregnancy, high estrogen, high thyroid bonding globulin, high total T4, and then the free T4 is also going to stay normal. So always check the T4 and the TSH in pregnancy, not just the total T4, because you might mistakenly diagnose hyperthyroidism. Cool beans, guys? Are those beans cool? Increased estrogen during pregnancy elevates the total T4 levels with free T4 and TSH remaining normal. All right, here we go. A 58-year-old woman presents to the clinic with complaints of fatigue and night sweats over the past 2 months. She reports mild diffuse lymphadenopathy. She has a palpable cervical axillary lymph node, but no hepatosplenomegaly. And then we got the hemoglobin of 12.5, hematocrit of 37, leukocyte count is 20,000, segmented neutrophils 30, and we have a whole bunch of other labs to let you guys look at here. Flow cytometry, analysis of peripheral blood, lymphocyte reveals all of the following. And look at that. Wow. Oh, it disappeared. Which of the following findings on flow cytometry is most indicative of clonal lymphoid proliferation in this patient? All right, so we know there's monoclonal B expansion, and that's going to skew the kappa lambda light chain stuff. All right, so that ratio is going to be skewed. That's just one of the features of CLL that we have to know. And CLL is going to show co-expression of CD5 and 19 plus the 23 positivity. And so yes, it's the skewed ratio is what's involved here. And so they have CLL, so they have the surface globulin light chain restriction, and that shows strong kappa bias, 80-5. So it's a weird lopsided kind of thing there. It's normal. Normal is 2.2 to 1. Cervical lymph nodes are not palpated in the cervix. So high percentage of CD19s, that's a B cell marker. And so that's going to be normal or malignant. It does not necessarily indicate clonality. And then the CD5, T markers, not specific for it. CD23 helps distinguish it from mantle cell lymphoma. And absolute lymphocytic count is a whole host of them, so suggestive but non-specific. All right, so we got to diagnose CLL with flow cytometry. That's what this question's about. Fatigue, night sweats, lymphadenopathy, these are B cell symptoms. Lymphocytosis of 65 suggests there's some sort of leukemia going on. And that's the immunotype of CLL. And then we have these changes in the expansions of B cells with kappa light chain. So that's really the kicker right here, is this kappa lambda ratio. You have a neoplastic transformation of the B cells, clonal expansion, loss of diversity, and that skews the kappa lambda ratio. You have malignant clonal infiltrates in nodes and blood, and lymphadenopathy and lymphocytosis. Immune dysregulation and hypoagamoglobulinemia or autoimmunity. So here are the key features right there. And yeah, 80% of patients with early stage CLL are diagnosed incidentally just from routine blood work. So really just make sure to look out for this blood work when you're diagnosing patients. And here is the bottom line, my friends. The surface kappa to lambda light chain indicates clonal proliferation in suspected chronic lymphocytic leukemia. Very nice. Very good stuff. Here's the next question. We have a 68-year-old man brought to the clinic by his wife due to sudden onset dizziness, weakness, and blurred vision that started 3 hours ago. He has a history of smoking, peripheral artery disease, and hyperlipidemia. On arrival, he is pale and sweating profusely. His pulse is 115 per minute. His blood pressure is 88/55. Abdominal examination reveals an ill-defined pulsatile mass in the midline. Neurologic examination is unremarkable. An E scan of the abdomen is performed. Which of the following is the most likely diagnosis? All right, so let's look at these most important little figures here. I'm going to highlight a lot of the stuff so we can just highlight the most important thing. I kind of want to highlight happy there. Basically, the big thing that I would note here is there's sudden hypotension. There's a pulsatile mass in the midline. Okay, that alone tells you that we have a surgical emergency. This is also classic in older males, let's say, and they have some sort of a vascular disease history. So looking at these, I would think older male, vascular disease history, blood pressure is low and it's acute, and pulsatile mass. Say it all said it. Ruptured aneurysm aortic. Very, very nice, right? Blown out from within. So they have hypovolemic shock and abdominal pulsatile mass. So it's a AAA. Myocardial infarction associated with chest pain and ECG changes. Acute pancreatitis has epigastric pain radiating to the back and elevated lipase and amylase. Bowel obstruction, you have abdominal distension and high-pitched bowel sounds. And that's wrong because obstruction does not cause pulsatile masses. And then the kidney stones, flank pain, hematuria. So we need to understand abdominal aortic aneurysm, dilation of the aorta, usually below the renal arteries. Risk factors are male sex above 65, smoking, and atherosclerosis. Most of them are asymptomatic until they rupture, leading to retroperitoneal bleeding, hypotension, and death if untreated. Physical sign is pulsatile abdominal mass. So smoking is a huge risk factor, atherosclerosis and peripheral artery disease, male sex, and Marfan and Ehlers-Danlos syndrome. Here's the pathophysiology. You have atherosclerosis, which damages the aortic wall. You have the weakening of the media and the adventitia. You have progressive dilation, which forms the aneurysm, and then there's rupture that causes retroperitoneal hemorrhaging. There's compression of nearby structures, causing possible flank and back pain. All right, so 50% of patients with a ruptured AAA die before they even reach the hospital. And so look out for smoking, peripheral vascular disease, and hyperlipidemia. Here is the bottom line, my friends. Sudden dizziness, hypotension, pulsatile abdominal mass suggests a ruptured abdominal aortic aneurysm. Here we have a 45-year-old man presenting to the clinic with the complaints of right shoulder pain that has been gradually worsening over the past month. He reports no history of trauma, but mentions that he works as a bank teller and has recently taken up swimming as a leisure activity. He also discloses a 10-year history of rheumatoid arthritis, for which he takes long-term corticosteroid therapy. Physical examination shows tenderness and reduced range of motion. An X-ray of the shoulder reveals decreased bone density and proximal humeral fracture. Which of the following conditions is most likely responsible for the radiographic findings? Chest noob is thinking C, and Sedal is thinking osteoporosis. Okay, so he's got long-term corticosteroid use, and he's got a fracture without trauma. So he's taking corticosteroids long-term, and on the radiograph, he has decreased bone density. So Dr. Saswan is thinking D because of the steroids. Yes, it is osteoporosis because of the steroid use. All right, so they have atraumatic shoulder pain and the proximal humerus fracture. There's decreased bone density on imaging. Long-term corticosteroid use and rheumatoid arthritis are risk factors for secondary osteoporosis. And let's talk about the mechanism for this one. So glucocorticoid use inhibits the osteoblast differentiation and it promotes osteocyte apoptosis. All right? Chestnube says this is why I don't want to go into medicine. That's totally fair. Rheumatoid inflammation, cytokines, IL-6 and TNF-alpha stimulate the osteoclast. Decreased bone formation and increased reabsorption. There's a net loss of bone mass, and there's weakened trabeculae, which is fragility fractures, especially in axial and proximal limb bones. All right. Low bone mineral density on imaging. No trauma, yet fracture. The fracture locations are vertebrae, hip, wrist, proximal humerus, steroid use, and normal labs unless it's severe. Usually normal, all of these things in osteoporosis. So 50% of women and 20% of men over age 50 have some sort of an osteoporotic fracture in their lifetime. All right, so chronic shoulder pain, no trauma, proximal humeral fracture, and he's got the corticosteroids. So those are all risk factors there. Prolonged corticosteroid increases the fracture risk, making osteoporosis the likely cause. That's the goal, making everybody MDs. A 67-year-old woman presents to the clinic for follow-up after undergoing a biopsy that is confirmed with diagnosis of metastatic lung cancer. When the physician discusses the diagnosis and prognosis with her, she becomes tearful. So she's got an emotional response, she's in distress, and she says, how am I supposed to handle this? So so first of all, you identify, and you say, how am I supposed to handle this? That's the direct empathy, right? She wants empathy. And so we have to do communication. We have to help her out. And then so we have to always empathize. And remember, the way to do these ethics questions is you always have to think, what is the principle that you're going to be doing? Okay, so empathy, you have to say, okay, this must be difficult for you to hear, right? You have to provide some sort of an empathy response if they are in distress. There's your ethics question for you. There are many resources available. Here, our goal is to empathize and empathize. None of these empathize, okay? So we definitely have to empathy and validation. That's one of the principles that you have to be aware of for ethics. Okay, so validating the patient's feelings is crucial in addressing emotional distress after cancer diagnosis. There you go. All right. Here we have a 16-year-old girl presents to the primary care physician with a 7-day history of fatigue, fever, and sore throat. She's got a positive monospot test and atypical lymphocytes and irregular nuclei. The atypical lymphocytes are which of the following? What are they? She's also got a temperature. So we know that she has infectious mononucleosis, right? She's got Epstein's-Barr virus. Monospot test tells us that. And we know this infects the 21, the CD21. And then we know the atypical lymphocytes are going to be E. Yes, Dr. Sawasan. Nice. You guys are both correct. Very, very good. It is going to be the T lymphocytes. And you are correct. It is the CD8 T cell lymphocytes. That's correct. All right. Killer T's in monomadness. Epstein's-Barr virus infects the B cells, but the atypical lymphocytes are reactive CD-positive T cells. Splenomegaly occurs from T cell proliferation. So Epstein's-Barr virus infects the B cells via the CD21 receptor, and the immune system responds with your CD8 positive cytotoxic T cells, which appear as large atypical lymphocytes on the smear. EBV infects the B cells, but the atypical lymphocytes are not themselves. They are the reactive T cells. And that's kind of the hardest part about this question, if we're being honest. Good morning, Renata. Good morning. Renata's been grinding like crazy. We're here to cheer her on. You got this. So Epstein's-Barr virus is going to infect the B cells through CD21, and then we have the CD8 positive T cell response. That's how it goes. If I were to say ciprofloxacin, what would you guys think of? Ciprofloxacin. That's awesome, Sedal. Here we go. A 62-year-old woman presents to the clinic with a 3-day history of increased urinary urgency, painful urination, and left-sided flank discomfort. She reports a low-grade fever and chills over the past 24 hours. Her past medical history includes recurrent urinary tract infections. Vitals, you have a temperature of 100.9, heart rate is 92, and the respiratory rate is 92 per minute. Nice. Tendinitis and P450 inhibitor, fluoroquinolones, very good. I was especially thinking of fluoroquinolones for this one, and we'll see why in a second. But all amazing answers. This is good. Urine analysis, we have positive leukocyte esterase is 2+, and previous urine culture is growing Klebsiella pneumonia resistant to several antibiotics, including ciprofloxacin. Genetic analysis indicates the resistance is likely due to a mutation. Which of the following is the mechanism of resistance? What do you guys think? What are you guys thinking? So there's a resistance to several antibiotics, including ciprofloxacin. That means there's fluoroquinolone, as Iamrant here said. And Dr. Sawasan says, A, yes, alteration of the target site of the DNA gyrase. Good, Sadal's got it correct as well. Nice. This is fluoroquinolone resistance. Now, Klebsiella pneumonia also is important. And that's a gram-negative rod that's known for the horizontal gene transfer. And then genetic mutations, right, that points away from enzyme acquisition like beta-lactamase stuff. Fluoroquinolones, topoisomerase 2, that would be the DNA gyrase. And positive nitrates and all that stuff confirms upper UTI. Okay, resistance is futile to fluoroquinolones. Fluoroquinolone resistance is commonly due to mutations of DNA gyrase. DNA gyrase is the bacterial target of ciprofloxacin. A mutation changes the binding site so the drug can't inhibit DNA replication. All right. And we were also thinking C, so let's talk about that one. Poor mutations can contribute to the resistance, but typically not enough alone, especially affects the beta-lactams. All right. So mutations in the beta-lactamase enzymes, that would be carbapenemase, and that's for penicillins and cephalosporins. Modification of 23S, RNA, and the 50S, that is linezolid and macrolide resistance. That targets protein synthesis, so it's a little different. All right, so fluoroquinolones inhibit the DNA gyrase, and Klebsiella is an encapsulated gram-negative rod, common in UTIs and nosocomial infections, and fluoroquinolone resistance mechanism is DNA gyrase. The GYRA mutation is the target site, and you have positive nitrates and 2+ leukocyte, as well tells you that you have a UTI, so untreated polynephritis, sepsis, and renal scarring. So fluoroquinolone resistance is so common that over 25% of Klebsiella isolates can be resistant in hospitals. So crazy. What a weird world we live in, right? We're just a bunch of like evolved apes running around infecting each other with nosocomial infections that gain resistance in hospitals. And here we are studying on a YouTube stream. What's going on? It's just what a time to be alive. Here's the bottom line. Let's just dive in. Klebsiella pneumonia resistance to ciprofloxacin is primarily due to an alteration of the target site of DNA gyrase, which you guys all know because you're a bunch of champs. Alrighty, guys, we only have 11 more questions until we finished all of NBME 30. Wow, we've done this for 20 hours or so. Okay, so here we go. Oh, wow, you already answered the question. E. Okay, not quite. Do you have another guess instead of E? So here we go. 55-year-old woman presents to the clinic with a 2-week history of visible blood in her urine. Okay, so that's going to be painless, gross hematuria, and that's a hallmark of urothelial or transitional cell carcinoma, right? Maybe that's helpful. She has a 30-year history of cigarette smoking. That's a long time, but she quit 5 years ago, all right? And urine analysis reveals numerous red blood cells, but no signs of infection or proteinuria. An ultrasound of the abdomen and pelvis is performed and shows a mass within the bladder. Which of the following environmental exposures is most significantly associated with this condition? Okay, great. What's the answer to this question here? She's a 55-year-old woman. She has a 30-year history of smoking. She's got visible blood in her urine, but it's also painless. Okay, does that make you think of anything? We're thinking B. Nice. Benzidine, Dr. Sawasan. Nice. Very, very good. All right, and so there's also that mass within the bladder. So there's a bladder neoplasm, and that's urothelial carcinoma. There's no signs of infection or proteinuria that rules out any glomerular infectious causes. And so, yes, there's blood in the bowel. There's bladder cancer. There's benzidine and beta-naphthylamine that's found in the dyes in the rubber industries. And smoking is the modifiable risk factor here for these aromatic amines. So urothelial carcinoma of the bladder is the most common type of bladder cancer in adults. And it's the strongest environmental risk factor for this malignancy is exposure to these aromatic amines, particularly benzidine. And that's through smoking and industrial exposure here. So asbestos has mesothelioma. Radon would be a basement lung cancer stuff. Lead, basophilic stippling, and PAHs, that would be scrotal or lung cancer, not linked to bladder cancer. So here is the bottom line. Bladder cancer is strongly linked to benzodine exposure, especially in smokers. Okay, now we got a question from the chat. So I want to go over to the community section because we do these as well. Any random questions you guys have? So let me copy your question so that everybody else can see it on YouTube. I'll paste it here and then I will expand it out and drop it there. And then let's talk about it. Okay, so let's do actually a question on that condition, if that sounds good to you. Okay, guys, so this is a question brought to us by Dr. Sawasan. They're asking about TERP now having E. coli infection and resistance after multiple antibiotics from different classes, and the answer they chose was pump efflux. A 68-year-old man develops fever and dysuria 3 days after undergoing a transurethral resection of the prostate. Okay, now he's got fever and dysuria. Urine cultures show E. coli that is resistant to multiple antibiotics, including fluoroquinolones, beta-lactams, and aminoglycosides. Genetic testing reveals the resistance is due to efflux pump mechanism. Which of the following mechanisms is likely responsible for the drug resistance? All right, so basically what's happening is E. coli is going to be very common after catheter-associated UTIs, especially in procedures like TERP, right? You have the transurethral resection of the prostate. And so sometimes these infections are resistant not just to one antibiotic, but also many, right? And that's not because of any enzyme difference or ribosome difference. Instead, it's just the bacterial pumps, right? These efflux pump, they're like the bouncers, and they toss the drugs out. And so and the reason why you know that this is the case is because of the diverse group of organisms here. So it's not just resistance to penicillin, right? It's also fluoroquinolones and aminoglycosides all at once. And so that defense only can come from a broad spectrum mechanic like the overexpression of your efflux pumps. And so here is just efflux pump overexpression. So after TERP, right, there's an increased risk of UTIs. That's why they're saying after TERP. Resistance to multiple antibiotics from different classes, that tells you that it's not some one little thing like a change of beta-lactamase, or it's not like in our other previous question, fluoroquinolones and DNA gyrase, right? This is going to be multi-drug resistance. And so it's going to be the efflux pump, which involves tons of them because it's broad spectrum defense. So E. coli can express transmembrane efflux pumps that remove antibiotics. So that's an example of this question for multi-drug resistance for E. coli, especially after TERP. So TERP causes the E. coli. E. coli has that resistance to broad spectrum antibiotics. TERP causes E. coli, let's say, and other organisms which are mentioned. So they give you a whole host of them, the gram-negative E. coli infection, but they also have several other genetic adaptations which confer resistance, antibiotic resistance, and that is going to be like a broad spectrum resistance. And that's in E. coli, you have those greater efflux pumps. All right, so moving on to our next question here. I just get so jazzed up talking about science. And I'm realizing that we were already at 189, but let's just do another practice question for 189, just a double whammy, right? Because I feel like that was a little bit hard, but here, the practice question. You guys understand this one. Here we have a 55-year-old factory worker, painless gross hematuria. What's the answer? We have transitional cell carcinoma, right? We have painless gross hematuria. There's bladder cancer. So the answer is these aniline dyes. Smoking history and transitional cell carcinoma is caused by aromatic amines. So aniline dyes are one of them. Okay, so that's just another way that this could present on test day. So just be aware of this. The presentation of urothelial carcinoma is gross hematuria and often painless. And these occupational carcinogens, you have to know which ones, the amines, anilines, benzodine, all of those you should be aware of. Aromatic amine exposure, aniline dyes. Okay, so just be aware of those occupational hazards. There's also going to be like a bottom line, transitional cell caused by aniline dyes, especially in industrial workers. So there we go. For this one, we have a 7-day-old male infant with poor feeding, vomiting, and lethargy. The mom reports no complications during pregnancy. On examination, the infant is irritable and has muscle hypertonia. Distinct sweet odor is noted. Restriction of which of the following is going to be effective in treating this patient? Well, what is the answer? I know you guys know this one. The sweet odor. That's classic for maple syrup urine disease. The odor resembles burnt sugar due to the accumulation of branched chain keto acids. And so the answer is going to be, who knows? Valine. All right. Also be on the lookout for elevated plasma levels of leucine, isoleucine, and valine. Poor feeding, vomiting, lethargy, neurologic findings due to neurotoxicity of accumulated leucine, and also keto acids. Dietary intervention is necessary. You have to restrict the branched chains because you just can't deal with them. You just can't. Autosomal recessive disorder caused by a defect of branched chain alpha keto acid dehydrogenase, leading to buildup of all of these. Tyrosine, that's relevant in albinism and tyrosinemia. Methionine is in homocystinuria, which show marfanoid features. Think PKU. Lysine, not going to be associated with this question. Branched chain amino acids are going to be elevated. Here's the bottom line. Maple syrup urine disease requires dietary restriction of branched chain amino acids, particularly valine, to prevent metabolic crises. All right, so here we go. 55-year-old woman presents to the clinic with the complaints of persistent cough and occasional difficulty swallowing that has been present for several months. Physical examination reveals a palpable suprasternal notch, and chest X-ray is obtained, revealing a mass in the anterior mediastinum. Subsequent thyroid functions show we have elevated TSH and normal T4. Radioactive iodine uptake. A scan is performed demonstrating significant iodine uptake in the mediastinal mass. What is the diagnosis? Ooh, okay, I kind of made a mess of that with my highlighting. I'm trying to be a little bit more posse highlighting. That's P-A-U-C-I. Basically, mass in the anterior mediastinum. That means that it's localizing the lesion anatomically. We know where it's at. Mass in the mediastinum. And also elevated TSH and normal T4. That tells us that there's a subclinical hypothyroidism. So there's impaired and some impaired thyroid hormone production. And so the answer is going to be C, ectopic. Ectopic. Because there's impaired thyroid hormone production with compensatory TSH elevation. All right, so here's what's happening here. Let's scroll down. Significant iodine uptake. It's a hallmark of functioning thyroid tissue. And so we have thyroid tissue that migrates abnormally during embryogenesis, commonly presented as ectopic. And that's going to be tissue in the base of the lung and mediastinum or anywhere along that thyroglossal duct pathway. So ectopic thyroid tissue results from abnormal embryologic migration of the thyroid gland. Okay, why are they wrong? Mediastinal lymphoma, B symptoms. Lymphomas don't take up iodine, so that's the reason why it's not a lymphoma. Thymoma, myasthenia gravis, that arises from the thymus and does not concentrate iodine. How about parathyroid adenoma? Well, that's hypercalcemia, stones, bones, groans. Right? They don't appear in the anterior mediastinum. How about bronchiogenic cysts? Congenital fluid-filled asymptomatic. They don't take up iodine. So basically, we have to have a differential diagnosis for the anterior mediastinal masses, the 4 T's: thymoma, teratoma, thyroid, and terrible lymphoma. Basic thyroid physiology. So basically, what we need to know here is the pathophysiology as well. There's an embryologic error, and the thyroid fails to migrate, and you have ectopic tissue that remains functional. And so the pituitary compensates. We have the increased TSH due to the suboptimal T4 feedback. And so it's not always sufficient to meet the metabolic demand. And so you have that ectopic gland that can uptake the iodine. Okay, so 90% of the body's iodine actually ends up in the thyroid. So if you see a radioactive iodine uptake, it's like, oh my gosh, that's the thyroid tissue, wherever it is. And so a woman showing up with a mass of her anterior mediastinum, and she's got difficulty swallowing, she's also got some coughing. And so that rules out lymphoma, thymoma, and also cysts and parathyroid tumors. And so the TSH is going up because it might be missing, or she's missing out on something. So TSH is going to compensate. So the bottom line is ectopic thyroid tissue is the most likely diagnosis given the mediastinum mass and elevated TSH levels. Awesome, my friends. Awesome possums. Is it making sense? Are we vibing with that one? We only have 8 questions left until we're finished with all of NBME 30. The original question bank. Yes, W, says I am Rant. All right, here's our next one. Yep. Hematopoiesis already known. Here we have a 50-year-old man presented to the clinic with complaints of muscle weakness that worsens throughout the day, especially after periods of activity. Okay, so muscle weakness that worsens throughout the day. That is huge dead giveaway of hallmark of myasthenia gravis. Yes, there is, I believe. I am Rant. I believe there is. He also reports difficulty swallowing and speaking by evening time. Okay, so all that is leading us to myasthenia gravis. We know that it's myasthenia gravis. And which of the following is the target of antibodies in this patient's condition? Yep, hematopoiesis is right. It is nicotinic receptors. 100% nailed it. Nicotinic receptors. So also improvement. There's the tinselin test with edrophonium. That confirms the postsynaptic neuromuscular junction disorder. And also, you have bilateral ptosis and proximal weakness. This eye and proximal involvement are classic for myasthenia gravis. Bilateral ptosis and also the proximal weakness. Normal reflexes rules out peripheral nerve disease. So here's our explanation. They have myasthenia gravis, which is an autoimmune disorder where you're attacking the nicotinic acetylcholine receptors on the postsynaptic membrane, right? So nicotinic receptors. So voltage-gated calcium channels, Lambert-Eaton would be associated there. Muscarinic acetylcholine. So nicotinic is the answer, but muscarinic, these are like autonomic symptoms found in the autonomic ganglia, not neuromuscular junctions, which cause different symptoms like sweating or GI changes. Acetylcholinesterase, that's organophosphate poisoning. And if you inhibit that, it'll cause excess acetylcholine. Muscle-specific kinase, that's like atypical myasthenia gravis variants. And so the most common and classic antibody is going to be nicotinic receptor. All right, so neuromuscular transmission, acetylcholine is released from the presynaptic terminal. It binds to nicotinic acetylcholine receptors in the postsynaptic muscle membrane. Myasthenia gravis autoantibodies block and destroy and downregulate these receptors. You have a loss of receptor availability, progressive weaker contractions, and fatigue. Giving acetylcholine inhibitors increases your acetylcholine levels, improving the transmission. All right, you can barely keep your eyes open at the end of the day, but you're fine in the morning. Myasthenia gravis. Pyridostigmine can provide some relief. Nicotinic acetylcholine receptor antibodies to the nicotinic acetylcholine receptors. Okay, here's the bottom line. Antibodies of myasthenia gravis target nicotinic acetylcholine receptors, causing muscle weakness that worsens with activity. 7 more questions. And by the way, nicotinic receptors, those are the ligand-gated ion channels that respond to acetylcholine. There are two types. There's the nicotinic NN. The location is the autonomic ganglia, so the sympathetic and the parasympathetic, and the adrenal medulla. And those activate the postganglionic neurons. And there's also the nicotinic NM, and that's the neuromuscular junction. And that mediates the muscle contraction. And so that's targeted by drugs like succinylcholine, which is a depolarizing blocker, and then other derivatives as well, like non-polarizing blockers. So nicotinic receptors are ligand-gated sodium-potassium channels. They have fast action. And when acetylcholine binds, the receptor changes and you get a conformation, and then sodium rushes in, potassium goes out, you get depolarization. So myasthenia gravis is auto antibodies against the NM receptors, and botulinum toxin, for instance, is decreased acetylcholine release. And the curated drugs like rocuronium, those are an antagonist that are used in surgery. A nicotinic overdose, that stimulates both of them, and that causes like twitching, hypertension, tachycardia, and that's pretty much all there is to know. NN is the nervous system stuff, and NM is the muscle, the motor endplate stuff. All right. So nicotinic, neuromuscular junction, and also the ganglia, and muscarinic is going to be at the organs. Yep, hematopoiesis is exactly right. So hematopoiesis is talking about succinylcholine and malignant hypothermia. Definitely. So basically succinylcholine, that is as we said, the depolarizing neuromuscular blocker. So it binds to those NM receptors and it causes persistent depolarization, and that causes, malignant hyperthermia, and also like halothane and sevoflurane will do that too. So you have a mutation in your RY1 gene, and that causes defective ryanodine receptor on the sarcoplasmic reticulum, leading to uncontrolled calcium release, and then sustained contractions, and then heat production, all that stuff. All right, do you guys have an answer to this one? What do you think of this one? We have gram-positive diplococci. Which of the following is the most appropriate next step to differentiate the causes of her leukocytosis? All right, 68-year-old woman, hypertension, right-sided chest pain, severe dyspnea while gardening, 20-pack year smoking history, lisinopril, hydrochlorothiazide, pacification of the right lower lung, hemoglobin is just fine, platelets elevated, leukocyte count 24, should be from 4 to 11. All right, so that leukocyte count of 24, that's leukocytosis, and that makes us think it's a leukemoid reaction, right? And so we have to measure the leukocyte alkaline phosphatase score, LAP. She has the elevated white blood cell count, so it's leukemoid reaction versus chronic myeloid leukemia. The LAP differentiates between the two. LAP is high in leukemoid reactions and low in CML. A bone marrow biopsy is the definitive one, but it's super invasive, so don't do that yet. Flow cytometry, using leukemia and lymphoma to identify clonality on the first line for distinguishing between reactive neutrophilia. Bacteria culture, you already know the etiology, so that's silly. Why would you do that? Pulmonary function testing for chronic lung disease. Okay, CML has that BCR-ABL, that's the Philadelphia chromosome, chronic myeloid leukemia, and you have a lower LAP score due to the clonal neutrophils lacking the normal enzyme activity. So you have a bacterial infection, cytokine release, neutrophilia, leukemoid reactions, benign, high white blood cell counts with functional neutrophils, LAP score, an enzymatic test reflecting neutrophil activity. So your white cell count could be like boosted way up by an infection, and it looks like leukemia, and it's a leukemoid reaction. Wild. So a leukemoid reaction is that benign reactive neutrophilia, so an infection or stress, and has a really high LAP score. But your chronic myeloid leukemia is malignant myeloproliferation, and that has a low LAP score. So LAP in a leukemoid reaction, the neutrophils are really mature and they're functional, right? So they have increased LAP, but in CML, Philadelphia chromosome, 922, basically you're producing in excess, but you have dysfunctional or immature neutrophils. And so they have low LAP because they don't produce that LAP because they're malignant clones. So the CML is cancer, you have low LAP, and leukemoid is going to be high LAP. All right, so here is the leukocyte LAP score helps differentiate leukocytosis causes, particularly in suspected infections. 6 more. Okay, so here we have a 42-year-old woman presented to the clinic with a 2-month history of frequent diarrhea and weight loss. She's also had intermittent severe burning that improves slightly with food. And we have multiple small ulcers in the jejunum. What's the most likely cause? And look at that, calcium is elevated. So it improves with food. And so that's going to be some sort of a duodenal ulcer, right? Yep, Zollinger-Ellison syndrome for the multiple ulcers. You got it. That's 100% right. Yep, Zollinger-Ellison syndrome. You have that calcium, so hyperparathyroidism and pancreatic process, multiple small ulcers is going to be Zollinger-Ellison syndrome, the proximal jejunum, because it's not where they should be. Frequent diarrhea and weight loss, gastrin-induced hypersecretion, and activates the pancreatic enzymes, causing malabsorption. And so C, you got it right, 100%. So defective antral pylorus relaxation, gastric emptying problem, that's seen in gastric outlet obstruction. H. pylori infection would have ulcers in the duodenum and the stomach, does not explain the jejunum or elevated calcium. Autoimmune destruction of the parietal cells, that's chronic atrophic gastritis, B12 deficiency, causes hypochlorhydria, not hypersecretion of ulcers. Opposite physiology, intestinal villus blunting would be celiac disease. Can cause diarrhea, weight loss, but not peptic ulcers. All right, so we have to review the gastrin physiology. Gastrin is secreted by the G cells in the antrum of the stomach to stimulate the production of the parietals, stimulate acid production by parietal cells. ZES, a gastrinoma, usually in the pancreas or the duodenum, causes unregulated gastrin secretion, resulting in acid overproduction. Associations: MEN1, parathyroid tumors, hypercalcemia, pancreatic tumors, gastrinomas, pituitary tumors, prolactin. Cool. I like that. You guys are finishing each other's words now. I don't know what that means for you guys, but great. I'm happy to see it. Ulcers beyond the duodenum. Severe recurrent ulcers despite therapy. Diarrhea, weight loss, high calcium. All of these things, associations with the MEN1, these are all associated with gastrinomas. All right? So ulcers, they can burn right through your jejunum. And typically an ulcer pain gets better with food, but when they're beyond the duodenum, especially the jejunum, you should think of Zollinger-Ellison syndrome, leading to jejunal ulcers and diarrhea. Yeah, you guys are in symbiosis there. Nice. Let you guys stew on this one for a second while I do a little bit of coding. All right, here we go. A 64-year-old woman with type 2 diabetes presents to the emergency department with a 5-day history of increasing shortness of breath and also yellow sputum and fatigue. She lives alone. Was recently hospitalized for diabetic foot ulcer treatment. On examination, her temperature is 101.3 and blood pressure is 105/70. Lung auscultation reveals decreased breath sounds and agophony over the right lobe. Lab studies show a white blood cell count of 3,200, which is low. And chest CT shows nodular regions with ground glass opacities. Serum tests for galactomannan are positive. A positive serum test indicates the presence of which of the following components. Okay. So really the only thing here is we have these galactomannan tests are positive, and galactomannan is a polysaccharide component of the cell wall of the Aspergillus species. So does that help you answer the question? Breath sounds, agophony, yellow sputum, diabetic foot ulcer treatment, that's important, right? Yes, fungal cell wall, 100%, Aspergillus, yep. So the CT reveals nodular lesions. These are also the halo sign, right? Invasive Aspergillus, ground glass opacities, nodular lesion, halo sign, aspergillosis. White blood count is at 3,200 with neutropenia, profound risk of no significant risk factor for fungal infections. Recent hospitalization and diabetes, immunosuppression due to chronic disease, right? Increase the fungal risk. Halo of death, right? Invasive aspergillosis. So galactomannan is a polysaccharide found in the cell wall of Aspergillus. Bacterial endotoxin, lipopolysaccharide, is found in gram-negative bacteria, not fungi. So nope. Viral capsid protein, serologies of PCR for viral infections. Wrong because viruses do not allow the halo signs. Bacterial exotoxin, toxin-mediated illness like tetanus and diphtheria is wrong because no exotoxins are involved in fungal pathogenesis. Mycobacterial lipid, cord factor. Fungal sketchy time. But Aspergillus can kill immunocompromised patients in days. And it starts with something as subtle as just a little cough, and then there's a lethal lung lesion. And yep, so diabetic patients, neutropenia, presenting with that cough. Watch out. Watch out, my friends. Watch out. Here's the bottom line. Whoa! Hello. Positive serum galactomannan indicates fungal cell wall components, suggesting possible invasive aspergillosis in immunocompromised patients. Woohoo! Oh yeah. Oh yeah, the Duff Man. All right, here's a nice factoidy little question for all you factoid lovers. If I were to say cyclosporine, what would you be thinking of? What would you be thinking of? 58-year-old woman, history of rheumatoid arthritis, has started on an immunosuppressive regimen. Targets a protein crucial for T-cell receptor signaling and interleukin-2 expression. New onset hypertension, her gums have become swollen. Which of the following is most likely inhibited by the medication? Nice. Okay, thinking of some good things. Yes, calcineurin. Nice, nice. Indeed it is. So they're targeting a protein that's crucial for T-cell receptor signaling and interleukin-2 expression. This is the giveaway, right? That directly implies calcineurin, and then that's essential for your T-cell activation pathway and IL-2 production. Also, new onset hypertension. Is that what she's got? New onset hypertension. That is an adverse effect of cyclosporine, which is a calcineurin inhibitor. Swollen gums is also associated with this as well. Rheumatoid arthritis, immunosuppressants like methotrexate, and calcineurin inhibitors like cyclosporine block the IL-2 transcription by inhibiting the dephosphorylation of fat. Calcineurin is a phosphatase that activates transcription factor, NFAT, which is required for IL-2, calcineurin, and there's calcineurin inhibitors like cyclosporine and tacrolimus. They're both calcineurin inhibitors. They're used in autoimmune diseases and transplant rejection. They cause hypertension and gingival hyperplasia. Track 2 is for erythropoietin, mTOR, cell growth, sirolimus. Sirolimus is different, mTOR inhibitors. They affect the IL-2 response, but not associated with gingival hyperplasia, like tacrolimus and cyclosporine are. So T-cell activation, calcineurin, dephosphorylating NFAT, which then moves the nucleus to trigger IL-2 transcription, which is super important for T-cell proliferation. All right, so yeah, you guys are talking about tacrolimus. That's a calcineurin inhibitor as well, and it's used to prevent organ transplant rejection. It suppresses T cell activation by inhibiting the IL-2 transcription. And there's a question by hematopoiesis. What's the physiology with gingival hyperplasia? Immunosuppressants are a big one because it stimulates the fibroblast proliferation, so that increases the TGF beta. And also anticonvulsants can cause this. That promotes fibroblast growth. So usually it's the fibroblast stuff, right? And then the calcium channel blockers as well, that increases the expression of the growth factors in the gingival tissues. So tacrolimus is going to be associated with gingival hyperplasia, a little bit less than cyclosporin is, even though they're both calcineurin inhibitors. It's involving the fibroblast and the matrix components, and they're stimulating the production of inflammatory cytokines and growth factors. Yeah, so basically the gingival hyperplasia is fibroblast stimulation, extracellular membrane accumulation, and the impaired degradation. So here is the bottom line. Calcineurin inhibitors can cause hypertension and gingival hyperplasia in patients on immunosuppressive therapy. Cool. Very nice. Very nice. Ooh. So we have a 65-year-old woman with a history of sleep apnea and obesity presents to the clinic with increasing lethargy and shortness of breath over the past few months. She reports that she uses her CPAP machine irregularly, and she denies smoking and drinking. Her blood pressure is 138/86, respiratory rate is 22, BMI is 35, oxygen side is 89% on room air, and hemoglobin is 19, so that's elevated. Which alteration is most likely responsible for the elevated hemoglobin? Hematopoiesis probably likes this question. Yep, we have the increased erythropoietin production. So she has chronic hypoxemia and then she uses the CPAP irregularly. And so it's untreated obstructive sleep apnea, means that there's recurrent nocturnal hypoxemia. And so you have an oxygen saturation of 89% on room air. That's hypoxemia as well. So intermittent hypoxemia, the kidneys are responding by increasing the EPO. Polycythemia, elevated red blood cell mass. There we go. Obstructive sleep apnea. There's the pathophysiology. All right, guys, 3 more questions. Then we're donezo with NBME 30. Cause, so the hypoxemia, which causes the kidneys to be like, oh my gosh, I got to start to make more of that. They make more hematocrit. All right, so we have a 3-year-old female is brought to the pediatrician by her parents who are concerned with a light brown patch on her left shoulder. They report that the patch has been present since birth, but has not changed in size and color over the past year. The child is otherwise healthy with normal growth and development. On examination, there's a 4-centimeter uniformly tan, flat, oval macula on the left shoulder. The rest of the physical examination is remarkable, including skin, neurological, or ocular assessments. There is no family history of neurological conditions. Which of the following is most likely diagnosis? All right, a medical word for birthmark. So this is actually a light brown patch, right? And that is the color of cafe au lait. And it's present since birth, so it's congenital, right? And so it's cafe au lait spot. And it's uniformly tan, flat, and oval macule. That distinguishes it from any sort of irregular nevus. And so it's not Becker's, because that's hyperpigmented with overlying hair. The nevus depigmentosum is hypopigmented. It's lighter than the skin. Juvenile xanthogranuloma is yellowish. Congenital dermal melanocytosis is a bluish-gray lesion on the scrotum. And so there are some associations like NF1, but the pathophysiology here is you have excess melanin in the basal keratinocytes. You have a congenital origin, present since birth, and it's stable. And if there are multiple due to mutations in neural crest, then it's going to be neurofibromatosis 1, though. So there are 3 images, reference images, and there are 4 concepts. So I need to make them both have 4. Okay, does that one make sense? But yeah, so a kid's got 1 to 2 cafe au lait spots and no family history, no neurofibromas, and no leash, then yeah, you're right. It's likely just birthmarks. But if it's greater than 6, then it's going to be a neurofibromatosis 1, and you have to do some genetic counseling for sure. McKeown Albright, it has the irregular stuff. That's the coast of Maine. And there's also like tuberous sclerosis, and that more commonly has the ash leaf spots. Okay, how's the day going? Moise, life is good. I've just been chilling, just doing some coding, and we're almost finished with this, so I'm really excited about that. Wait, all right, folks, let's get back to business to defeat the Hun. All right, guys, we only have 2 more questions. Can we do it? Do we have it in us? Will we quit? Will we give up the fight? Is it time to surrender? Or can we do 2 more questions? I don't know, guys. I don't know. Let's do 2 more. Let's do it. A 67-year-old man with a history of chronic obstructive pulmonary disease presents to the clinic with worsening dyspnea and productive cough for the past 5 days. He also reports low-grade fever and malaise and a long-term smoker with a 40-pack-year history. Which of the following is most likely the mechanism for the patient's hypoxemia? Diminished breath sounds. Blood pressure 128/76. Dense consolidation of the right upper lobe. Impaired gas exchange. Is that what you guys are thinking? All right. So we have a productive cough. There's low-grade fever and consolidation. That's classic lobar pneumonia. Lobar pneumonia should make you think of what? Oh, we're thinking D? Is that what we're thinking? Anybody have any other ideas? Sidal says VQ mismatch. You guys should fight. Just kidding. What is the right answer? Is it diffusion limited gas exchange? Or is it ventilation perfusion mismatch? Okay, so let's look over like the most important aspects of this question right here. So I kind of highlighted way too much, so I'm going to unhighlight this stuff. Okay, So here it is, dense consolidation over the right upper lobe. That suggests lobar pneumonia. That blocks the alveolar ventilation in that area. Also look at this, pH 7.44, PaCO2 is 31, and our bicarbonate is at 20. That tells us there's respiratory alkalosis with compensatory low bicarbonate. And so this patient is hyperventilating, all right? Hyperventilation. There's respiratory alkalosis, compensatory low bicarbonate. The bicarb is low, all right. And PaO2, 64. This tells us that there's hypoxemia despite the compensatory hyperventilation. And so what we're thinking is C, ventilation perfusion mismatch. Ventilation perfusion mismatch. And so there's alveolar consolidation, and that blocks the ventilation to the regions of the lungs, right? So the blood still perfuses that area. You still got blood, but you don't have the air there. There's no ventilation. And there's an intrapulmonary shunting. That's the key mechanism for the pneumonia-related hypoxemia, intrapulmonary shunting. And so they have pneumonia that's superimposed on their COPD. So they have COPD and also pneumonia. And so you have a ventilation perfusion mismatch because the consolidated alveoli received no ventilation, like hardly any. Maybe a little bit, but just barely any. And yet they still get perfused. They still get the blood. So you have areas of low V resulting in hypoxemia. And that's the most common cause of hypoxemia in pneumonia. And it does not correct completely with supplemental oxygen, right? But what about these other answer choices? Widespread alveolar collapse. Well, that would cause severe hypoxemia, right? That's more like atelectasis. How about B, which is what a lot of us were saying? Inadequate ventilation due to the airway obstruction. Well, that's COPD exacerbation of asthma. And this person's main issue is alveolar filling, not bronchial obstruction. Alveolar filling is the problem. Ventilation perfusion is correct answer. Diffusion limited, gas exchange across the alveolar membrane. That would be seen in fibrosis and high output states. That's not localized consolidation. Fibrosis and high outputs is diffusion limited. And then high altitude exposure causing low inspired oxygen levels. There's no evidence of altitude exposure here. Okay, so why the lung is leaking oxygen? Pneumonia-induced VQ mismatch, leading cause of hypoxemia and pulmonary infections. Widespread alveolar collapse, atelectasis, COPD exacerbation. D is pulmonary fibrosis and emphysema and exercise-induced hypoxia. Diffusion limitation is rarely the cause of hypoxemia at rest and does not explain the focal findings of fever. VQ mismatch is associated there with mechanism of pneumonia and COPD exacerbation. And then you have an infection, so there's higher risk of pneumonia, and smoking destroys the alveolar macrophages and predisposes you to the infection. So let's explain this like super duper simply. Very, very, very simply. Basically, VQ mismatch is a spectrum. You have low ventilation to zero ventilation. And then when the alveoli are completely filled with fluid, like in lobar pneumonia, ventilation goes to zero. Perfusion still continues. That is a true intrapulmonary shunt. The hypoxemia in pneumonia typically does not correct fully with 100% oxygen, and that supports the shunt physiology. And so, yes, the best answer is definitely VQ mismatch, but I can see as well, like the most precise term for lobar consolidation and complete ventilation loss is an intrapulmonary shunt. And so, yes, that is definitely like a very, very good way of saying it. But in pneumonia, yes, there's actually no ventilation, so there's a shunt, definitely more accurate, and you get a gold star. You get a gold star, my friend. Okay, here's the bottom line. Ventilation perfusion mismatch in the affected area is most likely the mechanism for hypoxemia in pneumonia. All right, guys, last question. The last question. Hallelujah. Last question. Let's go. Here we go, guys. Question 200. We've been at this for days, over 4 days, and we finally are finishing today. Okay. All right. Last question. Who's going to get this right? The first person to get this right. If there's a way that I can, no, not 20 push-ups. No. Oh, I wanted to do the question first. Oh, I was so excited. All right. I'm going to do push-ups while you guys solve the question. Okay. There we go. I should stop promoting the Twitch channel. Oh, okay. Here we go. A 31-year-old man presents to the clinic with a 6-month history of unexplained weight loss, increased sweating, persistent anxiety, unusually hot, even in mild to warm environments. His heart rate is 110 beats per minute, non-tender, diffusely enlarged thyroid gland. Lab studies reveal an undetectable thyroid-stimulating hormone, an elevated T4 and T3, most likely due to hormones exerting their action through which the following mechanisms. This is a good one. All right, you guys can phone a friend. Hematopoiesis is pretty sure that thyroid is a cell surface receptor, probably G protein. What are you guys thinking? This is for all the marbles. Dr. Sawasan says B, not sure. This is a really good last question. I'm glad there's some good conversation about this. All right, so weight loss, heat intolerance, anxiety, sweating. Can we all agree this is hyperthyroidism, undetectable TSH, and elevated T3-4, so it's primary? Anybody feel super confident? All right, so there's unexplained weight loss, heat intolerance, and so this is an anxiety and tachycardia. Thyrotoxicosis, right? Thyrotoxicosis. And there's diffuse non-tender goiter, and that's most consistent with Graves' disease, right? Graves. Okay, so that's an autoimmune hyperthyroidism. There's elevated T3 and T4, and there's suppressed TSH, and that confirms primary hyperparathyroidism. So we got all that down. Cool. Now, thyroid hormones, they're lipid soluble. Does that help? Thyroid hormones are lipid soluble. They can act intracellularly, and they bind nuclear receptors to regulate the gene transcription. So they behave like steroids. Yes, 100%. You got it right. Hematopoiesis C. They behave like steroids. They cross the cell membrane, they bind to the nuclear receptors, and they alter gene transcription, changing the protein synthesis. They're essentially going to exert their effects by entering into the cell and binding nuclear receptors. And these receptors directly modulate the DNA transcription, and they alter the gene expression. And so, yes, 100%. Well, you got it right in the end, and that's all that matters. That's all that matters for me. And now let's talk about each of these. A, that's used by insulin and IGF, not thyroid hormone. Insulin and IGF use this pathway, the PI3K pathway. PI3K pathway, insulin, IGF. Intrinsic tyrosine kinase. Well, this one is going to be insulin and also your growth factors like EGF, PDGF. D-ligand-gated ion. That applies to neurotransmitters like GABA and acetylcholine. Activation of adenylate cyclase through the G proteins. That would be like TSH, ACTH, PTH, and glucagon, not T3, T4. So the hormones use different receptor systems, and peptide hormones are on the membrane receptors. Steroid and thyroid hormones are lipid soluble across the membrane, and they bind to intracellular receptors, and heat intolerance, weight loss, anxiety, and hyperthyroidism. So there you go. Good job, guys. Here's the bottom line. And thank you so much for the gifted sub. I really appreciated that, Moise. I'm going to use that to buy a cleaner for my huge water bottle. We did it, guys. We finished NBME 30. It only took us 4 days. But the bottom line is hyperthyroidism symptoms arise from thyroid hormones binding to and modulating gene expression. All right. Moise, really appreciate it. And let's see here. I just finished this overlay, so I'm curious what you guys think on this one. So if you guys are watching on YouTube, this has been fun. You can always join us on Twitch to kind of participate in this. I think I'm going to add some new features like labs are going to show, and also I'm going to have polling systems that everybody on Twitch can vote, and you'll be able to see each other's like votes rolling in. I think I'll do that. But yeah, we're going to have lab values. We're going to have polling systems. We'll love to see if you guys have any other feedback on what you'd like for me to add.
Please like and subscribe. Congrats on finishing the whole video. Here's some chill outro music. Please like and subscribe.